Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known, proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
Good morning. I would like to welcome you to the 10th Transcatheter Heart Valves meeting, a meeting that has grown over the years and has become of international stature, having a faithful and widening audience, mainly online due to the circumstances, a meeting that has grown thanks to the efforts of many gifted individuals, more than anybody else, of the president of the meeting, Dr. Konstantinos Parias, who is also the first speaker of the day. The topic that we will cover has to do with latest TAVI trials and upcoming device updates. Dr. Parias will update us on the Edwards TAVI trials and device updates. Dr. Parias?
Good morning. It's my great pleasure to start this year's meeting, and I welcome all of you that you're physically here or you're with us virtually online. And I thank Alexis for the introduction. I hope we'll learn many new things in these 2 days, and it will be a great opportunity to gather together all the people who were doing this business of structural heart disease therapies, and all this for the benefit of our patients. So the first session will be a collection of presentations for devices from the largest manufacturers, and what they are having ongoing, about newer iterations of the devices, about ongoing trials, and finally, we'll also one case that we believe that only the device of this particular manufacturer will succeed. So I start with the latest and upcoming Edwards TAVI trials and updates, and a case where the Edwards valve will succeed, disclosures, and the Ygea Hospital heart team that were doing all these procedures. And we all remember that the first valve that was implanted was a valve manufactured by Edwards, by Dr. Cribier, in 2002, a pioneer in this field, and his perseverance was fundamental in establishing the TAVI therapies. And this was the first patient. The first procedure was done through the septum, transeptally. And here we see all the evolution and all the research that has been put by Edwards into their TAVI device. You see how the scaffoldings, the stents were developed with different designs, different frames, and different cells to come to today's device. And you see the skirt prototypes that they've used, and they tested to end up with a dress that they are using in their current device. And so the most advanced, let's say, iteration was the Sapien 3 up until 1-2 years ago. With this design, the large cells at the top, the smaller cells at the bottom, cobalt chromium alloy frame, the outer sealing skirt, and indeed with this valve design we succeeded probably the best clinical outcomes in the clinical trials. And now we have the latest iteration, which is the Sapien 3 Ultra valve, with some changes in the skirt. So the composition of the skirt is changed, and also the height of the skirt is changed, and this has contributed in a further reduction of paravalvular leaks. And of course, together with the valves, there were a lot of development in the delivery systems, the delivery catheters, and the seals, all done by Edwards. So we are still using both Sapien 3 and Sapien Ultra, and here you can see the differences. So the skirt in the Ultra is about 40% higher than the skirt in the Sapien 3. All the Ultra valves, they go through a 14 frames transfemoral sheath whereas the SAPIEN 3, the largest size, needs a 16 French sheath. And of course, through the trials, or through all these years, we have seen by using this device and the newest iteration, an improvement in all the outcomes. You see here the reductions, the 30-day all-cause mortality from the initial studies to the very latest, which is close to zero. The reduction in the strokes, the reduction in the moderate or severe paravalvular leak, and with the newest ultra device, the moderate or severe PVL at 30 days is just 0.5%, which is close to zero. And with these devices, we have managed today to have a median procedure time of 45 minutes. 80% of the patients can be discharged on the following day, and most of them home. And the latest study we have is the PARTNER 3 trial with the SAPIEN 3 valve, and we have the 2-year follow-up that were announced last year. And you can see about 1,000 patients with an average age, mean age of 73 years old, so elderly, but not very elderly. STS score of around 2%, so low-risk patients. And you see at 2 years, compared with surgery, that we have a better arithmetic results. There was a trend at 1 year for lower mortality with TAVI that now disappeared, but still at 2 years, the all-cause mortality is lower with TAVI compared to surgery. In this study, strokes also, there is a significant reduction. There was a significant reduction at 1 year, still lower, not significant in 2 years. And here you see the paravalvular regurgitation. For moderate or severe, it's close to zero. And the mild, there is the usual difference between the surgical valves and the TAVI. About 1/4 of the patients are classified as having mild. And the reduction of the mean gradient, significant reduction, and in the aortic valve area, as you can see, it goes up, similar between surgery and TAVI. And here we have a difference in the valve thrombosis that at 2 years was higher in TAVR compared to surgery, 2.6% versus 0.7%. And you see here the composition of these numbers. So all the 3 surgical patients, they had a mean gradient above 20, but no raise of more than 10 millimeters of mercury of the mean gradient. And for the TAVI valves, as you can see, 7 patients had a mean gradient above 20 with an increase of more than 10 millimeters of mercury, and the rest as categorized here. So despite this difference, of course, strokes were lower with TAVI, as we have seen, and all-cause mortality was lower with TAVI. And the other difference is the secondary endpoints. We are all aware of this. Less atrial fibrillation with TAVR. There was no difference in new pacemakers between TAVR and surgery, below 10% in both of them. More, of course, LBBB after TAVI than surgery. And there was no significant difference in all the rest. And is it financially of our interest to do more TAVI than SAVR? The economical analysis from the PARTNER 3 shows yes, and there was a benefit or a cost saving of more than $2,000 per patient through the 2 years of this study when you do TAVI, when you treat aortic stenosis with TAVI versus surgery. And the ultra valve, we see here a comparison with the SAPIEN 3 in real life experience, and you see how it becomes the moderate close to zero, further reduction compared to SAPIEN 3. And about studies, we've all know the PARTNER studies. We've all know the early TAVR trial that is ongoing in severe aortic stenosis without symptoms. And another newest trial that is ongoing is the PROGRESS trial in patients with moderate aortic stenosis. So this study is about 750 patients will be included, and they will be randomized to TAVR versus surveillance. And of course, the RIA study, which is a randomized study in women, all comers, comparing TAVR with surgery. And we've just initiated this study at a year. Is that the end? Are we finishing with the Ultra device? Of course, no. We have newer developments. We have, first of all, the Altera system, that is the scaffolding, the base for the pulmonary valve to go and implant there the SAPIEN 3. And we have the newer iteration, the SAPIEN X4, that is coming probably this year, and also new revolutionary platforms that are tested. This is a glimpse of the SAPIEN X4 and the future platforms. And finishing, I will present the case that we believe that only this valve would be suitable. So this is a 21-year-old lady, a normal BMI, severe aortic stenosis with the comorbidities you see here. The most important, the congenital hip dislocations, multiple operations without success, restricted mobility but mobile. She could walk. And here you see the severe aortic stenosis, maximum velocity, transvalvular velocity of above 5 meters per second, aortic valve area 0.4, also moderate mixed mitral valve disease with moderate MR and a mean gradient of 7 millimeters of mercury, normal ejection fraction, pulmonary hypertension. This is the CT scan just to show you the dislocations that they will appear now, especially on the right side. You see the femur is completely away from the pelvis. And this is the CT scan of the heart. You see the extreme calcium on the mitral valve, the mitral annulus, and the significant calcium in the aortic valve. The Agason score of the aortic valve was 1,500 units. And here you see the projection that we intended to use for the implantation. And this is the axial imaging of the aortic valve, where you can see the small anatomy in general, and then again you can see there is a raphe between the left and the right sinus of valsalva. So this is a functional bicuspid with a calcified raphe, type 1, and this is the opening of the valve, the peripheral arteries and all the aorta. The sizes were borderline, as you can see, for a 14 French sheath. Small arteries, but we thought we could manage for 14 French. And these are the dimensions of the aortic valve annulus. You see area 247 and perimeter 55, 56 millimeters. The sinus of valsalva, notice that they are only 22 millimeters width, the sizes. And here are the company-provided analysis, where you can see the left leg is probably a bit better than the right, very small anatomy that could be okay for the Medtronic 23 valve, but the sinus of valsalva width is very low, and so it's not indicated. So this option for Medtronic is rejected because it would completely fill in the sinus of valsalva. And you see exactly there will be no distance between the valve and the left main coronary. And so this was rejected as an option. And the same, the accurate neo valve. For the small size, we need at least 21 millimeters annulus, and here the annulus was 18 millimeters. So for this reason, the only available option would be the SAPIEN, the small size, the 20 millimeters, which would be less than the sinus of valsalva width, that was 22 millimeters. And we also we're also thinking of undersizing this. So this is a procedure. So we select the left side, and we're in the left side now. This is the aortography. You see the extreme calcium and the very small anatomy, low coronary ostia height, the left ventricle, the gradient at the beginning of the procedure. This is the valvuloplasty with a 16 millimeters balloon and simultaneous aortography. You see there is some safe distance between the balloon and the left main artery. That's why we opted not to protect with a stent before implantation. This is the 20mm valve. This is the implantation. We had a little less volume than the nominal because we wanted to check first for corneostia patency. So you see the valve is not completely open with this downsizing. We check after that the left main. We see there is safe distance, and then we do a post-dilatation with a nominal volume, and the valve opens rightly. And here we see there's a very good perfusion to the coronary arteries. And this is how we end the procedure. And we have a very good echocardiography with no changes in the mitral stenosis and with some improvement, as you can see, in the mitral regurgitation. And with this, I would like to thank you. And it's up to you if you want to do any discussion now or if we go at the end. Perfect.
Wonderful, wonderful, and I think that wonderful, and I think that was a fantastic opening for the meeting. After all, that valve that you showed by Cribier was what started the transcatheter heart valve revolution, essentially, so I think it's only fitting that that's where we started our meeting as well. Our next speaker, I believe, will be online. Do we have him online, Dr. Toutouzouz, or not yet?
I'm here, yes. I can hear you. Can you see me? Can you hear me?
Like the voice of God, somewhat. We hear you, but we don't see you. Professor Dr. Toutouzouz, are you there?
Can you see?
Now,
you see me now?
Now we can see you. Thank you very much for being with us this morning. The meeting is being broadcast throughout the world and through the CTSNet. So thank you very much for joining us. Everyone knows Professor Toutouzouz, who doesn't need any introductions, and he has pioneered many of the studies that have changed the knowledge we have available about TAVI today, including his famous randomized trial about pre-dilation or not. Professor Toutouzouz, thank you for being with us. We will like to be on time as much as we can, so 15 minutes maximum. And we would like to hear about the latest and upcoming Medtronic TAVI trials, as well as hearing about a case where you believe only Medtronic could succeed. Thank you very much.
First of all, I would like to thank you, Dr. Patakos, and the organizing committee, especially Dr. Sparias, for the kind invitation to participate in this successful transcatheter heart valve Congress. Unfortunately, I could not be there, but I'm really happy to participate through the internet. Now, I will start in the other way. I will start with his case presentation. 76-year-old. You can see that he is severely symptomatic with bicuspid aortic stenosis. Actually, this case we showed in our congress in November, Cardiothoracic. It was very interesting, with Euroscore 2 of 11.47%, NIHA 3 to 4. The background, he had the cabbage in 2012 with Lima and SVG and SVG, 2 SVGs. Coronary angiogram, cardiovascular risk factors, hypertension, dyslipidemia, chronic kidney disease, stage 3B. And this was the medication that he was under for this case. The laboratory findings, nothing special except from the, he had an anemia of hemoglobin of 11 and creatinine of 2.2 with a GFR of 35. In the ECG, you can appreciate he had an LBBB, sinus rhythm, and these are the findings from, especially these findings from the ECG. This is the chest X-ray, as you may appreciate in this X-ray. And this is the coronary angiography. And you may appreciate that he has, this is the circ, this is the LAD, and RCA. You can see now the graphs. This is the vein going to the diagonal, and this is to the RCA graft, and the Lima to LAD. So pretty much patent grafts. This is the echo. You can appreciate that you can see here it's really stenotic valve, calcified, very calcified. And it has also moderate MVR. Ejection fraction is pretty low, as you may appreciate again in this 4-chamber view with the MVR obvious. Here you may see that he has also AVR, and this is the velocity 3.6 with a low ejection fraction. And this is the Doppler image with a PASP of 15 millimeters of mercury. Sorry, okay. Now, this is the CT, and you may appreciate that this is the annual dimensions of mean diameter of 28.3 millimeters. So, this is the calcification upon the valve. Here you can appreciate we have a significant, very calcified valve. The diameter, the heights are okay, and also it appears to be almost horizontal valve. The peripheral axis, again, problematic also this. You may see that it's less than 6, it's 5.9, very calcified tortuous vessel, and we had to deal with this patient. The procedural strategy was transfemoral, general anesthesia and intubation. We wanted to do also TOE to evaluate the patient during the procedure, to avoid contrast as much as we could. Temporary pacing, pre-dilatation because it is a bicuspid valve, and we had to choose a large valve. That's why we chose Everett R34. Of course, I would not say that is the only valve that we would place, but at that time, 2020, I think it was one of the valves that with very limited access, with a large annulus. In a bicuspid valve without any experience in other valves, I think it was in one or two valves that we could choose. And another important thing is that we wanted to see how it behaves and to avoid any post-dilatation if we could. But this is not an easy task with the risk of Pvl. And we had a plan to close the femoral access by Manda, as we already do. So this is the procedure. This is the TOE in the cath lab. You may appreciate here the TOE in the cath lab. Let's go much faster. This is the 3D. Nothing important. The gradient, of course I have the gradient after, but you'll see it. We did the pre-dilatation. Let's go to the echo. Okay, so we did the pre-dilatation because we want to see how it behaves, the valve actually. We had a very tough time to put in the height that we would like to do it. You can appreciate how calcified is the annulus. Landerkust, as you may see here, wire. This is during the implantation. Here you may appreciate the procedure. We tried to put it as much high as we could. Not an easy task to put it in exactly in the area that we would like. Not a perfect dilatation after the implantation. This is the echo. You appreciate that we had a leak, actually AVR. So we'll do the post-dilatation. This is the post-dilatation with rapid pacing. We achieved a better result, of course. And in the echo, you can appreciate how the AVR was minimized after the implantation. With very good hemodynamics post-implantation, tough case, and a closure with Manda without any side effects. So I can show you the difficulties that you can appreciate, especially in younger population, not very old, with this kind of patient. This is the post-procedural transthoracic echo. Actually, the MVR did not significantly improved. There is a slight improvement, but not impressive one. And you can appreciate that we have almost nothing or no AVR. But of course, it's a challenging case. Again, you can appreciate here in this. I would like to focus that the Medtronic program was really progressed during the last years, from the core valve that we started in 2008, and now we have the Evolut Pro Plus with certain characteristics that has improved the profile, actually the profile, but the behavior of the valve with better results. It is within 14 to 18 French shift equivalent. There is a very interesting program regarding the core valve from the extreme patients to very low patients, especially the US Evolut are low risk. And however, there is the Evolut low risk bicuspid registry, which is very interesting, with 150 patients in 25 medical centers with a risk score of only 1.4%. 30 days after the procedure, just 1.3 mortality or disabling stroke after the procedure, with a device success rate of 95.3%. Device success rate not with the VARC-3 definition, but as the termination that they already have. The vast majority of the patients survived the procedure. 96 showed correct position of the valve, and 100% of them had mild or no aortic regurgitation. Actually, patients with severe type 0 valve, almost 85% of them had a trace or no aortic regurgitation in these very challenging cases. I just remind you that the inclusion criteria were very strict, with annulus up to 30 millimeters. They were excluded with the triplet. All-cause mortality, and you may see here again the graph. As I told you, death or disabling stroke 1.3%, very good results. Mortality just one patient, and disabling stroke just one patient. Non-disabling strokes, 5 patients. Very important major vascular complications, only 2 patients. So pretty much very interesting results, with none in 60%, or a very mild AVR post-procedure in all patients, type 0 and type 1. So really good results. We have also the randomized results in the Evolut trial in almost 1,500 patients, with again comparable results with surgeons. You may appreciate here that the vascular access was 99% transfemoral, because we have this advantage with the Evolut valves to go to transfemoral. Even in this patient that I showed you, less than 6 millimeters, we could also implant a valve of 35 millimeters. So it's very interesting and challenging. The all-cause mortality, all disabling strokes at 2 years was comparable between surgeons and TARV. The secondary points, you may appreciate that there was no difference between surgeons and TARV at 2 years. This is very important. And the composite rates of estimated rates, the clinical implications, hospitalization, stroke, and death, you may appreciate that the hospitalizations is almost half compared to the surgical team. This is the moderate, permanent, and the PPM. It's less with TARV compared to the surgeons, and especially at 12 months, there is impressive reduction of PPM with the TARV. So we can achieve a better AVA with this valve. The CERTAVI also trial that was recently presented in 2022. Again, compared to the surgeons, the TAV with the Evolutar, and you may appreciate that the patients have very good quality of life compared to the surgeons at 2 years, better in the TAV compared to the surgeons. This is very important for the patients. I would like to present our results with this valve in, not our results also, it's a multi-center in
Sorry
Greece.
to interrupt, Dr. Toutzouzas, due to time pressure. I think if we can end with your results, because we're interested to see your results, so we would like to see
I just
this.
want to show you one graph, and I'm over. Very low, very low cardiovascular mortality in very high-risk patients at 8 years. We published this just 11 months ago, and Dr. Stavrogiannis. So my conclusion is that ARPRO is an excellent platform for performing TAV in the majority of patients. We have long-term data with this valve. Cardiovascular mortality is very low, and the special characteristics of the Evolut ARPRO, especially class, are sometimes unique. Thank you.
Thank you very much, Professor Toutzouzas, for your wonderful talk. Due to time constraints, if we have time, we will have the questions at the end, but thank you so much for being with us today. We appreciate it.
Thank you very much.
Our next speaker is Dr. Vlasis Ninos, an interventional cardiologist, director of the second cardiology department of the Balkan Medical Center at Thessaloniki. Has got a great experience in mitral clip, TAVI procedures, and he's going to give us a talk about the suitability of the Boston TAVI aortic valve and in which cases it's going to succeed. Thank you very much. Dr. Vlasis Ninos, please.
Good morning, Mr. Chairman. Thank you very much for the kind introduction and also for having me in the meeting. I would like to present the portfolio of the Boston Scientific Accurate Neo2 valve. As you can see, there have been 3 iterations, actually 2 iterations of the device, the Accurate Neo and the Accurate Neo2. The big difference between the 2 valves is the external skirt with the active reduction of the Pvl, which has made a big difference to the outcomes of this valve, as we will see on the data. And also a technical issue that there's a radio-opaque marker that was lacking from the first iteration of the valve that enhances the practicality and the accuracy of the implantation. Looking into the valve and considering the lifetime patient management when we are involved into a TAVI, the main issues that we're trying to address is to preserve coronary access, have optimal hemodynamics, durability, and looking into the valve and in-valve option in the future with preserved coronary access, since we're going to even younger population. This is the valve. Some of the features are that there's a unique top-down deployment, as we will see. There's an open frame at the top part. Despite being a supraannular leaflet, we have preserved access to the coronary arteries through the open frame. There's the active PV seal that really works very well, and the accurate positioning to the millimeter, because the system is locking on the leaflets, minimizes conduction system interference. So we have kind of best of both worlds. We have the accurate and fast position without rapid pacing that we see in the balloon expandable valves, but also the supraannular leaflet positioning with the bigger aortic valve area that we see in the self-expandable frames. And this is practically the implantation, as you will see. The Accurate Neo2 has this dot there that stabilizes, that shows us the exact implantation depth. We have the arches and the crowns opening, stabilize on the leaflet, and the release of the valve without any rapid pacing is very rapid, as you can see. And during the deployment, this excellent function of the valve, of the native valve, without any hemodynamic interference. The procedural success rate in most of the registries is 97.5%. The device usage time is very short, as you understand, and generally the results are very good. So moderate or greater PVL is up to 2.7%, mean gradients are single digit, and the need for new pacemaker implantation is usually less than 10%. And this is on the registries that you will see. Also, the big issue about the commissural alignment can be easily achieved. In the 3-cast view, you can see that the 3 posts are almost equally spaced out. And this is something we can achieve by just inserting the frame in a certain way with the flash port down at 6 o'clock and that really gives us many room for the future access to the coronary arteries. The durability, we have some data about the durability that on the bench testing and also from the first accurate platform, we have a registry that goes out to 5 years that shows that the valve area is preserved and the structural valve deterioration is really minimal. The CE-mark study of the Accurate Neo2 platform, 120 patients have pretty much confirmed this. And this the demographics of the patient, the size is implanted. As we said, the device usage time is very short. The success rate is interesting. The pacemaker implantation was somewhat higher than what we see on clinical practice, but that's something to be investigated further into the ID trial that is coming. But of course, the rest of the complications are really minimal. The ID trial is coming, is on the way, and we are looking forward to these results. It's still actively enrolling, and it's head-to-head comparison with the CoreVault system and the SAPIEN system. The early Neo2 registry with 554 patients showed excellent PVL performance from the valve. Mean grade is very low, new pacemaker implantation 6%, 30-day mortality very low, stroke very low. And these are the results compared to the Accurate Neo system. You can see there is a significant improvement in the PVL severity, which is thanks to the active sealing and also to the learning curve of the operators. We have to respect certain steps of the procedures. And if we do that, we have good results. Similar outcomes to the EPAL Neo registry with the device success being 97.9%. Very minimal embolization of the device, new pacemakers around 11%, in hospital stroke 1.1%. Overall, very good results. Interestingly, no severe patient prosthesis mismatch. This is due to the supraannular design, single-digit gradients, and greater than mild PVL in these real-life populations, 3%. So really good results and good outcomes. So the Accurate Neo2, as we said, we're looking now into the option of the valve-in-valve while the company is working on the positioning of the Accurate Neo into an Accurate Neo and standardizing the procedure. Bench testing and real-life experiences showed that both valves can be used. Even SAPIEN 3 can be used because the height of the frame of the SAPIEN really covers the height of the leaflets, the leaflet insertion point. So it can be used and it has been used in bench testing and real life experiences. You can see maintaining also coronary artery for the future. So successful anchoring and good hemodynamics and no PVL. And here is the bench testing of how SAPIEN 3 can be inserted into the Accurate Neo2. So in the access of the coronary arteries is very important. We have seen the ReAccess study and really a closed cell design can be problematic. This is no problem with the Accurate Neo platform, which is really very successful. And also with the addition of the commissural alignment can be facilitated even further. Some propensity mask scoring of comparison between the self-expanding and the balloon expanding transcatheter valve in small annulus shows that the patient prosthesis mismatch is no problem in small annuli. Here is a comparison between SAPIEN 3 valve and also it's very important, of course, to pre-dilate the valve, and this is something that we see. The RBBB registry showed that the pacemaker implantation is lower than the one expected with commercially available valves. So in a population that pacemaker can be certain, the need for permanent pacemaker in RBBB patient is about 30%, which is really smaller. This is a typical implantation just to show the steps. The marker is positioned at the annular level. You can see no need for rapid pacing. The crowns are opening and it's pretty much locking onto the leaflet. The arches are stabilizing the valve. And the third step is to open the frame in one movement and then removing the delivery system. And this is a typical result you get with the Accurate Neo2 with trivial or no PVL and commissural alignment. As you can see, the posts are equally spaced out. Tortuosity and angulation is usually a big problem. The valve is really versatile. The delivery system is flexible. In this really extreme case, with the help of a safari wire, not even a Landerquist, we had a Landerquist as a body wire. You can see that we were able to navigate the valve even here at the arch with some maneuvering of the system. It went through without any problems. And then once it got into position, implanting the valve was no problem with a very good outcome, as you can see. Even in very heavily calcified iliac arteries, it can be delivered. This, of course, has been facilitated by some balloon pre-dilatation, but it's very important to use the eye sleeve. The eye sleeve is a very hydrophilic and expanding sleeve, expanding sheath that is 14 French, but it opens up to facilitate valve crossing. We can even balloon inside the sleeve. We've done this on a couple of cases to open further the arteries, and this is a positioning on a Landerquist wire without any problems and a very good result. This is a bicuspid valve that, of course, is not CE marked yet for this valve, but it can be used. And as you can see, there's need for pre-dilatation. And here is a positioning in a very high position on the frame with a very good result, as you do for a bicuspid valve. And this is an interesting case of a patient with morbid obesity, relatively young, 65, but pulmonary hypertension, small annulus, at the border of what the company is recommending, 20.9 millimeters, 21 is the lower cutoff. But here you can see there's a big chunk of calcium at the LVOT, which can be problematic for any valve, and also in particular for a balloon expandable valve. And also what was interesting is a very low height takeoff of the left main at 7 millimeters with decent sinus of Valsalva width. Nevertheless, we chose to protect the left main, at least having a wire in position. And then this is the three-cusp view, the pre-dilation that we always perform with this valve. It's very, very important. And this is the positioning. As you can see, the valve is in the annulus. We open the crowns, we open the arches. It is maintaining the position, no hemodynamic instability. This is the opening of the valve. The frame expands gradually in this fibrotic. You can see the chunk of calcium at the LVOT level. We, of course, refrained from post-dilating this valve because we were concerned what will happen to the LVOT. But interestingly, there was only mild PVL, the hemodynamics were excellent, and the patency of the left main was preserved. So thank you very much for the attention. I hope I was on time and I'm available for questions.
Thank you very much, Dr. Niños.
So for the interest of time, we'll proceed with our next discussion. Address the issue of latest and upcoming Abbott TAVI trials and updates, a case where only Abbott will succeed. Dr. Michalis?
Good morning from Ioannina. Hope you can see my slides.
Yes, we can.
Okay, thanks. First of all, greetings from Ioannina. Finally and gradually the weather is getting some better. And today it was going to be only scattered thunderstorms during midday. So it's getting better for us. I have to say that I've never been very fond of giving this type of lectures because I don't believe that we can say where something is going to be the best or not. And also it reminds me my older days when I was doing PCIs, when in every single trial, when different stents were tried, the technical success was similar. So the main problem with TAVI is how we can address long-term outcomes more easier than the technical success. And let's go further down. I don't know, it doesn't move. Okay. So this is my conflict of interest. So what I tried actually to summarize is different questions that have been asked all these years that I'm doing TAVIs in regards with Navitor. And I summarized all these questions that I had to ask to different implanters that they do this type of work. First of all, I have to say that one question that I've never been asked is how should I read the CT scan? And I have to tell you that the main thing when you start and you are discussing about TAVI is that you have to be a master in CT scan. If you are not good enough, then you will never learn how to do TAVI. And this is my first comment. Now, the second question is Navitor a user-friendly on vascular access? I can tell you that it's a fantastic valve. It is hydrophilic, it's flexible, it has the lowest size on the profile, and it goes very smoothly within the vascular system. And you can see here how it moves. I'm not so sure if you can see the calcified axis, but it moves very nicely, and also it can go through very easily through the aortic arch. So there's no problem with that. It's very easy to be used. The second question that I'm asked is, do we need pre and post dilatation? Personally, I always use pre-dilatation. And I use a pre-dilatation with a balloon size with a smaller annular diameter, and post-dilate in cases that is a peak to bit graded more than 7, or if it's an AR more than trivial with a mean annular diameter balloon size. But not all operators find it necessary. In our Greek experience, and it's just published a Greek registry of North and Northwestern Greece with 90 consecutive patients treated with Portico in 3 centers, that pre-dilatation rate was around 50, and less than 50 was the post-dilatation rate. So in the question if it's needed, personally I use it, but not all people use it. The second question that I was asked is is it good for horizontal aortas? In my hands, possibly is the best self-expandable valve for this horizontal aortas, because the device does not have a spine adding kinks, so it can be used in a way that can conform into the horizontal aorta. There are certain trips that after the device has touched the non-coronary sinus, then you have to push a bit the device without a lot of pushing of the wire, and during the final releasing steps, you have to reduce all the pressure of the pushing and to allow the system to be under no stress, and there's no problem on that. And you can see exactly what I mean here in that small video. The second thing is how can I achieve commissural alignment? I'm not so sure if it is the right thing to say nowadays. It's a commissural alignment or a coronary alignment, and I'm not so sure if in any valve you can do it very accurately. I have to say that with Navitor, there's not a standardized approach, but my question is if it really is needed with such large cells, which usually allow easy access, as you can see in these small videos that I've done, and we can find it very easy to get into the coronaries. When you have to do that, you have to use standardized strip tips. However, use guiding catheters with smaller curves and use possibly extension guide catheters. Another question is, can I go through the subclavian in case that is needed? Definitely you can go with the Navitor through the subclavian, but everyone has to remember that subclavian access is not the same as transfemoral. The main drawback is the high risk of stroke, which is up to 6.5% in large series. The Navitor has several advantages, as flexibility, the low profile of the integrated sheath is stable and controlled during deployment, and these advantages may reduce the risk of stroke, but this has to be proven. Another question is if the valve has adequate radial and opening force. For a long time, many people thought that Portico has a low radial force. This is not true. Both Portico and Navitor have high radial force. What it has less has a lower opening force. The radial force means that the valve remains wide open against the force of the annulus for a long time. Opening force means that the valve anchors aggressively to the non-coronary cusp, and thus predictable positioning can be achieved. However, Navitor has achieved the predictable positioning by using the flex nav delivery system in possibly in different ways, and I have to tell you that it's very predictable. And the next question is, can I achieve a predictable positioning with the aortic annulus? Since we started using the overlapping cusp views and very simple and very strict steps, the predictability of all self-expandable valves is very high. And they use the 3 tips I use. I always use the overlapping cusp view. I withdraw any pressure of the guiding wire after the initial steps, which is the anchoring of the non-coronary cusp. And during this phase, you can go even faster if you want, but you have to use a rather fast pacing. After you anchored, go slowly. There's no rush. The valve functions immediately and there's no pressure drop. So stay calm. The valve can be recaptured almost till just prior to its release. And during the final steps, go very slow with no pressure on the system. And you are done. It's very simple, it's very predictable, and you never fail. What about PVL, post-TAVI? Navitor has a very low PVL leaks. The trivial or no leak is around 80%. And that is because has a skirt, it's an active cuff fills, and this works fantastically well. What about now, then that is shown also in the clinical outcomes of the CE mark approved studies, which again, you can show the numbers, which show that the mild or trivial TVL is 20%, and the none or trace is about 80%. So there's no PVL with this valve of a significance. Another question that I've been asked, how the valve performs hemodynamically. The valve performs very well hemodynamically, and there's a large effective orifice areas and single-digit gradients with this intra-annular valve. And these are our results from the study, which again shows very good results. I have to tell you that this is with Portico, not with the Navitor, and that's when we haven't standardized our steps during the procedure, which now have been standardized with the overlapping cusp view, and as I told you before, how I do it. If there's any news, the problem that we have with Navitor is that there was no a big valve for big annuli. This has gone. Now the Titan is in the market and soon will be available in Greece, and this is going to be able to treat annuli with perimeters up to 95 millimeters. And this is very good without any actually problems with enlarging the sheath of the valve. He's still keeping the very small sheath, which allows us to treat vessels less than the 5.5 millimeters. And in latest studies, now in the EuroPCR, the Portico next generation trial, the results, the 1-year results will be announced, which is a single-arm trial with almost 400 symptomatic severe aortic stenosis patients. The patients are at high and extreme surgical risks, and in this trial, a Titan arm will be included. And there's another trial, the Badenge trial, which currently is enrolling in European Union with 550 patients which have symptomatic severe aortic stenosis, but they are of intermediate and low risk surgical mortality. And in these patients, the valve patients will be included as well. In conclusions, I have to tell you a few things. First of all, we have to understand, everyone who is doing TAVIs, that TAVI is not a one-month show. A multidisciplinary team is needed. Before you start a TAVI program, you have to be a master on CTA. The best valve is the one you are experienced with. However, if you are a starter or you want to get experience with another valve, Navitor will be proven a pleasant surprise. Thank you.
Thank you, Dr. Michalis, for this very informative discussion and for your personal experience as well. I don't think we have time for questions, and thank you very much. We'll be proceeding to the next roundtable. Thank you.
Thank you.
Κύριε Σπάρια, με ακούτε?
Ναι.
Καλημέρα.
Καλημέρα.
Ο κύριος Ιακώβου παρακαλεί να κάνει την εισήγησή του τελευταίος.
Κανένα πρόβλημα. Το προβλέψαμε.
Ευχαριστώ.
Καλημέρα σας και από μένα.
Καλημέρα κύριε Μασογωστό.
Καλημέρα. Αν βλέπω είμαστε όλοι εδώ, ο κύριος Ζαχαρούλης, εγώ, οπότε μπορούμε να ξεκινήσουμε. Θα αλλάξουμε λοιπόν τη σειρά. Ο κύριος Ιακώβου θα πάει τελευταίος και θα ξεκινήσουμε με τον κύριο Νίκα. Πείτε μας πότε είμαστε έτοιμοι για να γυρίσουμε στα αγγλικά. Πείτε μας πότε. Τώρα? Okay, we're ready to continue with our next session that I'm going to chair together with Dr. Voudris from Onassis Center, who is with us virtually online, and Dr. Mastrokostopoulos from the Navy Hospital, who is also joining us online. And of course, I have Dr. Zacharoulis here from Evangelismos Hospital with me. And this session will deal with TAVI complications and how to avoid them. And we have very remarkable speakers with us that will tell us about the tips and tricks and help us to avoid these complications on our patients. So the first speaker is Dr. Nikas, Dimitris Nikas from Ioanna Hospital. And he is going to present a very serious complication when it develops in the hybrid or the cath lab, sudden hypotension during a TAVI procedure. If we are connected and when you're ready, so we have this change in the sequence of the presentation. Dr. Iakovou will be last in this session, and we start with the rest of the speakers. Okay, we have some PC issues here. um, Okay, so it's a complication session, and that's why we have complications here with presentations from our local Macs and PCs. And we move again, and we go to Dr. Dardas from Thessaloniki, who is connected virtually with us, and he will solve the issues of complications, PC complications. Petros, thank you for being with us.
Thank you. Thank you very much, Kostas, and thanks everybody and you personally for the very kind invitation, this fantastic meeting. Now let's start the complication session after we overcome some of the complications, and let's speak first about vascular complications, mostly the transfemoral vascular complications, and how to manage them and how to avoid them. These are my disclosures. Now, how frequent they are, they used to be very frequent. They are not that frequent now, but they are still there. So we have to bear in mind that the complications in the vascular field
Petro, sorry to interrupt you. Can you put the full presentation, Mol, your presentation, the full presentation?
It's full.
Full screen.
It's full screen.
We don't see it full screen.
Well, let me do it once more. What about now?
Okay. Yeah, okay, we can see it. Thanks.
Thank you. Now, the vascular complications are still there. So it's in the range of possibly more than 2%, sometimes even more. And they have an impact on mortality, as we all know, morbidity, reduced quality of life, increased cost, and mortality. Now, what are the main predictors of major vascular complications in transfemoral TAVI? We all know them, the sheath to femoral artery ratio, and although the sheaths are better now, are smaller, they still have an issue. Of course, the experience of the center, and the main problem is the femoral artery calcification. And this is the difficult scenario we're all confronted with from time to time. 82 years old female, a small patient with a previous mitral valve metallic, severe RCA disease, severe aortic stenosis, heavily calcified tortuous iliacs, porcelain aorta, a high Euro score, opted for TAVI and PCI to the right. So she's got all the features for adverse outcomes. She's got calcification everywhere. She's small and she's anticoagulated. And you can appreciate here the calcification of the iliacs and the calcification of the femorals as well. And this is the game starting. Push more, push even harder, and try more. In the end, you can get the valve through. And we were lucky enough to have a quite good outcome and preserve the femorals. However, this is the main predictor for vascular complications.
Petro, sorry to interrupt you again, but your screen is stuck. We see the same slide. We don't see what you describe. Can you close and open the presentation again and go to the full screen mode?
Well, typical complications. So what about now?
No, we still have the same appearance. It's not the full screen.
Okay, let me stop the share and share it again. Okay, let's start the share. What about now?
Go full screen mode? No, it doesn't go full screen mode.
It must be your problem because my computer, it is full screen.
Can you go full screen up in the red bar? Are you full screen up there?
Where? Hang on. Well. No, I'm not, but...
There, yeah. Go full screen there?
No.
No. No. Go to προβολή. Πήγαινε στην προβολή, εκεί που λέει προβολή. Παίρνω οδηγίες από τους τεχνικούς μας.
Να ξαναβγώ δηλαδή από το...
Όχι, πήγαινε εκεί που γράφει προβολή πάνω. Αναθεώρηση, προβολή. Πάνω.
Να μου το δείξετε, παιδιά, λοιπόν.
Πάνω, εκεί που είναι η κεντρική, αρχείο, στο PowerPoint, εκεί που γράφει προβολή.
Πρέπει
στην κόκκινη μπάρα. Όχι, δεν χρειάζεται να βγει. Στην κόκκινη μπάρα, πάνω, εκεί, δεξιά, εκεί που γράφει προβολή. Εκεί. Προβολή. Σκέτο προβολή. Πέτρο, εκεί που γράφει προβολή. Okay, I think we have to stop here. You'll get some help from our technical department. And we're ready with Dr. Nikas again. It's a full complication session. So go back to Dr. Nikas, sudden hypotension. And Petros, you'll be with us shortly. You'll get some help from our technicians.
Okay, thanks.
Good morning, and I'm very happy that I'm not the only one having complications here. So, I don't know whether you can see the full screen, okay? So, I'm very happy to discuss this strange complication, which is a hypertension. Hypertension. What means hypertension in the cath lab during TAVI or after TAVI? This is a conflict of interest. And this is a presentation outline. I'm going to just present you a short list of all the causes that may cause hypertension during TAVI or after TAVI. And then I'm going to focus mainly to this new, at least to us cardiologists, syndrome, the suicidal left ventricular syndrome. And of course, I'm going to present some solutions on how to treat or prevent this complication. What's the incidence of hypertension or shock during TAVI? As far as I searched the literature, actually, we don't know. We don't know because all the causes that they lead to hypertension or shock during TAVI or after TAVI, it's counted separately. Therefore, it's not the complication is a hypertension or shock. It's not counted in the TAVI trials. Therefore, we don't know. We don't know which is the incidence of hypertension during TAVI. But in this small paper, Laborde, sum up all these causes which lead to complication like hypertension and concluded that it may be up to 20%. So it's relatively common complications, not so rare as we think. And this is a short checklist we have to check when we have a complication like hypertension in the cath lab or just after the cath lab. In my mind, I always categorize the complications in different things in order to how to search and find what's the wrong with our patient. And in my mind, actually, I categorize this hypertension checklist as causes related with the vascular complication, causes related with cardiac complication, and causes related with the valve itself. And there's a long list. There are many causes that may create hypertension in the cath lab. This is the vascular complications, acute iliac femoral rupture, the retroperitonal bleeding, the aortic dissection, the aortic annulus rupture. The stroke itself may create hypertension. The cardiac, we all very much aware about this complication, occlusion, tamponade, aortic insufficiency, mitral insufficiency, conduction disturbances, and the suicidal syndrome. This is, I'm going to focus today. This is something, at least to my knowledge, this is something new, which we have to be much more careful in the future. And also the valve-related, when we have valve malposition, valve migration, or valve malfunction. I suppose that we all agree that these all complications are very well known to all of us. So, and we know how to identify, how to recognize, how to treat, how to prevent this kind of complication, except for one, this one, the suicidal left ventricle. And in order to do this presentation a little more interesting, I'm going to very shortly present the case. It's a relatively old female patient, 86 years old, which was hospitalized in a hospital with acute pulmonary edema and severe dyspnea for several days. She was a lady with a very small stature. The BSA was 1.35. She had severe COPD, and therefore she referred for TAVI because of the small stature, the severe COPD, and the very small aortic annulus, as this was measured from the echocardiogram. It's 1.8 centimeters. This is the analysis of the CTA, and you can appreciate it's annulus of about 21 millimeters diameter, 69 millimeters in perimeter, so it was a borderline between 23 and 25 portico valve. And we decided to go with a larger one in order to be secure, not to have a pop-ups or any other complication. This is the echo of our patient. You can appreciate it's a relatively hypertrophic ventricle, depression of ejection fraction. This is the pre-procedural baseline echo. The procedure was uneventful and easy, I would say. This is the right femoral axis, valve implantation. You can appreciate that the valve is a little bit constrained at the very end of the procedure. However, since we didn't have any gradient between left ventricle and the aorta, we decided not to post-dilatate because it was a really small annulus and we were pretty much afraid to have a pop-up of the valve. Closure was fine. We don't see any hemorrhages or anything else or dissections. So patient left the cath lab asymptomatic in a very good position, in very good condition, and she went to the ICU, where half an hour afterwards, she had a hypertension, she had a shock. And what was happening? So we called to the ICU. We immediately brought up our list of our complication, and we start checking all this checklist to see what's going wrong. We checked the patient immediately for obvious reasons of hypertension, like hemorrhages or hematomas. There was nothing. And we grabbed the echo, we did the echo to the patient, and this is what we found. You can appreciate here a very large and very hypertrophic ventricle, which hypercontracting. It's almost occluding the left ventricular cavity. It creates this severe gradient, this dagger shape gradient in the mid cavity. So this is the typical suicidal left ventricular syndrome. And what is the mechanism between this one? Patient eventually, we gave a lot of fluids, and she went well and discharged home on day 4. So what is this mechanism behind this very complicated and very strange, at least to us cardiologists, complication? It's obviously the abrupt reduction of the afterload, of the resistance that the aortic valve creates in the long term, makes this ventricle, I call it supernormal ventricle, supercontracting ventricle, to contract so forcefully that eventually blocks the left ventricular cavity and blocks the outflow of the ventricle. Therefore, the patient leads going to the shock or hypertension. And it's not a new phenomenon. At least to the surgeons, it's very well known from the early years of surgical replacement of the aortic valve. This is a small study from 1996, 100 patients. We had a surgically replaced aortic valve, severe aortic valve replacement due to severe aortic stenosis. And as you can see, 40% of those patients eventually had intraventricular gradient, severe intraventricular gravity at rest, whereas another 30% of the patient had intraventricular gradient in provocation, either with vasodilator or in inotropic stimulation with dobutamine. And from this study, we know for many, many years now that there were many parameters that may be associated with increased risk of left ventricular suicidal syndrome occurrence. This is the small heart. The smaller the heart is, the end-diastolic diameter and end-systolic diameter, the worse the probability to have a left ventricular syndrome. The mitral annulus calcification, the aortic valve area, and the ejection fraction. This is what I told you previously, the hypercontracting, the supernormal left ventricular heart. These are the patients that are going to end up with a left ventricular suicidal syndrome. And this is another study which actually confirmed the previous results that in patients who had valvuloplasty only, not replacement or implantation of TAVI valve, the valvuloplasty only, 100 patients, you can see that those with the small ventricles, the ones that had ventricle and diastolic diameter of the ventricle less than 4 centimeters, may have severely and significantly higher rate of complication, both for intubation, for cardiopulmonary resuscitation, tamponade, or even death. So the smaller the heart is, the higher the probability to have complication. So size does matter. Don't forget about this, that size does matter. The smaller, the worst. But the good thing is that, as we see from the literature, this strange complication may be almost 100% preventable. I mean, you can see that all parameters that may be associated with the left ventricle suicidal syndrome are only parameters that can be measured or estimated before the procedure and not afterwards. And this is something very important. So, to my mind, these are the most important predictors. I mean, the small stature, the female gender, the small left ventricular cavity, the bulging intraventricular septum, which is very common in very old female patients, the severe hypertrophy of the patient who has a long-standing aortic stenosis, and the supernormal, the supercontracted left ventricle. These are the most important predictors that may lead the patient after TAVI to this strange complication. And what is the treatment? As I told you previously, the main mechanism behind this complication is the abrupt reduction of the afterload. Therefore, obviously, even though it's not always the true in medicine in generally, the main mechanism to treat this complication is to increase the afterload. Therefore, we have to give fluids to the patient in order to maintain the afterload as well and the preload. We have to give inotropic and, let's say, norepinephrine just to create peripheral vasoconstriction. Sometimes we have to give beta blockers as we treat hypertrophic cardiomyopathy to reduce this hypercontracting, the force of this hypercontracting ventricle. I think all of the basic measures that we can do, at least at the time the patient is in the cath lab or even after in the ICU. But sometimes, even though in most of the cases the obstruction is in the mid cavity, of the left ventricle, sometimes there is a huge bulging intraventricular septum which may obstruct the outflow of the left ventricle. So in these cases, there are proposed two mechanisms of treatment. The one, and the most easy one, is to put a pacemaker lead in order to change the electrical synchronization of the left ventricle and reduce the bulging of the intraventricular septum. And the other one, when these symptoms persist, from the literature, there are several reports with good results to make an alcohol ablation in the first septal perforation. So there are two different approaches to treat those patients who have this complication because due to the bulging of the intraventricular septum, whereas the surgical removal or resection of the bulging of the intraventricular septum is not proposed in most of the cases. So what we do when a patient has acute hypertension in the cath lab or just after the cath lab, this is our protocol we use in our hospital. So first of all, we check for vascular complication, first of all. We exclude immediate, obvious, and occult severe hemorrhages. We check the access site. So if everything is okay, we go forward. If everything is not okay, we treat accordingly as proper in any case, transfusion, vascular surgery, or balloon inflation, or whatever. If everything is okay, so we don't have any hemorrhages, we grab the echo and we check also for cardiac problems with cardiac complication. And of course, in cases in patients that we have these parameters I showed you previously, we of course check for suicidal left ventricular syndrome. And what we do when we anticipate a patient to have this kind of complication, this is very important because there are many things that we can do before the procedure and also things that we can do after the procedure. So if we have a patient with a characteristic I showed you previously, a small lady with a hypertrophic ventricle, a very small one, I think in these cases, we hydrate the patient very well. We discontinue strong vasodilators. We maintain fluid equilibrium as best as possible. We do a meticulous pre-procedural planning in order to be quick, in order to be fast and secure when we do the procedure. We check very well the CT of the patient, access of the patient has to be done in very good manner. And then most of those patients, we place as one-Ganz catheter in order to monitor the fluids and the pressures in the pulmonary artery. After the patient leaves the cath lab, because as I told you, this is a complication that not is not going to happen in the cath lab, but it's going to happen after a couple of hours or even days afterwards. Most of the time, we maintain this one-Ganz in order to measure again the pulmonary pressure. We maintain the temporary pacing lead in order to pace the patient if this is needed. And of course, with whole hypertensive medilation, vasodilation is necessary. So in conclusion, I believe that hypertension during or after TAVI is a common phenomenon. We have to be aware about this. It may be attributed in several causes. I show you the checklist. It's a long checklist. We have always to keep in mind that we have to check each of these complications separately. Quick and secure recognition of or the real cause is essential for the good prognosis of our patient. And of course, operator must be aware for the suicidal heart syndrome, which is one of the most catastrophic complications. Thank you very much.
Thank you, Dr. Nikas, for this wonderful presentation. I think it was complete, very round. Unfortunately, due to the original complications we had with our computer systems, we're kind of constricted in terms of time. So we could take questions at the end of the session, I believe. And it's with a great deal of pleasure that I will present our next speaker, Dr. Katzimaklis from the Navy Hospital, who's going to talk to us about the complication of valve malposition and embolization. George, you have the podium. Thank you. And please try to keep the time down to 10 minutes if we can. Okay. Thank you.
Right, thank you very much. Let's try to distribute and save some time from all the next presentations equally.
Okay. I would like to thank the organizing committee for the kind invitation to participate to this conference as a speaker. The topic of the speaker would be for valve malposition and embolization. This is my conflict of interest. As we all know, these are the recommendations from European Society of Cardiology for 2021. For TAVI, as we see here, TAVI is recommended in patients more or equal than 75 years old, in those who are at high risk or unsuitable for surgery. Also, for patients with special individual clinical, anatomical, and procedural characteristics. And these are the characteristics that favors TAVI or surgery. I'm going on. In the future, in the near future, with the aging population, the number of TAVI procedure is going to grow up more than tenfold over the next decade. So we have to tailor our choice of device or treatment, especially to the patient. But till we reach this level of treatment, we should find the solution for a lot of clinical scenarios and complications during the procedure. Perhaps one of the most serious, potentially devastating, is the malposition, migration, and embolization of the TAVI device. Malposition, as a definition, is the deployment of a TAVI device in an unfavorable position. Migration is the displacement of a TAVI within minutes, hours, or days after implantation. Embolization is of a TAVI implies the loss of permanent contact with the native valve structures. Now, which is the incidence? The incidence in the early randomized TAVI trials with partnered trials, the TAVI embolization occurred at a rate of 0.5 to 1%. In the latest randomized controlled trial with low-risk patients with balloon expandable devices, it was 0.2%, and with self-expandable devices, again in low surgical risk, is 1.2%. Razmakar was the first who tried to find some predictors or determinants with a published article in Journal of the American College of Cardiology in 2013. From a total of approximately 2,600 patients, they find that 63 from them underwent TAVI in TAVI, and 26 they had an embolization event. These were the identified causes from the operator for the embolization cases. As we see here, 30% from them, there was no causes, or there was no cause that was identified. The majority of them was malposition, or there was a pacing failure. The mechanism for a second TAVI implantation for aortic regurgitation, especially when was this regurgitation paravalvular, was the malpositioning. When was transvalvular, was the leaflet malfunction. For the leaflet malfunction, when there was a second valve implantation, the main cause was the tiltation of the valve, a post-dilatation, and the heavy calcified leaflets, native leaflets. The second try was done so as to see some predictors for embolization. From a trial was done by Kim in European. It was published in European Heart Journal in 2019. It was the travel registry. There were recorded cases of periprocedural valve embolization in patients with TAVI between 2010 and 2017. The percentage was approximately 1%. This was the flow chart of travel registry. The reason for embolization are heterogeneous. Malpositioning in half of the patients led to valve embolization due to manipulation, post-dilatation, sizing errors, and fast rate pacing failures. Whilst most cases were technical issues, there is an important patient factor which is an independent predictor for embolization. This is the presence of the bicuspid aortic valve. Also, the use of self-expanding valve, first-generation valves, the lack of calcification of the native aortic valve and leaflets and annulus, and the inadequate identification of the landing zone were also some predictors. When we have a TAVI valve embolization, and that occurs towards the left ventricle. This is because of insufficient anchoring of the valve, because the aortic pressure pushes the closed valve towards the left ventricle or toward the aorta when a rapid pacing during the deployment of the valve is interrupted. In 2021, a Chinese team find some anatomical predictors for valve malposition during self-expanding TAVI, and this was the STJ, the stenotubular junction height, which they find that if it was more than 24 approximately millimeters, or there was an AL ratio minus 0.96, the AL means annulus perimeter to left ventricle outflow tract. This means that if there was a conical left ventricular outflow tract and tall aortic sinuses were strong anatomical predictors of valve malposition, especially the self-expandable TAVI. Now, how we are going to treat them? With bailout measures, which include repositioning attempts using snares or perhaps biotoms or balloons. Multiple valve implantation, second or third valve, and conversion to surgery. As we see here, if we are going to go to a conversion to surgery, this is very worse. This has very worse outcomes with significantly higher 30-day all-cause mortality, but not 1 year all-cause mortality. We must pay attention when we have the the CT angiography, pre-procedural, so as to see if there is aortic tortuosity, if there are small or large annulus, if there is heavy calcification or there is no calcification, and if there is also a left ventricle outflow tract hypertrophy. When we use the bailout strategies for embolization, these are going to be chosen based on treatment urgency. If there is a hemodynamic compromise or obstruction of blood flow, and the location of the prosthesis. When the valve is embolized into the left ventricle, removal of the device is going to be very difficult, mostly performed by open heart surgery. However, conservative management by advancing a balloon over the wire and pulling the TAVI device into the aorta also has been accomplished. It's very rare and very difficult. The majority of embolization occur into the ascending aorta. It can be managed percutaneously. An embolized TAVI in the ascending aorta should be percutaneously pulled to an area where the lumen of the aorta equals the diameter of the TAVI outflow, and a stable position without obstruction of important side branching is assured. Aggressive manipulation should be avoided because of the risk of aortic dissection. While self-expanding valves usually require snares for repositioning or biotoms, embolized balloon expandable valves are mostly manipulated with balloons. As we can see here, with a balloon expandable valve, sorry. Okay. As we can see here, there is an embolized valve in ascending aorta. We use a balloon. We can bring the valve in the aortic arch, but there it would be very difficult to go more down because there is a possibility for a dissection. So using the wire of the pigtail, we can use a balloon so as not to provoke harm to the posterior wall of the descending aorta. Here we can see an embolized accurate neo in ascending aorta. Accurate neo is a self-expanding valve. This self-expanding valve, it's better to use a balloon and not a snare because the stabilizing arcs of the valve are very weak. Here, as you can see, the repositioning maneuver caused an unfolding of one of the upper stabilizing arches of the valve, and this provoked an dissection type B, which was conservatively managed. So, the majority of the embolizations are going to happen during the procedure. If it's going to be in the ascending aorta, the main causes are the malpositioning, manipulations, post-dilatation, pacing failure, and sizing errors. If it's going to be toward the left ventricle, the main causes are malpositioning, manipulation, sizing errors. For the Pvl strategies for treatment, for the aortic, for the ascending aorta, it's going to be repositioning, valve-in-valve, and conversion to surgery. And more often, the conversion to surgery is when the valve is embolized into the left ventricle. As a summary, when we have a balloon expandable valve, the main causes for the embolization is the high deployment, the underside prosthesis, and the rapid pacing failure, and the treatment would be snaring with balloon and anchoring in the descending aorta. For a self-expandable valve, the main cause is high deployment, undersized prosthesis, post-dilation error, or there was no disengagement of the prosthesis and the delivery system. Snaring is with a lasso and anchoring in the ascending aorta, it would be the solution. When we have a balloon expandable inside the ventricle, the main cause would be the rapid pacing failure, undersizing prosthesis, and failure to pull the flex cath out of the balloon. It would be perhaps the conversion to the open heart surgery, it would be perhaps the solution. And when we have a self-expandable into the ventricle, perhaps the main cause it would be the low deployment and the wrong annulus plane, and the solution would be the snaring and pull into a correct position. How we are going to prevent all of this? Meticulous pre-procedural planning with correct measurement of the aortic annulus by the CT, it would be the gold standard. The selection of the most appropriate prosthesis type and size of the individual patient, accurate deployment techniques, assurance of adequate temporary pacing, proper closed-loop communication between operators, assistant, and technician. And I'm going to show you a case. As you see here, there was a problem, you're going to see after, with a case. It was a patient with a mitral valve, a mechanical mitral valve. It was during a live case. It was during a live demonstration. So as you can realize, we are going to have a high implantation here. We try to have a high implantation, okay? But when we tried to pull out the delivery system, the valve was traveled into the ascending aorta. The patient went worse, and after this, we implanted a second valve. This was during a live demonstration. Finally, we should admit that due to the inherent nature of TAVI devices' interaction with the native valve apparatus and the lack of such suture-based anchoring, the risk of malposition, migration, and embolization will remain part of the TAVI procedure. Thank you.
Thank you, George. Excellent presentation. Just a comment, when we have multiple valves implanted for malpositioning, we should always remember that if we leave the moved valve open and it functions in sequence with the second valve we put in the aortic annulus, then there will be a compromise on the coronary perfusion. The reason being that because the malposition valve closes, it reduces the diastolic pressure. It creates like a space between the two valves, and this reduces the coronary perfusion, and that's why we should always consider to put a stent and keep the malposition valve open, not functional. It's not always the case, but theoretically it always happens, and in some patients you see the results as a clinical outcomes. Thank you.
Okay.
Dr. Woodridge, you want to continue? Are you with us? Dr. Mastrokostopoulos?
Yes, hello, good morning to everyone. Thank you very much for the kind invitation. So, because I think we're a little bit back on time, it is my great honor to present Dr. Vardas, an interventional cardiologist.
No, just go on with Dr. Iacovo. I still have a problem.
Okay.
Yeah.
So it is my great honor to present Dr. Iacovo, an interventional cardiologist from Onassis Cardiac Center, who will present his talk. Dr. Iacovo, you have.
Okay, thank you for having me. In order to share my screen, someone has to, I think Dr. Vardas has to stop sharing his. So, yep. There you go. So, thank you for the invitation. Sorry for the small delay because we had some longer than expected procedure. But anyway, it's a pleasure for me being here, and many thanks to Kostas for this invitation. It's always a pleasure to contribute to this conference, which is actually somehow the best conference regarding this entity, the transcatheter treatment of structural heart disease. So this is the next few minutes, I will present some data on this very rare complication, but we know it's a catastrophic one. The coronary obstruction is generally recognized during the seconds, minutes after the valve deployment. However, delayed coronary obstruction can happen hours, days, even months after the initial implantation of the valve. This is an older case with SAPI NXT placed in a Hancock 2 valve. You see after the dilatation, you have a upward movement of chuck of calcium, which is underneath the ostium of the left main, which resulted in cardiogenic shock, and also you see the occlusion of the left main. So this has to be treated immediately, and it happened in this case with the placement of another stent at the ostium of the left main. The incidence is usually less than 1% in a series of cases, especially in the early 2010s. Now the incidence of coronary obstruction is a lot less because the interventional cardiologists learn to manage the situation and take preemptive steps. So in most of these cases, it's less than 1%. If it's a balloon expandable valve, you have a higher incidence, actually double the incidence. And if you have a valve-in-valve procedure, this goes to more than 2.5%. And of course, it's a catastrophic phenomenon. It can result in death. The mortality is 100% if you cannot deal with that, especially in left main closure. If it's successful, still, you see in this Ribeiro article published in JAC 9 years ago, still you get to have 22% mortality rate at 30 days. Even patients that undergo bypass have a 50% mortality rate. There are several risk factors for coronary obstruction, the anatomic ones like low coronary ostia, the narrow Valsalva sinuses, the heavy bulkhead leaflet calcification that can move upwards, impeding the flow in the left main mainly. We have transcatheter heart valve related factors, which is the high implantation, the commissural malalignment, and of course the inherent anatomic and bioprosthetic valve factors like the externally mounted leaflets, that some valves have, like the mitral flow, the trifecta. Of course, there's the supraannular position of the bulgy calcified leaflets of the bioprosthetic valves. And early on, it has been recognized as the anatomic parameters as the main culprits of this catastrophic situation, mainly the height of the both coronary ostia and also the aortic sinus of Valsalva diameter. Of course, in the long axis, we can measure in the CT. If we, both in the left and the right, if we can keep the orientation, we go to short axis, we measure the aortic, the sinus of Valsalva width, and also at the basal aortic annulus. So we can anticipate the impediment or this complication. There are several purported mechanisms. Of course, is the most obvious one is direct obstruction by coronaries by the leaflet, the indirect obstruction by sinus sequestration. When we have small sinuses, the obstruction of the calcific noodle on the leaflet, the commissural post, and sometimes the obstruction of embolized material. This is one example when we have a 91-year-old woman with critical aortic stenosis, high risk for, of course, surgical procedure and also for TAVI because of the small anatomy, no obstructive coronary artery disease, small annulus, as you can see here, borderline height of coronaries. And you see some sac of calcium. Okay. And after balloon dilatation, you can appreciate in the TOE some upward movement of the calcified nodule at the left main. Due to that, stent is placed at the mid part of the LAD. And after placement of the valve, and in order to treat the paravalvular leak, there was a post-dilatation, and after that was hemodynamic compromised due to the impediment in the flow of the left main, which was fixed with a subsequent stent implantation, and you can see a good result after the placement of the stent. But it's not only the acute coronary obstruction that can happen, which is most often the case, but sometimes, especially in self-expanding valves, we see a late occlusion, days, even a year later. In the paper of this multi-center study led by Azim Latib, published some years ago. And of course, even in these cases, the mortality is more than 50%. And conversely to the acute coronary occlusion, it's self-expandable valve use is the culprit compared to the balloon expandable valves. This is another case that shows that how do we deal preemptively with this situation. This is a case that we did maybe a year ago, 80-year-old man with soaring mitral flow, placed 3 years ago with bioprosthetic valve failure. He has a coronary artery disease as well, visual impairment. He cannot move around, but he has a lot of symptoms. So we are dealing with the situation of narrow anatomy. You see the sinus of Valsalva, and height is very small. We have actually deficient sinus, and the coronary ostia, especially in the left main, it's very low at 4.5. So we try to do the best for the patient. We excluded the balloon expandable valve in this anatomy. If we go back to the anatomic and bioprosthetic valve factors, we're dealing with narrow sinus of Valsalva, small height. We have a valve with internal stent frame. And we know the main triggers, as we all remember, when we do the screening for these patients, we have to look for the coronary height. It's less than 12. The sinus width is less than 30. And it's critical also the valve to coronary distance, which when it's less than 4 millimeters, this is a red light. But if we go to the valve-in-valve application, and we remember also the characteristics of the valve, of the mitral flow, and the Evolut Pro in it. And also we measure the valve to coronary, to left main, it's 6 millimeters. So we consider that this is doable with acceptable risk. In order to minimize it, we decided to do a chimney procedure. Patient was high risk, so we decided to treat the coronary artery disease. Also at the same time, we placed 2 stents at the LAD and also a stent in a snorkel fashion in the left main at 2/3. You can, with the expansion of the valve, as you can appreciate on the left, we did place the stent with a good result. And in order to facilitate easy access and the lessening of the incident of the incidence of any deformity that might happen due to the compression of the stent frame from the frame of the valve, we did double kissing with a Nument balloon in the valve. You can appreciate here the final image with no residual leak. The mean gradient was 14 millimeters, so we decided that it was acceptable, and we decided at this point not to crack the valve. And this is the 1-year follow-up. We did cardiac CT. The mean gradient was a little bit higher, but still patient is asymptomatic, has negative stress echo, and you have a nice apposition of the stent. You can appreciate on the right here, and no evidence of deformity of compression, as you can see. So in order to do all this preemptive assessment, you need to, of course, to always take into account the anatomic characteristics of the patient, and of course to understand the device, the waist diameter, the outflow diameter, especially the frame and the commissure height, and the skirt, of course. And as
sorry to interrupt you, but you have to conclude because we're 20 minutes.
Yes, only these are the last slide, Kostas, thank you. So since we are dealing with more and more TAVI in TAVI, in the future, this will happen the first. A lot of, maybe 7 out of 10 cases will not be able to reach the coronaries. That's why we need to do, in order to avoid this complication, we need to do, of course, the conventional prevention, or in some centers, the basilica takes care of the sinus sequestration. The fissing sinus cannot do anything for the obstruction by mass of calcium or the skirt obstruction. And in some centers, you have good clinical results with a high success rate of more than 95%. So in conclusion, coronary obstruction is still one of the last serious procedural complications. Still has a lot of high mortality rate. The main culprits are the anatomic characteristics of the patient, and also the valve procedures. The balloon expandable valves are associated with a much higher coronary obstruction compared to the self-expanding valve. Prevention is the best, and you have to use meticulous pre-procedural imaging and make precise measurements. It can be basilica, or the preemptive coronary protection can be used for high-risk patients. When we are dealing with partial occlusion, the success rate of coronary dilatation is very high. We should have low threshold for coronary angiography, and we have to do intensive monitoring, maybe avoid the early discharge in these patients, as we do most often in these days. Thank you very much for your attention.
Dr. Iacovo, thank you very much for the excellent presentation. Are we going to have any comments on questions now, or at the end of the whole session?
I think we have to accept the delay, and you are free to make a comment, Adonis.
Okay, thank you very much. So, Dr. Iacovo, very nice. Fortunately for us, we don't have to do any basilica, or we have done one chimney technique in our hospital just to be sure that we will not have an occlusion. But do you think that the basilica as a technique is, we have shown that it's feasible, but I don't know, you have done it, performed it, is it easy for you? Because if someone just reads about it, I think it will be a little bit complicated, not sure for the final result. I don't have any personal experience with this technique, but I would like to hear your opinion on this.
This is very interesting. I know that there are certain operators that they swear by basilica. I think, but we haven't done any because we didn't need. Actually, the last 1,000 cases that we keep records from 2015, we haven't done any. I remember only one case that we couldn't do due to the anatomy of the patient. So most of the times we do snorkeling and the chimney technique, and a couple of times we did bilateral, but actually we haven't done it. Maybe also, another factor is there's a learning curve. So in order to have a good learning curve in the basilica, you have to do a lot of cases. Maybe you should stop doing the snorkeling, and it's a different kind of approach.
Just a comment here, Yannis. I think every time we put a stent for either protection or to reopen an occluded coronary artery, there is a downside to this, and the downside is that you cannot access the coronaries through the main lumen of this stent in the future. It's extremely difficult, and if you have to go into the coronaries again, you may have to accept that you go through the cells of this stent and you modify this stent to get access. So we shouldn't, without second thoughts, go and implant stents during TAVI because of this problem.
Yes, I think you are absolutely right. I couldn't agree more. This is more important as we get in the younger ages. Since we were dealing, up to now, with more than 80 years old people, and maybe recathing the patient, it was not that important. Maybe now is the time to reconsider the whole thing. And if we go to 75-year-old and 70 years old old patients, then maybe basilica would be one of the answers, yes.
Dr. Woodris, you want to continue with our next presenters?
Okay, do you hear me? So it's a great pleasure for me to introduce Dr. Dardas from Thessaloniki, who is going to present a very interesting point: serious vascular complications during TAVI. Petros.
Thank you once again, and sorry for all the problems we had before. I hope that you've got my full screen now. Is it all right now? You can see okay?
Yes, we can see you very well.
Okay, thank you very much. Now, as we said in our introduction before, the frequency of vascular complications, although it's falling, is not negligible. So it's still more than 2%. And there is an impact on mortality, as we all know from these vascular complications. Now, what are the predictors of major vascular complications in transfemoral TAVI? The main predictors are the CT to femoral artery ratio, the center's experience, and the femoral artery calcification. And this is the difficult scenario. Is a patient with full calcification everywhere, 82 female, short patient with a metallic mitral valve, severe right coronary disease, severe aortic stenosis, heavily calcified entorches, iliacs, porcelain aorta, high Euroscore, opted for a TAVI and a PCI to the right coronary artery. And you can appreciate the calcification on the iliacs and on the femorals. We've chosen this route because it was very difficult to go from anywhere else. And this is the scenario. We have to push harder. and we have to push more hard, and in the end, we managed to go through. However, this is the predictor of major complications. So in the end, we had a very good result, but we have to appreciate all these features that I said before. What are the most common complications? Dissection, rupture, infection, occlusion of the vessel, artery avulsion, failed percutaneous closure, and retroperitoneal hemorrhage. Now, the major issue is, the more common is vascular dissection, vessel perforation, and access-size hematoma according to large series. Start from the dissection, it happens up to 20% of cases, possibly recently not that much, but it's still a complication. And whether the dissection requires treatment depends on the extent of the hemodynamic relevance. Usually, we can end up with a prolonged inflation of a balloon, and most rarely with a self-expanding stent. But generally, the mortality of dissection is low. And you can see dissected common femoral artery here. You can appreciate on your screen. We dilated the balloon, and we had a very good result after balloon inflation. Perforation or rupture can occur if the delivery seat is inserted in a small calcified artery. It can happen up to 7%. It's got a high mortality, especially if it goes unnoticed, because it can create retroperitoneal bleeding. And the solution in this is in small perforations, sometimes they can go away with the balloon. In bigger perforations, you have to implant a stent. And sometimes it's quite useful to have these coda balloons. All the cath labs must have a coda balloon. It's conformable balloon, and you can deliver it either in the iliacs or in the aorta. And it takes the shape of the vessel and it prevents the hemorrhage, so you can act more in control. You can see a case here of rupture of the femoral, tried with the balloon, still rupture, post-ballooning, still hemorrhage, covered stent, and then we had a final, good final result. And another case with a bigger rupture, so went directly for a covered stent in this case. These were in most earlier days when we had bigger seats and with good result. What about infection? It can happen. The superficial wound infection is more frequent, but we have all to bear in mind the deep periarterial infection that can result in significant morbidity. We had one case that, fortunately, it went quite well, but this is a case from the literature that you can assess. There is not only superficial, but here there is deep wound infection, something that has to be managed very thoroughly. What about stenosis, thrombosis, or occlusion of the vessels? Mild stenosis of the common femoral artery is usually not symptomatic and not clinically important. Sometimes it requires a post-dilatation. Stenting should rarely be necessary. And we have to bear in mind that if a thrombosis occurs after hemostasis, then there is always risk of distal thromboembolization, resulting in reduced perfusion of the limb. And you can see here a case. After hemostasis, there was thrombosis of the vessel. We ballooned it. Post-balloon, still thrombus. But after prolonged balloon inflation, the problem was resolved without distal emboli. Now, one of the most scary and fortunately very rare complications is artery avulsion. It can be caused by adhesion of the sheath to the iliofemoral artery. It's very unusual, but what you feel if you have a complication like that, you feel resistance during sheath withdrawal, and suddenly you have hemorrhage, you have hypotension, and you need to be prepared for this. You have to have an occlusion balloon. We had a case like that, and we had resistance when we were trying to withdraw the sheath. We managed different maneuvers, but we had resistance. Suddenly, the patient became hypotensive. We noticed, we reacted quite quickly. The surgeon came down, we put an occlusion balloon, and this is what came out with the sheath. But the surgeon acted very quickly. He put a graft, opened the patient, put a graft, with very good result. We continued from the other side. He had a high bifurcation, and after we ended up with a TAVI, had a rupture on the common femoral, but fortunately it was managed with prolonged balloon inflation and final good result, and good TAVI result for the sake of the history. This is very scary, it comes very rarely, but we have to bear in mind this. Now, sometimes we have failed percutaneous closure. It can happen with all the device we use. It is solved either with prolonged manual compression, balloon angioplasty, more aerial stent implantation, and sometimes surgery. And you can see a case here. After we used the Manda failed to close the artery and we had quite severe bleeding. So, prolonged ballooning and post-ballooning, there was still bleeding. We put a stent, a cover stent. Post-cover stent, there was still bleeding. As you can see here, we applied a prolonged balloon inflation. We had a good result, but the Manda was missing. And we found the Manda in the end of the femoral artery, and the surgeon had to take it out because the Manda embolized. But in the end, we had a quite good result with full opening of the distality of the vessel. Now, as I said in the beginning, the most scary complication is the retroperitoneal hemorrhage, and we have all to bear in mind on this. It can be created either by injury to the aorta, to the iliac, to the proximal common femoral artery, but sometimes even a small branch, like the inferior epigastric artery, can cause retroperitoneal hemorrhage. And we have to use a CT scan or angiography worse in the cath lab. Sometimes the diagnosis is delayed. And most of the retroperitoneal hematomas, they don't require inversion if they are small, but if the patient becomes unstable or the hemoglobin does not respond, then we have to act either with a cover stent or embolization or surgery. Now, sometimes, as we all know, transfemoral access is impossible because the femorals are blocked or because there are stents that we cannot put the valve through those routes. And we have other options, subclavian and subapical, direct aortic, more recently transcarotid. All these approaches have pros and cons. We're not going to go through in thoroughly, but the transapical has got bleeding, apical scarring. You may puncture close to the LAD and create problem, and you may have long-term complications. Transaxillary, you can have thrombosis of the artery, dissection, which is more important if there is a patent lima, and transaortic, you can have tearing of the aorta and sometimes deep wound infection or mediastinitis. Now, most recently, there is a paper which describes the use of lithotripsy in femoral arteries that are not so easy to go through them, and the results are very good and very encouraging. 188 patients, and they had 100%, they succeeded in 100% of the cases, and that makes the transfemoral TAVI to go up to 97%, the non-transfemoral TAVI to go down to 3%, and the IVL-assisted TAVI, lithotripsy-assisted TAVI to increase. And this is a case that we had very calcified in the small femoral arteries with concentric calcium. We went to the left was inaccessible, the right with severe stenosis, but because we tried other options were not very feasible, so we tried the ideal balloon, the shock wave, and we managed to open the artery. We had a very good result, and then we ended up with a case. Also, ultrasound-assisted transfemoral access is very, very useful and reduces the complications. And there is a paper on that, the PAUL study. It's a bit older, but it shows that hematoma, not only hematomas are less, but any complication is reduced by ultrasound-assisted transfemoral access. So in conclusion, Mr. President and ladies and gentlemen, to prevent the vascular complications, we have to make appropriate screening with a CT scan to see the calcium, the tortuosity. We have to bear in mind adjunctive techniques, ultrasound-guided puncture. Always get prepared with a crossover balloon occlusive technique, and also we have all the measures we mentioned before in order to treat the potential complications and think of alternative routes like transaxillary, transcarotid, transapical. Thank you very much.
Thank you so much, Dr. Dardas, for your excellent presentation. I really appreciate it. I would like to ask a question. I have some time, Dr. Sparias. Just a short question. In very distal femoral dissection, do you think that cover stent is a good idea?
Well, if it's very near to the bifurcation, then you have to consider that if you put a cover stent, then you end up with blocking the one of the two branches of the femoral artery. So in these cases, you may consider either prolonged balloon inflation, or you may consider surgical calc. Operation, yes.
I think it's a law that if you put a cover stent and you obstruct the profunda, you'll get an ischemic leg. So it's a law that if your cover stent goes down there, it's surgery. The solution will be surgery.
That's why what we've found, and I'm sure you have found as well, since we started using as a default strategy the ultrasound, we have lessened these complications because we know where we go. We can see the bifurcation. We're always at least 2 centimeters above the bifurcation, so we avoid to go too close.
And another question, do you think that shift from one exercise to other ones at the same time is a good idea, or try to have the second exercise a few days later?
Well, it depends on the patient, depends on various circumstances. If you have a complication which risks the patient, then you have to settle the complication first. In the case I showed, the patient was not very well, so we have to do something with the valve because the patient was hemodynamically compromised. But usually, if one access fails, it's better to do it as a second stage, second procedure.
Thank you.
Just a short comment regarding the repair of the common femoral artery, Petros Dimitris from Ioannina. The point of the common femoral artery, it's a flexion point. So if we put a covered stent there and the patient is mobile, he can move, so he can walks a lot, we have to be prepared for stent thrombosis because those stents are kinked. And since they're kinked, it may be thrombosed very easily. So we have to consider this patient or either surgical repair as a first option or long-term antiplatelet therapy. That's a rule.
That's absolutely true, especially when you deal with younger patients. If you
Yeah,
have an elderly patient.
In young patients, we never put cover stents.
Okay, and thank you, Petros. I think we should move to our last presenter with a delay of 15 minutes so far, and I hope Dr. Latsios will help us to give us a talk of 10 minutes. A very important issue, even today, at least moderate PVL. What should we do? George?
Hello, good morning from me. I regret that I'm a little bit far away down Kyphisias Avenue. I'm still in Athens, but due to logistic and COVID reasons, I regret, and I hope it will be the last time I will be away. Also, thanks the organizer, thanks Kostas Parias, Stratis Patakos, and especially Greg Patakos, which is always at my audience, and I can congratulate him for that. I will try to convey some messages and some problems regarding PVL, and I'll start right away, and be free to stop me for discussion whenever you want, because if I start talking, I can go on for 5 minutes or for forever. So basically, indeed, PVL post-TAVI is a problem, still exists, and it leads to mortality. Moderate to severe AR post-TAVI increases 2 to 3 times mortality. So it's not just an aesthetic problem, but it's also a mortality problem. And 10 years ago, it was quite often. We would see it quite often, even mild or some or most of the time, but even moderate to severe would be to 10 to 30%. Somehow, due to newer devices, this thing has come down. So nowadays, it is not an option to leave the cath lab after a TAVI procedure with something more than moderate to severe. So most of the time we have nothing or mild, but even mild to moderate can exist. And we know some decades now which are the problems that can lead us to this problem, to this PVL. And also, like I had with great interest, and I learned a lot of things from the esteemed co-speakers that spoke before me. Very correctly, Dimitris Nikas said that PVL that can happen sometime, half a day, 12 hours, 24 hours after the procedure is an option that we should think if you have a severe hypertension in the CCU. So it's a cath lab problem and a CCU problem, and we have to know how to sniff it and how to deal it. Basically, the problem, the anticipation of the problem and the planning should start before the procedure. And CT, I will be very brief, helped us a lot to try to minimize and provided us with a lot of insight and a lot of tricks and a lot of know-how, how to deal and how to best prepare. Basically, knowing better how the annulus works, knowing that it's eccentric, knowing better how to measure the annulus, not just diameters, but also that is eccentric, how to measure perimeter, how to localize, and I'll speak later about it, where the calcium is. It is circular, it is either in the outside, it's in the tips, and it's symmetric or asymmetric. Basically, the basic thing we've learned is that we tend, for the patient's sake, to upsize our prosthesis based on what you used to do, autography or transthoracic or transesophageal echo. Nowadays, we routinely, in borderline cases, try to upsize the prosthesis, and it is proven that this translates into lesser PVL and, more importantly, lesser mortality. And this is published data by our group and several others. Second, the technology has helped us with newer valves, with skets, with stuff, with all sorts of toys that come up on the prosthesis. Much better, much more modern, much friendlier technology to reduce paravalvular leak. And that leads to better numbers, leads to lesser degree of severe or moderate to severe paravalvular leak because the companies, because the technologies, because the people to try to make and evolve these devices help us. What can we do? Let's go to the complication if the thing happens during the procedure before our eyes. First of all, we have to think that not all beasts are the same. The same amount or the same of regurgitant, let's say, contrast, or the same picture can have very, very different effects regarding the patient that this regurgitant volume goes to. So on the one hand, we are very lucky we have a patient with a dilated left ventricle, some CHF and 2+ AR pre-existing. This patient can tolerate very good PVL. On the other hand, this elderly woman, 85 years old, with a severely concentric left ventricle with no end-systolic volume, can very badly tolerate even small amounts of mild PVL. So not all of these are the same. That regards to impact of PVL. Also, the severity of PVL is very difficult to measure. It's very difficult to decide which mild to moderate to leave and which mild to moderate aggressively to deal with. And basically, we tend to rely our decisions on hemodynamic data and not on echo. That's why we tend to do all our patients, all these elderly patients under conscious sedation, and we seldomly use general anesthesia and transesophageal echo in pure TAVI procedures. And we don't like when we see a low diastolic pressure, which leads to an increased LV and diastolic pressure. We don't like when we don't see a notch. And Gruber described some time ago an index, which is the AR index, which comes from the diastolic in the aorta and in the ventricle and the systolic. And the cutoff point is the 25. Here you see an excellent result. These two diastolic pressures are far away each other. But here you see an unacceptable result, which they prove that leads not only to bad acute, but also to bad long-term outcomes. So a 25 cutoff point is of significance, and the significance of that index is that it takes into consideration also the systolic blood pressure, because a 45 diastolic with a blood pressure of 90 is something entirely different with a systolic blood pressure of 160, let's say. It reflects to a different degree of regurgitation. We are happy, we are extremely thrilled that we have forgotten the need for emergency surgery. They said 10 years ago, 12 years ago, that 1% of the people that had TAVI needed to go to emergency surgery with detrimental mortality results. This is not only not a good option, this is not an option, it's only if we don't know how to do. Hopefully, that's why most of the cases, this comes from valve dislocation, as Yoros Katsimaglis said before, and also from severe regurgitation, which we cannot deal with in the cath lab. So what can we do? First, we have to know beforehand, and we are very lucky that TAVI patients are the best studied patients in interventional cardiology. We have to know where the calcium is. It's symmetric, it's asymmetric, it's in the non-coronary, it's in the tips, it's around the valve, where it is. And deciding, taking into account this measurement, these images, we decide on our option. So you have a very different approach if the calcium is rather outside the valve, so we go with aggressive predilatation. On the other hand, if it's mainly on the tips, we put the valve in and we decide to aggressively post-dilate. Predilatation is not an innocent thing. It can lead to various stuff from severe AR and collapsus to stroke. And there are some advantages on the trial, the multi-center trial we've performed with many Greek centers that took part in it. We've seen that the PVL had nothing to do with predilatation, and this was a very strict trial. So basically, a message from this trial is that we can do equally well without predilatation, without any turn, not only without any consequence, not only on survival, but also on PVL after the trial. Some basic tips, which are, I'll tell you why, mainly of historic importance. We should have them in our mental armamentum. What to do if you have more than moderate AR. We have to decide why we have more than moderate AR. Because the prosthesis is too deep, because the prosthesis is too shallow, because it didn't expand that well because of the calcium, or because it was initially too small. And we have different ways to deal with. Here you see an unexpanded prosthesis. We post-dilated and we ended up in much better result in a high position. Post-dilatation is rather common. Here you see from a USA TAVI registry, about 22% of patients undergo post-dilatation after a coronal prosthesis, and the AR goes from 60% to 14%, with other no alarming issues, no statistically alarming issues in terms of in-hospital MACE. So it is being done and it is safe. However, we can have some exotic complications. Here you see a post-dilatation to lead to a subvalvular VSD that we had a few days later. We had to close it with a VSD occluder. Here you see a valve that went too deep, that could not be repositioned, that was the pre-repositioning era, and we had to to pull it. We had to snare it up. Some tips and tricks about it. A, don't try to snare it from the leg because you really don't snare the valve. You just take the aortic arch down, which is rather terrifying when you see it on the screen. B, pull it from the right radial or right brachial. And C, don't pull it too hard because you can have a supraannulally dislocated valve. So when you stop pulling, when the diastolic pressure that you keep monitoring on your screen increases, gets to normal. When you have to put a second valve, and it is also a good option to have a second valve in the lab, you have to put a second valve if the first one went too high, if the second valve went too low inside the left ventricle. And here are some examples. Here you see a very deeply positioned valve which could not be snared. Here you see the arch coming down, and we have to put a second one in to have this final result with a double layer of stent across the coronaries. Hopefully this patient had been operated upon due to CABG. Here you see a valve that we tried to snare it up, and this valve was dislocated in the ascending aorta, and we had to put the second valve in an in-series manner after the one after the other. Also a tip here is try to keep hold of the first valve by means of a snare, otherwise you can finally end up putting all two valves inside the left ventricle. And here you see the final angiographic results, which is rather satisfactory. Let us add the second valve. And here you see our only case, and worldwide I think it's the only case, when me and a few of our friends then had to manage this patient, this elderly patient, with two valves. One went too deep, one went too shallow. Finally, we managed to make it happen. And here are published data that patients do quite well, midterm results, 3 years follow-up, having a second valve either in the ascending or in the descending aorta. And we've had to deal with patients that we had to put a second valve in, either when I was in Germany or even here in my home hospital. All this is, we should keep it in mind, but it is of historic consideration, because nowadays the technology let us to reposition the not fully open valve in a better position. So most of the time, unfortunately not all of the time, we are able to test the position of the valve, and if we're not satisfied by it, reposition it in another position. But there are times that we have to post-dilate, pre-dilate, or even put a second valve in, and all of us that I am happy to say I'm among very, very experienced operators in Greece should know about it and should convey all this knowledge to the newer generation. Thank you. Ending, I'll say that Pvl unfortunately still exists, and if it exists after the TAVI, has a great impact 2 to 3 times in mortality. Even with newer valves, mild Pvl is common, and we should, because of various reasons, because the surgeons wait in the corner, because the patients, even the low-risk patients, should go for 15 or 20 years doing well with the TAVI we put them in. We should try to make perfect the result each and every time. This is the further ending, the initial book about TAVI. I'm closing with my home city, and Χρόνια πολλά to Achilles and to Larissa for tomorrow. Thank you very much.
Thank you. All right. So I think we conclude. I would like to thank all the discussants and distinguished speakers. I think it was a very fruitful session, although we had some initial complications as a complications session. And I would like to thank everybody and give the speaker to the...
Thank you all. I think we just carry on with the next mini session, which is the opening greetings.
Καλησπέρα σας. Κύριε Πρόεδρε και Διευθύνοντα Σύμβουλε του Θεραπευτηρίου Υγεία, κύριε Καρταπάνη, κύριοι συνάδελφοι, με πολύ χαρά και τιμή για μια ακόμη φορά το τμήμα των διακαθεδριακών βαλβίδων οργανώνει ακόμα ένα πανελλήνιο, ένα παγκόσμιο συνέδριο με αντικείμενο τις διακαθεδριακές βαλβίδες. Όταν πριν από χρόνια, όταν πριν από 10-12 χρόνια αποφασίσαμε να ιδρύσουμε το τμήμα αυτό, οι τεχνικές αυτές ήταν ακόμα στα σπάργανά τους, ήταν ακόμα μέσα από την κρυσάρα του χρόνου, μέσα από την κρίση των παγκοσμίων συνεδρίων και εργασιών και υπήρχαν πολλά τα διλήμματα και πολλές ερωτήσεις. Όσο περνούν τα χρόνια, όσο περνάει η εμπειρία μας, τόσο βλέπουμε ότι οι τεχνικές αυτές όχι μόνο προχωρούν μπροστά, αλλά είναι τεχνικές οι οποίες ενώνουν και την καρδιολογία και την καρδιοχειρουργική. Είναι τεχνικές οι οποίες μας κάνουν ενωμένοι να προχωράμε μπροστά, να αντιμετωπίζουμε τον ασθενή ανάλογα με τις ανάγκες του και όχι ανάλογα με το τι θέλει η κάθε ειδικότητα, να ενώνουμε δυνάμεις, να συμπτύγουμε αδυναμίες και να μπορούμε να βρίσκουμε λύσεις για τα καθημερινά αυτά προβλήματα. Το συνέδριο μας αυτό θέλουμε να έχει ένα ενωτικό κλίμα. Μέσα στο τελευταίο δίμηνο του διχασμού, των διαφωνιών και μιας κατάστασης η οποία πραγματικά κρατάει τον κόσμο σε μια αμηχανία, σε ένα δίλημμα, σε μια αγωνία θα έλεγα, σε μέρες παγκόσμιας κρίσης, σειράξεων και επιπλοκών, εμείς από τα μικρά ταπεινά μας μετερίζια, το μόνο που μπορούμε να κάνουμε είναι, βάζοντας μπροστά την επιστήμη, να έχουμε μια ενωτική προσπάθεια. Εμείς με το συνέδριο αυτό δεν πάμε να κηρύξουμε τα δικά μας καλά και τα δικά μας κατορθώματα. Πάμε να ενώσουμε τις δυνάμεις που υπάρχουν στη χώρα μας, είτε λέγονται Ιπποκράτιο, είτε λέγονται Ωνάσιο, είτε λέγονται Αττικό Θεραπευτήριο, είτε Ναυτικό, είτε 401, είτε Κρήτη, είτε Γιάννενα, είτε Θεσσαλονίκη. Για να μην παραλείψω πολλούς συναδέλφους, στην Ελλάδα γίνεται μια πολύ αξιόλογη προσπάθεια, πάρα πολύ καταξιωμένοι συνάδελφοι προχωρούν μπροστά. Επίσης, είναι χαρά μας που το συνέδριο αυτό το αγκαλιάζουν επιστήμονες αναγνωρισμένοι από όλο τον κόσμο. Είναι πρωτοφανής η συμμετοχή Αμερικανών διακεκριμένων καρδιολόγων και καρδιοχειρουργών. Δεν μπορούσε κανείς να φανταστεί με πόση ευκολία και με πόση προθυμία διακεκριμένοι συνάδελφοι από το Harvard, από την Cleveland Clinic, από το Houston, από την Καλιφόρνια, έρχονται να αγκαλιάσουν την προσπάθειά μας και ευχόμαστε στο μέλλον να είμαστε εκείνοι που θα τους έχουμε εδώ, γιατί η χώρα μας, εκτός από την επιστημονική οικογένεια, θα τους έδινε και την ελληνική φιλοξενία. Προς το παρόν, αυτή η διαδικτυακή προσπάθεια αφαιρεί την προσθήκη της επικοινωνίας. Είμαι σίγουρος όμως ότι είναι θέμα χρόνου, σε λίγο να είμαστε όλοι μαζί και να μπορούμε να βλέπουμε αυτούς τους διακεκριμένους ανθρώπους που είδαμε πριν από 3 χρόνια, των οποίων η παρουσία τιμούσε την κλινική μας, τιμούσε το θεραπευτήριό μας, τιμούσε τη χώρα μας. Μαζί λοιπόν με τον συμπρόεδρο, τον κύριο Σπάρια, να ευχηθούμε καλή επιτυχία του συνεδρίου, να ευχαριστήσουμε το Θεραπευτήριο Υγεία για τη συνεχή υποστήριξη την οποία έχουμε, να ευχηθούμε στο μέλλον οι διαδικασίες, οι γραφειοκρατικές που έχουμε με την έγκριση των ασθενών αυτών να απλοποιηθούν, ώστε οι ασθενείς οι οποίοι μπορούν να βοηθηθούν από τις προσπάθειες αυτές να αυξάνονται μέρα με τη μέρα. Ευχαριστούμε λοιπόν κύριε Καρταπάνη για την όλη υποστήριξη και να σας προσκαλέσουμε να κηρύξετε κι εσείς την έναρξη του συνεδρίου μας αυτού. Σας ευχαριστώ.
Καλημέρα σας. Μετά από 3 χρόνια, αν θυμάμαι καλά, 2,5, ξέρω εγώ πόσο ήταν, ξαναγίνεται αυτή η προσπάθεια, αυτό το συνέδριο, έστω και με τον τρόπο που περισσότερο διαδικτυακά και λιγότερο δια της φυσικής παρουσίας. Αυτά ίσως είναι και τα κελεύσματα των καιρών. και πρέπει να προσαρμοστούμε, αλλά όπως και να έχει, νομίζω ότι είναι μια πάρα πολύ σημαντική πρωτοβουλία, η οποία ελπίζω να καθιερωθεί να γίνεται πάλι σε αιτήσια βάση όπως ήταν και στο παρελθόν, γιατί έχει να προσφέρει πολλά, έχει να δώσει πολλά, έχει να βάλει στο χάρτη τις νέες εξελίξεις σε αυτό το τομέα, ένας τομέας ο οποίος ουσιαστικά οδηγεί την καρδιολογία. Η καρδιολογία και η καρδιοχειρουργική πηγαίνουν προς τα εκεί. Θεωρώ πλέον ότι πολύ σύντομα θα μιλάμε για τον τομέα καρδιάς, για το heart center, αν θέλετε, αν μπορώ να το πω έτσι, το οποίο θα περιλαμβάνει κλινική, επεμβατική και χειρουργική προσέγγιση σε αυτό το κομμάτι, και νομίζω ότι η συνεργασία όλων όσων εμπλέκονται στην αντιμετώπιση του ασθενούς με οποιονδήποτε τρόπο, είτε διαγνωστικό, είτε κλινικό, είτε επεμβατικό, χειρουργικό ή οτιδήποτε άλλο, είναι αυτό το οποίο θα μας δώσει τη δυνατότητα, θα δώσει τη δυνατότητα μάλλον στους ασθενείς να έχουν προφανώς καλύτερη αντιμετώπιση, αλλά και καλύτερα αποτελέσματα στην προσπάθεια της αντιμετώπισης του προβλήματός τους. Οι βαλβίδες καρδιάς εξελίσσονται συνεχώς, κάθε χρόνο βγαίνει κάτι καινούριο, το παρακολουθώ μέσω του κυρίου Σπάρια, μου τα φέρνει, μου τα δείχνει, προσπαθούμε να τα περάσουμε και εμείς στην Ελλάδα, όχι πολύ εύκολα πάντα, υπάρχουν δυσκολίες, υπάρχουν αντιδράσεις, αλλά νομίζω ότι το ποτάμι ποτέ δεν γυρνάει πίσω. Το ποτάμι έχει μία ροή, μία κατεύθυνση και ό,τι βρίσκει μπροστά του το παίρνει. Και θεωρώ ότι και σε αυτή την περίπτωση αυτό θα ισχύσει. Όποια εμπόδια ή όποιες, αν θέλετε, δυσκολίες μπορούν να προκύψουν κατά τη διάρκεια της ροής του νερού προς τον αντικειμενικό σκοπό του. Πάντως, θέλω να πω και να το επισημάνω, και αυτό το βλέπουμε το τελευταίο διάστημα, η πολιτεία πλέον έχει δει ότι και έχει αγκαλιάσει αυτή την προσπάθεια και σε εμάς εδώ, καθότι να ξέρει ότι τουλάχιστον εδώ στον όμιλο το δικό μας, στο Υγεία και ιδιαίτερα στο Υγεία, είναι το μεγαλύτερο πρόγραμμα που υπάρχει αυτή τη στιγμή στην Ελλάδα. Και δεν σας κρύβω ότι με τα νούμερα τα οποία παρακολουθούμε σε συστηματική βάση, ο τομέας καρδιάς του Υγεία μπορεί να συγκριθεί μόνο σε πανελλήνιο επίπεδο μόνο με τον Άσιο, που εκείνο είναι ένα αποκλειστικό καρδιολογικό νοσοκομείο, ενώ εμείς είμαστε βέβαια γενικό νοσοκομείο. Με αυτά θα ήθελα να ευχηθώ καλή επιτυχία, είμαι σίγουρος γι' αυτό. Και τώρα να κηρύξω την έναρξη, θα θεωρηθώ ότι είμαι σαν πολιτικός που δεν μ' αρέσει. Να είστε καλά.
Θα μου πείτε. Κύριε Διευθύνοντα Σύμβουλε, κύριε Συντονιστά του τομέα καρδιάς, νομίζω ότι μας παρακολουθεί διαδικτυακά, φίλε Κώστα Σπάρια, Στρατή Πατακέ, αγαπητοί συνάδελφοι, καλημέρα σας. Η εξελίξη στην τεχνολογία είναι αναμφισβήτητα αρρωγός στην ιατρική επιστήμη. Πιστεύω ότι η ειδικότητά μας και ειδικά η επεμβατική καρδιολογία είναι από τις πιο ωφελημένες. Αυτό όμως δεν αρκεί. Για να προάγεις την ιατρική επιστήμη, οφείλεις να ανταλλάσσεις απόψεις, να μοιράζεσαι εμπειρίες, ανησυχίες και να αναζητάς καλύτερες λύσεις για τα προβλήματα των ασθενών. Όμως και να μεταφέρεις εμπειρία και γνώσεις στους νεότερους συναδέλφους. Σε αυτή την αλληλεπίδραση προόδου, τεχνολογίας, γνώσεων και ανησυχιών, στοχεύει το Διεθνές Συνέδριο Διακαθετηριακών Βαλβίδων, που οργανώνει πάνω από 10 χρόνια τώρα το μόνιμο τμήμα του νοσοκομείου μας. Η επιτυχία του είναι εξασφαλισμένη. αρκεί να ανατρέξει κανείς στους συμμετέχοντες διεθνούς κύρους. Τελειώνοντας, θα ήθελα να τονίσω ότι είναι τιμή μου να χαιρετήσω την έναρξη του συνεδρίου αυτό, εκπροσωπώντας το Επιστημονικό Συμβούλιο του Νοσοκομείου Υγεία και να ευχαριστήσω τη διοίκηση του νοσοκομείου και τον Διευθύνοντα Σύμβουλο που είναι συμπαραστάτης πάντα στις ιατρικές μας και επιστημονικές μας ανησυχίες. Ευχαριστώ και εύχομαι καλή επιτυχία.
Να προχωρήσουμε με τον Διευθυντή Επεμβατικό Καρδιολόγο του Θεραπευτηρίου Αλεξάνδρα και Πρόεδρο της Ελληνικής Καρδιολογικής Εταιρείας, κύριο Κανακάκη. Έχουμε συνδεθεί με τον κύριο Κανακάκη. Έχει βιντεοσκόπ. Ωραία. Κύριε Κανακάκη, έχετε το λόγο.
Καλημέρα και από μένα. Είναι μεγάλη μου χαρά να βρίσκομαι σήμερα σε αυτό το συνέδριο. Εκ μέρους του Διοικητικού Συμβουλίου της Ελληνικής Καρδιολογικής Εταιρείας χαιρετίζουμε τις εργασίες του συνεδρίου Transcatheter Heart Valve Greece 2022 και ευχόμαστε κάθε επιτυχία στις εργασίες του. Αγαπητοί συνάδελφοι, σήμερα οι διακαθετριακές επεμβάσεις βαλβίδων μετά από 20 χρόνια επιτυχούς εφαρμογής περιλαμβάνουν ένα σημαντικό ποσοστό των ασθενών με βαλβιδική νόσο. Στις ΗΠΑ και σε κέντρα της Δύσης, ήδη από το 2019 ξεπέρασαν τις χειρουργικές αντικαταστάσεις με ενδονοσοκομιακή θνητότητα 1,5% σε κέντρα υψηλού όγκου και 2,5% τον πρώτο μήνα. Στο ερώτημα τι γίνεται στη χώρα μας, μπορούμε να πούμε ότι η πορεία των επεμβάσεων TAV στην Ελλάδα αλλά και των άλλων επεμβάσεων ακολουθούν ικανοποιητικό ρυθμό ανάπτυξης και σε αυτό το σημείο θα πρέπει να τονίσουμε τον πρωτοποριακό ρόλο που διαδραματίζει το τμήμα διακαθετριακών επεμβάσεων του Νοσοκομείου Υγεία με τη διεύθυνση του κυρίου Σπάρια και των υπολείπων συνεργατών και βέβαια της καρδιοχειρουργικής υποστήριξης με τον κύριο Πατακό. Αν και η Ελλάδα υπολείπεται ακόμα του ευρωπαϊκού μέσου όρου, έχουμε τη δυνατότητα περαιτέρω βελτίωσης με τη συμμετοχή περισσότερων κέντρων και εκπαιδευμένων επεμβατικών καρδιολόγων. Να τονίσω ότι είμαστε από τις χώρες με το μεγαλύτερο αριθμό επεμβατικών καρδιολόγων και είμαστε σχεδόν η χώρα με το μεγαλύτερο αριθμό καρδιολόγων στον δυτικό κόσμο, ανά εκατομμύριο πληθυσμού. Η Ελληνική Καρδιολογική Εταιρεία, ακολουθώντας τις εξελίξεις σε αυτό το τομέα, ίδρυσε ομάδα εργασίας βαλβιδοπαθειών για ολιστική ανασχόληση με τις βαλβίδες και συνεργασία με τον τομέα, με την ομάδα εργασίας επεμβατικής καρδιολογίας και την καρδιοχειρουργική ομάδα. Το συνέδριο το σημερινό καλύπτει όλο τον παραπάνω προβληματισμό και θα ασχοληθεί με όλα τις εξελίξεις στον τομέα των βαλβιδοπαθειών μέσα από εισηγήσεις πρωτοποριακών επεμβατικών καρδιολόγων και από τον ελληνικό και τον διεθνή χώρο. Ιδιαίτερα θέλω να τονίσω τη μεγάλη παρουσία πρωτοπόρων καρδιολόγων, επεμβατικών καρδιολόγων στον τομέα των βαλβιδοπαθειών από το διεθνή χώρο και καρδιοχειρουργών που κατατάσσουν το συνέδριο σε ένα συνέδριο με διεθνή απήχηση που δεν έχει να ζηλέψει τίποτα από τα συνέδρια που γίνονται στις ΗΠΑ και στην Ευρώπη. Εύχομαι καλή επιτυχία στο συνέδριο που τη θεωρώ δεδομένη και τα συμπεράσματα θα συζητήσουμε αμέσως μετά. Ευχαριστώ πολύ.
Ευχαριστούμε τον κύριο Κανακάκη και πιστεύω ότι αυτά που είπε και από αυτά που προβλέπει, γιατί ας μην ξεχνάμε, μια και είναι και η έναρξη του συνεδρίου, ότι και εσείς από το δικό σας μετερίζει, κύριε Κανακάκη, μπορεί να γίνει και ένα fellowship διαδερμικών βαλβίδων, γιατί αυτός ο τομέας που μόλις τώρα έγινε εδώ και 10-15 χρόνια, δεν θα μπορεί μετά να μπαίνουν αυτοδίδακτοι, θα πρέπει να γίνει ένα fellowship το οποίο θα διδάσκει τις διακαθητριακές βαλβίδες σε καρδιοχειρουργούς και καρδιολόγους. Αλλά αυτά θα τα κουβεντιάσουμε από κοντά. Το επόμενο βίντεο, διότι ο καθηγητής και τομεάρχης του τομέα καρδιάς το έχει βίντεο σκοπημένο, θα δείτε το βίντεο του καθηγητού κυρίου Βάρδα με τα μηνύματα για την έναρξη του συνεδρίου μας. Ο καθηγητής κύριος Βάρδας.
Κύριοι συνάδελφοι, είμαι ιδιαίτερα ικανοποιημένος να απευθύνομαι σε εσάς σήμερα τους συνέδρους ενός γνήσιου, πρότυπου και πρωτότυπου επιστημονικού γεγονότος, του συνεδρίου Transcatheter Heart Valves 2022. Το συνέδριο αυτό, όπως γνωρίζετε, οργανώνεται από το Τμήμα Δομικών Καρδιοπαθειών του Ομίλου Υγεία, του Νοσοκομείου Υγεία, στο οποίο ηγείται ο εξαιρετικός κύριος Κώστας Πάργιας, ο εξαιρετικός κύριος Στρατής Πατακός, μαζί με συναδέλφους εξαιρετικής ποιότητας και γνώσης, όπως ο Μιχάλης ο Χρυσοχέρης και ο Γρηγόρης ο Πατακός. Κύριοι συνάδελφοι, εμείς στον Όμιλο Υγεία και προσωπικά εγώ, σαν συντονιστής του τομέα καρδιά του Ομίλου, είμαστε εξαιρετικά χαρούμενοι και ικανοποιημένοι που ζούμε, συνεργαζόμαστε, πράττουμε και σκεπτόμαστε για το καλό των ασθενών με τόσο αξίους συναδέλφους. Είναι άξιοι και είναι πρωτοπόροι και το τμήμα διακαθεδριακών βαλβίδων είναι γνωστό παγκίνος για την πρωτοπορία του, για την καινοτομία του, για τις διεθνές συνεργασίες του και την state of the art δουλειά του. Λίγα λόγια τώρα για αυτό το συνέδριο. Συναποτελείται από μία faculty περίπου 100 ατόμων, εξαιρετικά γνωστών και εξαιρετικά έμπειρων. 36 από τους συναδέρφους αυτούς προέρχονται από διεθνή επιστημονικά Ινστιτούτα. Είναι γνωστό ότι στην Ελλάδα οργανώνονται πολλά συνέδρια. Το συνέδριο ωστόσο αυτό των διακαθεδριακών βαλβίδων 15 χρόνια τώρα πρωτοπορεί, διδάσκει, καινοτομεί και είναι ό,τι που αξίζει, ό,τι πρέπει για να το παρακολουθήσει κανείς και να μάθει γνήσια και νέα πράγματα. Κύριοι συνάδελφοι, και πάλι θέλω να σας χαιρετήσω για την συμμετοχή σας σε αυτό το γεγονός. Θέλω να σας ενθαρρύνω να παρακολουθήσετε τις εργασίες του, διαδικτυακά ή με φυσική παρουσία, και να συγχαρώ ξανά όλους αυτούς τους πρωτεργάτες σε όλη τη χώρα που εργάζονται στο πεδίο των διακαθεδριακών βαλβίδων και επιμέρους ασφαλώς την ομάδα του κυρίου Σπάρια και του κυρίου Στρατή Πατακού για όλα αυτά τα οποία κάνουν για τους ασθενείς πρώτα, για την επιστήμη και αναμφίβολα για τον Όμιλο Υγεία. Σας ευχαριστώ πάρα πολύ.
Good afternoon. The next session is about small and large annulus consideration in TAVI and SAVR. And the first speaking is Professor Kofidis from Singapore. And his talk is about mismatch, patient prosthesis mismatch in SAVR and TAVI. Professor Kofidis, you can speak to us.
Good afternoon, everybody, from Equatorial Singapore. Allow me to address you in the official language of the event, the English language today, and allow me to share screen. I hope you can see my slides going on presentation mode.
Αυτό δεν είναι βίντεο.
This is live.
Okay.
Yes, this is indeed live, as discussed with the organizing committee. So I would like to thank the chairman as well as the organizing committee for having me as part of this very important event, and my personal regards to Dr. Spargas for assigning me the task of talking about PPM in SAVR versus TAVI today. Now you will realize that PPM is certainly not my field of immediate clinical interest or research, but I would like to oblige because he gave me a great opportunity to survey what is out there. And because this issue has been bothering us for decades now, because in my personal opinion, there has been little disruptive change to impact the matter of PPM, except from transcatheter devices, as we will see in the next couple of slides. These are my disclosures. And this is Singapore, ladies and gentlemen, is slightly bigger than the island of Corfu, Kerkyra, or maybe half the size of the island of Rhodos in Greece, with a population of 6 million. This is Singapore 100 years ago, and this is Singapore today. So what is the point? My point is that a problem in clinical practice cannot be resolved often within the same level, within the same system where it was created. We have been using, we surgeons, I'm a surgeon myself, circular stented devices for the last 50 years with incremental changes in their design, eventually being confronted with patient prosthesis mismatch. The progress I've shown you in Singapore was only possible because of force majeure, because of impact from outside, a charismatic leader, and incisive changes that brought about the disruption, basically, and the progress. And eventually, this is what needs to happen to avoid PPM in future, beside transcatheter devices from the surgical point of view. This was a bit of an effort to contextualize my presentation today. So in the next 15 minutes or so, we'll be going through valve hemodynamics and definition of PPM. We're going to be talking about methods of measurement. We must distinguish between different methods of measurement. We will survey upon the impact of PPM on SAVR as well as TAVR patients in comparison. We're going to spend 1 or 2 minutes having a look at the clinical trials that are out there, and allow me to offer you a bit of a perspective of what's next, at least in the surgical domain. First of all, the measurement of transvascular pressure gradients and EOA is very, very important to assess valve hemodynamic function and identify PPM. However, there is discordance and differences between various methods of measuring PPM and EOA. To the definition of PPM, prosthesis with normal function but too small for patient's size. We may have normal EOA, but abnormal, small indexed EOA over the BSA of the patient. So according to the VARC criteria, valve, indexed EOA, mild PPM is considered when the indexed EOA is about 0.85, moderate between 0.85 and 0.65, and lower than that is considered severe PPM. The metrics are slightly different for obese patients, as you will appreciate at the bottom of this table. Take, for example, the Sapien 23 millimeter prosthesis and a patient of a BSA, let's say 1.95. The predicted effective orifice area indexed as per recommendations, as per data by the manufacturer, will be 1.45, which yields an indexed effective orifice area of 0.72. However, the same prosthesis, echocardiographically assessed, may yield a severe PPM, as you will appreciate on the lower left portion of the slide. Abbas has further distinguished between echocardiographic and catheter-based measurements of PPM in effective orifice area. And he concludes that for all valve platforms, regardless of type and size, they do demonstrate discordance between their echocardiographic and invasive mean gradients, exhibit the same invasive mean gradient, and generate higher discharge echocardiographic mean gradients compared to post-TAVR. This phenomenon is even more pronounced when we look at small diameter transcatheter prosthesis, as you will appreciate on this diagram here, for both balloon expandable BEVs as well as self-expandable prosthesis. What could be the causes of overestimation of PPM by EOA measured by echocardiography? It could be underestimation of LVOT diameter. It could be overestimation of gradient and underestimation of EOA because of pressure recovery distally. It could be overestimated in obesity because of over-indexation of EOA, or in cases of low flow state. Here is another example of predicted versus echocardiographically measured effective orifice area and hence occurrence of PPM. First by the manufacturer, as you can see, take for example Sapien 3 and Magna Ease for a patient of a BSA of 1.98, and you will see that they are within normal domains. If you look at the method 2, for example, with direct CT scan measurement, this measurement method will yield still a normal orifice area. However, echocardiographic method will yield for the same patient an EOA index of 0.57 and hence severe PPM. As per pressure gradients post-implantation, even the effect of anticoagulation must be taken into consideration, as you will appreciate parenthetically on this slide, in the long run. Let's spend a few minutes looking at the trials out there. For example, the Partner 2A trial. The incidence of severe PPM is markedly lower with predicted versus measured EOA. Incidence of severe PPM is definitely lower in TAVR compared to SAVR. This is a fact. Now, what about the impact of prosthesis-patient mismatch on outcomes? In surgical aortic valve replacement, severe PPM by the predicted EOA method, as provided by the manufacturer, for example, is rare but independently associated with worse outcome, which is not the case in TAVR, where severe PPM by the predicted EOA method is absent. If we look at the STS-ACC TVT registry, all-inclusive, including all TAVR devices, latter identifies 63.3% patients within normal region, 24.6% with moderate PPM, and 12.1% with severe PPM, however, without any impact on 12 months mortality. Miyasaka has reported the Ocean TAVI registry with 1,558 patients using observed EOA indexed and identifies 8.9% of the patients as with moderate PPM and only 0.7% of the patients with severe PPM. Let it be mentioned here that only 9% of those patients receive the Medtronic core valve as a type of balloon, a self-expandable valve, but no significant association between PPM and 1-year mortality. How about comparing BEVs and SEVs, balloon expandables and self-expandables? Okuno, for example, observes more severe PPM with balloon expandables valves. but no impact again on 1-year mortality in the matched analysis. Dr. Zondergaard reports on the NOTION trial, 8-year follow-up, referring to structural valve deterioration, which, if I'm not mistaken, is part of the faculty of this event, and finds that SAVR, surgical aortic valve replacement, results in much more frequent structural hemodynamic valve deterioration in the long run compared to TAVR interventions. One more slide on what is out there in terms of literature and data. Meta-analysis by Head, for example, with a mix of predicted and measured EOA indexed assessment yields an incidence of severe PPM around 10%. The SAVR registry shows 11%. The partner one, again, clear differentiation between TAVR and SAVR in favor of TAVR. Core valve, even more so. We're talking about hazard ratios here. Partner 2A, 6 versus 24%. However, the partner 3, low risk partner, shows a somewhat similar result, not such a significant difference, for reasons that we will allude to later in the conclusive side, eventually because the new generation TAVR prostheses have design differences compared to the overhauled ones. How about the impact of PPM on structural degeneration of bioprosthetic valves? Of course, bioprosthetic surgical valves are subject to wear and tear, as are TAVR, but the 664 patients with surgical prostheses, Fleming reports at a follow-up time of 6.1 years that PPM is indeed independently associated with a 2.3-fold increase in the risk of structural valve disease. How about root enlargement as a method of escape for the surgeon to facilitate the implantation of a larger procedure and avoid PPM? Well, possible, but you see that it's indeed an independent predictor of higher mortality, surgical mortality, with adjusted hazard ratios given. So how does PPM look in the TAVI era? Is it becoming obsolete? I wouldn't say so, but definitely less. And no matter how you look at it, severe PPM by measured indexed EOA or severe PPM by predicted EOA, there is obviously a better performance of TAVR prosthesis right now. And severe PPM being rare with minimal impact on post-operative long-term outcomes. This is something to discuss, and I invite experts in the field basically to share their opinion from the TAVR perspective, why women don't fare as well as men in severe PPM in the first 12 months post-implantation. The late mean gradients after TAVR, of course, are superior, better, lower than the gradients of the surgical prosthesis on average, as we will see as published by Gleason here on the left side of the slide. And they yield a better orifice area compared to the surgical valves. And again, as mentioned before, balloon expandable are worse than the core valve, self-expandable prosthesis in terms of mean transprosthetic gradient. Ex libris, ex litere, in summary, PPM increases the risk of mortality and structural valve deterioration, particularly in younger patients and those with BMI below 30. PPM seems to cause higher post-procedural mortality in surgical patients. PPM incidence is higher with later generation TAVR devices because of the development of a skirt or covers. And the method used for the evaluation of EOA is very, very critical, predicted versus measured. And then again, what kind of measurement, echocardiographic versus catheter-based. It seems that balloon expandable devices cause more PPM compared to self-expandable devices, TAVR devices. TAVR definitely causes less incidence of moderate and severe PPM compared to surgical devices. TAVR patients constitute a very heterogeneous group, having said that, with a wide range of pathologies, heart function, covariates, which may affect the measured EOA as well as the PPM occurrence. There are, of course, I must mention some gray zones. For example, the introduction of sutureless valves, which are not favored by every cardiologists, in my understanding and experience, or even less invasive procedure, shorter CPP runs, less inflammation, which overall can impact the early phase of structural valve deterioration. Root enlargement techniques, yes, but in experienced hands and as they are associated with higher risk. Now, I don't want to leave my surgical colleagues here without an optimistic perspective. So what does the future hold? We must be aware that this disruption must enter the field in order to change the game, the rules of the game. The same with the comparison between PCI and surgery in complex advanced triple vessel disease, where earlier studies only involved non-arterial grafts. What about prevention by better preparation of surgery, better preoperative and also real-time study of the patient anatomy and topography? On the right side here, we'll see how an aortic valve replacement looks like in our practice, in our program today, in the Department of CTVS in National University of Singapore. And on the left side, an example, what you see is a real-time one-to-one superposition of a holographic image of the patient on the chest. We did the first human application about a year ago here in our institution, where the surgeon can achieve better ergonomy, make surgical decisions and anticipate trouble, as well as appreciate the root and the valve sizes better just before he enters the chest. So better imaging eventually and better preparation may change the rules of the game and provide surgeons as well as cardiologists with a vertical exit from the problem of PPM. Look, for example, at these new developments. We're entering collaboration with Simulia from California, where computational prediction modeling and digital virtual simulation in device development and testing can play a crucial and milestone role in avoiding PPM in future, not only at the level of clinical implementation, but also at the regulatory level, can save thousands of animal and, of course, human lives when implemented and in full swing. I won't miss the opportunity to finish by sharing our own procedures developed in my lab. How about biomimicking prosthesis? On the left side of the slide, you see the traditional prosthesis, mechanical as biological in the market. In the middle, you see how a mitral valve repair looks like with a ink test. And on the right side, you see our prosthesis, a biomimicry, physiologically built and designed prosthesis in the in vitro tester in the United States right now, scalloped, D-shaped bileaflet with a flexible annulus. How about personalized implants beforehand planning an implantation, what is best for this particular patient based on preoperative scans, which is, and I'll show you a clue how our prosthesis basically incorporates this feature in this little video here. Ample mobility of the annulus, beautiful fish mouth effect and huge orifice area, which expectedly, naturally, results in much, much smaller pressure gradients here, not only by a bit, but a multifold smaller compared to what is on the market right now. Allow me to leave you on this optimistic perspective surgically, and I shall thank you for your attention as well as in advance for any questions and discussion. Thank you.
Thank you very much for your talk. Do you have any question from the audience? Professor, I have one comment and one question. The first, my comment is okay? It's okay? Okay. Professor Kofidis, I have one comment and one question. The first, about the valve deterioration in Notion trial. I have to say that as for the surgical group, the valves that were implanted were mitral flow and trifecta. So there are two valves that there are no in the market today, especially mitral flow. And as for trifecta, we have the third generation of trifecta. And my question, so I think that is not right to have any comments about any comparison about the deterioration of the valves. And the second is that what do you think about the difficult and the problematic situation of a patient with PPM and paravalvular leak? Do you think that it is, what do you think about it?
Okay, let me address your comment, Dr. Kotoulas. Thank you for your comment. Of course, I will agree with you, and we know that this particular trial, and let me be frank and open about it, is not necessarily surgically inclined, so I will agree with your comment without further addition. We know the inclination of Dr. Zondergaard, with all due respect as a faculty of this event. And I do agree that Trifecta, unfortunately, disappointed in the last couple of years as an internally stented valve with not so good long-term outcomes and fast structural valve deterioration. Definitely not a good comparative platform, but we have to check upon what is existent out there in terms of literature. Now, PPM, a paravalvular leak, is basically a higher level of problems, higher level. So certainly, a dual problem like this should not happen and is rare. I don't know if our fellow colleagues from cardiology can offer solutions by embolization of paravalvular leaks. Are you referring to first-time implantation? Then, of course, we must look in alternative salvage techniques on the spot. How big is the leak? Are we talking about the patient who is post-operatively landed on the ICU already and has a paravalvular leak in the process? I guess this is critical for our surgical decision making, because an intraoperatively hemodynamically significant or even less than that significant paravalvular leak will immediately lead to a decision making by the surgeon. What can we do? Either we enlarge the root, accepting this at somewhat higher surgical risk, but there are other methods as well. For example, lifting or tilting the graft, doing a modified mental procedure with a procedure higher than the level of the annulus, and Cabral shunts or individual Cabral shunts. So there are a couple of ways we can escape, but God forbid we don't want to come into the situation of having two problems at once. In the long run, embolization, or if the aortic valve regurgitation is significant, potentially symptomatic, then we have to think of a redo, as far as I understand your question.
Thank you very much. Let's continue. The second speaker is Dr. Patakos, and his topic is suffering extra small annuli, valve selection and consideration for root. Dr. Patakos.
Thank you, Dr. Kotoulas. Thank you to everyone for being here today. And I really appreciate the talk by Dr. Kofidis because it's an excellent segue into my discussion. I think Dr. Kofidis gave already a lot of the basic science regarding PPM, patient prosthesis mismatch. So I wanted my talk today to be a little bit more practical about what we do as surgeons when we have a patient with a small annulus in order to avoid PPM. So what's the problem with the small annulus? Dr. Kofidis already told us size matters. And I grew up in Washington, D.C. As everybody knows, for the NBA teams here, it used to be called the Washington Bullets. Now they're called the Washington Wizards. They were famous because at one time they had the tallest and the shortest players in the NBA. So size matters. And we frequently get these questions from people that have not been in the operating room. Why don't you just put a large valve in everyone? I had a cardiologist ask me, why don't you just put a 23 or bigger in everyone? And this photograph is the answer. If you can put this foot in this shoe, it's the exact same idea. So nobody wants prosthesis patient mismatch, and this is to the point that the companies now are even putting pocket guides to show us as surgeons why we should avoid PPM and how their valve does better than competitors for avoiding PPM. So here you have some of the negative side effects of PPM listed with higher transprostatic gradients, LV outflow obstruction and persistent hypertrophy, decreased postoperative cardiac indices, decreased late survival, decreased functional classes, NYHA, sudden death, decreased quality of life, higher incidence of late complications, increased bleeding risk, CHF, and reoperation. So it seems like there's a large body of literature to suggest that this is something that we should do our best really to avoid. And so when we come down to it, most valves have a sizing chart similar to this. So you can see, just as Dr. Kofidis was discussing previously, we have our expected effective orifice areas, and we can look at the BSA of the patient. And so frequently when I'm doing an aortic valve replacement, we look at what the BSA is, and we see, are we going to be in the green, yellow, or red? And this is really here, the red is even where moderate starts. Nobody wants moderate, but the red is where moderate starts. It's below 0.6 or 6.5 to be considered as having severe prosthesis patient mismatch. So most of the time we're in the green, and you can see that, and I think this is important, that even a 19 millimeter mechanical valve, which is a small valve, and we rarely implant the 19 millimeter valve, is okay, is in the green up until a BSA of 2.0, and it's only when you get to a BSA of 2.2 that you get to below 0.8, which the red is where you have any kind, where you start having moderate PPM, not severe, moderate. So I think it's important that we think about this, because I think about it every time that I have a patient who comes in for a clinic visit. And not to be judgmental or anything, but most of the time when we have a patient that is at risk for PPM, it tends to be a patient who is shorter and more overweight. And that's because the body frame is smaller, and the additional kilos that they're carrying on their frame increases the BSA. So you have a patient whose annulus is the same size, but their BSA has now increased. So it's usually not the 100 kilogram patient who's 175 centimeters tall who has the problem, because they have a large annulus. They're a big person, they grew. It's the person that has grown horizontally, so to speak, that is most at risk. If we look at the gradients also besides the mechanical valves, I think this is an interesting study from the Annals of Thoracic Surgery, 2016, for the 19 millimeter biological valves. How do we do? So this study analyzed 447 patients who underwent aortic valve replacement, and 54 received the 19 millimeter valve. They had a follow-up around 5 years, maximum out to 15, and they had echo data before and after. And what we saw with these patients is that their gradients were quite good, I would say, having a mean gradient of 14 at 5 years is very good. Obviously, when you get to larger sizes, 23, 25, 27, the gradient is going to be smaller, and so there's a statistically significant difference. And also, if you look at the effective orifice area indexed, it's the same thing eventually. So these patients had slightly higher gradient, clinically not that big of a difference, and more prosthesis patient mismatch. However, when you look at the long-term follow-up out to 5 years, there was no difference in overall survival, cardiac-related mortality, or MACE. However, I think we take this with a grain of salt, and all of us do what we can to implant the largest possible valve size to make sure that our patients have the best hemodynamics possible. Now I'll look at a few of the surgical options, none of which is perfect, and to be honest with you, none of which has proven to be essentially superior to the other. This is what Dr. Kofidis was mentioning. This is essentially a chimney Bentall procedure. So what you do is you take a mechanical valve, or a biological valve for that matter, and you put it inside of a tube graft. And instead of putting the valve to come up to the edge of the tube graft, you allow for a few millimeters of tube graft to be below the valve, and that way you're essentially sewing the LVOT, or the aortic annulus, to the tube graft and not to the valve. Using this technique, these authors were able, from a 19 millimeter aortic annulus, to implant a 23 millimeter aortic valve with a mean gradient of 11 millimeters of mercury. Now, if you only go 2 or 3 millimeters above the valve skirt, you can directly reimplant the coronary ostia. If you go any higher than that, you will need a Cabral modification or interposition with saphenous vein grafts or Dacron grafts as an interposition, as Dr. Kofidis mentioned. So this is similar to what we perform here on a routine basis to our biobental. This is the biobental that we perform. In the past, when a patient needed a bental procedure, they were only receiving mechanical valves. And I think it's a shame when you have a 70 or even 80-year-old patient who needs a bental for them to get a mechanical valve. So what we do in the present at IGIA, and this is one of our cases, we take the biological valve of our preference, we insert it into a tube graft, we hand sew it, and then we reimplant the coronaries. You can see the third picture, you can see the coronary ostia above and below the left and right coronaries. The other valves that have gotten a lot of attention are these rapid deployment valves, the Perceval and the Edwards Intuity. The Perceval has become more popular in Europe and worldwide has more implants. I think there are pros and cons to both of these valves. The Perceval was originally, actually, interestingly, developed in order to be a transcatheter heart valve. And that's why the title is essentially PERC-E valve, percutaneous valve. However, this was modified and is now used as a surgical valve. And the benefit is that essentially you don't have to suture it in place, and so you don't need a sewing ring. When you look at the gradients that these valves give you, they're quite appealing. And when you look at the Perceval group in the left-hand column and you compare it to a conventional group in the right-hand column, the Perceval group had statistically significantly lower gradients. And I think it's very important to say that even the small Perceval does well. I think where it comes in handy most often to us is for patients who have a small annulus. And you see that the mean gradient goes from preoperatively from about 45 to 11, 9, 10 with follow-up post-op. Now, there are other things that we can discuss about Perceval. Does it have a higher paravalvular leak rate? Does it have a higher rate of needing pacemakers than a conventional surgical valve? But as I said before, I don't think that there's any strategy that's perfect, and you have to look at the pros and cons of each approach. This is a homograft valve. This is a picture I had taken in Houston, where we often use these valves for patients who had endocarditis, especially endocarditis of the root, but even prosthetic valve endocarditis. The pros are that you have no sewing ring, so this is an all-tissue valve, and it also includes the ascending aortic tissue, if you need it, if your patient also has an ascending aneurysm. The downsides, and these are major downsides in Greece, are the cost, which is extremely large, and the availability. We had a case in Houston where we had to use 2 homografts, one on top of the other, in order to go all the way up to the arch, and the total cost just for the homografts was almost $50,000. So even in the United States, there are very few centers that have this, Cleveland and Houston being the preeminent centers. Now, the next part of my talk focuses on aortic root enlargement. There's many options, the Manugian, the Nix, the Rastan-Kono, all of these have their pros and cons. And I think that there's a lot of confusion around these, and each surgeon favors their own approach. Looking at this manuscript from JTCVS about aortic root enlargement, what are the operative risks? It was interesting to note that this was presented live at a conference as a paper, and even some of the preeminent cardiac surgeons, Craig Miller from Stanford and Thor Sun from Mayo Clinic, had disagreements about what the definition was of a Manugian versus a Nix. That goes to show you 2 things: the frequency with which this is applied, and whether we have one technique that is superior to the others. And I think it's clear to say that most surgeons choose one approach that works for them. We use the Nix, we go down to the middle of the non-coronary, and I think if you have one approach that works well for you, you should use it and stick with it. I think this is the best operative video that I've ever seen, and I stole it from the group at Toronto about how they perform aortic root enlargement. So you can see a bovine pericardial patch. They've excised the non-coronary leaflet. They go down and they sew this. They have not extended it onto the mitral leaflet, but they've essentially only removed the non-coronary portion of the annulus. The patch gets sewn in. You see on the left side video. And on the right side video, you can see that the valve is then sewn. On the 2 other sides, it's sewn normally to the annulus. On the side of the patch, you have to sew it from inside out in a different technique. And this usually allows you to upsize by 1 to 2 sizes. So if you were going to go for a 19 millimeter valve, you can get either a 21 or a 23. And as I said, there's about 10 different techniques for how you can do this. And then the benefit is that you can also use this patch in order to close your aortotomy. If you've implanted a large valve, it helps you with that. The slight downside is that there is a slightly increased bleeding risk because you now have created 2 additional suture lines on the aorta and 1 at the level of the annulus. So I'm going to close with this. This is my suggested algorithm. I think that in the era of TAVI, it's important that for all patients that are at risk of PPM or that are considering whether they should have a surgical operation or a transcatheter valve, we obtain an aortic annulus protocol CT scan for all of these at-risk patients or the patients trying to decide between open surgery and TAVI. We discuss the pros and cons of SAVR versus TAVI for these patients. And if they choose SAVR, I think that we should make sure we perform an annular debridement that's adequate. We should look at the sizing of the prosthesis. And then using those sizing charts, if we consider that there's risk for PPM, we should either consider a rapid deployment valve or annular enlargement. There's no, of note, there's no long-term data to suggest that any of these strategies, and it's the same for TAVR, that whatever you do for one of these patients with a small annulus, that it makes a difference in long-term outcome and survival. So I think it's somewhat dealer's choice here. And the alternative option, or if you have a root that's enlarged, is also to use a chimney Bentall operation. Thank you very much for your attention, and we look forward to solving these problems of size with you in the future as a team.
Thank you. Any question from the audience, please? No question. Just to, do you have a question?
Thank you very much. An exciting
Dr.
presentation. How often is root enlargement performed in Greece, in percentage-wise, let's say? I mean, it's good to know.
Yeah, we don't, I don't think we have national data unless somebody else has it. I can tell you that for us, it's a single-digit number of cases that we're doing per year. Partially, it's the fact that we don't see these cases frequently. Partially, it's the fact that some of these patients are now going to TAVR. And the last is that when needed, we perform the NICS procedure. So I think the operative volume is low.
Thank you, Greg, for this precise and accurate talk. Well, I'm making an assumption, or I'm speculating if the distension of the aortic annulus due to systematic oversizing and the absence of shorings and may have the potential mechanism accounting for the superior hemodynamic profile associated with TAVI procedure compared with standard SAVR.
Yeah, so I didn't hear the first part of the question. So TAVI, let me, if you would be so kind, look at one thing. If you look at the latest partner trial, or I can't remember if it was 2 or 3, but there was no superiority actually of TAVI in one of the latest Edwards trials over surgery. And why was that? It was because a lot of the surgeons performed annular root enlargement. So we believe that if you perform an annular root enlargement, you can have equal or better effective orifice areas with TAVI. And we have people from Edwards here, they can correct me. I can't remember if it was partner 2 or 3. But there was no superiority, and that's why actually Medtronic turned and in their commercial says the only device proven to have superior EOA compared to surgery.
Okay.
So that, but I take it what Dr. Maginas is saying with a grain of salt, that yes, that's all good and dandy, but only if you do a good aortic root enlargement. How many surgeons do a good aortic root enlargement? I hear you loud and clear.
And what is the learning curve of this method? It's quite...
Yeah, it's not as steep as you think for someone who does surgery, who does aortic root surgery, but you have a very good point that if you're not doing 5, 10, 20 cases per year, how do we know that you're going to have good outcomes? I agree with you.
Okay.
Just a practical question only. What's the advantage of these new valves like the Pvl or the Intuitive Medtronic comparing to the using the standard ones? I mean, why to use a transcatheter-like valve and have not all the benefits of the other valve from the surgical ones?
So I'll answer your question with some humor. When we looked at these valves, you can say they have all the pros of TAVI, but someone can look at them and say, they have also the negative aspects of TAVI, but you also have a sternotomy or a mini sternotomy or whatever you have. I think when you look at the data for Perceval, what you see is that it saves you maybe 20 minutes of pump time, of time being on cardiopulmonary bypass. But you do have slightly better gradients and slightly better effective orifice areas. And so some surgeons, I'm not saying that we know this to be true, because to be honest with you, the data isn't 100% convincing to me either way. I don't have much in favor or against what I think you're about to say. But if you have removal of all the calcium, you have removal of all the leaflets, you perform a good operation, you have good gradients, and if in the future you can do a valve and valve into these valves, it's one of the many options we have. But I don't think that the algorithm is quite clear for these cases yet.
I'm pointing this out because in our experience we have a couple of cases with early deterioration, especially for the Pvl valve. And the problem is that it's very difficult to enter through these large struts in order to do the TAVI. You don't know where you enter through. You enter through the center or through the struts, which is really big struts.
Yeah.
Do you have the same experience?
Yeah, so, and I think we can have Dr. Sparias perhaps make a comment on that as well about the Perceval. There is a problem when you use the Perceval valve, especially for a small valve, you have to make sure that you're sizing it well. It's the same thing as with a TAVI valve. If you have a small annulus and you put a valve that's too big for that annulus, it's not going to expand properly. And we all know that when you have a stent frame that's not expanded properly, those leaflets do undergo faster deterioration, 100%.
Just a comment on this. I think when you see the valves, a SAVR and a TAVR, you immediately see that the scaffolding of a TAVR valve occupies 2 millimeters. There is no SAVR or rapid deployment valve with a scaffolding that's only 2 millimeters thickness. So size by size, a direct comparison, you always get a larger orifice with a TAVR device for the same anatomy. So whatever the studies and the outcomes about PPM say, I think it doesn't probably matter because you see the reality in front of your eyes. The newer devices that they have skirt also occupy some area. Probably that's why in Partner 3, that is a study you referred to, there was no difference, but surgeons also improve, they do more
root enlargement,
better things.
Yeah.
Dr. Triantafylou, do you have any comment?
Yes, I was expecting to make a question. I mean, what is the parameters that would lead to a decision to put a valve, a Perceval type valve and not do aortic root enlargement? And if a surgeon decides to implant a Perceval, why not do TAVI from the beginning?
Yeah, I think these are very good questions. As I told you, I think this is dealer's choice, so every surgeon will answer this question differently. For us, I think that if we can get an adequate, good result with a Perceval valve and we don't have any problems with prosthesis-patient mismatch, the bottom line is that you have, we look at having lower morbidity and mortality with this. When you add an aortic root enlargement procedure, you're unfortunately making it a bigger operation, and we have to be honest with ourselves. So if we think that a patient will have optimal results with a Perceval rapid deployment valve, we'll use it. If we think that they won't, we'll go to a slightly bigger operation. It's like asking, why does somebody have a Bentall procedure versus having a straight tube graft? It's what do I think will be better for them in their future? In terms of why don't they have TAVR? It has to do with the whole debate of TAVI versus SAVR. And so there's many reasons why a patient may still choose to have a surgical aortic valve replacement. It's not dead. I know it has decreased a lot, but surgical aortic valve replacement with a biological valve is not dead. Some of our patients look at the data and they look at the 5-year durability of TAVI leaflets, which have half the thickness of a biological valve. And I can tell you that some of your cardiology colleagues are telling patients that you have to be careful after 5 years with a TAVI valve, or after 7 years, or after 8 years. Whereas for surgical valves, we have more data. TAVI started in patients who are 80, 85 years old who could not be operated. And so for now, until the 10-year data from Partner 3 and from the Medtronic study come out, low-risk trial come out, we don't have good 10-year data for TAVI. That's one of the reasons why people still choose surgery. There are many benefits to TAVI. I feel comfortable with both operations. I like both operations. There are patients better geared for each operation. So I think we're still discussing what patient should have which procedure.
Just another question. With a failed fast deployment valve, such as Perforation, which is difficult to treat with valve-in-valve with TAVI, is there any experience with redo surgery? And how does it go?
Yes, there is, and thankfully this doesn't happen from our center. We have experience from another center, but the answer is that it's a relatively easy valve to remove. That's the first thing, and the second thing is that all of the cardiac surgeons, I think that you are at high volume centers, are performing echocardiography, transesophageal in the operating room before the patient leaves. And so the vast majority will be identified before the patient goes to the ICU. Is there a small percentage that is going to have an issue post-op that wasn't identified in the TE in the operating room? Yes, and the valve can be removed just as a TAVR valve can be removed.
Thank you.
Thank you. Few comments. First of all, TOE, intraoperative TOE, is essential, or especially mini stenotomy or right thoracotomy.
I agree.
The second one is that we have a new valve, the Resilia valve, with TAVI technology.
The Inspiris valve.
And of course, Inspiris valve, and of course we have the Connect conduit, the only one dry aortic root conduit. And I'm curious to see a new generation of TAVI valve with Resilia tissue. I think that it will be the final step of the TAVI technology.
Revolution.
Because Resilia valve has 0% of deterioration in 5 years, surgical valves. So I think that in TAVI cases, with better EOA, there will be a real new world in aortic valve stenosis treatment.
I agree with you wholeheartedly, yeah. I'm glad to see that my talk brought about so much debate. Thank you very much.
Okay, thank you.
Thank you very much also. And let me take the opportunity to thank the organizing committee for inviting us all here in this exceptional session. And I think it's time to go ahead. Professor Pibarro needs no introduction. He's a well-known cardiologist, professor, and he works in University Laval in Quebec. He has sent us a video, and we are, I think, ready to go ahead and see it, and we'll ask questions after the completion of the video. He's going to be available to answer the questions we have. Professor Pibarro, are you here?
So the important difference that we had, in the high risk, intermediate risk, with the first generation of balloon expandable valve or self-expanding valve, where actually we had much less mismatch and high result within TAVR versus SAVR, is not as striking now in the low-risk population. The reason is essentially because in low-risk population, with more favorable anatomy of the aortic annulus and aortic root, the surgeons have been able to implant larger valve with better hemodynamics, and so they actually reduce markedly the rate of severe PPM, with SAVR. Whereas with TAVR, the sizing remain more or less the same compared to the previous trials. Still, of course, there is overall more paravalvular leak with TAVR versus SAVR, even in the low-risk population. But here again, the difference has shrunk between TAVR and SAVR. And we still have, numerically higher moderate or severe paravalvular leak, but not statistically significant in TAVR versus SAVR. However, of course, we still have much more mild PVL in TAVR versus SAVR, even in the low-risk population. This is a large contemporary series from Germany looking at the hemodynamics following TAVI in the small annulus. And well, actually, they had about 13% patients with small annulus in their series, defined as a annulus area less than 400. And among these patients, 10% had severe mismatch, 28% had moderate mismatch. And well, severe mismatch was generally associated with more aortic valve calcification, even smaller aortic annulus area, and lower stroke volume index. On the other hand, you had less mismatch and less severe mismatch when a self-expanding valve was used, when post-dilatation was used. And the two other panels shows actually the rate of prosthesis patient mismatch and moderate severe paravalvular AR according to the different type, different platform of transcatheter valve. And interestingly, the balloon expandable valve such as the Sapien 3 or the mechanically expanded valve such as the Lotus had a higher rate of severe and moderate mismatch compared to the self-expanding, so the Evolute, the Accurate Neo, and the Portico. But on the other end, the self-expanding had more moderate or severe paravalvular leak compared to the balloon expandable Sapien 3 or the mechanically expanded Lotus. And well, this is important to keep in mind because generally the impact on outcomes, on mortality, hospitalization is more important with the moderate severe paravalvular leak versus a severe prosthesis mismatch. So what are the clinical outcomes of TAVI in the small annulus? Well, quite good. This is again the data from the Partner 1A trial. Actually, the survival in the small annulus was as good as in the medium annulus. And the only tertile where we saw some increase in mortality was the large annulus, because essentially of the higher rate of paravalvular leak. And if we look, you know, at the mortality in the different tertiles of annulus in TAVR versus SAVR, well, in the small annulus, although this was not statistically significant, you do see lower mortality rate with TAVR versus SAVR. Whereas in the medium annulus, this is neutral. And in the large annulus, you tend to see a switch, a crossover, where actually now SAVR has a lower mortality than TAVR. Not significant, but there is a trend. With the self-expanding in the core valve high-risk trial, if we look at the patients with the small annulus and comparing those with severe mismatch versus non-severe mismatch, and this is actually all patients with a small annulus, TAVR and SAVR merged together, and you see that patients with severe mismatch had about twofold higher mortality at 2 years compared to those with non-severe mismatch. In the TAVI small registry that really focus on patients with a small annuli, interestingly, and this was TAVR with the self-expanding valve essentially, you have 9.4% severe mismatch, and these patients with severe mismatch actually had significantly reduced survival. And when you look at the factors that were associated with the increased risk of mismatch, well, the valve with intra-annular design versus supra-annular were associated with a high risk of severe prosthesis patient mismatch. On the other hand, the factors that were protective were essentially if you had more oversizing, interestingly, you have less mismatch because generally you have better hemodynamics. And also if you use post-dilation, less mismatch as well. Interesting study published last year, which is actually a real-world outcomes using the 20mm Sapien 3 valve compared to larger valve of the same valve, Sapien 3. This is a propensity score match analysis from the TVT registry, and actually there is no difference at all in terms of mortality at 1 year. It's about the same in the group of patients who received a 20mm Sapien 3, which is quite small, versus those with a larger Sapien 3 valve. And if you look at the predictors of mortality, well, actually the size of the valve, again, is not a predictor, as well as severe prosthesis patient mismatch and even the discharge gradient, high risk gradient. On the other end, the moderate or severe paravalvular leak, again, this is a heavy risk factor for mortality associated with increased mortality, as well as a new permanent pacemaker. So now to the last part of the presentation is about the durability of the TAVI in the small aortic annulus. And there might be a matter for concern here because in a small annulus, of course, you may have to use more of a sizing and therefore under expansion of the valve. And if you have under expansion, as you see on this video, you will have more pinwheeling during diastole and bending stress of the free margin of the leaflet during systole. And this will translate in increased mechanical stress on the leaflets, repeated billion of time, of course, during the lifetime of the patient. And when we look at this in vitro, you see that in the small annulus, that is more the red bars here, when you got into the smaller annulus and you implanted 23 millimeter sapien at the time, of course, the percentage of oversizing increase, the percentage of underdeployment increase, and with that, the leaflet stress increases. And indeed, if you look at, different studies, there are patient-related factors and process-related factors that will eventually determine the occurrence of structural valve deterioration and therefore eventually the failure of the valve. And well, among these factors, you have younger age, diabetes, hypertension, renal failure. But you also have a patient-related factor, especially severe prosthesis-patient mismatch comes out as often a risk factor, especially in the SAVR series, high residual gradient, small valve size, important oversizing, or on the other end, important undersizing. We also know that newer generation are of less structural valve deterioration versus older generation. TAVR versus SAVR, we don't know yet. Self-expanding versus balloon expandable transcatheter valve, we don't know yet, but there are some ongoing studies. So in conclusion, TAVI is associated with, I would say, surprisingly good hemodynamics and clinical outcome in the small aortic annulus, better than I expected initially. And TAVI may actually be superior to SAVR, if you look at the gestalt of this in the small annulus. We may need a randomized trial, and there's actually one ongoing trial led by, again, Josep Rodés-Cabau, which is the VIVA trial. Self-expanding TAVI is actually associated with less mismatch, less severe mismatch, lower residual gradients compared to balloon expandable TAVI. But on the other end, more paravalvular leak. So what will be the net benefit? We don't know yet. We need a randomized trial to compare self-expanding versus balloon expandable in the small annulus. The results of the Lytton trial, which is in the context of valve in small failed bioprosthetic valve, will be presented at EuroPCR. And there are also ongoing trials, the SMART trial, the PEST trial. So stay tuned. Long-term durability of TAVI may actually be reduced in the small annulus because of increased leaflet mechanical stress. So we'll have to wait for the longer-term follow-up of the ongoing trials. And on this, I thank you very much for your attention.
As you understood, there was a technical error that did not allow us to see the first few minutes of your presentation. Let me first apologize, and second, to see the first few minutes, and then we'll have the opportunity to ask questions on your presentation. I think, if you don't mind.
TAVI in the small annulus.
Yes, please, let's see.
So before getting started, I do have some disclosure that are listed here. So what is the definition of a small aortic annulus? Well, by echo, it is defined as a diameter of 21 millimeter or less, whereas by CT, a small aortic annulus is generally defined as an annulus area less than 400 millimeters square, 410 in some studies, or a perimeter less than 70 millimeter. And in SAVR series, it has historically been defined as a labile size of the prosthesis of 21 millimeter or less. And so in the first part of the presentation, I will discuss the hemodynamic outcome of TAVI versus SAVR in the small aortic annulus. And this is a case of a 75-year-old woman who had a small area, annulus area, close to 300. She received a TAVR with a SAPIEN 3, a size 20. And leaflets have a normal appearance and mobility, but there is a high residual gradient at the pre-discharge echo, mean gradient of 26. AOA is 1.10, which is close to the normal value for this valve, 1.2. So the prosthesis is doing what it should do. It has a normal function, but it is too small for the patient body size. And indeed, the AOA index for body surface area is small, 0.64 centimeter square per meter square. And in the valve 3 criteria for definition of prosthesis-patient mismatch is defined as a prosthesis that is functioning normally, but is too small for patient body size, and so for cardiac output requirements, right? And severe mismatch is considered when the index AOA is smaller than 0.65 centimeters square per meter square, with the caveat that in obese people, so BMI more than 30, you should use lower cut points, so 0.55 instead of 0.65. And the consequence of mismatch is, of course, the persistence of high residual gradient across the prosthesis. So in valve 3, we define high residual gradient as a mean gradient more than 20. So what is the clinical relevance of this high residual gradient and suboptimal hemodynamics after EV?
And again, sorry for this technical error. I think we can see you and we can ask questions now. Other question for Professor Pibara from the audience? Dr. Christopher Harris, please.
Hello, can you hear me? Hello? I wanted to ask,
yes.
Thank you for the talk, it was very interesting. If we implant the 20 millimeter sapien valve, technically speaking, that's a circle that has a 314 square millimeters of area. How does that end up in echocardiography to be 1.1 square centimeters? Is it
VR? These are the data.
I'm not sure.
Yeah, so that's a good question, actually. You know, the size of the valve does not necessarily predict the size and the area of the effective orifice area that is available for flow. And this is well known for surgical valve. This is well known for transcatheter valve as well. You always, you know, because of the stent, because of the leaflets that occupies a portion of the annulus area, you certainly lose some of the area available for flow. And you always have to keep in mind that there is a convergence of the flow. So the effective orifice area, that is the cross-sectional area of the jet, which is the one that determines the pressure gradient, is actually always smaller than the anatomical orifice area because there is this phenomenon of flow convergence. And maybe I would say the efficiency of the occupation, if you will, of the anatomical orifice area is somewhat better with the transcatheter valve versus the surgical valve because the stent is, yes, present, but less bulky, thinner. But still, you know, we lose some of the effective orifice area. The other thing that should be kept in mind is that the Doppler echocardiography has a tendency to overestimate the gradient and underestimate the effective orifice area because of different reasons. First, we use some formula like the Bernoulli formula, the continuity equation, and we do some assumptions that are valid for severe native aortic stenosis, but not as valid for the prosthetic valve, the normally functioning prosthetic valve. And also there is the phenomenon of pressure recovery, where a portion of the pressure recovery occurs after the valve, after the vena contracta. And so when you compare echo versus catheter, for example, in the cath lab, for those of you who eventually do some invasive assessment at the time of TAVI, you often find lower gradients and larger valve areas with catheter than with echo. So that's all the factors that explain why you may have an AOA of 1.2 in a transcatheter valve of 20 millimeters sapien 3.
Thank you very much. Dr. Sparias.
Dr. Pibara, thank you for being with us. A similar question, when we have a balloon expandable valve that gets the circular shape always compared to self-expanding valves that are not entirely, they have some ovality always, do you think this affects the maximum velocities you record with echo due to the different conversion dynamics? You always have a higher velocity in the center of a circular area, I believe.
Yeah, no, absolutely. So This is something that we have tested in vitro. So even with a balloon expandable, if you implant a balloon expandable in a quite oval annulus versus a circular, actually it does not impact too much the hemodynamics. And even in vitro, at least on post-duplicator, you tend to have actually lower gradients in an oval annulus than a circular annulus, which surprised me initially, but this is because some of the leaflet, at least one or two, may open to a greater extent, whereas in a circular, all leaflets are maybe a little bit less, if you will, maximum expansion. But that's a small difference. Now, between balloon expandable versus self-expanding, yes, you are right. Often in self-expanding, you may have more oval or non-circular deployment because of less radial force. But on the other hand, you have to keep in mind that self-expanding, not all, but of a supra-annular design. So the leaflets are not at the level of the annulus, where often the shape of the stent is oval, but more like maybe 10 millimeter, 10, 12 millimeter higher. And because of this supra-annular design, the shape of the stent, if you will, is, yes, indeed, oval at the level of the annulus per se, but is more like circular above, so I'm not sure, it has the ovality that we see eventually on CT is often below the stent, maybe less. Still, you have some ovality at the level of the leaflets, but it's more like supra-annular. One thing, however, we have to keep in mind, as I mentioned in my presentation, not only to focus on hemodynamics. It is not because you have better hemodynamics, lower gradients, and AOA that you're necessarily going to have good durability. Because, for example, the non-circular deployment may not impact too much the hemodynamics and may actually help the hemodynamics, as I mentioned, but it may increase the mechanical stress, the distortion of the leaflets. And when it's repeated billions of times during follow-up, it may impair durability. So this is a bit of a paradox. You may have eventually better hemodynamics in the short term, but less durability in the longer term. So, and same with oversizing, when you oversize, you tend to have better hemodynamics. If you are in a gray zone of annulus, if you have two possible sizes, and we tested this in vitro and same in vivo, if you select the larger valve, so more oversizing, you're going to get better hemodynamics, somewhat lower gradients, larger valve areas. Not big difference, but still. However, you have more mechanical stress, you have more pinwheeling of the leaflets, and I think, although this is not yet well demonstrated, but I think we're going to have shorter durability of the valve, which is an important, of course, objective nowadays as we implant TAVR valve in younger patients with longer life expectancy, of course.
Do you think post-dilatation should be more liberal in small annuli?
Yeah, I think, in partner one, we'll look at this, partner two as well. When you do a post-dilation, indeed, of course, you improve the deployment of the valve. It is helpful to reduce paravalvular AR. We've shown that with Becky Ann. Generally, when you have a significant AR, you do post-dilation, you're going to reduce the AR on average by 1 grade, which is good. And indeed, as well, also, we saw, and we have seen that in partner 3 as well, although there was less mismatch overall. But with post-dilation, we are able indeed to improve the gradients, the residual gradients, and the mismatch. And I think post-dilation, if you think you have some high residual gradients, eventually confirmed by invasive measurements, or the stent of the valve does not appear fully deployed, on your angio, on your senior fluoroscopy, well, I think we should not hesitate, do a post-dilation. Of course, there is always a price to pay for any additional procedure, and there is a small, as you know, signal with cerebrovascular events when you do post-dilation. However, the analysis that we did in partner showed that we believe that the small increased risk of cerebrovascular events associated with post-dilation is more associated with the concomitant risk factors, because of course we tend to post-dilate in patients who have higher risk profile, more calcification, etc.
Thank you very much. Really excellent. I think we can go ahead with the next presentation. Thank you, Professor Vibaro.
Thank you for having me. It's a great pleasure. Great meeting. Congratulations.
Thank you.
Dr. Triandafilo, we may proceed with Dr. Triandafilo, please, if he can hear us. No?
Yes, I'm here. I would like to present the next speaker, Dr. Cassel from the German Heart Center. He is well known for his contribution to the field. He will present us an intervention about TAVI in extra-large annuli and in high-risk AR. Dr. Cassel.
Thank you for invitation. I'm so honored to present this topic, TAVI in extra-large annuli in high-risk aortic regurgitation. My name is Mitchen. I'm from University Hospital at Zurich. Unfortunately, Dr. Max Kazo is unable to do the recording presentation, and I will present him to do it, and hopefully he will join the online discussion. And here is the disclosure. And as we all know that the commercial transcatheter heart valves are mainly covering the diameter from the 18 to 27. And when the annulus is bigger than 27, there are only two valves available. They are Sapiens 3 and Evolute R. Then we can define such annulus as the large annulus in TAVI procedure, which means it has the bigger perimeter than the 85 and larger area than 575. And also, once the aortic dimension is larger than all the commercial sizing, we define such annulus as extra-large annulus. And first, let's think about what's the challenges in such situation. First, obviously, is the embolization. And we know once the annulus is big enough, and we need more the anchor, and the calcification is when the main factor we need to think about is whether it's enough for the extra annulus to anchor. And also the challenges for the paravalvular leak and the coaxial difficulty, especially in the self-expanding valve. And in such anatomy also has a high precedence of the bicuspid aortic valve, which has more difficulty and also in sizing. And finally, I would like to talk about the concomitant with the aortic regurgitation. First, we have looked at this paper, and we know it compared the annulus of the large one and the extra large group. And we know there's no big difference between the two groups. That tell us if we have the proper selection and the optimized strategy during the procedure, we can also achieve good result. So it's possible to treat a extra large annulus. And also in this paper, it tells us for the balloon expandable valve, we may get better clinical outcomes than the self-expanding valve. In another paper, it studied what's the risk factor of the paravalvular leak, and we know it could be the eccentricity of the annulus, and also it depends on the maximal diameter of the annulus, and also it has the impact if the LVOT area is much larger than annulus. Now let's go to the procedure techniques. First, we need to think about the selection. Once the annulus is larger, first we need to look at the calcification. It isn't enough for our anchor. And the relationship is if we want to treat a much more bigger annulus, then we need more calcification. And in our practice, we know that for the sapien, we can do the overfilling, do the overexpansion. And every 2 milliliters overfilling could achieve 1 millimeter bigger valve. And next, we need to get a good annular reconstruction. And maybe we already know clearly the annulus is the hinge point of the leaflet in the LVOT. And also for the bicuspid aortic valve, we would recommend the volume sizing to define the annulus again and to see the relationship between the hinge point and the balloon. And also we can use the classic follow the right cusp rule to achieve a better core plan. And for the valve cross technique, I just want to use 1 or 2 sentences to describe. As we know, we may always use the AL1 with the straight wire, and in such situation, we may use the AL2 and to choose a larger diameter to do the crossing clockwise and counterclockwise movement. But I would recommend we can also do the pull-back technique. It means we can advance our AL1 or AL2 to the left coronary side and just to do the simple pull-back technique. And at the same time, we advance our straight wire step by step until it drops into the left ventricle. And next is the deployment height. And as we know, if we want to do the aortic expansion, that it means we will achieve the more foreshortening of the sapien frame. That means we need to change our deployment. We need setting the valve a little bit slightly below. And usually in our setting, if we want to treat 70% in the ventricle and 70% in the aorta and 30% in ventricle, we usually place the marker, half marker or the 1 marker above the annular plane. So in this setting, if we want to do the aortic expansion, we need to place the marker a little bit lower. That means we can just place the marker in the line of the annular and to do the aortic expansion. And this is our paper that shows that the ability of the aortic expansion. And you can see if for a 23, but well, if we add 2 millimeters, we can achieve a 24. Wow. And also for the 26, if we give a 3 millimeters more, and we can get a 27.5. Wow. That means every 2 milliliters, we can get a 1 millimeter bigger of the valve. Next is the stepwise deployment. When we to deploy the balloon expandable valve in the extra large annulus, we need to balance the paravalvular leak and the aortic rupture. Especially in our selection, we have a very heavily calcified annulus. That topic would become more important. You have two ways to do it. First, you can do a deployment in 2 rapid pacing. You can deploy it with a little bit overfilling, and when you realize it's not enough, and you can do a second step in the post dilatation. And also we would recommend, if for an expert hearting, we can do a 1 rapid pacing. That it means when we have a 30 millimeters annulus, then our plan would be a 29 sapien valve, but we will overfilling the 4 millimeters of the syringe to prepare it. And when we deploy it, we will stop in the 2 millimeters, because now in the chirurgically, it means we already treat with 30 millimeters valve, all right? And this we need to have a good cooperation between the first operator and second operator. The first operator is to observe the relationship between the hinge point and the valve frame to see whether we have already reached the hinge point. It means we reached the annulus or not. And the second operator needs to feel the resistance in the syringe. Is there we have more space, and we can add a 2 cc more. And such a good cooperation between the heart team and we can to decide, do we need another 2 cc? And this we call the one-rep pacing strategy for the stepwise deployment. Let's see a video. First, we need to change the placement if we want to do an overexpansion. And now we with 2 cc less and 1 cc less, we still adding the volume, and until we've finished all the prepared work. And after the deployment, and we may consider the post-dilatation. As we know, once we deploy the valve, the main pressure is in the diastole. Its diastole pressure could cause the embolization, and it will towards the ventricle. So our purpose is we can do a flare the outflow. That the technique is simple. We just align the middle marker of the balloon with the outflow of the Sapien 3, and we inflate it. And also at the same time, you can observe a probable leak. If you are not satisfied, you can also do a flare the inflow to reduce the probable leak. And last, I want to have 2 slides to show the aortic regurgitation. And we can do the pure aortic regurgitation in TAVI, no problem. And our principle is to oversize in 2 millimeters if the valve is no calcification, which means if you have a 27 aortic annulus and we need to treat it with the 29 Sapien. And if the valve is larger than 27, we would think there is no valve can treat such patient, but there's an exemption if the valve has a heavily calcification. And then we can do it until it may have a 27 dimension, and it's maybe also available. And this is the list of the valve which treat for the aortic regurgitation, and we know that only one valve that get a CE mark, and maybe in future there's some transfemoral transcatheter heart valve to treat with the aortic regurgitation. Then we may have the better option. Thank you so much.
Thank you very much, Dr. Mitsen, for your very concise presentation and the technical tips. I would like to ask for any comments from the audience.
No, there isn't.
There is no question.
No.
Okay. I would like to ask a question myself. How about the concerns regarding the overexpansion of a stent frame regarding durability in cases like that?
Okay, thank you so much. First, I'm sorry that Dr. Kaiser is not there, and I represent him to do the online discussion. And this is a very good question, I think. Because of the Sapien 3, we know has the difference with the Sapien XT, it has the possibility to do the overexpansion. But I think the leaflet with the suture is kind of limited, so our strategy is less than 2 cc.
There's a connection problem.
Προχωράμε.
Συνεχίζουμε.
Can we roll? And now, we may proceed, yes. And the last subjects of our table
is about the TAVI with severe calcification of valve in the aorta and an Agatston score around 5,000. Well, it's our strong belief that not only Houston has a problem, but everyone in planet Earth when it comes to severe calcification of the aorta and valves. And even it's well accepted, in contrary with the previous teacher, that some degree of calcification is needed to ensure the stable implantation of the valve. Are you ready? Okay. So, we are lucky, very, very lucky to hear one of the most talented interventionalists in the world in structural heart disease, my mentor, Dr. Spargias, how we can manage this kind of patients. The floor is yours.
Thank you, Dimitri. The problem, we all need some calcium to implant a valve. You cannot do TAVI with 0 calcium. But what happens when this calcium is too much? And what happens when we have an Agatston score, let's say 5,000? Then certainly we have a problem, and I will explain why is that. Starting with an example, a patient of ours with this Agatston score, more than 5,000, as you can see here. This is the calcium distribution in the aortic valve, LVOT, and further down, and this is the axial imaging of this patient. And you can appreciate that there is heavy calcium in the STJ, in the leaflets, but also at the annulus and subannulary. And a sagittal view of the same patient to better appreciate the calcium. So certainly this is too much calcium. Are we all in agreement? So we'll see what we did with this patient, and certainly a lot of calcium can create problems. It can lead to poor sealing, so paravalvular leak, disruption, annular rupture, and probably stroke. There is a lot of evidence that it also increases the incidence of stroke. How do we classify calcium? I think it makes sense to say that when we have just one nodule of calcium that is less than 5 millimeters is mild. When we have multiple nodules, or when we have an arc that is more than 10% of the annulus is moderate, if we have an arc that is more than 20%, or if we have a nodule that is more than 1 centimeter in any direction, or multiple nodules, then we have severe calcium. So from this study, they found, as you can see, close to 2,000 patients, that when the patients had the moderate severe calcification, they had worse all-cause mortality during the following year after TAVI. And when we see where is the calcium, we can distribute this and say this is at the annulus level or at the leaflets, or it's in the LVOT. And this is just an average of patients undergoing TAVI, and where you can see the average calcium score we get is 700 at the valve level, and much less in the everyday patients below the LVOT, just 20. And if you want to correspond this with the Agatston score, here is the correspondence. So the 750 we've seen earlier, the average, is just above 2,000 Agatston score. And again, in this study, they found that the more the calcium, the worse the mortality and the lower the survival over the following 5 years. In another study, they did the same, comparing patients with using the older TAVI devices versus the same TAVI devices, and they ended up in a funny conclusion saying that if you have very high Agatston score, more than 5,000-6,000 with the older devices, this is a predictive factor of worse outcome. But when you have an Agatston score of less than 3,000 with the newer devices, this is not a prognostic factor anymore for worse mortality. So annular rupture is our major concern when we deal with this very high Agatston score. And this can happen, can be located in into the annulus, but more often subannulary, and it can be to the free myocardial wall or to the mitral valve leaflet, to create a hole in the mitral valve leaflet to go into the intraventricular septum, either proliferating the muscle with blood or creating a VSD if it's high in the membranous, or create iatrogenic Gebauer defect connecting with the right atrium. And finally, supraannular, when we close the coronary artery, when we have a dissection at the STJ or injury to the sinus of Valsalva. And we know very well that LVOT calcifications, moderate to severe, are independent risk factors for annular rupture with balloon expandable valves from that old study, a strong predictor, 6 times more the odds ratio. And from this study, where they examined patients that they were operated acutely for rupture, they realized that the vulnerable area of the annulus is between the left coronary artery and towards the right sinus of Valsalva. And why is that? This is because this is exactly this area. This area has nothing to cover it, nothing above it. Everything else has the skeleton of the heart, or in front here you have the pulmonary artery and a less powerful skeleton, but still there is skeleton. This area is completely uncovered, and when we have a rupture here, it's a free rupture. And this is exactly that area. When we see the axial imaging, it corresponds to this arc, that, as you can see, it's from the left coronary towards the right sinus of Valsalva. In this study, they examined where exactly the calcium was located, and they discriminated between the upper LVOT and the overall LVOT, because it makes sense to believe that this is the area that is more vulnerable to injury when you are close to the annulus. And they also checked the location of the calcium in the 3 different sinuses. And they came out with this ROC curves, where they found that the upper LVOT calcium volume was more predictive of bad outcomes than the overall LVOT volume and the aortic valve region calcium volume, which was the lowest. But when they took the 3 different sinuses, the volume of calcium in the 3 different sinuses, according to the earliest manuscript that I presented, you would expect to have the highest risk below the left coronary, but they found here that they had the higher risk in the non-coronary cusp. It was an association between the calcium in the non-coronary cusp was worse and the other 2 slightly lower. Moving to PVL, there is a very well-defined correlation between PVL and annular calcium from a number of studies. The more the calcium, the more the PVL. And this is not just the calcium on the LVOT, but also the calcium on the leaflet. So they're both independent predictors of PVL. And when we see from another study, when we have moderate to severe calcium, then you can see that we have about 12% at least moderate PVL compared to half of this when we have none or mild. This is an interesting study where they checked the no or mild calcium with moderate severe calcium, and they discovered that in both balloon expandable and self-expanding valves, the bailout, the need for bailout was higher, much higher with the self-expanding from 1.4, as you can see, to 4.9. The risk of annular rupture was higher only in the balloon expandable, as expected, and the residual aortic regurgitation was higher when you had calcium with both valves, numerically higher with self-expanding. And continuing this study compared valves, and they found, again, when we have more calcium, then we have more bailout for the older devices, less with the newer devices. You see here, altogether 3.8 down to 2.6. Annular rupture also going down with the newer devices from 3.3 to 1.3, and residual regurgitation always again goes down and significantly down with the newer devices. The prognostic impact of calcium score in another study, they just reiterated, found the similar results that it was down with SAPIEN 3 and Evolut R, the newer devices, to lower incidence, significantly lower compared to the older devices. So when we have PVL with extensive calcification, we should consider post-dilatation when the device is under-expanded, but we should be very careful with the sizing and avoid non-compliant balloons, and also consider plugging, especially with EVP4, which is ideal. And what happens when we have a lot of mitral calcification? We see that very often in patients that we're doing TAVI. Does it relay any importance for our TAVI? Yes, it does, because when it's connected with severe mitral stenosis, then the prognosis is very, very bad. So we shouldn't do TAVI in patients with severe mitral stenosis. But as you can see, if there is mild or moderate stenosis or just calcification, then the outcomes are similar and acceptable. And when we have severe mitral stenosis, as you can see in these patients, we see more pronounced reduction in the LV systolic pressure, LV and systolic pressure, aortic systolic pressure after implanting the valves. And if you think of pathophysiology, it makes sense. And actually, for the end diastolic pressure, if you have a reduction of more than 20, this means worse outcome. And extensive calcification in the mitral valve is also connected with more moderate paravalvular leak in this patient. And this is from the same study, up to 62% had some paravalvular leak. That's why from this study, they recommended to consider a self-expanding valve, but with generous oversizing. And a few words about stroke. It seems there is a connection between new strokes or at least new findings on MRI with the aortic valve calcification score. The higher the score, the higher the number of these new lesions. And this is from another study. Again, the solid hits were higher, significantly higher in general during the procedure related to the valve calcium score, but also the solid hits were more frequent at valve positioning, during the valve positioning in these patients. We've seen earlier this from the study I described, and also in this study they found particularly that the right sinus of Valsalva calcium in the LVOT below the right sinus of Valsalva was connected to more strokes. But of course, there is some controversy. This is another study that took the Agason score by thousands, and they failed to find a connection between Agason score by thousands and stroke. And coronary occlusion, of course, is the other problem, because when we measure the valve to coronary distance, we have these three parameters: the sinus of Valsalva diameter, the valve diameter, and the leaflet thickness. If we have a very calcified and thick leaflet, this adds to this and it reduces the VTC compared to a thinner valve. And let's see this example. This was a lady at around 80 when this valve was implanted 6 years ago. This is a 26 Evolut R. And you can see the implantation that this valve appeared to fill in everything in the sinus of Valsalva, but of course, because of the open cells, there was no problem with the ostia of the coronaries. And now this lady comes back with severe stenosis, a gradient of 5, and this is the CT scan. So what would you do now? Would you, unfortunately, there's no option for valve-in-valve in this lady. So this is something we should always keep in mind, especially as we expand to lower-risk patients. Think of what will happen when this patient comes back for TAVI, because there's no point to do TAVI today and send this patient to surgery after 5 or 6 years. Of course, Basilica is here, but Basilica is not for everybody. It's not something generalized today, at least. And so how to manage in general the LVOT calcium? Careful screening, assess the CT scan ourselves, certainly prefer a self-expandable valve. It's safer, but you have a trained with more PVL. But if you go for a balloon expandable valve, you should avoid any oversizing. Probably just go 0% oversizing, and very careful when you do post-dilatation, always follow the smallest diameter rule for selecting a balloon. And finally, we may have to accept more PVL in these heavily calcified valves and plug if necessary. So this is what we did in that patient with a 5,000, more than 5,000 Agason score. This is the balloon where we assess how the calcium moves, and also we assess, we do a sizing test to see what kind of regurgitation we have with this balloon. And here is a 29 Evolut R valve. You see the opening of the valve, and the final result, very good result with this self-expanding valve, and you can see how well it's expanded. So you can get this result today. And a few more examples of patients with Agason scores of 5,000 or more. This is another patient with calcification in the LVOT and on the leaflets. You can see calcification of 13 millimeter extending down in the LVOT. Also horizontal aorta. This is a combination that makes things even worse. Very small right side, but good left side. Sizing is for 29. A self-expanding valve. This is the axial imaging. You can see the calcium, extensive calcium on the leaflets and below, the aortogram and LV gram. And again, this is a 29 Evolut R. You see it's compressed. And we do a post-dilatation because we had some moderate PVL, and this is our final result. Very often when you have that calcium, you see that you get a recoil of the valve. You dilate, you post-dilate the self-expanding valve, and when you deflate the balloon, the valve recoils and comes down again. And this is something that is disappointing when you see it. This is another result, another case with even more calcium, I would say, and also functional bicuspid valve, as you're going to see in the axial sequence. You see there is a raphe between the right and the left. And I give you the opportunity to see it again. And the calcium extending in the LVOT, the measurements, and the aortogram, LV. The balloon with a 20 millimeter diameter balloon. And you see how the calcium moves when you inflate the balloon. So this is the right cusp. You see the right cusp, how it goes out and touches the sinus of Valsalva there. And here is again an Evolut Pro, 29 millimeters. And as you would expect, it's very compressed because of this calcium. And you see this is an LAO view and this is an RAO view. On the RAO view, there is a lot of compression, so we come with post-dilatation. And here you will see the recoil I was telling you earlier. So observe how when the balloon deflates, the valve frame comes down again. But at least you know you did a post-dilatation, and this is the final result, certainly improved. You see how it was and how it became after the post-dilatation. And I think this is the last case. Again, a lot of calcium, close to 5,000. And here the calcium is on the anterior mitral valve leaflet. This is the area that is less of risk of rupture, as I've shown earlier, because it's distendable. Compared to other areas, but this is a lot of calcium, so you know from the beginning that you're going to have some paravalvular leak from this area. And this is like a rod of calcium also. So you have to be very careful with this anatomy. You should avoid balloon expandable valves. And again, a RAFI here, it's again a bicuspid valve to make things even worse with a lot of calcium. This is the highest risk of TAVI you're going to do. And here, the axial imaging from the CT scan to appreciate the calcium and the bicuspidity. And this is the orthography. This is a gradient we had at the beginning. This is a balloon. Another balloon, larger to access exactly where the calcium goes. So if you see that the calcium moves and threatens to go outside of the sinus of Valsalva, you know that you shouldn't go with something larger than this, and you should be even more careful. And this is a 2034, I believe, Evolute Pro, and the opening. And as you've seen, we've used self-expanding valves in all these scenarios, and with good result. But because the patient went into pulmonary edema during this procedure, very low ejection fraction, we did a post-dilatation. We didn't want to leave any paravalvular leave in this patient, and indeed there was no, and indeed he recovered very well the following day. This is the hemodynamics after the implantation, and this is the echocardiogram on the following day, no PVL, and improving left ventricular ejection fraction. Thank you for your attention.
Thank you, Kostas, for this really accurate and comprehensive talk. Well, according to your point of view, which kind of calcification is more prone to complications? I mean, if you have any more calcification, symmetric or less, and asymmetric, or to be accumulated in one cusp, for example. Well, the burden is enough to define the risk.
I think the more calcification you have, the higher the risk. This is the starting point. So if you have an Agassiz score of like more than 4,000, you start to treat this case differently. You know it's a high risk. If it's more than 5,000, it's too much. And if it's more than 6,000, probably you should say, okay step back. Probably this is not a patient for TAVI. You should go for surgery. And then you should go and see into the details of the CT scanning to see the distribution of the calcium. And as I showed earlier, that area is the high-risk area. When you have calcium in the LVOT below the left main and from the left main towards the right coronary artery, because this is an area that it doesn't have any coverage. So if you have a rupture there, it goes into the pericardium freely. There's no possibility of like a self-fulfilled tamponade there.
Okay. Is there any comment or question from the audience? From the no?
Can I ask a question?
Yeah.
Congratulations, Kostas. As you showed us, there are some recoil in the self-expanding valves, and in your case, there is also some refolding of the. It's not only that it shrinks; it seems like the struts fold inside. So, what do you do in this case?
Yeah. This is the worst. If you see a folding of a self-expanding valve, an evolute in this case, and this is the worst case scenario, and you cannot leave it like that, because if it gets a tendency to fold, it may keep folding the following days and may become like a U. And we have seen a case like this happening. So if you see that folding, you should post-dilate 100%. And make sure that you have done your best. I don't think there is a problem if there is compression. Compression is not a problem because this is a supraannular valve. So if it's compressed at the annulus or just below, the valve is still circular because it's supraannular. But folding is the one that you cannot leave the patient with.
If Dr. Triandafylou has nothing to say.
Just one small question. I have seen some case reports about the application of intravascular balloon lithotripsy for several cases of extremely calcified aortic valve. What's your opinion about this technique?
I think, first of all, it has some connection with a higher risk of stroke. Generally, as a general comment, I tend to use embolus protection, brain embolus protection when I have a very high Agatston score, or at least that's my intention. For IVL in the aortic valve, I think you have to use multiple balloons, 2 or 3, and it has to last for some time. You cannot just inflate and deflate. So I'm not sure you can have 3 balloons simultaneously and do IVL like for 20, 30 seconds. This increases the risk of the procedure. It's a very prolonged BAV with no circulation, and you should balance and weigh very well the risk of doing this versus following just the regular, the standard procedures that we are all doing, a pre-dilatation and then going with a safe, self-expanding valve. So it's not something that I would consider to do unless, like, I have calcium that is circular at the annular lever. So when it's completely circular at the annulus, and I know that I shouldn't break this with a balloon. That would be the only case I could think about it.
Okay. Well, we have no break. We may proceed to the next round. So thank you very much.
Good afternoon, everybody. I'm Dr. Pipilis, a clinical cardiologist here at the Hospital. I have with me Dr. Stamatis Adamopoulos from Onassion Hospital, Dr. Kostas Papadopoulos from the Inter-Balkan Hospital in Thessaloniki, and we have online also Professor Avramidis from Cyprus. I would like to welcome you in the next session, which is devoted on transcatheter edge-to-edge repair, and we will discuss important issues. First of all, we would like to thank the Transcatheter Valve Department and Dr. Sparias, the director, for organizing the conference, and congratulate him on his excellent clinical achievements and academic presence. With us, we have a very good faculty with echo experts and heart failure experts as well, as you will see. And without losing too much time, I would like to ask Dr. Michalis Chrysocheris, who is the Deputy Director in the Transcatheter Department, to start with the importance of echo guidance in transcatheter edge-to-edge repair from screening to procedure, which is very important in planning the procedure. Michalis, 20 minutes? Yeah?
Yep. Dear colleagues, thank you very much for the honor to be presenting in this conference.
We will be discussing in the next few minutes issues regarding echocardiographic screening of patients referred for transcatheter edge-to-edge repair, as well as issues pertaining to the procedures themselves as well. Can I have the slides, please? Okay. So the title of the talk is From Screening to Procedure, TEER Echo Guidance. So the main two devices that we have available is the MitraClip, which is now in generation 4, and the Pascal device, which has been CE marked for the past few years. For the Gen 4 MitraClip, we have multiple iterations. We have the wider devices and the smaller devices, and the devices that have longer arms and shorter arms. And depending on the characteristics of the valve itself, we can choose which one to implant. Most centers these days use the wide devices, and depending on the leaflet lengths, use either NT or XTW. For the Pascal device, it's already a wide device. The ACE iteration has a width of 6 millimeters, and the regular Pascal device is at 10 millimeters, with a span of 26 millimeters of the arms of the device when it's fully open. It's a device that's from nitinol, so it has the feature that it absorbs the vibrations of the valve during cardiac systole. When we get a patient that presents for screening for transcatheter edge-to-edge repair, there's multiple issues that we need to address: mechanism, severity, jet number, and location. But the most important one is the morphology of the leaflets themselves that we're going to be repairing, whether they have calcium indentations. We need a minimum leaflet length of at least 7 millimeters to be able to apply these devices. The valve area, so not to cause stenosis, the gradients, and everything else that's very important. For primary or organic mitral regurgitation, we have multiple phenotypes in this, where we have lesions on the leaflets, like this is a P2 flail, or a very wide anterior flail in this case, a complex posterior flail with multiple ruptured cords, a more localized posterior flail, and a medial commissure flail in the P3 area in this images here. For functional mitral regurgitation, we have essentially tethering of the leaflets could be symmetric or asymmetric, and secondary to that, significant regurgitation, ischemic or non-ischemic cardiomyopathy. And there's the entity of atrial functional MR, where we have primarily dilatation of the atria and annular dilatation causing secondary MR because of that. Regarding the severity estimation of mitral regurgitation, the most recent guidelines emphasize that we have the same criteria for severity between degenerative and functional mitral regurgitation with an ERO of 40. We could also assess severity of regurgitation by using multiplanar reconstruction and assessing the vena contracta area of the regurgitant jet. In terms of leaflet evaluation, we apply heavily this biplane imaging modality in order to get a very detailed appreciation of the anatomy of the leaflets. Especially in this case, as you can see, there is significant calcification of the annulus as well as the subvalve apparatus. And we have to be very thorough in assessing what's the mobile leaflet length of this mitral valve. And we see that we have at least 7 or 8 millimeters mobile on the anterior and posterior segments. With this granular way of understanding the morphology of the leaflets with biplane, we get a lot of information, and we apply it heavily to also focus and localize where the jet is and where we need to implant our devices. We supplant that with 3D echocardiography as well, and we get a more broad overview of the valve. And if we gain down the gains, we can see where the calcium distribution is. As we can see in the base of the anterior leaflet, there's a significant chunk of calcium in that area. Measuring 9 to 10 millimeters for the posterior leaflet and 8 millimeters of mobile leaflet length. This is a patient that was successfully treated with Pascal device. In terms of more advanced imaging, as we saw before, biplane imaging is the principal modality that we use, but it works very well with the orthogonal planes, when we work in the center of the valve in the A2P2 area, where the corresponding long axis view, which is plus 90 degrees, shows very well the mid part of the valve. However, when we move into the commissures, and especially in the medial or lateral commissure, then we cannot apply orthogonal. We have to be less orthogonal or more orthogonal, depending on if we're working the commissure, the medial or lateral commissure, to get a proper understanding of the coaptation zone of the valve in these areas. So, for instance, for the medial A3-P3 commissure, we have to go with the corresponding long axis plane to be at 110 degrees in this case. And for the lateral commissure, we have to go with more like in the 160s, 170 degrees long axis view. Another progress in the field that has allowed us to have a better understanding of the anatomy of the valve is the transillumination imaging, where applying a light source and seeing how the shadows develop in the anatomy, we can have a better feel of the pathology of this valve, creating a photorealistic effect. Further, we can use transillumination with transparency, which gives us a very nice interface between tissue and blood within the 3D data set, and it gives us a better delineation of cardiac anatomy and devices. Here we see a patient with a flail A1 to A2 with 2 ruptured cords, how it looks in photorealistic imaging and with transillumination. Further, we have the possibility of live 3D multiplanar reconstruction, in which case we get a 3D volume data set and we reconstruct the commissural and long axis planes in the upper 2 boxes, and on the left-hand corner on the bottom we have the short axis of the valve. And in this case, this way we can be very detailed about assessing each particular area of the valve, and we can move, for instance, here we're right in the center of the valve. If we move more towards the lateral commissure, we have the red line that intersects this area of prolapse, and we can see in the upper red box how the corresponding long axis view looks. And this allows us to be very accurate in measuring leaflet lengths and assessing the anatomy where we need to implant our devices. Here we're even further in the lateral commissure, and we see in the left upper hand corner how the leaflets look, how the coaptation looks in this area. And here we're back in the center of the valve, and if we go into the medial commissure, here we align the green bar to be in the coaptation zone, and then in the red bar is the corresponding long axis image that allows us to see that in this area we don't have anything significant, any significant pathology. Further, the use of transillumination with color allows us to understand better where the color jet is coming from and where we need to aim with our devices. This live 3D possibility is very important when we do procedures because it allows us, by reconstructing the commissural and long axis images, to have a better understanding of the trajectory and position of the devices when we steer towards the valve. And this is very useful to be able to, in one image, understand the whole procedure and be able to guide the whole procedure with one essential image. The only drawback is the decreased frame rate of these images, only 9 Hz, for instance. So we often have to go back to simultaneous biplane imaging as well. But this is a very nice tool to have. In addition, photorealistic imaging allows us to better understand the device over the valve and how it approximates the different structures inside the left atrium. Further, once we have deployed the valve, the device, we can go back to 3D multiplanar reconstruction and understand how much leaflet is inserted by scanning, for instance, a bit more medial to the device. We can measure the free length of the posterior leaflet and then understand how much leaflet we've captured within the device. Further, with photorealistic imaging and transillumination, we can also understand better where the residual jet might be located and how our device is implanted in the valve. With this, we'll proceed with a couple of cases that sort of highlight screening and procedural aspects of echocardiography. This is a 73-year-old gentleman referred for severe degenerative mitral regurgitation. For all these reasons, we did a thorough examination, and we found that he had a dilated left ventricle with an relatively preserved ejection fraction. There's a severe torrential mitral regurgitation from the medial commissure, and here we see why. We see the P3 area of the device being flail, and torrential color coming from this area as well. With 2D biplane imaging, we understand the severity. This is looking with photorealistic imaging from anterior. The medial commissure is on the left-hand side of the image, and torrential mitral regurgitation from that area. We can measure with multiplanar reconstruction the flail gap, which is about 14 millimeters, and the length of the leaflets, which was about 16 millimeters. Flow reversal in the pulmonary veins and torrential regurgitation, as we can see here. The valve area is assessed always with multiplanar reconstruction, 5.8 square centimeters. And we answer all these questions: severe degenerative MR with P3 flail, long leaflets, big valve, no gradient, and dilated left ventricle with an impaired systolic function, and moderate pulmonary hypertension. In this case, we opted for a wide MitraClip XTW, which we see here the process of transeptal puncture, which we do with the use of 3D en-face view of the atrial septum from the right atrium. Here we see the device, the catheters coming down from the SVC down into the right atrium and approaching the area. We want to be septal and posterior and superior on the fossa ovalis. And here we are ready to proceed with transeptal. The height should be adequate at more than 4.5 centimeters. In this case, it was 4.3. We can measure it also in the reverse four-chamber view if we don't have, if we're foreshortening in the other views. Here we've already been across the interatrial septum with photorealistic imaging. The insertion of the steerable guide catheter into the left atrium, and the device inserted, steering in the medial commissure in biplane imaging, and the 3D for alignment of the device along the coaptation zone in the A3-P3 area. We can have very nice images for the device with photorealistic imaging. And here we have the grasping of the leaflets with the device. Both leaflets are sitting on the device very nicely. The dropping of the grippers, and the final result with one device. Surprisingly, a very mild residual MR. And we see here we can assess with multiplanar reconstruction the insertion of the leaflets. This was a surprise because it was a very wide prolapse, and we were able with a wide XTW to seal the anatomy and have mild residual MR. And here we see that we essentially have a single orifice valve with a valve orifice area that was estimated to be adequate, and a mean gradient of 2. It was 2.06, the valve orifice area in the bigger orifice. And here's a patient with a mixed mitral regurgitation, a 74-year-old patient with dilated left ventricle, and moderately impaired left ventricular ejection fraction, and a severe regurgitation coming from a wide area of the coaptation zone. And we can see here that in the lateral segment of the valve, we have degenerated changes with prolapse and a ruptured cord. But in the medial side of the valve, there were features suggestive of a tethering effect. So that's why we classify this patient as a sort of a mixed functional and degenerative mitral regurgitation, probably a delayed presentation after a long period of time. With MV quantification, we can get this modeling of the valve and the leaflets and have several measurements. We see here that on the lateral side, we have the area of prolapse. On the medial side, we have more tethered of the leaflets and evidence of some functional. And the mitral valve area was estimated to be a very big valve at 10 square centimeters. And in this case, we opted for, we see here the screening of the valve we do with biplane imaging from one commissure to the other to understand the leaflets. With 3D color, again, we see the extent of the regurgitation with a bigger jet in the medial side of the valve but definitely a significant depth from the lateral side. To the vena contracta area, that was 1.5 square centimeters. So in this case, the patient, we proceeded with Pascal device, and we opted for a wide Pascal, the big Pascal device in the center of the valve that we can see here with optimization, a separate optimization initially of the, we have a separate grasping of the posterior leaflet, and in the subsequent images, because we had significant medial regurgitation, we optimized it further, and this is a release of this Pascal. And then we had this appearance of significant regurgitation from the lateral side of the valve, in which case we assessed that we had a good residual orifice, and we went ahead with the Pascal ACE, which is the narrower version of the Pascal, and we implanted 1 Pascal in this area here in the lateral side after aligning, and this is the dropping of the clasps that you're going to see here. The single most important thing with these procedures is to have, if you can, document the closing of the device to understand that we have secure leaflet insertion. And with these devices, we have no problem optimizing them if we have any doubts or any reservations about how much leaflet we have inside. It's something that we do. We have still residual significant MR further lateral, and another device will be implanted in this area here as well, another Pascal ACE. Right next to the other one. It's very important to be parallel with the previous device, so it will be right next to each other. And this is the final result, the final mean gradient after releasing the 3rd Pascal device with a good reduction of this torrential mitral regurgitation to mild to moderate degrees. We can assess with multiplanar reconstruction each individual Pascal device that we've implanted. Here's the original one in the center, and this is the 2nd Pascal device, and this is the 3rd Pascal device. We can assess each individual one as to how well they've been, the leaflets are inside, and we can measure with multiplanar reconstruction all orifices, and we can see with the photorealistic color where this residual color is coming from. With that, I would like to conclude that thorough echocardiographic screening is imperative for mitral TEER procedures. It sets the stage for a successful procedure. The newer imaging modalities that we have, that we saw, enhance our understanding of the mitral valve pathology, and also have tools that can help us better be more accurate in our implantations and add to procedural efficiency. Thank you very much for your attention.
Thank you very much, Dr. Chrysocheris. Is there any question from the audience?
Kali, thank you very much for an excellent presentation and sharing with us your excellent also experience. Correct me, my understanding is that the success of TER depends on the severity of MR, of the success of the good intervention result, of course, but also the contractile reserve. Do you advocate in some sort of equivocal cases to perform either dobutamine Streseco or maybe CMR in order to estimate the scar burden? If we've got a scar burden, let's say more than 25 to 30%, the clinical and hemodynamic results are not very inviting, not very promising.
Yeah, that's the holy grail in functional mitral regurgitation, is to understand whether it's a proportionate or disproportionate degree of regurgitation. For many patients with secondary MR, the main driver of symptom is actually the severe mitral regurgitation, which is something that they can live with an ejection fraction of 25%, but they cannot live with severe regurgitation. So definitely all these patients that are referred to as must be on optimal pharmacologic treatment, including the latest medications. And we have a low threshold to consider further imaging for the scar burden, as you mentioned, and so on. But I think the main thing is how convinced we are that the degree of regurgitation is really disproportionate to what you would expect for this patient.
Right. Okay, thank you very much.
Michalis, congratulations
for the excellent topic. We've done lots of cases together. We never followed the Everest criteria. We've done commissures, flails, acute MR cases. So, which one is the valve that we shouldn't touch finally with these new devices?
I think calcium is an enemy of our procedure, both in the TAVI, in the aortic valve, also in the mitral space. If we have significant calcification and evidence of stenosis, then definitely these are, or with patients who have mixed mitral valve disease, then these are patients that we cannot really approach. Then we have to discuss other interventions. Definitely, if you don't have good imaging, if you cannot see, then that's another limitation of this technology. But in general, the reason we've expanded to other non-Everest anatomies is because if you can see it and you have decent enough leaflet length to grasp, then you probably can have a good effect, reduce the MR without causing, and you can predict which patients may have stenosis afterwards. So if you can have a decent enough valve size, valve orifice size, then you can definitely proceed safely with edge-to-edge repair.
And in a kind of stenotic valve or a valve with MV ring, a previous repaired valve, would you suggest Pascal or MitraClip?
I think for patients who have old annuloplasty and relapse of significant regurgitation, there is the possibility of edge-to-edge repair, depending on the anatomical features and the leaflet morphology as well. If you have good enough leaflet length to grasp, these cases have been done with MitraClip as well as Pascal. I think Pascal has we have the option now to choose between a nitinol device, which is the Pascal, and a cobalt chromium device, which is the MitraClip. We would opt for the nitinol device in patients who have very calcified anatomies, short mobile leaflet lengths that we're concerned about the possibility of avulsion of the leaflet if we closed very aggressively with a MitraClip device versus a nitinol device may be more softer on these anatomies.
And it works like a spring, Pascal.
Yeah,
so doesn't create a high ingredient at the end, I guess.
Yeah, technically speaking, it has this coil. It's like a nitinol device that follows the vibrations of the valve, and it's in a way a bit more friendly to the valve anatomy. So we tend to consider it over the MitraClip in patients who have calcified anatomies and short leaflets in general.
Dr. Avramidis, hello from Cyprus. Do you have any comments or any questions?
Hello from Nicosia. Mihaly, that was a great lecture. I very much enjoyed it. Now, I'm interested in pushing the boundaries. And this was touched on earlier. If you have a patient who is borderline, so you have a very big LV, maybe 18 millimeters, 20% ejection fraction. And despite optimal medical therapy, he's still very symptomatic. Should we go on with repair or should we not? What's your opinion?
I think that the transcatheter edge-to-edge repair is a very low morbidity procedure, technically speaking. So if we're convinced that this patient has significant disproportionate MR, then I think it's more than justifiable to go ahead and proceed with the procedure. Definitely, surgery would be a high-risk procedure and probably not indicated at all. But for edge-to-edge repair, the morbidity is very low. And technically speaking, we would definitely consider the patient.
Great, thank you.
Okay, we'll ask Dr. Adamopoulos to present the next speaker.
Is Stefan with us?
Yes.
Hi, Stefan. Hi, Stefan. This is Stamatis.
Yes, Stan, good to see you. Good to see everybody.
Very nice to see you. And I'm actually, Stefan, honored to introduce Professor Anker, one of the most influential European personalities in the demanding field of heart failure. Actually, Stefan served as president in the past of Heart Failure Association, is the next editor of the European Journal of Heart Failure, with enormous contribution through pioneering studies in the pathophysiology and therapy in heart failure. A recent example, Stefan, of your crucial role in heart failure is the beneficial effects of empagliflozin, the SGLT2 inhibitor, in preserved ejection fraction, heart failure with preserved ejection fraction, through the Emperor Preserved trial, the first study with robust, with favorable findings in this category of patients. So Stefan will talk to us about HFpEF therapy in 2022, guidelines, probably they have to rewritten, new evidence and the pipeline.
Hello, everybody. It's a great pleasure to really talk at your conference in Greece. I'm sorry I can't be there in person, but good friends everywhere, and really we need to move forward, improving the care for heart failure patients. One important part is heart failure with a preserved ejection fraction, and I would like to give a very quick update of what is going on there. Well, in heart failure with a preserved ejection fraction, really as a big component of heart failure overall, at least half of all heart failure patients do have HFpEF. In the last 15 years, we tried to make progress with different therapies, but quite often rather unsuccessfully. The patients suffer, they have poor quality of life symptoms. The patients basically also have an increased mortality. And in order to target what is going on, we know that they have many comorbidities, and this leads, of course, to many treatments being given. For instance, when you think about the polypharmacy of these patients, and polypharmacy is defined when patients have at least 10 different treatments in terms of pills, you can see that quite a big proportion of patients has well above 10 such treatments. And this is even without the inclusion of devices in the therapy. Now, with the new diagnostic algorithms, we basically look here for natriuretic peptide levels to really exclude heart failure being present. But when we think there is heart failure, we need to look into more detail about the ejection fraction. And particularly in this presentation, I'm concerned about patients with ejection fractions above 40%, mid-range ejection fraction when it is up to 49%, and 50% and higher heart failure with a preserved ejection fraction. Now, our guidelines make a number of recommendations now, and for the HFmrEF patients, they are built on the subgroup analysis and meta-analysis we know from several trials. This relates to RAS inhibitors, beta blockers, MRAs, but also sacubitril valsartan. In terms of devices, we don't have very much there yet, but I hope that in the future we can achieve this. But this may be also something for our discussion later on. When we are talking about true HFpEF patients, 50% and higher, then targeting the comorbidities and diuretics were recommended recently. But of course, you know there is new evidence, and I will cover this. When it comes to the beta blockers, candesartan as the example for an ARB, or spironolactone as an example for the MRAs, as early as 2019, we started to recognize that these mid-range ejection fraction patients should already get therapies. And here are some of the results that are the basis of this. This is the CHARM preserved study. In the CHARM preserved study, the overall result where borderline kind of showed a trend. You can see a reductions of 10, 11, 12% for the hazard ratios. But if you look at the right-hand side, there was something very significant, recurrent events for heart failure hospitalizations, that today we would recognize as a full success. If you then take the TopCat study and spironolactone, very similarly, the total number of heart failure hospitalizations was really strongly reduced. But at the time, we didn't have these recurrent events as an analysis, as we have done now also in our device trials. At this time, we didn't have this as the primary outcome. So the overall primary outcome, as you can see here on the left, was not quite significant. So near misses already twice. And another near miss, the Paragon HF trial, 13% reduction, this time really looking at recurrent events, but still the p-value 0.06 didn't quite make it. So several times we were very close. Now there is some interesting additional information. For instance, there was a sex interaction that women actually receiving sacubitril valsartan had quite a big benefit with 27%, men not at all. There is no biological rationale. So we were focusing really on ejection fraction. And if the ejection fraction in the Paragon trial was below the median, 57% and less, then there was quite a significant effect. But in the patient with higher ejection fractions, there was nothing at all. So what about devices? Is there any evidence that we can use devices in such patients? And the first data came actually not from a device for treatment, but from a device for diagnosis. In the Champion trial, CardioMEMS device was used, and you can see here the recurrent rates of heart failure hospitalizations. When you measure the pulmonary artery pressure, you can, when you adjust by this, then the treatment of the heart failure patients, you can reduce the events. And particularly in higher ejection fraction patients, here even above 50%, we see a very strong benefit. But we have to be honest, the event rates and the number of events was actually rather small. So we need to repeat these kind of tests. But very much encouraging that something can be achieved for HFpEF patients. So where's the near-term future? With regards to devices, there is the CCM trial, the AIM Higher study. 1,500 patients is a morbidity mortality trial for cardiac contractility modulation for patients with ejection fraction of 40 to 60%. And despite the unsuccessful COVIA study with intraatrial shunts, there are several other trials ongoing, the Relief HF trial, and very soon also the Frost HF trial with Occlutech, trying to still improve the outcomes of HFpEF patients also using devices. Now, again, this is the target, have basically a big success in patients with 50% and higher, but of course, it's difficult to achieve. Let's see whether what we can have done in the CardioMEMS Champion trial for these patients can be achieved. Well, with regards to the true HFpEF patients, this is the current recommendations. Focus on the comorbidities, focus on symptomatic management. We need to improve of it. And one big and important trial that I think is now indicating to us that we can improve on this is the Emperor Preserve trial. This trial was very successful in that it actually reduced the event rates for cardiovascular death and heart failure hospitalization by 21%. We reported on it in August last year. Empagliflozin versus placebo was compared in patients with ejection fractions above 40%. And interestingly, when the patients were followed for 26 months, and overall you see these very significant results, but already after 18 days, the results were significantly positive. So this is really encouraging. When you look into the subgroups, it worked for the diabetic and non-diabetic patients. You know that empagliflozin is an anti-diabetic drug, but now, since the time that they were tested in the reduced ejection fraction heart failure patients and worked in diabetic and non-diabetic patients, we know that SGLT2 inhibitors also bring about benefits in non-diabetic patients with heart failure. And this is also true in Emperor Preserve, where you can see here that both in diabetic and non-diabetic patients, we have significant results. Now, in contrast to what I showed you about the Paragon trial, also for men and women, we have significant results. So this is very encouraging. And if you then look into the baseline therapies of patients, what if they already receive MRAs? What if they already receive a RASI? Still, empagliflozin gives extra benefit. And if you look into the ejection fraction, there is no significant trend. The treatment works in all the patients, and this is a good signal. Now, there's more than just the primary endpoint, which was cardiovascular death and heart failure hospitalization. There is also first and recurrent heart failure hospitalization, reduced by 27%. And there is also the kidney function over time. The slope of the decline of GFR was significantly reduced. So there is a protection of kidney function over time. Quality of life is also improved. Here you see the Kansas City cardiomyopathy questionnaire. However, this is maybe one domain where devices can do much better. Clearly, drug treatment in HFpEF is not as good yet, as we know that many devices can make it for patients. I think we can still do much better for it. So as a first summary from this year, Emperor Preserved is now a clearly positive, unequivocally positive trial compared to all the previous trials that gave us some good signals, but were not successful at all. If we look specifically, and this is new data that we are just about to publish for the true HFpEF patients with ejection fractions of above and equal 50%, then I think we can also see that there's a 17% benefit in those patients with 50% and higher. Here are the results for other previous trials. Clearly, we now have a drug that works. So why do I say all of this in a conference that focuses really on, for instance, the treatment of valvular disease? I think that we have a good idea about the phenotypic approach in HFrEF patients. I suggested to you maybe in the future we should also use a phenotyping strategy for the HFpEF patients. And phenotyping can be many things: atrial fibrillation, high heart rate, it can be iron deficiency. Maybe it can also be valvular function. And certainly in the revised ReShape HF2 trial, we are now moving to include patients up to 50%, so that at least the component of the HFmrEF patients who have functional mitral regurg, maybe also atrial mitral regurg, that these patients are included and we gain knowledge about them. At this moment, I would like to also say, whatever we do in our device trials, we have to give patients best underlying therapy. And this best underlying therapy in HFpEF patients, in patients with ejection fractions above 40%, definitely now needs to include SGLT2 inhibitors. You may have seen only like last week, also the DELIVER trial with dapagliflozin reported positive. Its headline results were announced in a press release. We know the trial worked out, so we have now 2 HFpEF trials with positive results. The details we will probably see at the ESC Congress end of August. But in HFpEF, when you do new interventions, SGLT2 inhibitors need to be on board. If we do continue with intervention trials in HFrEF, all of this needs to be on board. We need to have the foundational therapies there already. So I'm looking forward to the discussion how we better can improve device therapies for all of these patients, but we need to understand they need to have a good foundational therapy, and this is what it is. In HFrEF, in HFpEF, it's so far really only SGLT2 inhibitors, of course, together with diuretics. Thank you for your attention, and I'm looking forward for the discussion.
Stefan, very happy to listen to you very carefully, to your excellent presentation, but very happy to spread the word about the new pharmacological approach in HFpEF therapy. Actually, Emperor Preserved was not designed for mildly reduced ejection fraction, but 1/3 of this population belong to this sort of range, between 40 and 50%. Don't you think that Emperor provides us the opportunity to change in the foreseeable future, in some amendment, in some modification, in some update, the level of recommendation from 2B to 2A for SGLT2, especially with empagliflozin? Because I think it's the first drug of the big 4, big 5, whatever is the approach that provides us very robust data in this mildly reduced population. What do you think?
Yeah, thank you so much. Well, basically, I think this is a strong opportunity for the patients with HFmrEF that SGLT2 inhibitors in the near future will, for HFmrEF, but also for true HFpEF, have a class 1 recommendation. I'm saying this not only because of the Emperor trial results, but really also because We now know that the DELIVER study
That's
overall is successful. And with DELIVER and the Emperor together, it should very likely, of course, we haven't seen all the details yet, should very likely be an upgrade in the recommendation.
So it's a class effect then. You're right. I don't know if you would like to comment about MRA, about aldosterone antagonists, because Top Cat was not nicely designed, but we used to use aldosterone antagonists, especially spironolactone, in HFpEF patients. And I don't know if you would like to comment with you've got this sort of experience. That's why I'm asking you, Stefan. I don't know if you would like to comment about finerenone, the specific MRA inhibitor, especially after Fidelio study in patients with diabetes and chronic kidney disease. I think it's imminently coming in the HFpEF area, isn't it? Finerenone, I mean. We lost. Αυτός. Και να θέλαμε δηλαδή. Okay. Ωραία, απλώς το ρωτούσα ότι η σπυρονολακτόνη... I'm sorry, that's right. Είναι... Shall we proceed to the second? Okay, anyway, we use aldosterone in this sort of category of patients with nice results. So despite the approach of the guidelines that diuretics is the only pharmacological approach to this sort of patients, aldosterone antagonists are quite useful, and finerenone is one of those, but which is now being studied for this category of patients. We've got nice results with finerenone in diabetic patients with kidney disease, regardless of heart failure. But there's a study, there's an ongoing study, and we're going to have in a couple of years the results with respect to finerenone in HFpEF. I think we have to carry on. Kostas? Yeah. Sorry, Kostas. Another Kostas. Is he with us?
The advantage to ask you guys.
Yeah.
Is there any end, as an interventional cardiologist, we have all the pharmacological treatments that we see, they are coming, they're improving outcomes in HFrEF, HFpEF. We have seen the SGLT2, sacubitril valsartan. We have seen that CRT is also improving outcomes, reduces MR. We have seen that preservation of sinus rhythm also has been shown to reduce FMR. So is there an end to this optimal medical treatment, non-device treatment, before start thinking about TER, transcatheter edge-to-edge repair?
If I may continue on that, it's important if mitral regurgitation is an endpoint in any studies of heart failure with reduced ejection fraction as a secondary endpoint, because that's important as a...
I mean, where do we stop? Do we say, oh, this patient has these two drugs, you have to put another two, you have to convert the sinus rhythm, and then think about it? Because when you have a patient with symptoms, like severe MR, you have to prioritize things, and we need to find a consensus between us, heart failure doctors, general cardiologists, and interventional cardiologists. Where do we stop, and where do we move to a device treatment?
Very difficult question. I think we have to react quickly. Although theoretically, Kostas, our approach is to finish with the big four. I mean, beta blockers, ARNIs, SGLT2s, and MRAs, and with CRT, which by definition might reduce the degree of mitral regurgitation. I think we have to act simultaneously. Very quickly, we have to titrate and to implant the CRT as well if it's indicated, and decide to reduce the burden, left ventricular burden with mitral regurgitation. Stefan, just to finish my approach, for us, especially this mitral clip or mitral valve repair approach is very important for us because we delay the evolution, the progress of heart failure. And there is a registry where, especially in the class 3, even class 4 patients with TER, where 2/3 of the patients listed actually for heart transplantation or about to be listed for heart transplantation, 2/3 had an uneventful first year without heart failure hospitalization, without valve implantation, without heart transplantation, and 1/4 of them were delisted because of the improvement of their situation. So for us, TER, mitral valve repair, is of paramount importance, and we have to act not with preemptive strike, but act in a proper time. Would you like to, yes? Kostas?
Yeah, just continuing on my previous question. Hi, Stefan, this is Kostas. I don't know if you can hear us now. Welcome back.
Yeah, I can hear you very well.
I was asking about the balance between pharmaceutical and non-device treatment and the timing of the device treatment. And I'd like to know, would you get a patient with disproportionate MR and be more aggressive with device treatment instead of a patient who has like proportionate MR? I mean, get a patient with proportionate MR and delay more, trying to be optimal in all the medical treatments that are coming now. But when you have a patient with disproportionate MR, then this patient has probably have to act earlier. Would you agree with this approach?
I would actually fully agree with your approach. Yeah. I mean, it's always a good idea to try to optimize medication, but exactly the patient, as you indicated, with disproportionate, maybe we should really target them differently and give a higher priority to the devices as early as possible. But if you agree, particularly in the HFrEF, in the HFmREF, in the HFpEF space, there, of course, we need to have more research and data. But in the HFrEF space, sure, I agree.
Yeah. Costa, sometimes we are reluctant. We were discussing last week, if you remember, we're reluctant to perform this soft TER in the mitral valve in patients with pulmonary hypertension above, let's say, 70. But even in this category of patients, because it is not a coab profile patient, the patient with a high pulmonary hypertension, but still this sort of patient might have reversible pulmonary hypertension. So even in this sort of patient, we have to give an O or nitroprusside in order to see if we've got a reversible pulmonary hypertension reduction of PVR. So even this sort of, let's say, advanced heart failure patients with pulmonary hypertension, they might be benefited, and they might belong to this sort of mitral bridge population I've just mentioned. Yes, thank you very much, Stefan, for your excellent contribution and for your friendship and for your collaboration throughout the years.
Yes, and thank you, and hopefully some of you we meet next week in Madrid. Talk soon.
Yes, I'll see you there.
Bye-bye.
Okay, we'll continue now with Dr. Papadopoulos, who will introduce the next speaker.
Yeah. Now we will continue with Professor Rebecca Hahn from Columbia University. She will talk about prediction of transcatheter edge surgery repair, clinical and technical success.
I'd like to thank the conference organizers for inviting me to speak today on the prediction of mitral transcatheter edge-to-edge repair, clinical and technical success. I'm Rebecca Hahn, and these are my disclosures. How does Mitral Valve Academic Research Consortium define success? The technical or procedural success measured at the exit from the cath lab should include the successful deployment and correct positioning of the first intended device. In addition, device success should be measured at 30 days and at post-procedural intervals, and should include a reduction of mitral regurgitation to either optimal or acceptable levels without significant mitral stenosis, defined in the guideline as an area of greater than 1.5 or greater than or equal to 1.5 centimeters squared and a transmitral mean gradient of less than 5 millimeters of mercury. Optimal mitral regurgitation reduction reduces the MR to trace or absent, and acceptable reduces MR by at least one class or grade from baseline and to no more than moderate MR in severity. Patient success measured at 1 year includes device success and then other metrics of functional and quality of life improvements. Predictors of outcomes following transcatheter edge-to-edge mitral valve repair have been recently reviewed. In this review, you'll see clinical factors that define outcomes, echo factors, procedural factors, and biomarkers. And those outcomes include all-cause mortality, cardiac mortality, heart failure rehospitalization, major adverse cardiac events, and device failure. Now, for clinical factors, one should consider that indeed is New York Heart Association class, so symptomatology, as well as whether or not there's an ischemic cardiomyopathy, prior aortic valve surgery, atrial fibrillation, baseline renal function, as well as the surgical risk scores. Echocardiographically, one should evaluate the mitral valve, and on the left-hand side, you see the parameters that have been associated with adverse device outcomes. The AP diameter, as well as the medial lateral diameter of the LV inflow orifice, the flail width, and the mitral valve orifice all determine outcomes. In addition, non-mitral apparatus-related echocardiographic predictors of adverse outcomes following mitral tear include LV size and function, right ventricular dysfunction, pulmonary hypertension, and the severity of tricuspid regurgitation. Some of these predictors are the same for the prediction of an unsuccessful surgical repair outlined in the European guidelines. When one looks at the anatomic suitability for TEER and therefore the prediction of device success, one can look at a variety of parameters. This happens to be the German classification divided into the optimal, complex, and very complex valve morphologies, perhaps indicative of a green, yellow, and red zone. And you can see that posterior leaflet mobility, as well as multi-segment pathologies and poor leaflet quality, may indeed define a patient population that may have suboptimal mitral tear results. This red zone has recently been defined by the Heart Valve Collaboratory and published by Scott Lim and co-authors. As you can see here, anatomies associated with stenosis include mitral annular calcification and calcified leaflets, as well as small mitral valve orifices. Anatomies associated with inadequate mitral regurgitation reduction include extreme valve complexity, cleft leaflets, shortened posterior leaflets, as you can see here, severely tethered leaflets, and large coaptation gaps. And then finally, there are some anatomies that may actually reduce the ability to perform either transeptal puncture or inability to grasp the leaflets by TEE imaging. This is an example that you see on the right-hand side of an interrupted IVC, which did not permit the advancement of the guide. In addition, clinical factors should also be considered as a red zone. Patients without a meaningful survival or with non-severe mitral regurgitation, non-moderate or severe, and those on inotropic support unrelated to mitral regurgitation might be patients unsuitable for TEER. The green and yellow zones are a work in progress at this time, but include many of the parameters that have already been discussed. And the issue really becomes that as we iterate the devices, and you can see that for the mitral clip device, there's now NT, NTW, XT, and XTW devices. And for the Pascal device, there is the P10 and the ACE device. And so the anatomic considerations and choice of device size and type may change over time. We know the periprocedural factors are also important to monitor. We would like to see a decrease in the V wave and during right after the procedure, and we would like to obviously see the reduction in mitral regurgitation while maintaining a mitral valve area and a low mean gradient. But in addition, the periprocedural complications like pulmonary embolus or acute cardiogenic shock, bleeding, pericardial tamponade, these are all complications that will determine in-hospital mortality. When one looks at the post-procedural echocardiographic predictors of mortality, heart failure, and reintervention after TEER, you can see that post-procedural mitral valve orifice area of less than or equal to 1.94 centimeters squared may determine outcomes. We've used also a valve area of less than or equal to 1.2 centimeters squared per meter squared, so indexing for body size, understanding that small patients may not require the same valve areas. We also look at residual mitral regurgitation, preferably by 3D vena contracta area, using a cutoff of 20 to 25 millimeters squared to determine whether or not a second device might be necessary. Transvalvular mitral valve pressure gradients of greater than 4.4 have been associated in both primary and secondary disease with adverse outcomes, but multiple studies really showing that possibly may be more important in primary MR. Now, the ASE, the American Society of Echocardiography, has published its guidelines for assessing residual regurgitation after device therapy. You can see that for the edge-to-edge repair device, that a small vena contracta and small convergence zone will be some of the parameters we would use to determine the significant reduction in mitral regurgitation. But my personal favorite is the 3D vena contracta area, as noted, with our cutoff of somewhere around 20 to 25 millimeters squared to determine whether or not a second device may be necessary. This study shows that in some patients after percutaneous mitral valve repair, that a vena contracta area reduction by greater than 50% compared to those with less reduction have improvements in left atrial and left ventricular remodeling. And so again, in some of the more difficult patients, one should have a realistic view of the reduction that you expect to see after the mitral TEER device. When one looks at transmitral gradients following transcatheter edge-to-edge repair, we know that in the study coming out of the COAP trial by Halaby, that mean gradients do not seem to determine outcomes in secondary mitral regurgitation, whereas for primary regurgitation, studies have suggested that mean gradients do indeed predict outcomes. Now, other studies suggest that mean gradients are important even for secondary mitral regurgitation. And the Yoon study that it's recently published suggests that mean gradients may not be important for primary disease. And so at this particular time, there's a lot of discordant results about mean gradients. And some of that may be related to the fact that mean gradients do not only reflect the mitral valve area or the severity of mitral regurgitation, but also are very dependent upon heart rate and flow. So increase in stroke volume and an increase in heart rate will actually increase transmitral gradients. In this study of native mitral stenosis, the authors look to correct transmitral mean gradients for heart rate and flow. And in that setting, we're able to detect significant outcomes associated with high corrected gradients. This may be something that may be of importance after TEER as well. The other way of assessing hemodynamic success is invasive. So inside the cath lab, we would often not only look for a reduction in the V wave, but also reduction in mean pressure and a reduction in pulmonary pressures and an increase in systolic blood pressure, which would be indicative of increased forward flow. We, on echocardiography, like to look at the resumption of forward systolic flow in the pulmonary veins. In this study, the S to D velocity time integral ratio of less than 0.72 was associated with adverse cardiovascular events. So when you can improve that ratio to greater than or equal to 0.72, then you have much better outcomes at 12 months. This is a second study that looks at any change in the morphology of the pulmonary venous inflow, so any improvement at all. And if you have any improvement, whether it's from reversal to blunting or blunting to systolic dominant, those patients also have a better 2-year outcome. The other parameters to look at are the biomarkers, so NT-proBNP and troponin T, significantly associated with outcomes, as well as some of these other biomarkers. And so we now know that we have a number of clinical factors, echocardiographic factors, procedural factors, and biomarkers that may help identify patients who are at risk for adverse outcomes. And in selection and risk stratification of these patients, which previously have been based on surgical prognostic scores and technical feasibility, one must also consider the clinical, structural, and procedural factors that affect prognosis after transcatheter edge-to-edge mitral valve repair. And these should be integrated into the pre-procedural evaluation and follow-up of these patients. A better understanding of the factors that affect prognosis in patients undergoing this device might improve management of the high-risk patients that we are currently seeing with severe mitral regurgitation. Thanks for your attention.
Thank you, Professor Han, for this great lecture. She's not with us, I guess. Okay. So, Dr. Spargas, in primary MR, things are easier than in FMR for the criteria to implant an edge-to-edge repair device. You have a high-risk patient, you have the anatomic criteria, so you go for the implantation. In FMR cases, we need to predict which patient is going to have a benefit from this method. So, according to your experience, which patient would you reject from edge-to-edge repair? The patient with a very low ejection fraction in FMR cases, a patient who is hemodynamically unstable, a very ill patient.
The patient with right ventricular, profound right ventricular failure with tricuspid regurgitation.
The spectrum of FMR patients is really huge, and you can get from the unstable patients, the compensated heart failure, terminal patients, to patients that are relatively well, but they have MR, and then there is the question of if this MR is real, is disproportionate, or if it's an MR that would normally follow and fit this type of left ventricular dysfunction, proportional MR. So if we have, like Becky said, the clinical criteria, the anatomical criteria, and the markers. So the anatomical criteria are the same. So if you have a patient that has mixed mitral valve disease, so there is also the component of stenosis, then certainly it's no. But if you have calcium, this is where Pascal made an advancement. We can now be more aggressive with TEER in patients with calcified annulus with some calcium on the leaflets. And it's safer and probably with less reduction of the area. And then is the length of the posterior leaflet. This is a very crucial factor. It's the first thing we see. If the posterior leaflet is sufficient length to grasp it. we need ideally more than 8 millimeters. If you have less than 8 millimeters, then it may be difficult. And then is the number of jets. If usually in FMR you have a central jet or slightly lateral in ischemic MR. But if it's mixed and you have multiple jets arising from different sites in the coaptation zone, then again this is a problem. And now if you go to the severe, how unstable is the patient, this is very important. On one hand, you don't want to treat a patient who is futile, but on the other hand, you don't want to reject a patient of the last potential benefit. And this balance sometimes is very difficult, and I think these are the patients that got into the MITRA France study and diluted the results. So if you get this like end-stage patients, you may have a successful procedure, reduction of FMR, some symptomatic improvement, because even these patients have some symptomatic improvement, but you may not influence long-term survival. So we should be careful on our judgment in those patients that do not fulfill the COAPT criteria, but we should not be completely negative on them. And all our efforts should be to get them before they reach to that final and terminal stage, because then they can really benefit, even on mortality terms. If we get them very late, if we let them go to that stage, then if we do a procedure, it will be just for symptomatic relief, probably.
Is there a level of pulmonary hypertension which is prohibitive? You say they mentioned 70, or?
In COAPT, they use the 70 echocardiographically, but we have series, published series of patients with more than that, that they also benefited. But certainly, if you have a patient with severe pulmonary hypertension, this is also a contraindication, let's say, for surgical approach. And again, you fell into that area, you say, should I reject the patient and do nothing on him, or offer the last possible, the last chance, the last hope? What
but it might not be fixed. So we have to see the reversibility.
This is exactly what I'm going to say now. What you said earlier, that even in those patients, measuring the pulmonary pressure just on echo at one time point may not be fair, because we know that if you upload the patient, if you unload the patient, or if you give treatments that reduce pulmonary resistance, you may change that. And the other thing is that there may be a difference, a discordance between the pulmonary pressure measurement on echo and the pulmonary pressure measurement on hemodynamically, invasively. And these patients that they have this discordance, they have the worst outcome. Something we should
The sub-studies of COAPT and MITRA-FR recently concluded that proportionality might not be the only answer for the differences between these two trials. And they say now that we should include not only ERO, but also regurgitant volume in the equation. And of course, we should take into account RV function and tricuspid regurgitation as well. But one last question from my side. How often, now that you repair also the tricuspid valve, how often do you go for a double repair, mitral and tricuspid valve, in these functional MR cases?
First of all, we don't have in Greece those volumes of tricuspid repair. We still have a problem with approval, so we have the patients, but it's not so often to go and offer this therapy for bureaucratic reasons. But we tried both. We tried concomitant treatment and we try it at different times. I think it depends on how easy is the mitral tear. If it's easy, quick, without problems, and if TR is severe with dilated annulus of the tricuspid valve, then you might say, okay, it only took 1 hour or 40 minutes. You know that this TR is not going to go away, so you do it at the same time. But if you get engaged into a difficult MR mitral tear that lasts 2 or 3 hours, it's crazy to try and prolong a procedure in these high-risk patients. So you better go separately. And the other thing, when you go separately, you have this small proportion of patients that they improve their TR after you correct the MR. It's difficult to predict who will do it, but we know from studies that up to 30% they improve their TR after you correct the MR. Especially those who don't have the severe TR and who don't have those hugely dilated annuli.
There are a couple of German, or just looking in the literature, a couple of German registries, retrospectively anyway, favoring the concurrent. In class 3 and 4, actually, heart failure patients, the concurrent repair improves the survival. But
I think in the future, as we gather,
we need randomized studies.
We
right?
gather experience in tricuspid tear, and this is happening now. It will become easier, faster, so I think it's unfair to judge from the experience we have so far, which is very little in the tricuspid field. In the future, when we expand and we have more experience, I think it will be easier to make these judgments.
Do we have any questions from the audience? Okay.
Dr. Avramidis.
Dr. Maginas, and then we will continue to the next speaker.
Yeah. One second, Dr. Avramidis.
Just a small one. Thank you very
Yes.
much. Let's assume that technically you can grasp the leaflets. And in my impression is that almost all patients benefit clinically from TEER. So the question really is, and also the pulmonary pressures fall and people feel better. The question in my mind is that we should select the patients who can have a long-standing benefit clinically and from the test, because the disease is progressive. You cannot alter the myocardial problem. This continues to deteriorate, and at some point it will come back in terms of symptoms. So we should select patients who will benefit clinically not only for 4, 5, 6 months, but for 2, 3, 4 years. And this is the target.
Because some of them will be a futile treatment, and you're going to correct the mitral regurgitation, but not the pump failure. The pump failure will be there, and it's very difficult to distinguish which symptoms will be from one or the other. And probably Costa's work on this, on getting some sense of the myocardial reserves, even in those patients with low ejection fraction, either by echo, stress echo, or MRI, even to see for fibrosis, will be helpful. And I think there is a lot of research work going on in this field now, and we'll see the results soon.
Dr. Avramidis, if you have any comments, and then you can proceed to the next speaker.
Thank you, Dr. Adamopoulos. In fact, my question was the same as yours on pulmonary hypertension. It was very ably answered by Kostas. Before introducing the next speaker, I would like to grab the opportunity of congratulating Kostas, Parias, and all the organizers for such a wonderful seminar. In fact, if you look at all the titles, everything that you want to be answered about this field will be answered if you can stick it out for 2 whole days. So that's congratulations. Now, it's a pleasure to invite the next speaker. It's Dr. Koulogiannis from Morristown in New Jersey in the US. And Dr. Koulogiannis who will be speaking on the imaging assessment of TEER success and complications.
Γεια σας. My name is Konstantinos Koulogiannis. I'm from Morristown Medical Center in Morristown, New Jersey in the United States. I'm a non-invasive cardiologist and echocardiographer and a member of our valve team. I'm here today to talk to you about imaging assessment of mitral TEER success and complications. These are my disclosures. This is what the current mitral valve TEER landscape looks like. We have four MitraClip devices that are currently approved, the NT, the NTW, the XT, and the XTW. And then we also have two Pascal devices. We have the wider original Pascal and the thinner Pascal Ace. Of note, Pascal is commercially approved in Europe. However, it remains investigational in the United States. And, important thing to keep in mind is that despite the differing device features, the overall, procedural result evaluation is fairly similar between the two sets of devices. So how do we go about defining mitral valve TEER success? There are two key questions. Two key concepts, I should say. One is MR reduction, and the other is absence of significant mitral stenosis. And of course, the two are very connected. They go hand in hand. So an ideal mitral valve TEER result will give us MR that's mild or less. However, we all know that what's achievable is going to vary, especially from one patient to another. It's going to depend on the baseline mitral valve pathology, the starting MR severity, in addition to the starting mitral valve area. So ultimately, what's a success is mild or less. However, what's an acceptable MR reduction may vary from one patient to another. Next is the absence of significant mitral stenosis. Traditionally, we've looked at transmitral gradients, and we've said that a mean gradient of less than or equal to 5 is an acceptable result. However, we do know from recent series, including COAPT, where we looked at secondary MR, that those patients, even that had gradients above that, actually did well clinically. Moving on beyond gradients, that we think that there's a role for mitral valve area planimetry by 3D, especially when it comes to procedural decision making. We'll now talk a little bit about post-TEER MR evaluation. We know that MR evaluation can be challenging, and fortunately we have guidelines to turn to. This is from the ASC guidelines in 2019. I've highlighted some of the key features from these guidelines that are relevant to this discussion. So we know that with any MR, whether it's at baseline or post-intervention, an integrative approach is best. Of course, we look at the color Doppler. Things of note that are particularly helpful for TEER are going to be looking at the pulmonary vein flow, looking at the vena contracta width, 3D mitral valve vena contracta area in selected cases, and of course, last but not least, there's a role for invasive left atrial hemodynamics. So this is a case illustration of some of the concepts that we'll be discussing. So on the left side of the panel, you see the starting mitral valve anatomy. This is a very large P1 scallop flail with multiple torn cords and very severe associated MR. Of course, we see pulmonary vein systolic flow reversal. Following a single, this is in the pre-W days, so following a single device implanted at A2P2, we see that there's some MR reduction. However, pulmonary vein flow remains reversed. Following two additional devices that were implanted laterally, so for a total of 3 devices, so we see a significant reduction in the color Doppler flow, as you can see on the top right, and on the bottom right, you could see that pulmonary vein flow is now systolic dominant. Now, compared to the last case where we implanted 3 devices, so we had enough valve area to do that, and we were left with very little MR, this is a different story. So this is a patient that had MR originating from A2P2 and A3P3. After a single device that was placed centrally, we're left with 2+ MR. MR jet is predominantly coming from the medial orifice, and there's minimal MR coming laterally. So questions that we ask ourselves at this point is, first question is, can we do better? And the second question is this an acceptable result for this patient? So this is where looking at MR by color Doppler, by really looking at MR a little more granular level, by doing 3D vena contracta area analysis, is going to be helpful. So in this particular case, the vena contracta area is 0.24. This falls into the 2+ range. And this is where we have to consider, can we do, what else can we do? Is there a role for repositioning the device? is there a role for implanting another device? In this particular case, we did neither one of those. This was the best MR that we could get, given this mitral valve area. And we also knew, just based on the residual mitral valve area that was present following a single device, that we were not able to implant an additional device without causing significant mitral stenosis. So again, this is an example of an acceptable MR result. It's not ideal, but it is acceptable for this particular patient. So in order to do the type of analysis for MR 3D vena contracta area, image quality really matters. And we're certainly not advocating that you have to do 3D VCA for all patients. However, it can be especially helpful in those patients where we have to make difficult decisions about additional devices, or whether we're grading MR as being mild versus moderate, 2+ versus 3+, etc. So image quality matters in order to do this. So we need good 2D imaging in order to have good 3D. We need to optimize our 3D image. And then we also need to really pay close attention to balancing spatial versus temporal resolution. So the focus should not be on frame rate alone. There should be really an emphasis on getting good image quality with good spatial resolution. Next, we'll move on to talk a little bit about TEER success as it relates to mitral stenosis. So when we do TEER, it's important to measure the mitral valve mean gradient. When we do this, a physiologic heart rate is ideal. It's important to also keep in mind that a transesophageal echo gradient will oftentimes differ from what you see on a transthoracic that's performed, a day or two later. In addition to mitral valve transmitral gradients, it's also important to keep in mind that really, what we're most interested in is the actual valve area, and we have ways of measuring this intraprocedurally in addition to post-procedure. So in the cath lab, really the best way of doing this is with 3D and with multiplanar reconstruction. And what we do is we compare this to baseline to get a sense of the mitral valve area reduction. Ideally, our goal is to maintain a mitral valve area that's more than 2. As you can see on the right side panel, this is a patient with 2 devices that were implanted. We measure each of the 2 holes independently, and you see that the lateral area is 0.9, the medial area is 1.1, resulting in a cumulative valve area of 2 and a transmitral gradient of 3. So we're happy with this result, provided, of course, that the MR reduction is adequate. So do post-mitral valve TEER gradients matter? Fortunately, we've had a couple of papers that have come out very recently, in addition to last year, and we don't have time to fully get into these. However, there's an excellent accompanying editorial by Dr. Hahn and Hausfleider, and you can see the table of note from that paper. So post-TEER gradients probably do matter. However, it's complicated. There are differences in primary versus secondary MR patients. So we think prognostically they may be a little more important for primary MR patients rather than secondary MR patients. We also do realize that there's going to be some variability, as we've already discussed, when we're measuring gradients on transthoracic versus TEE. And of course, we all know that gradients are very much dependent on both heart rate and cardiac output. So this is a case of a P2 flail, and we'll talk a little bit about the risk of mitral stenosis and procedural decision making. So on the top panel, you see baseline anatomy. There's a P2 scallop flail and a starting mitral valve area by 3D of 4.3 centimeters squared. So as we would expect, following a single XTW device, we have a significant reduction in mitral valve area. We measure each of the two holes independently. So the medial orifice is 1.7 and the lateral orifice is 1.0 centimeters squared. So this is an important analysis, and if after a single device here you're left with mild or less MR, you're essentially done. You don't really have to think about it too much more. However, it's important to keep in mind that if you still have significant MR, this is the type of analysis that's really going to be very helpful to guide you in terms of your decision making. Because as you could imagine, depending on where the MR is coming from, whether it's the medial orifice or the lateral orifice, when you consider placing an additional device, you're going to have an impact on that valve area. So I would argue, the medial orifice 1.7, that's pretty good. So if you have to put in a second device, ideally you want to leave that orifice alone because that's providing you with a significant amount of valve area. So again, this is just an example of some of the considerations that we have intraprocedurally and how 3D and the assessment of valve area is helpful. So next we'll shift our attention to discussing some procedural complications of TEER and imaging. So the top two are really what we're going to focus most on is SLDA and leaflet injury. Fortunately, both of those are relatively rare. SLDA rates in most contemporary series are 1 to 2%. Of course, typically associated with MR recurrence, and as we know, the treatment options are fairly limited. Leaflet injury is fortunately even more rare, so things like a new flail or tear or perforation. So on the right-sided image, you can see this is a nice example of a SLDA, and we see a device that's attached to the posterior leaflet alone. So when it comes to TEER and SLDA, we're very familiar with a TE based evaluation. However, most of these patients, I would argue, that we're going to encounter with SLDA, really the initial suspicion is going to be based on transthoracic study. So things like MR recurrence, of course, are going to be clues to that. So, and we put this slide together just to illustrate that you can do this and you can make this diagnosis by transthoracic, by a meticulous exam. So this is an example of biplane imaging. So you could see on the left-sided panel, we're interrogating the lateral clip, and we could see on the orthogonal view that it's attached to both leaflets. We have two sets of images here. We have parasternal at the top and apical views at the bottom. When we shift the cursor more to the medial clip, however, we could see that there's SLDA, and the clip is attached to the anterior leaflet alone. So again, transthoracic is helpful, and especially when you complement it with biplane imaging. So this is a quick case. This is a patient that was transferred to us from an outside hospital for a potential redo in a patient with a single leaflet device attachment. So two clips were previously implanted in an outside site with a medial clip that had SLDA that was attached to the posterior leaflet alone. So if you look in the top two images, you see with the biplane at the lateral clip, that looks fine. However, when we move the biplane to the medial clip, we see that the clip is attached to the anterior leaflet alone. And we could see this on the bottom right panel when we look with 3D. The MR is predominantly coming from the medial orifice. And fortunately, when we're thinking about how we're going to approach this patient, fortunately the valve area from that orifice is adequate. So we have a valve area of 5.2. So this is a patient that we think can be treated with a catheter-based approach. So we performed this case and we ended up implanting 2 additional clips immediately. As you can imagine, this is time-consuming and technically challenging, but fortunately in this particular case, we were able to get good result. So we had a total of 4 clips implanted, 2 old and 2 new, and our final result was 2+ MR with mild pulmonary vein flow blunting. Transmitral gradient was 5, and the mitral valve area was 1.6. So again, the valve area is probably a little bit lower than what we'd like. However, in this particular patient, that's what it took in order to get an acceptable MR result. This is a different case to illustrate the concept of a leaflet tear post-TEER. So on the baseline, at baseline in the top 2 panels, you could see this is a patient with mitral aneuritic calcification, really very prominent at P2. And if you look on the top left image, there's subvalvular extension into the LV. And equally importantly, you see the base of P2 is immobile. And this is associated with significant MR, as you see on the top right. So following attempt at transcatheter edge-to-edge repair, you could see, if you look in the bottom left panel, you could see with the blue arrows, there's a mobile echo density on the left atrial aspect of P2, and that's consistent with most consistent with a tear. And there is significant new mitral regurgitation that's coming from that spot, as you could see on the bottom right image. So again, these findings are consistent with a leaflet tear post attempt at TEER. This is a dreaded complication, and this is something that it's important to keep in mind when you see this type of anatomy with this much MAC with an immobile posterior leaflet. It's you have to be very, very careful. So by way of summary, TEER success relies on excellent imaging at baseline, as you've already heard earlier today, but also intraprocedurally. And also, of course, it's important to have good procedural decision making. The key intraprocedural questions we've already discussed when we do these cases are as follows. Is there adequate MR reduction? Is there clinically significant mitral stenosis? And really, these are the two main things that we're looking for when we do TEER. In order to accomplish these things, do we need to reposition a device? Is there enough valve area for an additional device? And of course, is there any anticipated difficulty placing this additional device, if necessary, of course. Thank you very much for your time today, and thank you to the meeting organizers. My name is Konstantinos Kologiannis, and σας ευχαριστώ πάρα πολύ.
Congratulations, Dr. Kologiannis.
Thank you, yes.
What I would like to know is, it was a wonderful lecture. What I would like to know is this. You touched on the AST very briefly. You had a lot to say, of course. Now, usually the AST is not a problem. But what I would be interested in is what would alert you after the procedure that there is a problem, either acutely or chronically, the need to follow up over the next few weeks and months?
Thank you. That's a great question. Fortunately, ASTs are not much of an issue. It's fairly small, and most of them, especially if you have a good MR result, most of them will close by the time we get subsequent echoes, whether it's at 30 days, at 6 months, or 1 year. However, there are those few patients where either we've created a bigger AST than we'd like because of the guide and just tearing the septum if it's a little delicate, or those patients that have a lot of TR, a lot of just high right-sided pressures, significant pulmonary hypertension, where that AST doesn't close. What we're most interested in seeing is not so much left to right shunting. That we think is relatively acceptable, although who knows what's going to happen as we move this therapy to lower and lower risk patients. But at least in the high risk patient population that we have the most experience with, we think it's a relatively benign thing. However, what we're really concerned about is right to left shunting. As blue blood entering into the left side, hypoxemia, etc. That's not very common, but there are those cases where in the lab, if we see bidirectional shunting, we look up at the monitor, we reduce the FiO2, we see that they're basically hypoxic. We'll close the shunt on the table. So it's happened. Really, it's pretty rare, but we'll see over time. Over time, as we move this therapy into, I think it's an easy decision to make when you have right to left shunting. Essentially bidirectional shunting, and you can anticipate that to a certain extent. Severe TR, severe pulmonary hypertension. What I'm interested to know about is as we move this therapy to lower and lower risk patients, hopefully in time, what will happen to those folks that have left to right shunting? So that I think that remains to be seen. My hope is that that won't be a detrimental issue, but I don't think we have all the answers to that. Do you have any
That's wonderful, thank you. Perhaps I can ask the panel. Yes.
Yes, this is Dr. Papadopoulos. Dr. Kologiannis, thank you for being with us, and congratulations for your work. I would like to ask about going to lower risk patients and patients that are younger, more active. Should we assess the mitral stenosis and the mean gradient with either supine bicycle exercise echo, or immediately after finalizing our procedure, should we do a TTE rather than a TE? Because sometimes we see a difference at the mean gradients in TTE, and then when the patient is awake and not sedated.
I think this is an excellent question, and really this is my concern as well. What we see when the patient is asleep is frequently completely different from what we see the next day when they're, a little bit after the procedure, or the next day when they're awake and we do a transthoracic. We could typically count on at least 1 or 2 millimeters of mercury more in the gradient, when they're asleep under more physiologic conditions. And as you mentioned, that's at rest. So, God only knows what it's going to be when they exert themselves. So really, our emphasis is, we look at the gradient, of course, and as we've heard from, my talk and from Becky's talk a little bit earlier, there are some data that are emerging about the importance of gradients, although it's still a complicated issue. But really, this is where we focus on the valve area. We want to see what the anatomy is, the anatomical orifice area, rather than just the gradient. In the lab, we'll routinely do 3D planimetry of the mitral valve at baseline, of course, and after repair. And as I mentioned before, we use this data to guide our procedural decision making, and to assess our final result. So we rely on that just as much as we rely on mitral valve gradient. Now, of course, if someone's starting with a valve area of 6 and you put in a single device, it's going to be fine, provided that the leaflets are okay, that there's not significant MAC, etc. So you don't have to do this routinely for every patient. But anything below that, when you're putting, when you're doing this in valves that are in the 4 to 5 range or even lower, when you're putting in multiple devices, really looking at the anatomic orifice area, we think is very important. And yeah, I think gradients are great. Gradients are easy to measure, but they don't tell the full story, like you're saying.
Thank you.
To answer your question about about doing a supine bike, we normally don't do that. In the lab, the patients are asleep, of course, and then, unfortunately, by the time we'd be able to put them on a bike, the device is already deployed. So we can't undo what we've already done. So really, this is why looking at the valve area, I think, is helpful.
I have a follow-up of a couple of patients that were symptomatic 1 year after TEER, and the MR was increased, but not more than moderate, and the mean gradient was approximately 10. We know from exercise stress echo that in order to name a mitral stenosis as severe, you need a mean gradient more than 15. But if you have a mixed result with moderate MR and kind of moderate MS, 1 year after the transcatheter edge-to-edge repair, how can we manage these patients? This is a clinical question. We didn't have an answer for this patient.
Yeah, unfortunately, there's no great way to manage these patients. Clinically, we do the best we can, of course, with medicine, with diuretics, with negative chronotropes, beta blockers to really try to slow them down, to try to minimize the heart rate and the impact of exercise on the heart rate. However, there's not a lot we can do. From a transcatheter perspective, there are some emerging concepts and some emerging data about re-interventions in these patients, either that have too much stenosis or that have too much MR. This is still, these are few and far in between, but this is something that we're starting to recognize more and more, and we realize that there's an unmet need here, basically. This includes things like doing, electrocautery of the anterior leaflet, putting in a new transcatheter valve. So things that are still relatively exotic at this point. But that is something that people are keeping in mind. And, last but not least, of course, there's surgery, of course, right? Now, you could argue there's a reason why we didn't do surgery to begin with, but, that's the ultimate answer. So again, it's a really tough problem with no easy answers.
Okay, thank you very much. So we'll move to the next and the last speaker of this session. We'd like to introduce Dr. Moni Shuvi from Jerusalem, in the Share Zedek Medical Center. He has worked a lot on these issues, but he has also participated in a large registry on acute MR as a secondary to myocardial infarction. So he's best suited to speak about emergent and urgent TR, when and how. Dr. Xavi.
Good afternoon. It is my pleasure to present here in the Transcatheter heart valve Greece. And I will present today emergent and urgent TR edge-to-edge repair, when and how. So let's start with the clinical case. This is a 74-year-old woman that presented with chest pain and shortness of breath. She was diagnosed with acute inferior ST elevation MI. She was in KILIP class 3 and 4 in cardiogenic shock. An angiogram was performed showing acute left circumflex occlusion, and the PCI had no reflow after the procedure. The patient could not be weaned from the mechanical ventilation due to congestion, and you can see here tethering of the leaflets with severe mitral regurgitation due to acute functional mitral regurgitation. There was no damage to the papillary muscle in this case. So the diagnosis of acute severe mitral regurgitation is often challenging because the clinical picture is inconclusive. In many cases, the murmur is soft and even absent due to the rapid equalization of the pressure between the LA and the LV. Similarly, the color Doppler underestimates the severity of the MR, again because of the relatively low volume that causes the increase in the LA pressure and the equalization in pressure between the LA and the LV. In addition, the quantitative evaluation of MR severity was never validated in acute conditions, but rather in chronic MR, and therefore the quantitative evaluation cannot be used in acute cases. So in order to validate the severity of acute severe MR, we need additional tools. One of them is the echocardiographic features, such as showing the tethering, the leaflets. We can see patients with severe pulmonary hypertension without any reasonable explanation for that. You can see a right ventricular dysfunction. Another pattern that can help us is to evaluate the pulmonic vein flow. In many cases, it is reversal in those patients. And of course, hemodynamic evaluations shows prominent V waves. For example, if there is a patient with prominent V wave, very high LA pressure, and with low blood pressure, it might be a patient with severe mitral regurgitation. Therefore, the clinical suspicion is very important, and it is always required in patients with acute heart failure, especially when the LV dysfunction cannot explain the clinical picture of these patients. The difference between acute and chronic MR is, of course, the compliance of the left atrium. In patients with acute presentation, the compliance is low. Therefore, the flow to the LA causes a significant increase in the LA pressure and decompensation of the patient. And as we all know, the MR is part of the vicious cycle of ischemia, which causes additional decrease in the contractile function, additional MR, and therefore clinical deterioration in acute heart failure. So what is the clinical pictures of patients with acute MR? So there are the more severe condition, like the patient we presented before, cardiogenic shock and pulmonary edema. Those patients are in extremis. Other patients develop severe heart failure with pulmonary edema without cardiogenic shock. The less severe condition is patients that develop heart failure but can't be managed by medications. And of course, there are patients that have MR by echo, but they don't have severe clinical deterioration. Those patients probably had some previous degree of MR or other reasons for left atrium dilatation, and therefore the flow of the acute event doesn't cause a very severe elevation in the LA pressure. So what is the management in patients that develop acute severe mitral regurgitation? You can see here the guidelines that was published just recently. Not much about acute MR. Most of the data is not focused on those patients, but it's still written that most patients with acute severe MR require surgical correction, for reestablishment of normal hemodynamics and relief of symptoms. Unfortunately, we know that most of those patients are declined for surgery. They are too high risk, they are in extreme condition, and therefore they are turned down for surgery. Can we help those patients with other intervention? This is the first publication that we presented in 2019. This is a registry of 20 patients from several centers, including centers here from Greece, that patients that were in extreme condition and required salvage mitral clip for severe secondary mitral regurgitation complicating acute MI. Those patients were all in extreme conditions. We can see here that after the procedure was very successful. The MR was decreased in most of those patients. Dramatic decrease in left atrial V wave was demonstrated. PA pressure decreased, and most of those patients were able to recover. And the procedure was a bridge to recovery in patients with very acute heart failure due to the severe mitral regurgitation. There are some technical issues that often limit the ability to go and clip those patients with acute severe mitral regurgitation post-MI. One of them is severe tethering of the leaflet, which make it very challenging to grasp the leaflets. Now it might be better with the new techniques of independent grasping, but in the beginning it was really a challenge to do the grasp in those patients. Here we present a unique utilization of intra-aortic balloon pump that causes afterload reduction and therefore allow better coaptation of the leaflets and allowed us to do the procedure in those patients. Additional technical issues in patients with acute severe MR is a small left atrium, which make it a bit more challenging to manipulate the device in the left atrium, but in most cases it is definitely most operators are able to do those procedures even in acute conditions. Patients that are at risk for developing acute post-MI MR are patients that are presented with late arrival MI, patients that had suboptimal reperfusion, involvement of the circumflex artery, although we also see patients with right coronary and of course patients with anterior wall MI, and patients with multivessel coronary artery disease. So our next step was to compare percutaneous and surgical treatment for patients post-MI. In this registry compared patients that were treated with mitral clip, patients that were treated with surgical intervention, and patients that were treated medically. The data included a retrospective analysis of patients who had at least +3 MR and heart failure after MI from 21 centers in Europe, North America, and Middle East, and patients were treated by surgical intervention, mitral clip, or by just medical therapy. You can see here the baseline characteristics of patients that were treated with intervention compared to patients that were treated with just medications. We can see that patients that had intervention, either clip or surgery, were younger, but were in a more extreme condition. Most of them were in KLIP 3, many of them were in cardiogenic shock, required mechanical ventilation, and intra-aortic balloon pump. We can see here that the survival was significantly improved in patients that were treated by any intervention, mitral surgery or mitral clip. Next, we compared patients that were treated with mitral surgery, compared the patients that were treated with clip. We can see here that the procedure was successful in most patients. More than 90% success was in our registry. However, major complications were significantly higher among patients that were treated with surgery. Almost 30% of them had major complication, and this was of course translated to increased significant in-hospital mortality, and of course here 1-year mortality. You can see here that PMVR was associated with improved mortality compared to surgery. This data was published recently in the European Heart Journal. You can see the collaboration of all the centers, including the Greek centers. So for conclusions, we know that post-MI and other acute severe MR is associated with poor outcomes. PMVR or TEER is successful in decreasing the MR and improve the hemodynamic parameters. And when compared to surgery in patients with post-MI, it is with lower mortality rates, and it should be definitely considered as an alternative option in patients who are high risk for surgery, and we will need, of course, future randomized trial to validate those findings. I would like to thank you very much, and I'll be happy to answer any questions.
Dr. Shuvi, very important data. In the registry, the timing was within 90 days of myocardial infarction. What was the median day of the procedure, and how early is early?
That's a great question. First of all, good afternoon from Jerusalem. I'm very happy to take part in this great conference. We included patients that were treated within 90 days, but most of the patients had the intervention within the first month after the acute MI, and most of the patients were treated after 2 weeks, which means that there is some delay between the acute MI and the intervention. The reasons for this delay is first, patients are there is some efforts to stabilize the patient with other interventions like Impella, mechanical ventilation, intra-aortic balloon pump, and still acute mitral clip is, urgent mitral clip is not a very common among hospitals. Therefore, it takes some time to implement the importance of early intervention. Regarding the best timing of intervention in those patients, it's very difficult to predict. But there are some features that suggest that this specific patient won't improve unless you will intervene with mitral valve. First of all, the clinical scenario, most of those patients did not have good reperfusion of the myocardial infarction. They are late arrival. They had TIMI-1, TIMI-2 after the procedure. They develop heart failure, and they are intractable heart failure. They do not respond to intervention. They are treated mostly with Lasix and other diuretics. And therefore, you cannot really try medical intervention because all the other medications cause acute further deterioration of the kidney dysfunction, and they decrease the blood pressure. And therefore, most of the patients cannot really get the appropriate medical therapy for post-MI heart failure. And the only way to cut this vicious cycle of deterioration is to treat the valve and then to try and facilitate the medical therapy in those patients.
Okay. Dr. Manginas has a comment or a question.
Thank you very much. Excellent presentation and very difficult cohort. Can you tell us, please, those are patients who were rejected from surgeons before you attempted this?
Right, of course. All those patients were evaluated by the heart team, and as most patients with clinical deterioration in cardiogenic shock and very difficult conditions are turned down from surgery. We have this data from the shock trial even many years ago that most of patients that develop post-MI-MR are treated medically and face very poor outcomes. It is unlikely that surgeons would like to take a patient in cardiogenic shock with intra-aortic balloon pump and intractable heart failure for surgery. And we know from the data that although in many cases the surgery itself is very successful in decreasing the MR, the post-procedural complications often causes the poor outcomes of patients who underwent surgery in acute decompensated heart failure.
Can I ask a question? Hi, Moni. Thank you very much for your discussion. I can ask you, you mentioned about possible study between clip of TEER versus surgery. Is there any, in your mind, possibility of getting preliminary approval for TEER in these patients? Because it doesn't take away the option for surgery if they stabilize down the road. I mean, as an emergency bailout type of treatment, but to go into the guidelines, not.
I agree. I think that we were able to show in our data that the clip is a bridge for survival. Those patients should be treated with early clipping, and then after a month or two, or I don't know how many times later, they should go for the definite surgery if needed, and if those patients are still candidates. I must tell you that importantly, that if you take our data that compared surgery and clip in the acute setting and exclude all patients with in-hospital mortality, then you get similar outcomes between surgery and clip. This finding suggests that the benefit of the clip is to survive the in-hospital duration during the course of the disease. And in Israel, I think that in Greece it's a bit more difficult to get approved in acute cases, but in Israel we're getting immediate approval for patients that required urgent intervention. And we see in follow-up that most of them are improving after the procedure, and then you can start treating them for heart failure. There was a previous question that I heard, when to stop the medical therapy and go for TEER. So in many cases, you cannot really give the medical therapy unless you're giving the patient the TEER to stabilize them. It's also true in patients with severe chronic heart failure, that taking high doses of Lasix, and you cannot give them enough after reduction or ACE because they have kidney dysfunction and low blood pressure. And in many cases, the TEER allows you to treat them medically in the chronic and, more importantly, in the acute setting.
Okay, TEER without tears, then.
Okay, thank you very much. Thank you very much, Professor Subi, for an excellent contribution.
Dr. Bibilis, I wonder if I can ask a question.
Sorry?
From Nicosia.
I'm sorry.
Hi, how are you?
Dr. Subi.
Sorry.
It's fine. Just a very quick question. Now, this data, Dr. Subi, you're shifting the boundaries. I'm sure that you will be faced, if you haven't been faced already, with a lot of pressure to treat these patients. The surgeons will say no, the clinicians will say we can do no more. When do you say no? I cannot do anything. When do you say no?
In the acute setting, you mean, right?
Yes.
So I must say that in the acute setting, I try not to say no. because there are no other options. We did clips on patients with impeller, patients in ECMO. We did clip for them. So of course you won't take a 90-year-old man with a poor LV, but if you have a patient that is, as definitions, those patients were fine before because they came with acute myocardial infarction. So I must say that I don't say no in many cases, in all cases, I don't say no. And I must say that there is no big fight from the surgeons for those patients. So it's not very difficult to press you at the surgeries, the operators, that this patient should be treated first with clip, and then we'll see what next. Because you might not succeed with the clip, or you will have some temporary effect of the clip, but those patients are not precluded from future surgery. Therefore, I think this is a win-win situation, and not really, I don't feel a big fight from the surgeons for those patients.
That's great. Thank you very much.
Thank you.
It's time to finish then. Thank you very much. I mean, lively session, isn't it, Kostas? Provided anatomical and functional characteristics permit, as we very thoroughly discussed in this session, we are happy to have an interventional approach that not only improves symptoms and quality of life in short term, but as Nasos very nicely pointed out, it reduces also heart failure association, heart failure hospitalization and mortality in long term, which this should be our target, Nasos. Very rightfully you pointed out. So we must not hesitate to perform TEER in advanced heart failure patients, provided they fulfill COAPT criteria, but Kostas also criteria of myocardial reserve, because we might considerably delay the progress of the disease. So many thanks on behalf of my distinguished co-chairman for fruitful discussion, for interactive session. Many thanks to the organizers and especially to the founder of the unit, Kostas Sparias. Okay, we proceed, isn't it, to the next session.
Okay, so good afternoon, welcome back to our next session, which is a TAVI masterclass and discussion about the current guidelines. We have an excellent faculty in this session, mainly international faculty or exclusive international faculty, and we're starting with Dr. Tsetse, who is with us with a recorded video, and will present the latest on TAVI in bicuspid valves.
Good morning. So it's a real pleasure to provide this lecture about TAVI for bicuspid aortic valves, about bicuspid aortic stenosis. So my name is Didier Tsetse, and here are my conflicts of interest. The first thing that we need to keep in mind is that all the data that are available in the literature relate to highly selected bicuspid patients. So this brings us to that issue of patient selection for bicuspid aortic valves. And we all know that there are anatomical differences between bicuspid and tricuspid aortic valves. And to make it simple, in bicuspid aortic valves, the annulus, the auric annulus is larger. We have wider sinuses of Valsalva, different coronary takeoffs, sometimes at very acute angles. We have a highly calcified pattern of the leaflets, sometimes the LVOT and the aortic root. And all these features really provide that key aspects of bicuspid aortic valves. And let's keep in mind that all the data, once again, available in the literature are about highly selected patients. And we have this type of data coming from the literature, from this retrospective collaborative registry, really telling us that when a patient combines extent calcifications at the level of the leaflets and a rapid that is also calcified, this is going to impact the survival of the patient with an increased mortality up to 2 years after the procedure. So patient selection is key for bicuspid aortic valves. Having said that, one of the burning issues for bicuspid aortic valves remains sizing. And there is still controversy about sizing for bicuspid aortic valves. We have to combine different sizing methodologies. We may size only based on the annular dimension. We may size on some supra-annular measurements, whether it be the commissure-to-commissure distance or a supra-annular tracing. Or lately, we may, as a add-on, utilize the circle method that is extremely helpful for balloon expandable platforms. When you are in the gray zone, you just put a 20, 23, 26, or 29 millimeter circle within the anatomy of the patient, just to understand what is going to be the risk of aortic root rupture, annular rupture, or sinus sequestration. So these are the methods that we may combine for sizing in bicuspid aortic valves. CT remains the gold standard for sizing. With that CT scroll technique, you scroll from the aortic annulus upwards just to understand, apart from the matrix, what is the configuration of the bicuspid phenotype, serous classification, if there is a raphe, what is the calcification pattern, all these elements combined with the measurements as they were mentioned in the previous slide. And when we do that, we may identify the three configurations according to the Bavard algorithm, three configurations of the landing zone. The first one, when the annular dimension, mean perimeter derived diameter, matches the commissure-to-commissure distance, we are in a tubular configuration. I'm going to size based on the annulus. When we have the annular dimensions that are more than 10% smaller than the commissure-to-commissure distance. Once again, we're going to size based on the minimal dimension. In that flared configuration, it's going to remain the annulus. And it's only in tapered configuration in which the supraannular measurements provide dimensions more than 10% smaller than the annular dimension. In these very rarer phenotype configuration, we're going to size based on the supraannular measurements. So overall, in 88% of the cases, in close to 90% of the patients, sizing on the annulus makes sense. So if we want to provide a couple of metrics just to illustrate what is the oversizing that we utilize for bicuspid aortic valves, if we size based on the annular dimension, on average, what we see for balloon expandable platforms is that we have an oversizing that is close to 5%. So it's close to be a 1-to-1 ratio. If we utilize self-expanding platforms, it's more about 15 to 20% oversizing, just to seal and to properly anchor the device within the anatomy. If we decide to size based on the supraannular dimension and the commissure to commissure distance, most of the time it's close to be a 1-to-1 ratio. So this is a concept that we recently introduced. What is the utility of that supraannular tracing? And we did a retrospective analysis of all the bicuspid cases that we did in Toulouse. And when we traced at 4 plus 4 plus 8 plus 12 millimeters above the annulus, that supraannular tracing perimeter-derived diameter at plus 4 millimeters above the annulus provides as a really good correlation with the final mean perimeter-derived diameter of the device in the anatomy after the procedure. So this is going to help us anticipate what is going to be the diameter of the device. It may become circular, but diameter of the device post-implant. So this brings us to some procedural considerations. So the first consideration that we need to integrate is what is a proper projection, proper view, just to deploy the device. And as we're dealing with bicuspid aortic valves, that we have to move from a 3-cusp coplanar view to a 2-cusp coplanar view. The most frequent phenotype of bicuspid is type 1, left to right, and we need to work in this kind of cusp overlap projection, 2-cusp view, in which we overlap the fused leaflets in the same view. So it's really important to try to figure out with the CT scan what is going to be that 2-cusp projection for bicuspid aortic valves. Procedural wise, if we dive more into details, what we have learned from the Evolut X registry, that prospective registry that focused on a single platform, the Evolut Pro or the Evolut XL 34mm device for bicuspid aortic valves, a kind of all-comers prospective registry. What we saw is that a single device was utilized in the vast majority of the patients, and this tells us about how mature can be TAVI for bicuspid aortic valves in contemporary practice. Pre-dilatation was really a part of the procedure, and you can see that close to 90% of the patients have pre-dilatation. Repositioning was utilized in 1/3 of the patient, and definitely to achieve a proper implant depth, and post-dilatation was utilized in 55% of the patients. So here is a case example. You can see that the mean perimeter-derived diameter of this patient is 27.7 in the range of the 34. The LVOT matches the annular dimension. 4 millimeters above the annulus as proposed by the Pvl algorithm. The commissure-to-commissure distance is 32, so greater than the mean perimeter-derived diameter of the annulus. So we're going to size based on the annular dimension. And as we do regularly in Toulouse, that supraannular tracing 4 millimeters above the annulus, that provides 26, telling us that any kind of the device that we're going to put in the anatomy of this patient is going to maximum reach 26 millimeter mean perimeter derived diameter. The sinuses of Valsalva, bottom left part of the screen, are wide enough and with an extremely calcified anatomy, with calcium at the level at the tip of the leaflets and calcified raphe. So really a complex type 1 left-right bicuspid. All the metrics converge to the use of a 34 based on the annular dimension, because we are in a flared configuration, and keeping in mind that the mean perimeter derived diameter of the device is going to be 26. The cage that houses the leaflets of 34 Evolut Pro Plus is going to be 24, so we will have plenty of room for a perfect functioning of the leaflets. So let's go for a 34 evolute propose platform. So first of all, about that implanted view provided by the CT scan. And as you can see, with the CT scan, and what we try to achieve is to match, to overlap the left and the right commissures, so it provides us a RAO caudal projection for our bicuspid patients. What we do on a regular basis is to pre-deal, so pre-dilatation is part of the procedure. And then during the deployment, what we tried to achieve is a very high implant. So you start very high, and with the control and maturity of that cusp overlap projection, we can really get something that is high. Here is once again the next part of the deployment, and what I like to do in bicuspid aortic valves. Deployment most of the time is stable. Once we reach the annular contact is to really withdraw during that fast pacing, withdraw any tension provided by the wire just to get something that is stable. Rotational angiography with two orthogonal views just to make sure to confirm that the device expansion is appropriate and to decide whether or not to post-dilate. And this is the final result for our patient. High implant in that two-cusp projection, two-cusp view, and post-dilate if necessary, if the device is not expanding. So what I just would like to say to conclude, to remain within this the allocated time for this lecture, the key messages about TAVI for bicuspid aortic valves. The first one is that the CT scroll technique is really key for sizing. As a part of an integrative approach, combining the annular dimension, the supraannular measurements, just to understand what is the configuration of the landing zone. The annular sizing is going to be to make sense in 90% of the cases. Pre-dilatation should be part of a contemporary approach of bicuspid aortic valves. We have to achieve high implants, but remaining across the aortic annulus and reposition if necessary, particularly for self-expanding platforms. The centrum has to be assessed in two orthogonal views, or ideally with a rotational angiography. And at last, we need to post-dilate if necessary, starting with the minor dimension of the annulus at baseline and increasing to the mean perimeter derived diameter if necessary. Thank you very much.
We thank Dr. Tese. I don't know if he's live with us. Is he connected? No. Great presentation. I'm co-chairing with Dr. Patakos, Dr. Perez, and Dr. Papayoannou, who is online with us, right? Are you, Spiros, yes. Are you there?
He said he sent me a message. He'll be a little delayed. Yeah.
So I don't know if there are any questions or issues for discussion about
this talk.
This talk.
Perhaps we should go to the questions at the end. We can continue with Dr. Atluri. At this time, we would like to invite questions from the audience as well. So the next speaker is Pavan Atluri, who's a cardiothoracic surgeon from the University of Pennsylvania. He's the director of the heart failure, heart transplant and VAD program there, as well as a robotic and minimally invasive mitral valve and structural valve heart surgeon. Dr. Atluri and I
Hello, it's my honor to be invited to this wonderful conference and to talk to you about alternative access TAVI in 2022. I'm Pavan Atluri, one of the cardiac surgeons and associate professor of surgery at the University of Pennsylvania. My brief disclosures. So in the modern era, as cardiac surgeons and interventional cardiologists, we are often faced with this typical conundrum in the era of TAVI, of the patient with multiple comorbidities and very difficult percutaneous access, which is beyond feasibility for current technology, which then raises the question, how else can we take care of the aortic stenosis effectively? And this brings us to the various alternative access approaches, including transapical, transaxillary, and transaortic. Of course, transfemoral is the vast majority of procedures that are performed. Here, looking at the American STS TVT registry cohort data, you'll see that the vast majority of patients, almost 56,000, 58,000 have been performed by transfemoral means, with a very small portion that has been done by transaxillary and transaortic means. These alternative approaches are often associated with significantly increased procedural times, variable fluoroscopy times, and of course, mostly done in the intubated non-conscious sedation setting. Procedures have been performed very effectively with very low complication rates. Looking further at the alternative access techniques, including transaxillary as well as transaortic or TAO, which have been grouped together, you'll notice that there's been significantly lower all-cause mortality rates with the transaxillary approach, though there is a significantly increased stroke rate, which has been a little bit of the Achilles heel for the transaxillary approach. Though the readmission rates, need for dialysis, improvements in overall quality of life and functional status, hospital stays, as well as ICU stays have been remarkably lower. As a result, I think we've seen a very significant shift in alternative access approaches, with the majority of these approaches being performed by transaxillary means as opposed to transapical, TAO, or other, which we will not talk about here in the interest of time, which could be potentially transcaval approaches, which we also have experience with. In terms of transaxillary TAVR, there really are two means of performing this procedure. One is traditional surgical cut down on the axillary artery with control of the artery by vessel loops and direct access of the vessel utilizing a modified Selinger technique, as shown here on the left, versus a percutaneous approach, which has become more and more popular in the modern era. Again, the big complication with transaxillary approach really has been stroke. As we mentioned earlier, the stroke rate is almost 6% if you look at the STS TVT registry, which is significantly higher than both the high as well as intermediate risk partner trial data, but very consistent with the core valve extreme risk pivotal trial data, which was a stroke risk of roughly 7.5%. Now, the transaxillary subgroup of the core valve trial did have stroke rates of 6.5%, which really demonstrates that this is unlikely related to the device itself, and more related to anatomic changes with axillary access. There are some questions that do arise with stroke. Notably, is there a difference between right and left axillary sides? Notably, from the left side, we do cross the left vertebral artery as well as the aortic arch, though on the right side, you do cross the innominate artery. Contemporary TAVIs, of course, we are more and more considering cerebral embolic protection, which may alter these rates of stroke. And it should be noted there's really no difference between open and percutaneous approaches in terms of stroke with transaxillary procedures. When we compare both the surgical and percutaneous means of taking care of a TAVI, you'll notice that the data is very similar with no difference in all-cause mortality, stroke, rates of AFib, readmission rate, need for dialysis, pacemaker, bleeding, or major vascular complications. This is, again, data from the STS TVT registry. Looking at this recent meta-analysis comparing percutaneous versus surgical transaxillary access, which you'll notice is a percutaneous large bore access is very safe and potentially favorable from both a blood transfusion as well as major bleeding complication standpoint. Before we proceed with any transaxillary approach, it's important to obtain a very careful CT scan to evaluate for calcification as well as anatomic consideration. One of the major anatomic considerations to consider is angulation. It is important that the innominate or subclavian vessels to the aortic angle are greater than 90 degrees, as shown here. Less than 90 degrees makes it very difficult for retroflexion of the device upon entry into the aorta and can pose significant challenges for delivery across the aortic valve into the left ventricle, with very high risk of kinking of the sheath, which will pose significant challenges. Other considerations are to avoid the ipsilateral side of intracardiac devices, i.e. pacemakers, as well as if patent Lima grafts are present. Also avoid ipsilateral AV fistulas and consider contralateral side of the patient's dominant hand. Now, how was this procedure performed? Well, it's important to really understand the axillary artery anatomy and understand the three parts of the anatomy, which are really defined by the pectoralis minor muscle, with medial aspect being segment 1. Segment 2 is below the pectoralis, and segment 3 is lateral to it. The other major landmarks being the humerus head, the subscapular artery, lateral thoracic artery, and superior thoracic artery. You'll notice the segment 3 is very nicely bounded between subscapular and lateral thoracic vessels. This can be very nicely fluoroscopically visualized. Again, lateral thoracic, humeral head, subscapular artery. The vessel is accessed in that third point with a sheath between the subscapular artery and the thoracoacromial. Thoracoacromial artery. It is important to note that the brachial plexus is variable course, and therefore utilizing ultrasound guidance and direct access with a clean puncture is very important. First step is the screening stage following introduction of a 5 or 6 French catheter into either the ipsilateral radial artery or femoral access. A wire is actually, we track a wire up into the access vessel. And we engage the, in this case, the left subclavian, or alternatively the innominate artery with a steerable catheter, i.e. a JR4 catheter. Angiography is performed, and then the wire is tracked across the actual vessel. This will also help in identifying the vessel safely with ultrasound. Next, the landmarks are identified using angiography, notably the humeral head, the subscapular artery, and the lateral thoracic arteries. A micropuncture wire is then utilized to enter the third segment of the vessel. And then a micropuncture sheath is then introduced, and the location can be very cleanly confirmed. Next, pre-close sutures are placed in standard fashion, and the device is brought in across the arch with the sheath placed just within the aorta. And this is the device sheath. The valve is then crossed and the device is deployed. Following deployment, with a balloon across the vessel, and the access site, pre-closed device is removed, sheath is removed, site is closed, and completion angiography is performed. Major consideration and complications associated with transaxillary are, of course, related to bleeding. Though the rates of bleeding, minor bleeding, are low, they are significant. And these can be managed often just by putting a balloon across and proceeding with prolonged internal balloon angioplasty. You see a very nice closure here. And the other major complications, again, related to bleeding, are pseudoaneurysm. Acute limb ischemia is rather rare. And brachial plexus injury is something to be very cognizant of, as with bleeding, you can have compression of the brachial plexus related to hematoma within the region. So hemostasis and appropriate procedures to ensure clean entry are critical with the percutaneous approach. Alternatively, one could perform this surgically, which is also an excellent approach, by surgical cut down on the axillary artery. And of course, you can ensure hemostasis of the vessel by direct visualization. So in summary, data supports the superiority of the transaxillary access for TAVR versus alternative sites, notably the transapical or the transaortic, and really non-inferiority of percutaneous versus surgical approach. I would encourage you to choose the approach with which you are most comfortable. Percutaneous axillary access is an evolving mode of large bore access for TAVI in patients, which also, by the way, can be utilized for temporary MCS or potentially for supported PCI. Technical considerations of this procedure of the percutaneous procedure require very intimate knowledge of axillary anatomy and branches and its understanding in a multimodality imaging fashion. More data is clearly needed to understand the risk of stroke and efforts to mitigate this. I thank you for your time, and I hope this was a very an educational opportunity for you. Again, thank you for the wonderful invite at this very special conference.
I think that was a wonderful talk, and we thank Dr. Atleri very much for his contribution to our conference. Really, I was telling Dr. Spargus here, it's amazing how one person does VAD, heart transplant, robotic mitral surgery, and transcatheter valves, and that person's Dr. Atleri. Dr. Papaioannou is now online with us, and we'll be announcing our next speaker.
Hello, dear co-presidents, dear speakers, dear colleagues, good afternoon. It's a great honor to participate in this conference with such interesting dermatology and so distinguished speakers. We are always interested to hear about new methodology and new studies results by the experts. We will now proceed with the next speaker, one of these experts. Very well-known Professor George Dagas from Mount Sinai. Dr. Dagas will talk about valve leaflet thickening, CT studies and implication for antithrombotic treatment and further imaging. In patients suffering to TAVI, valve degeneration may happen. During echo, we may suspect dysregularization on valve leaflets, so we should consider performing CT in order to evaluate valve leaflets thickening. However, what is your plan in patients with lifted attenuated? Latest studies suggest the use of antithrombotic therapy. Let's listen to Professor Dagas. Thank you.
Κύριος Dagas τώρα. Dagas. 2 minutes while we get connected with the video from Dr. Dagas.
We're waiting for this.
Somewhere right now over the Atlantic Ocean. And the audio.
Remotely, virtually, through their internet connections at home or other hospitals. It's my great pleasure to join again for the first time in a mixed virtual and physical presence format after the end of the pandemic. Everybody's excited to be attending conferences in this forum. I'm going to talk to you today about the update on the aortic valve thickening studies and the implications for antithrombotic treatment and further imaging, the way they're required. And let's just start by saying that everything started only when we started looking at these valves with a high quality imaging with a 4-dimensional CT several years ago, enabling us to see not only a static image in gray, but also dynamic images, like a CT video in reality, that would show the leaflets opening and closing, and therefore make it easy to identify when they're not opening or not closing due to something that may be causing them to be stuck. And that something was a visible thrombus for the first time as realized. Before, I'm sure they were happening, but we were able to see them. So therefore, this became sort of a new phenomenon, mainly due to these great imaging capabilities we have. Those initial studies indicated that all sorts of valves were able to have this problem or exhibiting this problem in one or more of the leaflets. Surgical valves, surgically implanted valves, stentless valves, stentful valves, it didn't matter. There's been cases reported in any of them. Interestingly, this phenomenon was established as a very common, but of dubious importance really, although the concern is always very high. Why is that? Because theoretically, a clot on the leaflet of the aortic valve could travel anywhere in the body, including the brain, causing potentially neurological events, strokes, or TIAs. On the other hand, the original studies that were alarming, at the same time, they were limited. They were limited methodologically. Why is that? Because they were observational in nature, and therefore they were susceptible to major selection bias. What do I mean by that? Only the patients who might have a problem were imaged, clinical problem. Not everybody was imaged, so therefore we were receiving a skewed view of the phenomenon, perhaps a more alarming view than what it should be. Based on that, the American overseeing agency, the FDA, demanded that the ongoing at that point studies of the low-risk population of TAVR versus SAVR incorporate an imaging component at 1 month and 1 year. It was the only 2 studies that had this longitudinal imaging in all patients with no intervention into the pharmacological therapy one way or another. So whatever the result, the doctors were blinded. And the results were as follows. And you can see that the blue TAVR, the red surgery, by 1 month, one can say, well, maybe a little bit more clot in the TAVR. By 1 year, you can say this difference is really small. And about 20 to 28% of patients do have this problem or this imaging finding, so to speak. Interestingly, the patients who had it at 1 month, they were not the same who also had it at 1 year. It was a mixed bag. Some of the patients who had the clot at 1 month also had it at 1 year. And many patients who did not have the clot at 1 month had it at 1 year. So that made this phenomenon a fluctuating thrombotic phenomenon in a way that we really don't understand. And this fluctuation was really, I would say, also unexpected. Because if you were to ask me, I would say, sure, you may add some people by 1 year, but I would definitely expect that some of the people, most of the people who do have the clot at 1 month, they would also have it in 1 year. It wouldn't go away, but somehow it did. A very similar result presented in a different format with a self-expandable valve that have a supraannular position, and theoretically that may limit the chance for a clot. No change, no difference really between the surgical valve and the TAVI valve in this population. Again, the same flavor, a fluctuating clotting phenomenon. Some people have it at 1 month, some people have it at 1 year, all the way to a year. Again, a significant proportion, around 20% maybe or so, but again, a fluctuating phenomenon. So how can we experiment with antithrombotics or with some drugs in order to make this phenomenon better? Well, we experimented with the Galileo trial with a low-dose anticoagulation, the rivaroxaban, 10 milligram only. Remember, the AFib dose is 20 milligram. In combination with low-dose aspirin, everybody was using a combination at the time. We're expecting to be somewhat higher in bleeding with a new strategy. And indeed, there was a trend towards higher bleeding, higher major bleeding, as you see on the right side. What was not expected and disappointing, really, in the hypothesis was that mortality, as well as MACE, the major adverse cardiac events, cardiovascular events, were also elevated with rivaroxaban compared to the antiplatelet regimen. On the other hand, and a little bit counterintuitive to the criticism that a lot of people at the heat of that leaflet clotting frenzy, if you want, criticize the study for using too low a dose of rivaroxaban, and that this dose perhaps would do nothing at the valve clot. Well, it did quite the opposite. In the fraction of patients who consented to be part of the CT sub-study, the 4D CTA sub-study, at 3 months, we saw a remarkable reduction or prevention, if you want, of the significantly reduced leaflet motion, and also a major reduction in any kind of leaflet thickening. Unfortunately, we weren't, as I said, be able to realize that this would be beneficial for the patients due to the shortcomings of this strategy in the larger population and the clinical results. The popular TAVI investigators from Holland had a little bit of a different approach. They went and said, you know what, let's give all these oral medications, wherever patients are randomized, before the TAVI. So TAVI is done on fully protected antiplatelet or anticoagulant therapy, so we further minimize the strokes. And they included 2 cohorts. One cohort was patients who had some reason to be anticoagulated, and that was cohort B, a smaller one. And then the cohort A was similar to Galileo, that patients who have no other indication to anticoagulate, and therefore the control group here was aspirin alone versus aspirin plus clopidogrel. And in the indication for anticoagulation, it was anticoagulation, again, with or without clopidogrel. So this study was focused on clopidogrel. Let me make sure to everybody to understand that all the medications, including the clopidogrel loading, were started before the procedure. And the results were as follows. In the patients who had no indication for anticoagulation, clopidogrel seemed to increase the bleeding. However, this seemed to happen the first couple of days. So it was mostly related to the clopidogrel loading dose. In the aspirin dose on the other side, on the right side, you see that the strokes was, the MACE was somewhat increased over time with the aspirin alone, primarily after the discontinuation of the study medications at 90 days. So, in the anticoagulated group, we have a lot of bleeding. And why is that? Because the patients were subjected to TAVI on full oral anticoagulation. And there was 10 versus 20% the difference on day 1. I would say a lot of bleeding. Everybody would say a lot of bleeding. Many people would say a lot of bleeding. And I don't think anyone is using these drugs before the TAVI anyhow. Nonetheless, clopidogrel should seem to be only adding bleeding and offering nothing much to oral anticoagulation. So if our patients need oral anticoagulation, there's no need to add the clopidogrel. Let's come to Galileo, to Atlantis, I'm sure, which are very similar to Galileo, but again, including 2 strata similar to POP-TAVI. So you see every study here, every trial here is learning from the previous one. Again, a cohort of patients that need anticoagulation and a cohort of patients who don't need anticoagulation are included. Both cohorts have the same treatment arm, full dose apixaban 5 BID, and each stratum has a different control group, either Coumadin or warfarin, I should say, Syntrom, as in name in Greece, Coumadin in the United States, many names all over the world, and stratum 2 only antiplatelet therapy. In the anticoagulated stratum, and I'm going to present the stratum approach because overall there wasn't many differences anyhow, but the patients are so different that I think the clinical data wants to know per subgroup really in order to comprehend the results. No difference between apixaban and warfarin analogs, no matter what we look in this, I would say, pilot level study, about 200 patients per group only. In the stratum 2, no indication of anticoagulation, apixaban seems to be losing to antiplatelets in a similar way that rivaroxaban did in Galileo. There was increased mortality, increased non-cardiac mortality, very strong strength in increase in cardiovascular mortality, and overall increase in all sorts of MACE and thromboembolic events, as you see here. On the other hand, there seemed to be a reduction in the valve leaflet clotting. We're going to see those results a little bit more in the sub-study result that they presented last year. The study not yet published. And the results indicate that overall, the primary outcome, apixaban versus the control groups in the mixed population, overall population, no difference in the CT videos of the leaflet clotting and the motion. However, significant interaction. There seemed to be some benefit versus antiplatelet prevention of the leaflet clotting from 9% to 16%. That's a difference. Whereas in the oral anticoagulation, there seemed to be 9.5% with apixaban and nearly half, really 5.5% with Coumadin. Not so, I would say, interesting, the result. Let's come to another trial we presented 9 months ago, the edoxaban-based trial, ENVISAGE, as we call it, over 1,400 patients, edoxaban versus vitamin K, edoxaban group. By the way, this patient, everybody had fibrillation now. The hypothesis of anticoagulating patients who otherwise don't need it because they don't have atrial fibrillation did not go very far, as you saw, based on the few previous trials. But in this study also employed the chance, and I was exercised about half the time of edoxaban to go down to 30 milligrams due to low creatinine clearance or low body weight, as well as there is also an exclusion of some strange medications that really not very, that have a cross reaction. That's not a very frequent cause. Vitamin K with a classic vitamin antagonist with a classic INR 223 and a little bit lower in the Japanese population do a lower body weight in these patients. About half of these people overall were on antiplatelet therapy, and because this was for whatever reason, primarily coronary stents, I would say. This practice was more prevalent at that time than now. Overall, this was a non-inferiority trial. This was proven right, the non-inferiority to net adverse cardiac events, as you see on the left side, the lines are nearly on top of each other, all the way out to 2 years, edoxaban and vitamin K, a mix of MACE and bleeding. On the right side, you can see that the bleeding signals seem to be unfavorable, particularly beyond a year of therapy. So when you are administering these agents beyond a year, you have to be really careful and perhaps avoid or do something else or consider these patients for Watchman or I don't know, Coumadin. We really a lot of open questions when we follow such patients in a long time. We learn a lot. You see the bleeding, major bleeding was about 15% with edoxaban at 2 years and nearly 10% with warfarin at 2 years. And again, that's a big numbers in both. The main outcome, the non-inferiority, remains a key finding of this trial. So based on the guidelines of these and other previous trials that I'm sure I didn't repeat, but have rehashed, the European guidelines don't find a real reason for clopidogrel in any patient. In my mind, this is not so clear because the studies were all done with loading before the procedure. So no study has really tried the clopidogrel just after the procedure. So I have to be a little careful there. But clearly no need to load anyone with clopidogrel and follow dual antiplatelet therapy. In the high-risk patients, we may follow dual antiplatelet therapy as well. In our center, we follow dual antiplatelet therapy starting after the procedure for 3 months, according to the American guidelines. But given the location of your conference, I focus in the European guidelines in this talk. Once you anticoagulate the patient, there's no need for any concomitant therapy. At the same time, I don't think anybody does TAVI with pre-established oral antiplatelet agents on board, the way the popular TAVI investigators did. I guess the study is popular, but this approach not so popular. So the key question, though, is that we've been not so successful in showing a clinically meaningful way to prevent this phenomenon of leaflet clotting. But how about if we find it? And how will we image patients after TAVI? Let me just be brief and present a presentation, a slide really from a recent publication that essentially acknowledges that we have a serial T, and if the gradients are stable, then that's fine. And if the gradients are not stable, there could be a significant risk for a high-grade leaflet motion abnormality. We all understand that with a transthoracic echo, we may miss the mild or the moderate cases of leaflet thickening. But again, based on the previous studies, not much to gain about those for the time being. Whether those mild, moderate leaflet thickening may pose issues on valve durability further down the line, we don't know. Maybe they do. We're going to find out in other studies, but as of now, we don't know. So we focus in the severe cases. And those we interrogate them with a CT, 4D CT angiography, as I explained to you, the CT video, or if that's not feasible due to renal failure, perhaps with a transesophageal echocardiography. And in those cases, we start anticoagulation with a hope to dissolve the clot over a period of 3 or 6 months. And then we repeat the imaging and the echo and look for an improvement in the gradient. And very, very frequently we do fine. And again, the next question that happens at that point is that, well, anticoagulation is successful in those rare cases that the leaflet clots created about dysfunction acutely. Can we stop it, or we should have, or if we stop it, will it recur? We don't know that. So technically, I would say one after 6 months of anticoagulation may give a chance of several months off in order to see if this phenomenon repeats itself. And then perhaps surveil if it doesn't. But if it repeats itself, then you have to commit the patient on anticoagulation for life. And thankfully, this is a minority of patients. I'd like to thank you very much for your attention. And thank you for inviting me to this great valve conference.
I think that was a wonderful talk by Dr. Dangas, and we look forward to having him live here with us tomorrow. Dr. Pereas, do you want to introduce the next speaker?
Thank you. Thanks for having me too on this great session for this conference that is now really established in our local community. And it's a great pleasure to introduce a surgeon who is a pioneer not only in minimally invasive surgery, but also in the transcatheter techniques. So we're looking forward to the talk of Dr. Vinod Thurani, how I select my TAVI devices. Dr. Thurani, are you with us?
Hi, I want to thank the organizers for inviting me to give this talk on how I select my TAVR devices. I'm Vinod Thurani from Piedmont Heart Institute in Atlanta, Georgia. I wish I was there in Greece with you, but instead I'm in Boston, Massachusetts at the AATS meeting. So I look forward to seeing you maybe next year. These are my disclosures. So the TAVR technology really has exploded over the last decade or so, or the last 20 years when the first TAVR was done, and now is quite remarkable in what it has performed. However, there are factors to consider in choosing a prosthesis, and for the most part, they are anatomic, they're procedural risk, and there are also follow-up components of it, and we'll talk through all of those. For the most part, there's balloon expandable and self-expanding. There's also mechanical expanded, which is not available nearly as much anymore, or is taken off the market, at least in the US. And we'll talk a little bit about mainly just broad spectrums of balloon and self-expanding. The first is anatomic. You have to look at the annulus size. I think that's important. It's very different. Self-expanding use perimeter. Balloon expandable use area. And so I think that it's just very good for the operator to understand what are the differences between those, and looking at the different 23, 25, 27, even the 20 for the balloon expandable, and the 29 valve also. So just understanding the annulus makes a difference for me in how I choose that TAVR size. But really what becomes important, the next 6 topics that we'll talk about. One is coronary obstruction. I think this is really important now, as we see 1/3 of the patients in the United States are now low risk. Re-access has become very, very important for us. Risk factors for coronary obstruction are small, sinus of valsalva diameters, low coronary heights, leaflet height, and bulk. that is very long. And then, of course, the future need for TAVR and TAVR and valve. What's generally accepted is that coronary protection and later access is easiest with balloon expandable valves. Repositioning is only available with the self or mechanically expanding, and access may not be possible if the mechanical prosthesis is above the coronary ostia. So I think these are some important caveats to remember. Coronary disease is very prevalent in the TAVR patient. You can see here, coronary disease is up to 80% of a cohort. It's essential to know how to access these coronaries for long-term post-TAVR, and I think that'll become more and more important. There are many illustrations that show you the differences of what to do. Generally speaking, the anatomical issues are sinus-tubular junction, dimensions, the sinus height, the leaflet length and bulkiness, the sinus valve salvo width, and the coronary height. Of course, it's a little bit more difficult to do this with self-expanding valves because they generally are well above the STJ versus a balloon expandable, which generally is not above the STJ. So I think that the conversional tab orientation, the ceiling skirt height, and the valve implant depth are important more for the balloon expandable valves. In a study published in 2018, only about 38 patients out of 17,000 had delayed coronary obstruction. Overall in-hospital mortality, however, was 50%. So I think it's important to understand this pathway. You can see that a little bit more instance of delayed coronary obstruction in self-expanding over balloon expandable valves. So I think it, once again, is very important. And here you can see an algorithm in 2019 that kind of looks at the different pathways for this. And I think you have to understand this, what are anatomical and device-related factors that kind of predispose to impaired coronary access after a TAVI. And I think specifically in TAVI and TAVI, this becomes more of an issue, especially when the stent frames of the two prostheses will overlap. And the new stent will push and spread the previous leaflets over the original stent. So commonly a self-expanding valve does not go back into a self-expanding valve. You almost always have to use a balloon expandable valve for that. So I think this is really important, especially in low-risk patients where this becomes a bigger issue, I think, down the road. Number 3 is you assess the LVOT calcium. I think this is really important. LVOT calcium and prosthesis oversizing have been associated with annular disruption of ventricular septal defect and paravalvular regurgitation or leakage. And overall, the self and mechanical prosthesis may have an advantage both to reduce the risk of annular disruption. Balloon expandable has higher rates of root rupture with the initial inflation, while the self-expanding has more root rupture during the post-dilation for PVL. I think that you have to consider the aortic root angulation and tortuosity. Really, the balloon expandable prosthesis, because of the flexion, are a little bit easier, I think, for horizontal aortas. And really, if you look at aortas over a 40-degree angle, it's much easier to use a balloon expandable valve than it is a self-expanding valve. So I think tortuosity does make a difference, especially at the root side, more so than on the thoracic or abdominal aortic side. I think you have to understand the implications of permanent pacemaker implantation, or PPI. This is a moving target, as we all know. There's only a few randomized trials comparing the two devices. It trends obviously that mechanical expanded has more than self-expanding, which has more than balloon expandable in pivotal trials and registries. I think that it's influenced by non-device factors as oversizing, pre-existing conduction diseases and threshold for placement of the pacemaker, and also trends in higher implant position or reposition. You can see that in the bottom graph, the 30-day permanent pacemaker implantation rates are lower in the balloon expandable and higher as you get from self-expanding to the mechanically expanded. And you can see that about 16.5% in the low-risk Evolute study and 7.4% in Partner 3, which is a balloon expandable valve. So I think this is important to think about a little bit on how this is going to affect the future. And if you look at some pacemaker rates here, in the Reprise 3 intent to treat, you can see is 41% for the Lotus and about 26% for the core valve. Obviously, it does over time improve. For instance, the Lotus went from 35% down to 12%. So there is some pathway for improvement in this. I think the next topic is the risk and implications of AR due to paravalvular regurgitation. Also, it's a moving target with evolving devices. It's influenced heavily by CT sizing and oversizing, the calcification burden, the use of post-dilation echo assessments, i.e. a site lab, versus core lab, and the lack of some randomized comparisons for this. But overall, we've had a very good decrease in moderate severe paravalvular regurgitation. You can see from the original partner studies to the very last reprise studies that we had. Overall, if you look at the low risk, the incidence of moderate severe is relatively low, but mild is still in that 20% range. So we have done a good job, I think, with moderate severe, but not with mild paravalvular regurgitation. Here you can see similar data from the Partner 3 study at 1 year, showing very low rates of moderate or severe PVL, but again, a 20 to 30% mild PVL rate. So I think that's something to keep track of across the board. Here you can see that the current data suggests slightly less moderate and severe PVL with a balloon expandable SAPIEN 3 than the self-expanding, but high for the mild PVL for those. The lowest rate has really been with the mechanical expanding, but that's obviously now off the market, but it does make a difference as far as the calcium burden level goes. I think that you also need to consider hemodynamic differences in prosthesis patient mismatch, otherwise it's known as PPM. We have known that really the goal for TAVR is a larger effective orifice areas. We know that that leads to better survival and possibly better durability. The incidence of severe PPM has somewhere been in the 7 to 20% range. And you can see that across the board, incidence of PPM has been higher in balloon expandable compared to self-expanding valves. And this is just an overview of some of the different trials or registries for this. We do think this is important because severe PPM does lead to a higher mortality, at least already at 1 year, so definitely more by the 5-year time period. And there is a big difference between if you look at the second generation valves at the top, but let's just concentrate on the third generation valves. You can see that when you have a small annulus, PVR is about 47 to 43%. For blue is self-expanding, red is balloon expandable. You can see that you have a little bit higher PPM rate in this. And then as you get into the large annulus, there's less of a difference between it, but still you see a little bit higher or significantly higher in the balloon expandable versus self-expanding patients. And when you look at the mean gradients here, you can see the self versus balloon expandable in small annuluses. Specifically, you can see that this is the Accurate Neo versus the SAPIEN 3. You can see the Accurate Neo has better gradients across the board compared to balloon expandable. And you can see on the patient prosthesis mismatch, there is none is 59% Accurate Neo and 33% for SAPIEN 3. More moderate, about 44 versus 38%. You can see 22 versus 3% for balloon expandable versus self-expanding. You also see this in the Partner 3 study with about 8.3% for the for severe PPM by VARC2 definitions. You can see it was 1.1 for the self-expanding evolute valve. And this is just represented the TBT database showing discharge echoes with different valve sizes of balloon expandable versus self-expanding. Obviously lower gradients with a self-expanding valve. So the risk of root rupture injury minimal during deployment of self-expanding. However, the risk exists in post-dilation. Self-expanding has hemodynamic benefits as if phase sinuses are associated with smaller annuli. However, self-expanding has challenges of a coronary occlusion in these phase sinus. So I think these are kind of important aspect in these small aortic annulus patients. Where there's really not much major differences or really or great data to showing between the two includes those that have stroke. Partner 3 has shown lower 30-day stroke rates in balloon expandable valves, and self-expanding durability is unknown at this time. Cost effectiveness really has not been shown between the two valves either, except you would anticipate that the lower pacemaker rates, there'd be a lower length of stay in the balloon expandable valves. At the end of the day, I think that the balloon expandable valve is easier to use. There's because of the flex mechanism, there's better coronary reaccess. There's lower rates of pacemaker implantation. It's a lower profile and it's best for the future TAVR and TAVR. While the self-expanding has repositionable, it's less traumatic, potentially with a heavy LVOT calcium patients, and is better in the hemodynamic component of it. Our workhorse has been the SAPIEN 3 Ultra, and we've been using the self-expanding in niche scenarios across the board. Right now, the Accurate really isn't available in the US except in the Reprise 4 trial, and that we've been using it for that as it comes up. Thank you again for inviting me to give this lecture, and look forward to seeing you live, not only hopefully this year, but also in the future in hopefully Greece sometime. Again, thank you so much.
Fantastic. Thank you, Dr. Thorani.
Thank you, Dr. Thorani. It is interesting to listen to a surgeon giving you instructions how to select your TAVI device.
Yes, makes us proud.
Yeah, really.
Indeed.
I think we are blessed to have now Dr. Dangas connect with us. Is it true?
Dr. Dangas?
Yes, she's.
Kalspera. Hello there.
Hello.
Gregor. Hello, Kostas. It was pleasure to connect and pleasure to also listen to Vinod's talk. Very great discussion. Very great lecture.
Perfect. You landed on time. And
You're coming tomorrow or today? So we'll see you in person as well.
Absolutely. You'll see me in person tomorrow.
Perfect.
Perfect, George. We enjoyed your talk. It was really very informative, and you updated all our knowledge in the field. And we have one question from the audience for you. And the question is, what is your practice in antithropotic therapy for patients who are undergoing valve-in-valve or TAVI-in-TAVI? Do you treat them differently? Is monotherapy enough for them? Then this question separates into two arms. What if they are in sinus rhythm, and what if they are in atrial fibrillation? And I would add to this an extension. If you treat differently patients with very small aortic root anatomy, that you see that the space behind the native leaflet that goes outside the valve to the left main, let's say, is very short. The sinus of Valsalva became really small, and you see slow blood flow there. Do you treat differently also this patient population?
Yeah, well, these are three questions. That's great. I think, first of all, let's understand that we're talking now empirically based on general knowledge, not based on any type of randomized trial that was been conducted in general about all patients. So the results overall we covered in the lecture. Now we have questions regarding specific potentially high risk for thrombosis populations. These are the scenarios you presented. And therefore, whatever we say, and my answers would be, are not part of those trials. Those patients may have been a minority of any of the trials, but they pose certain tasks not covered by. So in general, there are thrombotic, I think, concerns in patients with valve-in-valve or double TAVI, or those who have limitations of the neosinus. That's the area that you just described, that's outside the cage or the outside the metal struts of the valve and in between the old sinus, let's say. This area is occupied by the native leaflets, so to speak, after they're crushed. Some of them can be long, can be bulky, can be eccentric. There's some areas, if the original and the native sinuses are not too big, they may get filled quite a bit in certain areas quite unfavorably. And in those situations, they may pose an immediate or a subacute threat to the left main coronary flow. Let's start from this last scenario. I think in those situations, you may, if essentially you're doing a TAVI and you feel very lucky, you did not cause any compromise of the left main, although you were concerned about it, I think those could be considered for a limited anticoagulation for a few months. Now, if we're dealing about a TAVI and double valve patient that is already in atrial fibrillation of some sort, I think the monotherapy is a good idea of an oral anticoagulant anyhow. So I think that case is closed. Now, what do we do about a valve-in-valve patient that is in sinus rhythm? And I think, again, we can consider the 3 months of anticoagulation. in a patient who we judge to be a reasonable candidate for it. So somehow is not at exceedingly high risk for bleeding based on our assessment of the patient. So that also requires some kind of a clinical judgment, so to speak. So I'm not going to say that a frail lady of 90 plus is going to be anticoagulated just because it's a double valve, maybe not. But maybe someone who is, less of a bleeding risk candidate should. Then finally, the other answer maybe you wanted to ask, but maybe not asked me yet, is what do we do with small size valves? Interestingly, more clots in general have been found in the large size valves. I think this is just a statistical thing, just because the larger valves have a larger surface, there is more chances for a clot. But when we go to higher grades of clotting causing leaflet dysfunction, then those are found more in the smaller valves. And why is that? I think because the valves here are smaller, you get a smaller, if you want, nudge in order to block the function. If the valve is bigger, you're just gonna maybe form more clot, but you really need a lot of clot to block a large leaflet. So maybe we're sensitive to the smaller valves, or the smaller valve, the smaller size leaflets are sensitive to these clottings. Maybe those could be anticoagulated. Again, I'm not sure. Particularly the smaller valves are typically fit in smaller size patients, and in general, smaller size patients are high risk for bleeding. So I'm also, if a patient has a smaller valve, I probably surveil a little bit more carefully. And if we see a dysfunction, then we initiate an anticoagulation to dissolve the clot. But I'm not ready to say that all small valves up front need to be anticoagulated. I think those single valves, I may say, a small size, a 23 or a 20 valve, again, maybe you surveil more carefully, but not everyone on anticoagulation. I think we have to be careful to avoid anticoagulation as much as we can, and at the same time we have to be vigilant enough so in case we see an indication, then we don't delay to start it in order to avoid having the valve function be irreversibly frozen, let's say, the leaflets by the clot that can then be organized and over time it become pannus and all that. So if something's happening, you want to really dissolve it early on. And I know we follow several cases and people call for similar parts of the world with those things, and usually those respond well. And the secondary question becomes, well, what do we start? How do we stop it now? And again, that's a judgment. If there was a clot that was causing a gradient, that was causing a valve dysfunction, you caught it, you anticoagulated the patient, 3 months, 6 months later, there is no clot, there is no gradient. I think from then on, it's again a judgment. Is that patient a low risk for chronic anticoagulation? If the answer is yes, well, maybe you should continue. But if the patient you judge is a little bit too old, maybe medium risk, maybe you after a year or 6 months or a year of anticoagulation, you get a break for 3 months or so and see by imaging, by the 4D CT, did the clot reaccumulate? And then maybe if the answer is no, you give the patient a break and stop and don't resume the anticoagulation.
Great, George. You covered very well all the three scenarios we gave you, and you added your own scenario, a fourth one. I think it's not just the size. I think it's more the gradient. When you finish a procedure, either in a small valve or in a valve, a double valve, and you see a high gradient, you end up with a high gradient, then you start to worry. And you say, what about if you add some clotting films here and the gradient will go up? So I think it's mostly the gradient you end up after TAVI that it concerns you, and you may decide to go. Would you tie your decision on the gradient mostly than the size?
This is another great question. The answer is yes. And that gives me an opportunity to explain what I do with a gradient. As you know, there is two kinds of gradients. One is a direct gradient that we measure in the cath lab, which is very accurate, actually the gold standard. Pressure gradient is a difference between the two pressures. That's the only time we measure that. With the echo, we measure the velocity, and then we calculate a gradient. Unfortunately, a lot of patients with TAVI have a lot of LVH. So they do get a lot of an instantaneous acceleration of the velocity because of the LVH. And often that's really not a very wide, I would say, envelope as we see in echo. However, it does give a very high number. And therefore, what I find is maybe a little misleading. In the echo gradient, you get a high velocity, and then you report there's a gradient of the mean gradient of 10, mean gradient of 15 or something, day one. I think is not a good practice to avoid measuring the invasive gradient immediately after the procedure, so you can get an understanding of what's happening with this difference. And then you note that difference. If you, in the end of the procedure, you have a cath gradient of like 0 to 2, and then you measure a mean gradient of echo by 12, let's say. Then you got to subtract those and say, you know what? I want to make a note that this patient has an instantaneous gradient due to the LVH acceleration of 10 that is not exactly a valve gradient. So then, from then on, you can measure your gradients more accurately with echo. Is there a jump? From 12 we went to 20? Well, that's a jump. But if you forget about it and then all of a sudden say, you know what, the echo is 16 at 30 days or whatever, then all of a sudden you're alarmed, like, oh my God, that's a big gradient. Well, maybe that isn't a big gradient because you had 12 on time 0 just because of the acceleration phenomenon. And that causes a little bit of a confusion in general. So I suggest always to measure the invasive gradient in order to note what the difference is and do a little bit of an auto-correction if you want. But yes, if you do end up with a gradient that you cannot get away, let's say you have a gradient, a real gradient of 5 or 8 or 9 by the cath, which is a lot, that's going to give you a gradient of maybe 20 by the echo. And somehow the valve is a little high and you don't want to postulate or do any other maneuver, then I would worry about this valve much more because, you know, you have already some form of an incomplete acceleration, correction of the AS. You know, yes, I would take an extra measure and anticoagulate this patient for a few months, because you really can't afford much here. I agree with that. Again, that's a minority of patients. Again, those patients not covered by any of the randomized trials. Patients with significant gradients post-TAVI generally were excluded from the randomized trials.
Can I ask you a question, Dr. Dangas? You mentioned you would not tolerate any gradient at the end of the procedure? No gradient? I mean, like, what would you tolerate as a hemodynamic gradient at the end of the procedure?
Hemodynamic gradient, I would hope we're always under 5, is not under 2. I don't know. We have a hemodynamic gradient, I think, it has to be really very close to 0.
Okay, okay.
And most of the time it is, actually. I don't remember the last time that was 2 or 3, but we don't get a 10 or something. Unless you may get something like that if you're in a constricted scenario of a valve-in-valve, that essentially you have a component of a PPM, patient prosthesis mismatch, that you cannot, sometimes cannot get away. And you have to, again, note it and accept it. So there has to be a little bit of a notation, if you want, like a correction factor for every patient. During the procedure, we achieve the gradient of whatever on echo. At the same time, the gradient of cath was that. And I think you always know that difference or note that difference with this patient going forward. So you get an understanding of what else may be happening in this heart, perhaps a mid-cavity gradient, perhaps many people have other things. And then you kind of need to carry that knowledge or that piece of information forward with you as you assess the patient periodically.
Perfect. Thank you for being with us, George, and we look forward to having you here tomorrow.
Me too. Great.
Thank you. And last but not least, Dr. Reardon from Houston, who is a real eminence in the field of cardiothoracic surgery again, and has pioneered and contributes to a lot of writing committees in the USA. So we're looking forward to a talk regarding valve guidelines update and a roundtable discussion.
Good morning. Thank you for having me at the Greece Cardiovascular Conference again. I'm sorry we're not there in person. I'm Michael Reardon, Professor of Cardiothoracic Surgery and the Allison Family Distinguished Chair of Cardiovascular Research at the Houston Methodist Hospital. Today we're going to talk about guideline updates. These are my conflicts of interest. I've been involved in most of the TAVR trials as a national principal investigator, but I'm also a cardiac surgeon, so I look at both sides of the equation. What's the data on which we built our guidelines and where we stand now? Well, there's been a number of randomized trials. There's an extreme risk trial for the Partner 1B, which was randomized against medical therapy and a 20% survival at every year for 5 years. When we did core valve extreme risk, we could no longer randomize because Partner was already out. So we used an objective performance goal, which was easily surpassed by TAVR. If you notice, the 5-year survival for the TAVR arms is virtually identical in these two trials. We then moved to high risk, where we used a primary endpoint of all-cause mortality. Partner 1A had non-inferiority over 5 years. The high-risk core valve pivotal trial was statistically superior for TAVR in years 1 and 2, but by year 5 was non-inferior. So high risk was approved in the US. Then we moved to intermediate risk, the Partner 2A and Surtavi. Now we have a primary endpoint of all-cause mortality or disabling stroke, non-inferior over 5 years for Partner 2A. A little worrisome, you see the curves cross at about 3 years, and it's going to be followed for 10 years, so we don't know if these are going to continue to diverge or become parallel. Surtavi is non-inferior over 5 years and pretty much parallel. Then we go to low risk, the Partner 3 trial and the Evolute low risk trial. When we go to low risk, you need more endpoints because you need more endpoints, more patients, and more time because there's less events. So Partner 3 decided to add events by using a composite endpoint of all-cause mortality, all-stroke, or hospitalization. Jeff Pop and I decided we'd be more conservative and stick with all-cause mortality or disabling stroke. We added time by using a Bayesian analysis, which allowed us an early look at the data to predict a 2-year endpoint, therefore adding time. Well, the low-risk trials turned out to be positive trials, and therefore low risk was also approved in the U.S. And the ACC AHA guidelines in the U.S. now say that if you're less than 65 or going to live over 20 years, you should consider surgery. If you're 80 or going to live less than 10 years, you consider TAVR. If you're a good candidate for transfemoral TAVR, between 65 and 80, you should look at the physiologic risk of surgery, the anatomic risk of TAVR, and the patient's preferences to make up your mind. It's a little different from the European guidelines, which say if you're 75 or less and low risk, you should still consider surgery. 75 or greater or high risk, you can consider TAVI. So a little bit of divergence in age, but most of it's based on age and longevity now rather than risk. And these are the highlights from the European guidelines, and just as I said, 75 is the main cutoff here. These were revised in 2020 for the US and 2021. So these are fairly recent revisions. And both these guideline committees really now look at these guidelines as a living document that should be frequently updated because of the pace of data becoming available. So right now for aortic stenosis in 2022, the question is SAVR or TAVR. Well, if you have aortic stenosis, it's a class 1 indication. There should be shared decision-making between the patient and the heart team. And the heart team should be a real discussion between the surgeon and the cardiologist, not just one or the other deciding what should be done. And surgery is still appropriate for younger patients, less than 65 in the US, less than 75 in Europe. We also look at TAVR for older patients, over 80 in the US, over 75 in Europe. And if you're an appropriate candidate for transfemoral TAVR, you should be having TAVI and not surgery. We also look at other indications. So if you have TAVI with TAVI or surgery for patients that are 65 to 80, TAVI is still a class 1 indication based on what patients want. For Europe, if you're less than 75 and with intermediate or higher risk, then you can start thinking about TAVI still. When we look at patients that have any indication for TAVR but have unsuitable anatomy for transfemoral TAVR, and I'd really say non-transthoracic TAVR is what we're really worried about. If you could have any non-transthoracic TAVR, it's probably equivalent to transfemoral. But if you can't have that and you have to have a transthoracic, that's a class 1 indication to stick with surgery. Patients of any age with high or prohibitive surgical risk, TAVR is still preferred. And then for patients that aren't going to live a year, neither TAVI or surgery is appropriate. These are palliative patients. This is a great article written by Catherine Otto. Catherine was one of the authors, lead authors on the U.S. guidelines, has been a leader in valve case. And again, what Catherine does is outline the differences in the ages, and you notice where the different bars start. Some of the other differences is that the Europeans recommend a mechanical valve for anybody 60 or under, US 50 or under, and then 50 to 60, you start thinking about what the patient wants. Over 60, think about a biologic valve. So this is what's happened in the US. There are now more TAVR cases done than all surgical aortic valve procedures of any type put together. These curves are never going to change back. There are going to continue to be more TAVRs. If you notice, though, the overall surgical curve, the red line at the top, has not dipped as much as the TAVR line is going up. And as a cardiac surgeon, I can tell you I still have more to do than I can get done most every day. Now, one thing that may change this is something I had the privilege of presenting at the ACC as a late-breaking clinical trial. We looked at the high-risk pivotal trial and the Surtavi intermediate risk trial. We used the randomized arm of both these trials to look at the risk of moderate or greater structural valve deterioration in surgery and TAVR. We define this as an increase of the mean gradient of 10 millimeters of mercury or more between the 30-day or post-discharge echo and the last available echo, and a final mean gradient of at least 20 millimeters of mercury or more, or moderate or greater intraprostatic aortic regurgitation. And if you had that or greater, you had moderate or greater structural valve deterioration. Oftentimes, patients that are younger and are being considered for surgery or for TAVR are often told you probably ought to have surgery because surgery has the best durability data. In this trial, with well over 2,200 patients that were randomized, what we found is surgery had a moderate or greater structural valve deterioration rate of 4.38% and TAVR of 2.57%, which was statistically superior for TAVR at the 0.0095 level. And the self-expanding valve is the only TAVR valve that's ever shown better durability than surgery. The same thing was done for Partner 2A, and the XT second generation balloon expandable valve actually had statistically more structural valve deterioration than surgery, but the third generation Sapien 3 had about the same amount, but of course these were the non-randomized continued access arm, whereas this trial that I'm talking about now was all randomized. The other thing that we showed in this trial is that if you did develop structural valve deterioration, whether you had surgery or TAVR, it doubled your risk of dying and doubled your risk of rehospitalization. So I think this kind of data is going to reframe how we talk to younger patients. We know that for the self-expanding valve, it has superior hemodynamics against surgery in every randomized trial that's ever been done at every time point to test it. Now for balloon expandable, the low-risk trial, surgery actually had better hemodynamics, but for the self-expanding valve, it's always better. Now we've shown that not only is it hemodynamically better, but it has less structural valve deterioration. So when you're thinking about the first valve for younger patients, this starts to make some sort of sense. We also showed that the advantage over surgery was even greater if you looked at small aneurysms less than 23 millimeters on the CTA, which are many of the women that we see. Mitral regurgitation, we have to think of it as primary and secondary. Primary mitral regurgitation, that's a class 1 indication for symptomatic patients and asymptomatic patients with LV dysfunction. We can start adding in atrial fibrillation or pulmonary hypertension by the European guidelines. And if you have a high likelihood of success, greater than 95% repair and less than 1% mortality, it's a 2A in the US, even for asymptomatic patients. Mitral valve surgery can be considered with progressive increase in LV size or decrease in EF, but that's just a 2B in the US. It does not exist in the European guidelines. If we look for the indication for primary MR, mitral repair is always recommended over replacement. That's a class 1. And if you can't do a repair and you just have posterior leaflet, doing a replacement is a class 3, should never have an indication. Regurgitation for primary, we now have MitraClip, the transcatheter edge-to-edge repair. It's now a 2A in the US, 2B in Europe. one thing that's about any of the mitrals that come in, guideline-directed medical therapy makes a real difference, and you should really make sure your patients are on good therapy before you stop. I'm going to skip a little forward because I'm going to run out of time here and talk a little bit about secondary MR. Secondary MR, we've never had a surgical trial showing increased survival with surgery for secondary MR, whether it's repair or replacement. Until we had COAP, we had no trials. COAP did show an improved survival. Now, interesting, MITRA-FR did not. If you look at the comparator arm that was medically treated in both of these, they had the exact same endpoints at 2 years. So they're probably equal patients. What was the difference? Less MR and COAPT, and with less MR, they got more guideline-directed medical therapy. Guideline-directed medical therapy has been shown consistently to increase your lifespan with secondary MR. So we need to remember that guidelines are guidelines. They're not legal documents. They're not mandatory edicts. They're not cookbooks. You need to allow flexibility for shared decision-making. And clinical judgment is paramount in interpreting the guidelines and in treating complex patients. Thank you very much. Pleasure to talk to you. Happy to answer any questions.
Thank you very much, Professor Reardon, for this excellent and informative talk. It looks like TAVI is here to stay, and surgeons need to remain close to the practice of TAVI because it's the real future.
Arthur, we think it's the future, we agree.
I think it was amazing the results on SVD that he has just shown to us from the core valve low risk trial, and this is a repetition of the NOSON trial with better performance of the TAVI devices to 5 years compared to the surgical devices. And since we have 10 minutes more before the closure of this session, I think this is the right time to present one live in a box TAVI case, and Dr. Christopher Harris will do that. A very interesting recent case of the last few weeks in 10 minutes. Michael.
Is it on?
Okay. Okay. So good afternoon. We're going to present the TAVI case. So let's go to the first slide. 1 second. First slide of this presentation, please. Can I control it from here? I guess I can. Huh? Okay, I can. Okay, so the patient is an elderly female, 83 years old, presenting with severe aortic stenosis, typical symptoms. By echocardiography, Emax was 3.7, the peak and mean gradient 55 and 35 respectively, and the valve area at 0.6. Preserved left ventricular ejection fraction with moderate LV hypertrophy. The coronary angiography was without any stenosis. She's burdened by chronic back pains, and she's with decreased mobility overall. She was considered by the heart team, and she was forwarded for evaluation for TAVR. This is the CT analysis, and what we can see is that the annulus in the left image had a dimensions of 19.4 by 23.6, with an annulus area of 362 millimeters square and a perimeter of 68.9. The LVOT was a bit more narrow at 3 millimeters depth. The sinuses of Valsalva were at 27 mean diameter. The sinotubular junction at 22-23, and the ascending aorta was normal in size. This is the projection angle, LAO 6, caudal 1 for the implantation of the valve. There was mild to moderate calcification of the leaflets, but nothing excessive. And the peripheral arteries were good for transfemoral access. So with that, we decided for a 23 millimeter SAPIEN 3 Ultra valve, which we see can go from 338 to 430. We would adjust the volume to something less than nominal to accommodate for the annulus size. We can proceed now with the presentation. Yes, the video, please. Yes. So we'll see peripheral access in the standard fashion, crossover technique and access from the right femoral artery. We'll skip a little bit ahead. Secondary access from the left femoral artery. And this is the root angiogram. We see that the size is correct. It's a small, relatively small size valve. Insertion of the 14 French E-sheath after pre-closure with 2 ProGlide suture closure devices. And this is the insertion of the 14 French E-sheath without difficulty. And here we see access into the left ventricle and the hemodynamics. Once we entered the left ventricle, hemodynamics confirming severe aortic stenosis with a peak-to-peak gradient of 60 millimeters of mercury. Good diastolic separation from between aorta and LV. And this is an exchange wire, a pigtail in the left ventricle. We see that it's a very irritable left ventricle with lots of ectopy. Subsequently, once things cool down, we inserted a extra small safari wire. Again, lots of ectopy. And what we've noticed is that the patient becomes hemodynamically unstable with persistent drop in the blood pressure, even though the wire has been repositioned to a different position. We see also left bundle branch block developing, and we have persistent low blood pressure in the order of 50 systolic, and the wire is withdrawn to get things back to a reset point and see how this will go. And we see now that gradually the blood pressure will start coming up. This is a first attempt at inserting. I'm just going to fast forward a little bit. You can see it takes a long time for the blood pressure to recover. An transthoracic echo is performed immediately on the table to exclude any pericardial effusion, any wall motion abnormalities of the left ventricle, any new, what we see is moderate mitral regurgitation, but we attributed this to maybe the new left bundle branch block, maybe some issues with synchrony, and so on. The blood pressure recovered nicely, so second attempt at getting a wire across. Just going to move forward a little bit. So again, we cross the valve. And this is a soft, soft wire. Lots of ectopy, very irritable left ventricle. We find a position that's more, things calm down. And then we advance the pigtail over this, and then subsequently, again, an extra small safari to advance in the left ventricle. This is the extra small safari again. So here we think we're okay. So wait a little. But then we see that the blood pressure starts dropping off again. After a period of ectopy, the blood pressure becomes progressively less. We see here that this is an unstable situation. So lots of ectopy, and the wire is withdrawn again. You'll see, we withdraw the wire again. We try different positions, but to no avail. And the wire is withdrawn again. So our initial plan was to do a balloon valvuloplasty and then go ahead with TAVI. So we decide now to skip the BAV part. The valve was not really that calcified. So we would prepare the valve, and then at the last minute, enter the ventricle, this time with maybe a different wire, an extra stiff amplets pre-shaped by us. And we see we don't have any significant regurgitation. Yeah, and then do things in a bit of a fast pace. So here the valve is ready to come to the table. We again cross the valve with the soft wire, a pigtail, and then over that we advance a extra stiff wire pre-shaped by us. And again we see the blood pressure becoming unstable again for no apparent reason. But as you will see, the blood pressure continues to go down. So here we're moving in fast motion to get the valve up. The blood pressure is in the 50s. So we do the balloon alignment in the descending aorta over the arch and ready to deploy the valve with a blood pressure of 50. We will do a rapid pacing. So this is a final root angiogram. Blood pressure is in the 50s. You see, I now have rapid pacing and deployment of the valve. This is minus 3 ml from the nominal volume. We withdraw the balloon catheter and we reassess, waiting for the blood pressure to recover. Blood pressure gradually recovering, and we do a root angiogram to see the valve looks well positioned. Again, this was a minus 3 ml. So we opt for slight post-dilatation of the valve to foreshorten the inflow of the frame. We see the blood pressure recovering nicely. And this is the final post-dilatation. So overall, this was with minus 2 ml on the volume of the valve. And this is the final angiogram. Well-positioned valve on echo without any Pvl. Normal wall motion without any evidence of wall motion abnormalities. No pericardial effusion. And after that, this was a standard closure of the axis and a good result.
I must say that this was the first time we have seen something like this all these years, just to have this instability with the wire into the ventricle. There could be many potential explanations. Dr. Nikas gave us an excellent talk this morning about suicidal ventricle, a small ventricle in a rather small lady. But I think there were multiple reasons. First was the new LBBB, so there was dyssynchrony in this hypertrophied ventricle. Then we had this runs of VT, and that could explain the drop of the blood pressure. But the worst thing was that we had this low blood pressure even without the VT. When there was stability, electrical stability in the ventricle, we still had low blood pressure. And the third, I think, that proved to be a part was the stiffness of the wire, because initially we have a safari wire that is very stiff, and then we decided to do something different, and we just got a extra stiff, amblets extra stiff wire that is much softer, and we pre-shaped that. And finally, when we did the final injection before expansion of the valve, there was a lot of AR. Mm-hmm. So I think that was also a part playing, explaining what happening. So we had probably a soft leaflet that was pushed by the wire. So we had additional AR that we couldn't see when we had wiring. So I must say that TAVI never stops giving you surprises, and that was a surprising case because otherwise it was a straightforward case, but it turned out to be a very difficult case. And that we came close to say, no, we haven't seen that before. Any comments?
Congratulations for going through the case with a good result. Of course, it's difficult to understand. It's multifactorial probably, but do you have, I didn't say that, do you have an echo during the low pressure? Or you had one?
Yeah.
And the ejection fraction was, overall contractility was okay at that time?
Yeah, we probably had some more MR than baseline, but as you noticed, the patient was going into LBBP when we were crossing, and then when we were pulling out the wire, the QRS was going narrow again.
Narrow, yeah. So there is clear association between the wire, the ectopy, and the low contractility, the low cardiac output, right?
It was also, so there were Ranso VT, new bundle branch block, AR from the wire that we have seen at the end. Initially, I was thinking that probably my wire was through the mitral valve codi, and we had MR. That's why we removed the wire, because we're thinking
three times the same phenomenon.
Yeah, but we're removing the wire and then making sure that going in again, we're away from the mitral valve codi. And we had the same problem again. So it was obvious that it wasn't interaction with the mitral valve.
So a very brave, good process. The other thing, the last one, is that I thought that I saw that there was a D shape on the LV at some sort of view by echo, and I was wondering if there was already pre-existing pulmonary hypertension that was squeezing the LV. I may be wrong, I don't know.
Yeah.
We have time for one last question before next session.
Thank you, Michalis, for an excellent case. It's clear to me that the most important reason for the low blood pressure is the AR, the significant AR. I had a similar case which have the same sequence of events, and as soon as we put very fast the valve, everything is solved. So I think the main mechanism here is the AR, severe AR, which we did not appreciate from the beginning.
We agree. Yeah, I think we have to go to the next session, but all the comments are duly taken. Great. Thank you very much. I think we have, perfect. I think we have, or we will have soon with us online, Dr. Billy Cohn. It's my pleasure and my privilege to introduce Dr. Cohn, who I first met when I was interviewing for a residency position at the Texas Heart Institute and Baylor College of Medicine. It's very difficult to introduce someone like Dr. Cohn. What do you say first? That he's world-renowned in the failure of VAD and mechanical circulatory support? Do you say that it's fantastic that he shows card tricks to Bono from U2? Do you say that he's an accomplished musician and performer in the Texas music scene? Really, I think from his lecture and from speaking with him, you'll see, just as I've seen, that he's the kind of person that is really very well-rounded, and that's why it's our honor to have him here with us today. Dr. Cohn, thanks for the privilege and the honor of being here with us today. All of Greece and all of Europe is excited for your talk.
Thanks for inviting me. It's a real honor to be here. I wish I were actually in Greece. I love Greece. It's one of my favorite countries. Congratulations on having such a wonderful meeting and so many wonderful speakers, and I can't wait to hear what I had to say.
I left out entrepreneur inventor, and multiple other things amongst your titles at Baylor, also at Johnson & Johnson now, but we're really very excited. I think we have your talk pre-recorded, and if you have the time to stay with us, then we'd love to have questions from the audience and have a short discussion at the end of your talk. Thanks so much for being with us.
Absolutely, that's my plan.
Thanks.
Again, thanks a lot, Greg. Hello, everyone in Greece. My name is Billy Cohn. I'm a cardiac surgeon, and I'm a professor at Baylor College of Medicine and Vice President of Medical Devices at Johnson & Johnson. I run the CDI in Houston, and I'm very grateful for the opportunity to be here with you today to present my take on how to develop medical devices. It's something I spent a lot of time doing in the last 25 years. First, I'd like to congratulate Greg, Dr. Patakos, on a wonderful meeting on transvascular heart valves. I wish I could be there in person. I hope you're having a great session. I'm sure you are. I'm going to be talking about medical device innovation, though, because that's where all those transvascular heart valves came from doctors like you who came up with an idea, put together a prototype, got together a team, and brought it forward. And looking backwards 25 years, it's actually easier than most people think. It's very prescriptive, and I've created sort of a little curriculum, if you will, for those of you who are interested in maybe pursuing that at some point to follow. If nothing else comes from this talk, if I empower one or two of you to take that journey, then I will have done my job. So I'm going to talk about my own path and talk about some of the things that I've learned in the last 25 years. Before I do, I have to make a disclosure. Everything I talk about in this presentation, I'm severely conflicted with. I'll try to maintain equipoise, but I encourage you to listen with the right filters. And then also, as a vice president of medical devices at Johnson & Johnson, I don't want you to think that this talk suggests any investment, emotional, financial, or otherwise, of Johnson & Johnson in these technologies. These are all things that I did on my own before joining J&J. Now, I was very fortunate. I got to train as a heart surgeon at Baylor College of Medicine. I was Michael DeBakey's last chief resident. He stepped down as chancellor at my graduation ceremony, and he stayed very active. Here he is lecturing at 99 years of age, shortly before his death. But my favorite photo of him is this one, where he's sitting down. He's in his late 40s. He's sitting down his wife's sewing machine, taking Dacron polyester and sewing it into a tube in anticipation of inventing the prosthetic graft. What a monumental achievement. It saved 20 million lives and limbs. And this picture, if nothing else in this talk has an impact on you, this should, because it shows that amazing projects, hugely impactful things, have very humble beginnings. There's no one listening to this presentation now that couldn't have sat at a sewing machine and sewed a Dacron graft out of Dacron polyester and done the experiment. And so coming from that sort of milieu, I started my own innovative journey. That had a big impact on me to see that anybody can innovate. And there's a lot of ways to innovate, and I should define this very quickly. We all know innovators. You can participate in technology that other people have invented. You can do clinical studies, but I'm talking about this last group, the idea of coming up with something, putting together a team, making a prototype and pushing it forward. And I am by no means unique in our generation of cardiac surgeons in doing that. Here are a bunch of cardiac surgeons, many of whom you know, and this is a very partial list. There's tons more. And in the next generation, perhaps people in their 40s, there's a new flock of them. But these are people that I know well that have all come up with an idea and pushed it forward and brought it to commercialization or close. And so my own innovative journey began here in the soup spoon aisle in a grocery store. I had seen articles coming out of South America in the mid-1990s, before many of you were born, describing off-pump coronary bypass. It was a very new thing at the time. And there were two guys in the United States doing them, Jim Fonger, who some of you may know. And I went and watched him do an operation, and he'd made his own stabilizer. Jim Fonger, very innovative surgeon, had taken a right angle clamp and with rubber shods made a tool that his assistant could hold on the heart and hold the artery kind of stable. And after watching the operation, I said, Dr. Fonger, congratulations. That's a great operation, but wouldn't it be easier if your stabilizer attached to the retractor so your assistant didn't need to hold it? And he said, yeah, I'm sure someone's working on that. Whenever anybody says that, it's you. I went to the spoon store. I bought a bunch of spoons and labels. I hammered them flat in the parking garage of my apartment building where I was living in Boston, cut them into various patterns. I had an idea for a way to make it work. I tested them in the animal lab, and after many successful animals, my chief of service, Ron Weintraub, encouraged me to try clinical cases. Here's my first mid-cab with my cut-up spoon. And as you can see, that's the LAD being held in position with rubber bands. And the first successful mid-cab. Industry saw that. They rapidly brought that technology to market. And it was my first successful patent, my first successful product. You can see evolving from the cut-up spoon to the actual commercial device. This was called the Cone Cardiac Stabilizer. It was brought to market by Genzyme. This is before the Octopus, before the CTS, before McKay. It was very exciting for me to see this thing, this fevered dream, this hammered spoon turn into a commercial product that was used in literally hundreds of thousands of cases. And I was determined at that early age, I guess I was 34, 35 at the time, to try to do this over and over again. And as a result, in 25 years of innovation later, what have I learned about this? Well, I've distilled it down to these 8 steps, 8 ways that you, everybody watching, can make a medical device. And if you stick to this rubric, to this algorithm, I think you'll find success. And I'm going to go through these steps in some detail. First of all, I don't think you guys realize what an essential component you are in the innovative process. Nobody, no engineer, no business leader, no marketing person, no consultant understands the unmet needs like you do, living this life every day. The frustrations you encounter in the operating room, the times you perseverate because you're not sure if you're doing something right, or you've had a complication related to that step before and you want to get it just right. The things that frustrate you in patient care, patient management, or navigating healthcare, those are the real opportunities to innovate. And you have them. No one else does. So I'm going to submit that you have a responsibility to innovate. Because if you take that to an engineer or to a business leader, you're the conversation they've been waiting for to get the party started. And you have that in your head. So if you have something that addresses an unmet clinical need in a field that you've got domain expertise and really understand, then it really is an unmet need. But you need to understand and respect the matrix. I'm not talking about Keanu Reeves. I'm talking about the matrix of things you need to get right to have a project that's going to be meaningful. And if you go down these, it's got to be a real unmet need. It has to have regulatory hurdles that aren't going to take a trial that's going to go on a decade. It can't cost too much to develop. It's got to have a large addressable market without a lot of competitors. There can't be any science fiction involved. It's got to leverage technology that exists. And the time it takes to develop it, something else can't obsolete it. I just made up this scoring system, but if you give each one of those a 1 to 10 score, 1 being the best, if the score is high, do a different project. It's so depressing for me to see people working really hard on a project that's never going to see the light of day because of these. But, and as you get more and more into your innovative path, you can take risks like I'm doing on the artificial heart. But this, if you can check these boxes and come up with something that passes the matrix, then start trying to solve it. And when you try to solve it, think simplicity. If you come up with a solution, you show it to your friends, they say, someone must have tried that before. It can't be that simple. Hurry up and patent it, because these are 7 technologies that everybody said were too simple to work. Angioplasty, when Grunzig first came up with the idea of angioplasty in a vessel, people stood in line to slap him in the face. They said, that's idiotic. And how many of you listening to this talk have ever used a Fogarty catheter? I'll bet everybody has. Every hospital has them. When Tom Fogarty thought of the balloon embolectomy catheter, he was a medical student. He showed it to Jack Cranley at University of Cincinnati, did a couple cases. They presented it at Grand Rounds. William Altemeyer was in the audience, president of the American College of Surgeons, and he stood up and said, only someone as junior as a medical student would not understand why this won't work. Well, it has worked and has been used in 25 million cases. So simple solutions. This is, by the way, the first commercial one from 1961 that Tom has in his office. Percutaneous aortic valve replacement. How many of you thought that was a good idea when you first saw it? You know, Well, it turns out it's changed the world. It's had a dramatic impact and countless lives have been saved. How about percutaneous AV fistula, making AV fistulas for hemodialysis with a catheter? Something I thought of that nobody thought was a good idea. Were they right or was I? Well, stand by. Be resourceful when prototyping. Oh, I know I just turned off a lot of you. You're saying, prototype? You didn't say anything about having to make a prototype. A lot of you have the misguided belief that you can't make a prototype. You can. The main reason for people not prototyping is this last one. You're afraid people will laugh at you. Well, if you make an inelegant prototype, don't show it to anybody. Just play with it for a couple days and then remake it and make it again. And after 5 or 6 times, you'll be holding something that you can't believe you'll make, that you made. And you realize, my God, I can do this. It's like playing guitar. It's like anything else. You get better at it with time. But if you're smart enough to do heart surgery, if you're smart enough to do a percutaneous valve replacement, you certainly can make prototypes. What's the key? Well, you need a prototype to follow Billy's 6 easy steps to starting a medical device company. Take a picture of this slide. It's the most important slide in talk. You need a good idea, but you're going to need a prototype. You're going to have to file a provisional patent, which costs a couple $100, and you're going to have to take a video and edit the heck out of it so it looks like your prototype's really working well. Why do you need to do that? Because none of you are going to be med tech CEOs. I've never been a med tech CEO. That's hard work and takes a very unique skill set. But with your prototype and your heavily edited video, you're going to be able to hire a CEO. That CEO writes the business plan, and then it's off to the races. That's why you need a prototype. That's why you need to learn to prototype. It's really fun. It leverages the skills you already have, and it's very doable, especially if you use the MacGyver principle. Do you guys remember MacGyver? He had the mullet haircut. He could use things that were readily available in his environment to defeat terrorists and fight nuclear war. If you understand MacGyver, then you'll immediately recognize this is medical device prototyping headquarters. On the shelves and aisles of Home Depot, you can find every type of thing out of every material to go home and MacGyver your prototype. And again, you don't have to show it to anybody. It's going to be inelegant, but after playing with it for a while, you'll say, you know, instead of using a hinge here, I should have used a folding piece of plastic. You'll go back to Home Depot. You'll remake it. You'll do it over and over again until you have something that you can make a reasonable video with. You have to be open-minded about where you source your materials. Open your filters. This is a true story. I was making a prototype of the central heart lariat that some of you may know. It was late at night. I needed a little tube. The guy wanted to know what for. I said, it's not going to help you. He said, well, is it electronics or gardening? I said, well, I'm making a device that's going to be used to tie off the left atrial appendage in patients with atrial fibrillation without opening the chest under x-ray. And he said, dude, we don't have anything like that. It was close to closing time. He had a clipboard in his hand and some Windex because he was doing inventory and cleaning the glass. And in the Windex was my little tube. So when you open your filters, there are resources everywhere. And then don't get hung up about the quality of your prototypes. I've been talking about that. Just do it. Know that your first iterations are going to be inelegant, but as you do it over and over again, they'll get better. These are the 5 that I'll show people. The 5 or 10 before this were really inelegant and didn't work, but I finally got to something that did. This is a prototype of Tom Fogarty. I talked about him earlier with a Fogarty catheter, one of the patron saints of cardiac surgical innovators. I show you this to show you his prototype, corn on the cob tongs and a coat hanger wire. If Tom Fogarty is allowed to make a prototype that inelegant, I submit that we all are. This is this is my second product to make it to market, Next Stitch. It's a suture chain for putting in valves. I don't know if any of you've seen it, but instead of this, I combined them all into a big chain. If you learned how to use it, it allows you to put a valve in super efficiently. You pass half as many needles and the spacing's always perfect. I went to a Genzyme key opinion leader meeting and presented this idea to them, and everybody said, that's the worst idea we've ever heard. There's no way that's going to work. My keepers at Genzyme said, don't worry about it, champ. You can't get them every time. You know, I'd just done the stabilizer with them. I said, no, this is on me. I described it and I didn't have a prototype. They couldn't understand what I was doing. I went to Hobby Lobby. I spent about $25 on some styrofoam and some yarn, took that back, and everybody understood what it was and why it would work. And it came to market. It's been on the market for 20 years now. We still get mailbox money every 3 months for this. Another secret to prototyping is that there are free resources everywhere. You know, every medical device has an expiration date on it. Find out where the expired stuff goes from your hospital. Call them. They'll let you rummage through. Here I am with my wife and two of the people from my lab. And I have a larder stocked with probably $25 million worth of expired catheters, balloons, stents, guide wires. Since all medical devices are sort of derivative of others, it's a great resource and it's all free. Call your hospital, find out where the expired stuff goes. This is my second company. This is the Lariat, and I'm just going to bang through this. This is a device used by electrophysiologists in the cath lab to tie off the left atrial appendage. In AFib, it's great if you don't have a left atrial appendage. Maybe makes it so you don't need to be on Coumadin. I went to my little lard of expired stuff. I ordered some magnets online. This was a long time ago, but I put the magnet on the end of a Fogarty bronchial blocker. There it is. There's a balloon catheter with a magnet on the end. I didn't want to spend money on an animal, so I made a left atrial appendage out of a Ziploc bag. I said, hey, if you can put a magnet and a balloon in the left atrial appendage and then guide a suture loop, by the way, that blue catheter, that's what I was using the tube and the Windex for, inflate the balloon and then pull the suture that runs up that light blue catheter and tighten the knot, you could tie off the left atrial appendage. Not super elegant, but that was my 12th iteration. I was really proud of that video. With that video, I was able to hire a CEO. He wrote a business plan. We raised the first money. We created the Central Heart Lariat. And now tens of thousands of patients have been treated with this. We just did a PMA trial trying to show that it increased the likelihood of converting to durable sinus rhythm after ablation. We missed our trial, but still it's a very effective way to tie off the left atrial appendage in the cath lab. You see these two magnets, one magnet inside the left atrial appendage, one intrapericardial, and the two magnets find each other very easily in the cath lab. Very exciting for me to see this turn from a fevered dream into something that's being done in hospitals all over the country. Here's the left atrial appendage. There goes the magnet. Here, of course, is a transesophageal echo probe. Here's the balloon. Here comes the pericardial magnet. Oh, missed that time. There, they connected. We use that as a rail, sort of Seldinger style. This is a gold nitinol wire that has a suture next to it. The gold wire is just so we can see where the suture is. Pass it over the tip of the appendage, beyond the base of the balloon. Inflate the balloon with contrast. That keeps the loop from slipping off as we tighten it. Puts it right in the base, as confirmed by transesophageal echo. Tighten the suture, open up the loop, take it off, no more left atrial appendage. Very exciting for me to see what that's become from my initial prototype. Of course, you have to protect your ideas. Why? Because you want people to invest money in them and they want to know they're protected. But filing a provisional is super easy to do. And then you have to build a team. How do you build a team? You have to be a cheerleader. What's your pom-pom? Your prototype. Use that to show people the elegance of what you've come up with, why they should quit their day job and work with you. And what else does a cheerleader do? When's a cheerleader most important? When things aren't going well. You have to bolster everybody and say, wait, I know it didn't work this time, but this kind of worked and this kind of worked. And you have to believe that there's a solution and you have to get everybody together. If you hire a good CEO, they'll be a cheerleader too, and they'll be able to hire all the engineers they used in their last company, and they'll write a great business plan and you'll be able to rock it forward. I always say, keep your eyes open. There are opportunities everywhere. Remember, people used to carry their suitcases through the airport before somebody put them on wheels. If you keep your eyes open, you'll see some of these opportunities. Here's a great quote about it by Sir Winston Churchill. Men occasionally stumble over the truth, but most of them pick themselves up and hurry off as if nothing's ever happened. Well, I was doing a lot of dialysis access when I was a general surgery resident. It was the closest thing I was going to get to do heart surgery until I was a heart surgery resident. And I realized they closed off a lot of the time. And I had the germ of an idea that didn't catch on until after I was already a heart surgeon. But I thought I could make dialysis access percutaneously. What made me think that? Well, you know, we usually sew them together. You all have probably done dialysis access at some point in your career, but they close off. About half of them close off in the first 8 weeks. They take a long time to mature. When I was a general surgery resident, I noticed, I had the opportunity to see a patient who was stabbed in the thigh, and the knife went through the artery and into the vein, and it made an arteriovenous fistula. And in the big book of vascular surgery, it said, you got to take them back and fix them. They'll never close on their own. Of course, now we can put covered stents in, but this was an indication of the durability of a traumatic AV fistula. Well, later on, when I was working in the ER, still as a general surgery resident, I saw this patient who got stabbed in the arm, who came back 8 weeks later with what looked like usable dialysis access. That made me realize there was an anatomy in the arm where there was an artery and vein close together, and that if you could traumatically couple them together, you'd get a fistula that stayed open really long. So after doing Central Heart, about 2010, I ordered some magnets. I went to my junk closet. I made these magnetic catheters. This is heat shrink tubing from Home Depot. They had little nails on them to act as electrodes. They went over guide wires. These were tips of catheters that I cut off from my expired catheter bin. And here they are going into the iliac artery of a sheep and the iliac vein of a sheep. You can see how the magnets lock together. The two electrodes were next to each other for a second. I fired the bovie through them and made a connection. Here's the little connection between the artery and the vein. I'm going to show that once again. There it goes. This is the electrode here. There it is in the artery. There's the electrode in the vein. Zap with radio frequency and then pull them out. And you'll see the connection here, right there. Anyway, very exciting based on that and that silly prototype. We were able to raise money. I hired Adam Berman as a CEO. After several years of experiments in animals, we made these devices. One went in the vein, one went in the artery. There was a spring-loaded electrode that would punch through the vein first, then the artery, and then running down each of these catheters were strong magnets, just like in my prototype. And we went to Asuncion, Paraguay, but only after realizing this anatomy. This is something that we all have in our arm. It's where the deep artery is flanked by two deep veins. It's right before the perforator, and here's the median antecubital. It's in the ulnar system and in the radial system. There's this anatomy. That's where we were going to put the catheters. Here we are in Asuncion, Paraguay, at the Italian hospital in Paraguay, putting one of our catheters in the vein. You can see us with our iPhones filming the operation on the screen. This is our first human, rotating the catheters so they come into magnetic alignment. Here comes the spring-loaded electrode being released. The artery and vein walls are wedged right in that gap. Zap, that was the radio frequency. We held our breath, took out the catheters, crossed our fingers, and we're delighted when we injected dye in the arteries and it lit the cephalic and basilic and median antecubital veins. And we did this over and over again. And it was extremely exciting with procedural development, how much easier this got. Here's another case. I guess not. They matured much faster because there was no vasospasm. There was no edema. The patency was better than surgical. And we were able to sell this company to Beck and Dickinson, where it's now being used every day in the United States and abroad. In conclusion, and I know I'm a little early. I went faster than I thought, so I'm going to add some to the end of this. You're all domain masters. You see unmet needs and challenges every day. You can imagine the solutions. I think what I showed you with Michael DeBakey's sewing machine and maybe even my cut-up spoons, important projects often have humble origins. You can do it. Get started now. And then this is not a dress rehearsal. Surround yourself with clever, inspiring people and do cool stuff. And so that's a little synopsis of the past of my medical device innovation journey. I'm going to describe one last project because I've got 6 minutes late by my calculation. And it has to do with my current work on the total artificial heart. And by the way, tons of innovation we're doing at Johnson & Johnson CDI, but I'm not supposed to talk about that in public. And so I'd like to share that stuff with you, I invite you all to visit us at CDI in Houston, Texas. But Bud Frazier, who sort of developed the mechanical circulatory assist, and partnering with Daniel Timms, we have a new take on the total artificial heart. This is a rotary artificial heart because, again, Bud Frazier introduced us all to rotary pumps with the Jarvik and the HeartMate 2 and led the world in introducing continuous flow pumps. He and I replaced a patient's heart with 2 HeartMate 2s. Daniel Timms saw that, reached out to us from Brisbane, Australia, where he'd been working on this device with only one moving part, magnetically levitated, double-sided rotor, the left rotor and the right rotor. The left rotor takes the blood returning from the lungs and pumps to the body. The right rotor, which looks sort of like a paddle wheel on a steamship, takes the venous blood and pumps to the lungs. It's microcomputer controlled. It'll outpump any mammalian heart that I've seen, and is an elegant, elegant device. This is what the device looks like. Part of that has been building an amazing team. It takes huge teams to do this kind of work. This is our team of Bivacor and the Texas Heart Cardiovascular Research Lab. It's been the project of a lifetime. And it's been so exciting seeing animals exercise on the treadmill with no pulse, no heartbeat, no EKG, like this animal that's 72 days. We've gone as long as 90 days. We're doing our trials with the FDA now. This will be the first practical, permanent total artificial heart. It'll never wear out. And we anticipate it'll probably replace our transplantation. This is an animal that's 90 days out. This animal, you can see how big he is, put on 80 pounds with our continuous flow pulseless total artificial heart. You know, the output goes from like 8 liters a minute up to 16, 17, 18 liters a minute with exercise. If we watch this video long enough, this output will continue to rise. There it goes, 14.3. Anyway, it's been super exciting, and the journey of a lifetime, having the opportunity to work with such brilliant people on such a brilliant device. And since I've got 3 minutes left, I'm going to do something rather unorthodox and go to an app on my phone where luckily he's standing up. This is a cow that we have going right now. This is live video to the Texas Heart Institute through my presentation to Greece, the beautiful animal. This is animal 35 as part of our trial with the FDA to anticipate first in man, which will probably be next year. Anyway, Greg, thanks for the opportunity to present. I'm going to be live in a moment and look forward to the opportunity to answer any questions you may have. Thanks a lot for the opportunity. Grant?
I'm sorry, we had the sound cut off for the first 2 seconds. What was that?
I was going to say that should be an advertisement for the effects of caffeine.
Yeah, you do a lot, exactly.
I know that was a lot of material. Hopefully it was relevant for some of the people watching. If nothing else came through, I've got a passion for medical device development, and hopefully I infected a couple of you with that.
I think it's awesome. I think, you know, in Texas, a lot of people see a cow and think ribeye, and some people see a cow and think total artificial hearts. So, you know, there's a lot that you can do, you know. So the first thing, you know, I was going to tell you is, and I've never said this to one of our invited speakers before, I think, you know, you owe an apology to our audience, because about 50% of us now feel less cool after seeing your talk and less talented. So thank you for showing us all of that. To slightly embarrass, tell me. Yeah.
So that's Bud Frazier in the middle there. And the black gentleman between Bud and I was one of the first HeartMate 2 patients. And there he is with his HeartMate 2. We introduced him to Bono.
Unbelievable. I have a couple photos here that we're going to show. Can we put the photos up? So this is Dr. Billy Cohn hanging out with Bono from U2. The next photo, and with Bud Frazier in the back, and that's one of your HeartMate 2 patients. This is, and by the way, I like that suit jacket. Very nice. With the Edge from U2. What's the next photo?
I got to jam with him. I got to play guitar with him.
That's fantastic. And okay, so here we have Michael DeBakey and Denton Cooley watching you implant something in an animal.
Yeah, a bivacor heart. That's
Bivacor.
the first time DeBakey and Cooley saw each other in over 40 years, because you know they had this big split. And,
Yeah, we see them there on the left.
Trained with DeBakey, and so we invited him to come to an implant, and he never would. And one day he showed up, and we called Cooley, and there they are like old chums.
Yeah.
And that's George Noon, by the way, right in the middle of the picture.
Unbelievable. So these are historic photos, and the next one, I think, really is just proof of why you got along so well with the guys from U2. We can go back now to your live video because we have the photos up. But do we have questions from the audience? We can field some questions from the audience. And I think the first question that I was going to ask is, how many people approach you? And how many of them actually make it to getting a product to the market? Or what's the most difficult step where people stumble along the way?
Great question. Too few people approach me. And every single person listening to this talk has a couple great ideas. And one of them, or two of them, or three of them has all the ingredients to be world changing. And people don't approach for the same reason that people don't sing karaoke. They're afraid of looking stupid, or they go, I don't have time for that. I'm telling you, take the first step. It's so much easier than everybody thinks. When you go back and look at all the brilliant devices, not just in cardiac surgery, in every field of medicine, and in every endeavor, people just like you came up with those, and it all started when they decided to do it. When they said, look, I've had this great idea in my head for the last 10 years, I'm gonna take the first steps. Once you start doing it, it's like rolling down a hill. It just keeps going and going. You may say, this is taking up too much time. I wanna spend every waking moment in the operating room or in the cath lab. That's okay. That's, everybody gets to pick what they wanna do. But if you wanna do this stuff, it's a lot easier than any of you think. And each step leads to the next logical step. One thing people always ask me, they go, well, how do you hire a CEO? What do you pay him? The answer is, you don't pay him anything. They're so eager to be working with key opinion leaders like you that have an idea. They'll go out, they'll raise the money. They'll say, look, this is Greg Batacos. He has this great idea. I've been a CEO of a company with that idea. Look at the prototype, here it is. We're gonna raise this much money, and this thing's going to be worth a lot of money, and everybody's going to be fabulously wealthy. Some venture capitalist believes it, writes a check. That CEO then pays themselves a salary from that check, and they proceed with a sense of urgency that you can't do because you're operating during the day and taking call and doing dissections in the middle of the night. That's the first step, is bringing in someone who's going to do that as their whole job, and you do that by leveraging your passion, your brilliance, your creativity, and this unique perspective you have from actually living the problems. So there are no hurdles to doing it. The biggest hurdle is deciding you want to do it.
That's fantastic. Dr. Cohn, we really appreciate it. I think we could sit here probably for another 5 hours and speak with you. We're a little over time, so unfortunately we have to move on, but we're going to have you come to Greece if you'll accept our invitation once all this coronavirus stuff is done. And outstanding. I don't know how the next session is going to follow after this one. So thank you so much for your time. I appreciate it.
Thanks, Greg. Thank you.
Bye-bye.
Πες μας πότε είσαι έτοιμος, Γιώργο, για να ξεκινήσουμε. Πού πας, μη φεύγεις. Έτοιμοι? Καλησπέρα σας και πάλι. Θα ξεκινήσουμε το μοναδικό session, το οποίο θα είναι στα ελληνικά και ίσως το πιο ενδιαφέρον και το πιο γεμάτο session της ημέρας. Αντίστοιχο θα υπάρχει και αύριο. Σήμερα, λοιπόν, θα πούμε τις πιο ενδιαφέρουσες και διδακτικές περιπτώσεις, TAVI cases που γίνανε στην Ελλάδα τον τελευταίο χρόνο και έχουμε την τιμή να έχουμε κυριολεκτικά όλους μαζί μας, κυριολεκτικά από όλα τα νοσοκομεία και από όλα τα hard teams και έχουμε συμπρόεδρο μαζί μου physically τον κύριο Κατσιμακλή, σε λίγο θα έρθει και ο κύριος Πατακός και έχουμε διαδικτυακά τον κύριο Μιχάλη από τα Γιάννενα. Σωστά. Λάμπρο, είσαι μαζί μας? Όχι ακόμη. Όχι. Μας ακούει. Τον κύριο Μπαϊκούση. Είναι ο κύριος Μπαϊκούσης μαζί μας? Ωραία. Με πληροφορούν ότι ο κύριος Μιχάλης και ο κύριος Μπαϊκούσης θα συνδεθούν σε λίγο, οπότε ξεκινάμε εμείς και θα ξεκινήσουμε το πρώτο περιστατικό από την Κρήτη, από το Ηράκλειο. Έχουμε μαζί μας τον κύριο Χαμηλό. Μιχάλη, καλησπέρα. Είσαι διαδικτυακά μαζί μας και θα μας μιλήσει για ένα περιστατικό TAVI με μεγάλο αορτικό δακτύλιο.
Καλησπέρα σε όλους, ελπίζω να ακούμε καλά. Τιμή μου και μεγάλη μου χαρά να είμαι για άλλη μια χρονιά μαζί σας, έστω και από μακριά. Και χωρίς καθυστέρηση, επειδή έχετε ένα μαραθώνιο περιστατικό μπροστά σας, θα προχωρήσω στην παρουσίαση του περιστατικού μας. Πρόκειται για ένα ασθενή 89 ετών διαβητικό υπερλιπιδεμικό με ιστορικό αγκιοπλαστική στα στεφανία του, ο οποίος παρουσιάζει δύσπνοια και σοβαρή στένωση αορτικής βαλβίδας. Από το υπερηχογράφημα διατεταμένη αορτική ρίζα και ανιούσα αορτή, ένα μέσο gradient 48 και ένα στόμιο 0,8 τετραγωνικά εκατοστά. Τα στεφανιαία του ήταν καλά, τα stent ήταν βατά σε γενικές γραμμές με μια ήπια επαναστενωτική βλάβη. Και ο ασθενής 89 ετών, θυμίζω, σε πολύ καλή βιολογική κατάσταση, με ένα Euroscore 1,19,56, ένα Euroscore 2,493 και ένα STS 2,98. Κουβεντιάστηκε στο hard team του νοσοκομείου και αποφασίστηκε να προχωρήσουμε σε εμφύτευση αορτικής βαλβίδας. Στο προεπεμβατικό έλεγχο έγινε όπως πάντα μια αξονική για να δούμε τα αγκία του και εκεί διαπιστώσαμε ότι ο ασθενής είχε ένα αρκετά μεγάλο αορτικό δαχτύλιο με μια διάμετρο μέση περίπου 31,5 εκατοστά, με αρκετά έκεντρο δαχτύλιο, αρκετά μεγάλο χώρο εξόδου της αριστερής κοιλίας, μια αέρια 7,52 και μια περίμετρο 99 χιλιοστά. Η αορτή ήταν κάπως οριζόντια, όχι ιδιαίτερα οριζόντια, η βαλβίδα δεν είχε ιδιαίτερο ασβέστη και τα πόδια ήταν αρκετά υλικωμένα, χωρίς όμως ιδιαίτερα προβλήματα. Με ένα τόσο μεγάλο αορτικό δαχτύλιο οι επιλογές είναι αρκετά περιορισμένες και έτσι το σκεφτήκαμε και αποφασίσαμε να προχωρήσουμε στην εμφύτευση μιας βαλβίδας που είναι σχετικά νέα στην αγορά, μιας balloon expandable βαλβίδας της MyVal, η οποία δεν θα σας φάω τον χρόνο να σας εξηγήσω ιδιαίτερα τα χαρακτηριστικά της. Είναι μια βαλβίδα με balloon expandable, η οποία έχει μια ιδιαιτερότητα ότι έχει αρκετά μεγέθη και έχει μια extra large βαλβίδα, η οποία είναι κατάλληλη για περιμέτρους μέχρι 840 τετραγωνικά χιλιοστά και μέχρι 100 χιλιοστά. Οπότε θεωρήσαμε ότι ήταν μια κατάλληλη βαλβίδα για να εμφυτεύσουμε στον ασθενή μας, ο οποίος, θυμίζω, έχει 752 αέρια και 98,9 περίμετρο. Κατά τη διάρκεια της εμφύτευσης κάνουμε μια κοιλιογραφία με καλή ιστορική λειτουργικότητα και μια αορτογραφία στη θέση εμφύτευσης της βαλβίδας, όπου φάνηκε ότι η αορτή ήταν μάλλον αρκετά πιο οριζόντια από ό,τι φαινόταν στην αξονική τομογραφία. Έχουμε λοιπόν μια οριζόντια αορτή, ένα μεγάλο αορτικό δαχτύλιο και όχι πάρα πολύ ασβέστιο στην αορτική βαλβίδα και έτσι αποφασίσαμε να προχωρήσουμε στην άμεση εμφύτευση της βαλβίδας χωρίς κάποια προδιαστολή. Σε αυτές τις περιπτώσεις η βαλβίδα, όπως βλέπετε αριστερά στην οθόνη, έχει ένα μάρκερ, ο οποίος τον βάζουμε λίγο πάνω από τον αορτικό δαχτύλιο, περίπου 2-3 χιλιοστά πάνω από τον αορτικό δαχτύλιο, και με ταχεία βηματοδότηση προχωρήσαμε στην εμφύτευση της βαλβίδας, χωρίς ιδιαίτερα προβλήματα. Η αορτογραφία αμέσως μετά την εμφύτευση με το σύρμα αρκετά καλή και χωρίς το σύρμα, χωρίς καθόλου μια υποψία διαφυγής και ανεπάρκειας και ανεπίπλεκτο κλείσιμο των ποδιών με 2 προglide. Επομένως, αυτό το περιστατικό είχαμε μια ομαλή εμφύτευση μιας MyVal, το μεγάλο μέγεθος, 32 χιλιοστά, το extra large, σε ένα μεγάλο αορτικό δαχτύλιο. Τώρα, δεν θα σας φάω το χρόνο, απλά θα σας πω ότι υπάρχει και το option να κάνει κανείς, να πάρει μια sapien 3 τη μεγάλη βαλβίδα, την 29, και να κάνει overexpansion με περισσότερο σκιαγραφικό. Υπάρχουν σειρές αρκετές που έχουν δημοσιευτεί. Υπάρχουν κάποια concerns, ας πούμε, στο ότι όταν κάνει κανείς overexpansion μπορεί να χαλάσει το integrity της βαλβίδας και το captation των πτυχών της, αλλά αυτό δεν συμβαίνει τόσο πολύ με την 29, μάλλον συμβαίνει με μικρότερες βαλβίδες. Και επίσης υπάρχουν κάποιες σειρές που λένε ότι όταν η διάμετρος του χώρου εξώπου της αριστερής κοιλίας είναι λίγο μεγαλύτερη από τη βαλβίδα, από το άνιουλους, έχεις αρκετά μεγάλη παραβαλβιδική διαφυγή, που μπορεί να δημιουργήσει προβλήματα στο μέλλον και στο durability της βαλβίδας. Στη δεξιά πλευρά της οθόνης βλέπετε μια σειρά που ένα 20 με 25% είχε mild to moderate regurgitation στο χρόνο περίπου. Και για να κλείσω το περιστατικό μου, η εξαιρετικά μεγάλη αορτική δαχτύλη δεν είναι συχνό έβριμα στις περιπτώσεις στον τάβη. Είναι περιστατικά τα οποία τα συναντάει κανείς σπάνια. Υπάρχουν νέες βαλβίδες με αρκετά μεγέθη που σου δίνουν τη δυνατότητα να επιλέξεις και μπορείς να τις θεραπεύσεις με αποτελεσματικότητα και με ασφάλεια. Σας ευχαριστώ πολύ.
Μιχάλη, να σε ευχαριστήσουμε. Ενδιαφέρον περιστατικό. Είναι πολύ σπάνια, ίσως 2 ή 3 περιστατικά στη διάρκεια της καριέρας μου να φτάνω σε τέτοια νούμερα. Δεν ξέρω, Γιώργο, εσύ την εμπειρία σου.
Μία φορά εμείς χρησιμοποίησαμε μία Edwards, την οποία κάναμε overexpansion, ήταν μία 29, αλλά ήταν οριακά. Δεν έχω συναντήσει τέτοιο περιστατικό.
Πολύ ωραία. Θα συνεχίσουμε λοιπόν. Σε ευχαριστούμε πολύ, Μιχάλη, διότι έχουμε μαζί μας πάρα πολλούς συναδέλφους, πολύ ενδιαφέροντα περιστατικά και θέλουμε να είμαστε on time. Έχουμε παράκληση από τον κύριο Γεωργίου, από τον κύριο Ευτυχίου. Συγγνώμη, δεν ξέρω αν ο κύριος Ευτυχίου έχει συνδεθεί. Όχι. Αν
Καλησπέρα σας. Καλησπέρα σας.
Είναι συνδεμένος. Θα ζητήσουμε από τον κύριο Βούδρη την άδεια του, επειδή έχει μετά μία ομιλία ο κύριος Ευτυχίου, απλώς να παρέμβει τώρα, να κάνει την παρουσίασή του. Είναι μαζί μας? Όχι.
Ναι, καλησπέρα σας.
Καλησπέρα. Σ' ακούμε.
Ευχαριστώ για τη διευκόλυνση. Ευχαριστώ και για την τιμητική πρόσκληση και είναι με πολύ μεγάλη χαρά που είμαι και πάλι μαζί σας. Λοιπόν, ένα πολύ σύντομο ενδιαφέρον περιστατικό, το οποίο έχει έτσι μια μοναδικότητα, ένα αρκετά σπάνιο, όπου χρειάστηκε να κάνουμε ένα valve-in-valve TAVI σε ασθενή ο οποίος είχε προηγηθεί σαν Pentras. Ο ασθενής αυτός, ενώ τον ψάχναμε για σοβαρή ανεπάρκεια μητροειδούς κατά ακρίβεια και είχαμε προγραμματίσει να κάνουμε ένα edge-to-edge repair της μητροειδούς βαλβίδας, το οποίο τον ταλαιπωρούσε, προσέξαμε λοιπόν κατά τη διάρκεια της επέμβασης για τη μητροειδή ότι η αορτική του βαλβίδα, η οποία την παρακολουθούσαμε και ήταν μέτρια η ανεπάρκεια της, ότι είχε επιδεινωθεί αρκετά. Ήταν μια προσθετική αορτική βαλβίδα, η οποία ήταν μια 25 χιλιοστό σωρήν mitral flow, η οποία είχε τοποθετηθεί το 2013 μαζί με ένα straight tube wrap 28 χιλιοστό και ταυτόχρονα και bypass. Ο ασθενής αυτός είχε περάσει μετά ενδοκαρδίτιδα της προσθετικής βαλβίδας 2 χρόνια μετά η οποία είχε αντιμετωπιστεί με αντιβιωτικά, ενδοφλέβια αντιβίωση, και είχε παραμείνει με μια μικρή ανεπάρκεια της αορτικής βαλβίδας. Είχε αρκετά θέματα υγείας, δεν υπήρχε θέμα να πάει ξανά για χειρουργείο, και εδώ βλέπετε την ορθογραφία του ασθενή με τη σοβαρή ανεπάρκεια της αορτικής βαλβίδας και βλέπετε το pressure tracing του ασθενή, όπου έχει μια διαστολική πίεση της αορτής να είναι ουσιαστικά ίση με την τελοδιαστολική πίεση της αριστερής κοιλίας. Υπήρχε και ένας βαθμός στένωσης με ένα LV aorta gradient στα 30 χιλιοστά στη λυσιτρακύρου. Ανατρέξαμε λοιπόν στο γνωστό application του valving valve, το οποίο μας δίνει έτσι σημαντικές πληροφορίες για την επιλογή της βαλβίδας που θα πρέπει να χρησιμοποιήσουμε για το valving valve procedure. Για τη συγκεκριμένη βαλβίδα, την 25 χιλιοστό σωρή, προτείνονται αρκετές επιλογές. Μία από αυτές ήταν και η Sapien 3 των 23 χιλιοστών, η οποία βέβαια θα έπρεπε να ήμασταν προσεκτικοί έτσι ώστε να καλύψουμε και το φως της προηγούμενης βαλβίδας σε όλους το ύψος. Επειδή υπήρχε αυτό το θέμα του χειρουργείου και το tube graft, ανησυχούσαμε για το ενδεχόμενο αν θα χρειαζόταν να κάνουμε και balloon valve fracture. Κάτι το οποίο, αν ήταν δυνατό, θα το αποφεύγαμε. Δεν ήταν κάτι το οποίο είχαμε ξαναδοκιμάσει και ίσως να είναι χρήσιμη και εδώ μια παρέμβαση από καρδιοχειρουργό κατά πόσον είναι καλή ιδέα να επιχειρήσεις σε ένα τέτοιο περιστατικό balloon valve fracture. Εδώ είναι τα χαρακτηριστικά της σωρήν. Το ύψος της βλέπετε είναι 15 χιλιοστών, το ύψος της 23 χιλιοστών Sapien 3 είναι γύρω στα 18, οπότε πρέπει να τοποθετηθεί η Sapien 3 σε ένα ύψος έτσι ώστε, όπως είπαμε, να καλύπτεται το ύψος των φως της προηγηθήσας βαλβίδας. Δεν κάναμε προδιαστολή και ευτυχώς δεν χρειάστηκε να κάνουμε ούτε μεταδιαστολή. Βλέπετε εδώ την ορθογραφία στο τέλος και βλέπετε πόσο ωραία έχουν διορθωθεί και τα αιμοδυναμικά του ασθενή με την αύξηση της διαστολικής πίεσης στην αορτή και χαμήλωσε και σημαντικά η τελοδιαστολική πίεση της αριστερής κοιλίας. Παρέμεινε ένα μικρό gradient 5 με 10 χιλιοστά, το οποίο όμως δεν ήταν σημαντικό για να μας κάνει να κάνουμε μεταδιαστολή. Αυτό είναι ο υπέρηχος του ασθενή πριν ένα μήνα, όπου βλέπετε δεν υπάρχει σημαντική παραβαλβητική διαφυγή, αλλά ούτε στην αορτική, αλλά ούτε και στην μητροειδή βαλβίδα. Κλείνοντας λοιπόν, και οι χειρουργικές βαλβίδες, όπως είναι πλέον πολύ καλά γνωστό, μπορούν να καταστραφούν είτε από ενδοκαρδίτιδα είτε από άλλους λόγους, και σε αυτές τις περιπτώσεις το valve valve είναι ίσως μια πολύ καλή λύση. Στο συγκεκριμένο ασθενή και το edge repair για τη μητροειδή αλλά και το valve valve θάβη, το οποίο είχαμε χρησιμοποιήσει, προσέφεραν στον ασθενή έτσι μια ολική διαδερμική λύση και για τα δύο του προβλήματα. Σας ευχαριστώ για την προσοχή σας.
Σε ευχαριστούμε, Χρήστο. Πολύ ενδιαφέρον περιστατικό και το sequence πρώτα της θεραπείας της μητροειδούς και μετά της αορτικής δεν είναι το συνηθισμένο, αλλά προφανώς η ανεπάρκεια της μητροειδούς ήταν πολύ πιο σημαντική. Σε ευχαριστούμε πάρα πολύ. Θα συνεχίσουμε με το επόμενο περιστατικό, με τον κύριο Βούδρη. Κύριε Βούδρη, σας ακούμε.
Καλησπέρα, ευχαριστώ για την πρόσκληση. Να περάσουμε σύντομα στο περιστατικό μας. Μια κυρία 80 ετών, συμπτωματική, λόγω βαριάς στένωσης αορτικής βαλβίδος, με πολλές συνοσηρότητες. Κρατήστε ότι είχε σοβαρή κυφοσκολίωση, πνευμονική υπέρταση, χρόνια από φρακτική πνευμονοπάθεια. Βλέπετε στην ακτινογραφία θώρακος την πορεία της αορτής και το αορτικό της τόξο, γύρω σκορδίο 5,7. Καλό κλάσμα εξώθησης, 0,7 τετραγωνικά εκατοστά το στόμιο της αορτικής βαλβίδος, μέσο gradient 49, μέτρια ανεπάρκεια μητροειδούς και τριλόχινος, πνευμονική υπέρταση. Φυσιολογικές στεφανιέρες αρτηρίες, αξονική αγγιογραφία, βλέπετε τη φοβερή ελίκωση στη θωρακική αορτή, δύο μεγάλες γωνίες, θα έλεγα 90 μοιρών και εδώ έχουμε μια οξύ αγωνία, ενώ οι περιφερειακές αρτηρίες ήταν εκπληκτικές. Heart discussion, αποφασίστηκε τάβη, οι μετρήσεις για την επιλογή της βαλβίδος, μια βαλβίδα Evolut της Medron, 23 χιλιοστά, εδώ βλέπετε την πορεία που ακολουθεί η θωρακική αορτή και με πολλή δυσκολία καταφέραμε και προωθήσαμε τον καθετήρα pigtail. Γίνεται η αορτογραφία και με βάση αυτές τις τεχνικές ιδιαιτερότητες αποφασίσαμε να χρησιμοποιήσουμε ένα εισαγωγέα central. Είναι ένας εισαγωγέας, τον βλέπετε στην εικόνα, που χρησιμοποιούν οι άγγιοχειρουργοί σε δύο μήκη, 28 και 64 εκατοστά. Εμείς επιλέξαμε τα 64 εκατοστά. Εδώ βλέπετε τον διαστολέα, εισαγωγέα, θικάρι, όπως θέλετε πέστε το, που έχει φτάσει μέχρι την αρχή του αορτικού τόξου και μέσα από αυτό το σύστημα καταφέραμε και κατεβάσαμε ένα μπαλόνι για να γίνει μία προδιαστολή. Παρά τα αυτά ήταν αδύνατον να προωθήσουμε την βαλβίδα Evolut και να περάσει την αορτική στένωση. Αποφασίσαμε να προωθήσουμε αυτό τον εισαγωγέα ακόμη περισσότερο μετά το τόξο στην ανιούσα θωρακική αορτή και με αρκετή προσπάθεια καταφέραμε και προωθήσαμε την βαλβίδα στη ρίζα της αορτής. Χωρίς να θέλω να σας κουράσω, η βαλβίδα προοδευτικά ανοίγει και εδώ έχει τελείως απελευθερωθεί και αυτή είναι η αορτογραφία μετά την επιτυχή τοποθέτηση της βαλβίδος, πολύ μικρή, παραμένουσα αορτική ανεπάρκεια, επανατοποθετείται ο διαστολέας μέσα από το θικάρι για να τον αφαιρέσουμε προοδευτικά και εδώ βλέπετε ότι το τελικό αποτέλεσμα μετά τη σύγκληση με ProGlide δεν έχει αφήσει κανένα πρόβλημα στην αριστερή μοιραία αρτηρία από όπου προωθήθηκε και η βαλβίδα. Αυτές είναι οι εκτιμήσεις από το triplex. Καλό αποτέλεσμα, απουσία ανεπάρκειας και σας ευχαριστώ για την προσοχή σας.
Όταν γνωρίζεις το device σου πολύ καλά, που προφανώς εσείς το γνωρίζετε, και πώς πρέπει να είσαι ανοιχτός στο να βάζεις καινούργια κομμάτια από hardware, όπως το Center που χρησιμοποιήσατε για αυτή την περίπτωση και ήταν απαραίτητο για να δουλέψει. Ήταν η Evolut Pro ή η Evolut R?
Ήταν η Evolut Pro.
Επειδή η R είναι λίγο πιο μαλακή και ίσως σε κάποια οριακά περιστατικά.
Αν δεν βάζαμε το θικάρι Central, δεν θα μπορούσε ούτε το καθετήρας να προωθηθεί, μπαλόνι δηλαδή, και να γίνει η προδιαστολή. Ήταν τελείως δύσκολο.
Συγχαρητήρια και πάλι. Επομένως, τώρα ξέρουμε ότι μπορούμε να χρησιμοποιήσουμε το μακρύ θικάρι Central για να βάλουμε μία Evolut. Ευχαριστούμε πολύ και θα συνεχίσει ο Γιώργος τις παρουσιάσεις.
Ναι, θα συνεχίσουμε με τον κύριο Ιακώβου από τον Άσιο. Γιάννη, διαδικτυακά, σε ακούμε.
Ωραία, ευχαριστώ πολύ Γιώργο. Να ευχαριστήσω και πάλι τον Κώστα για την πολύ τιμητική πρόσκληση. Είναι χαρά να συμμετάσχω έστω και διαδικτυακά σε αυτό το πολύ ενδιαφέρον συνέδριο, πραγματικά ιδιαίτερα ενδιαφέρον και πολύ πληροφοριακό. Είναι σε συνέχεια της παρουσίασης που έκανα το πρωί, αφορά την αποφυγή πιθανής σύγκλησης του στελέχους αριστερής στεφανίας αρτηρίας. Ξέρουμε ότι η σύγκληση των στεφανιαίων και σαν επιπλοκή μπορεί να είναι σπάνια, κάτω από 1% των περιπτώσεων ιστορικά, αλλά ωστόσο μπορεί να είναι καταστροφική, έχει πολύ μεγάλη θνησιμότητα.
Συγγνώμη Γιάννη, δεν έχεις κάνει share screen, οπότε δεν βλέπουμε την οθόνη σου. Βλέπουμε εσένα πολύ ωραία, αλλά όχι την παρουσίαση.
Πρώτον το... Να δω γιατί... Ναι, οκ, μισό λεπτό. Ωραία. Ελπίζω να φαίνεται τώρα, Κώστα.
Τώρα μια χαρά.
Ωραία, τέλεια. Οπότε υπάρχει λοιπόν πέρα από την οξία σύγκληση και απόφραξη των στεφανιών, υπάρχει και η όψιμη σύγκληση που συμβαίνει σπάνια, ειδικά όμως πιο συχνά στις αυτοεπιτυσσόμενες βαλβίδες σε σχέση με τις balloon expandable, οι οποίες έχουν αυξημένη επίπτωση αυτές οι επιπλοκές σε οξία φάση. Θυμόμαστε τους παράγοντες που έχουν σχέση με την οξία απόφραξη, οι οποίες μπορεί να έχουν σχέση με την βαλβίδα αυτή καθ' αυτή, που είναι υψηλή εμφύτευση, αν δεν έχουμε καλό alignment των βροχίνων της βαλβίδας, αλλά κυρίως είναι ανατομικοί παράγοντες, οι μικρές ανατομίες, κυρίως η χαμηλή έξωση των στεφανίων αγγείων και η στενή κόλπη του Βαλσάλβα, αλλά και φυσικά τα είδη των βαλβίδων που πρόκειται να θεραπευθούν στις valve-in-valve παρεμβάσεις, κυρίως σε βαλβίδες τύπου mitral flow trifecta που έχουν externally mounted leaflets. Αυτή λοιπόν είναι αυτό το περιστατικό, 80 χρονών ασθενής, με δύσμια σημαντική στένωση, όπως μπορείτε να δείτε στην υπερχογραφική εικόνα, με AVA 0,6, τετραγωνικά εκατοστά, ωστόσο καλό κλάσμα εξόδησης. 2 χρόνια πριν έχει βάλει μια mitral flow 21, έχει εγκεφαλικό επεισόδιο, υπέρταση, υψηλό κίνδυνο. Βεβαίως το χάρτη μου αποφασίζει ότι πρέπει να υποβληθεί σε διαδερμική αντικατάσταση βαλβίδας. Κάνοντας την ανάλυση της αξονικής με το θρυμμένσιο, βλέπουμε το ύψος στον κόλπο του Βαλσάλβα, ειδικά αριστερά είναι χαμηλό, 12 χιλιοστά, με χαμηλή έκφυση του στομείου, καλύτερη έκφυση, αλλά πάλι χαμηλή από τα δεξιά. Ωστόσο, το ύψος του κόλπου του Βαλσάλβα δεξιά είναι ικανοποιητικό. Θυμόμαστε λοιπόν αυτά τα 3 νούμερα, τα κάνουμε την ανάλυση. 12 χιλιοστά το ύψος από το στεφανίων, το πλάτος του κόλπου του Βαλσάλβα να είναι κάτω από 30 και η απόσταση της βαλβίδας από το στεφανίο στην short axis ανάλυση θα είναι κάτω από 4. Αυτά είναι κόκκινες σημαίες, πρέπει να το προσέχουμε παραπάνω. Κάνοντας λοιπόν την ανάλυση, βλέπουμε ότι αριστερά, παρότι το ύψος είναι μικρό στον αριστερό στεφανίο κόλπο, ωστόσο η απόσταση της βαλβίδας με το αριστερό στεφανιαίο αγγείο είναι 6 χιλιοστά, ενώ είναι 2,9 στην δεξιά στεφανιαία αρτηρία, ωστόσο ο δεξιός στεφανιαίος κόλπος έχει ικανοποιητικό ύψος. Πρόκειται λοιπόν να θεραπεύσουμε μια mitral flow, είναι σε νούμερο 21, πρέπει να θυμόμαστε τα ανατομικά χαρακτηριστικά της βαλβίδας, έχει 13 χιλιοστά ύψος, όσο είναι και το σκέρτ της Evolut Pro σε αυτή την περίπτωση. Οπότε αποφασίσαμε να χρησιμοποιήσουμε την Evolut βαλβίδα με χαμηλή σχετικά εμφύτευση και με καλό alignment. Επειδή είναι υψηλή κινδύνου ασθενής, θεωρήσαμε ότι έπρεπε να κάνουμε την αγγιοπλαστική την ώρα της τοποθέτησης της βαλβίδας για να αποφύγουμε ενδεχόμενη επιπλοκή και από τα στεφανία, και εφόσον πρόκειται να θεραπεύσουμε και με την τεχνική τσίμνη το στέλεχος της αριστερής στεφανιαίας αρτηρίας, θεωρήσαμε ότι ήταν καλό να το κάνουμε στο ίδιο session. Οπότε φτιάξαμε λοιπόν τον πρόστιο κατηλεπράτο με τοποθέτηση 2 στεν και συνέχεια χρησιμοποίησαμε την τεχνική τσίμνη, ανοίγοντας στα 2 τρίτα την αυτοκτησσόμενη βαλβίδα και βάζοντας ένα στεν 4x26 χιλιοστά στο στέλεχος και με όπως βλέπετε με σχετικά χαμηλή την τοποθετημένη βαλβίδα. Και αυτό είναι το τελικό αποτέλεσμα μετά την τοποθέτηση της βαλβίδας για να βελτιστοποιήσουμε το stent, το οποίο βρίσκεται σε αρκετά μεγάλο μήκος μέσα στην αορτή, και για να αποφύγουμε ένα deformity και ενδεχομένως να έχουμε καλύτερη πρόσβαση στο μέλλον, μια και πρόκειται για στεφανία ασθενή, κάναμε ένα double kissing balloon inflation με ένα lumen 20/45, όπως βλέπετε δεξιά στην εικόνα, και αυτό είναι το τελικό αποτέλεσμα, χωρίς παραβολική διαφυγή, με ένα gradient που το θεωρήσαμε σε αυτή τη φάση ικανοποιητικό. Ο ασθενής εξαιρέται το νοσοκομείο σύντομα, και στο follow-up, το οποίο έγινε σχετικά πρόσφατο, ζητήσαμε μια αξονική ώστε να δούμε αν υπάρχει deformity στο stent το οποίο υπάρχει στην αορτή. Δεν υπάρχει. Υπάρχει ένα gradient γύρω στα 19, δεν υπάρχει εικόνα θρόμβωσης, leaflet thickening. Όπως βλέπουμε, ο ασθενής είναι ασυμπτωματικός με αρνητικό stress echo, και βλέπουμε ότι υπάρχει βατότητα του στελέχους και ενδεχομένως σχετικά εύκολη πρόσβαση, που σε αυτούς τους ασθενείς είναι το μεγάλο πρόβλημα. Και όπως συζητήσαμε και το πρωί, όσο πηγαίνουμε και σε νεότερους ασθενείς και σε νεότερες ηλικίες, οι αυτοεκτισσόμενες βαλβίδες, ειδικά σε αυτό το σενάριο, σε valve και σε TAV θα είναι ακόμα πιο δύσκολο και πιο challenging για να μπορούμε να κάνουμε τη στεφανογραφία. Οπότε συνοπτικά, λοιπόν, αυτός ο ασθενής με σχετικά πρόσφατη εκφύλιση προσθετικής βαλβίδας τύπου mitral flow θεραπεύθηκε με την τοποθέτηση αυτοεκτισσόμενης βαλβίδας σε του Pro, χρησιμοποιήθηκε τεχνική προστασία με stent στο στέλεχο. Στο στέλεχος έγινε τσίμνη, και για να βελτιστοποιηθεί το αποτέλεσμα και για να έχουμε ευκολότερη πρόσβαση στο μέλλον σε ενδεχόμενη στεφανογραφία, κάναμε kissing balloon inflation. Ο ασθενής είναι ασυμπτωματικός, με βατότητα, όπως έδειξε η αξονική, στο χρόνο πάνω. Θα πρέπει να θυμόμαστε ότι παρότι προχωράει η τεχνολογία και οι βαλβίδες γίνονται καλύτερες και οι τεχνικές και τις μαθαίνουμε όλοι καλύτερα, θα πρέπει να θυμόμαστε ότι ναι, μην είναι σπάνια αυτή η επιπλοκή της απόφραξης των στεφανίων αγγείων, αλλά έχει πολύ μεγάλη θνησιμότητα. Συνήθως έχουμε καρδιογενέ σοκ. Πρέπει σε αυτούς τους ασθενείς ενδεχομένως, όσο ίσως δεν θα πρέπει να προχωράμε σε γρήγορη έξοδο από το νοσοκομείο, θα πρέπει να έχουμε χαμηλή ουδό, ώστε να αναγνωρίζουμε εύκολα και γρήγορα τα συμπτώματα, γιατί εφόσον το αναγνωρίσουμε και δεν έχει πλήρη απόφραξη του στελέχους ή της δεξιάς στεφανής αρτηρίας, αυτοί οι άνθρωποι μπορούν να αντιμετωπιστούν επιτυχώς. Ευχαριστώ πάρα πολύ για την προσοχή σας.
Συγχαρητήρια, Γιάννης. Το περιστατικό πραγματικά εντυπωσιακό. Θα πρέπει να πούμε ότι δεν ήταν μόνο το ύψος του στεφανιαίου, αλλά ήταν και το είδος της βαλβίδος. Η mitral flow είναι μια βαλβίδα χειρουργική, η οποία πράγματι είναι δύσκολη, γιατί μπορεί να κλείσει πιο εύκολα τα στεφανιαία, γιατί είναι ραμμένες οι λοχίνες από την εξωτερική πλευρά. Δηλαδή, είχες κι άλλο πρόβλημα, άμα χρειαζόταν, πράγματι.
Ναι, βεβαίως. Είναι συζήτηση που κάνουμε πολλές φορές με τους χειρουργούς για το είδος βαλβίδας που πρόκειται να τοποθετήσουν. Νομίζω πως αυτή η συζήτηση πρέπει να γίνεται με όλους τους χειρουργούς και πιο συχνά πρέπει να μεταφέρεται το μήνυμα ότι υπάρχουν μερικές βαλβίδες οι οποίες ίσως θα πρέπει πριν τους τοποθετήσουν να υπάρχει μια δεύτερη σκέψη.
Γιάννη, επί τη ευκαιρία, λίγο καταρχάς να πούμε αυτό που είπαμε και το πρωί, ότι άπαξ μπει ένα stent προστασίας, όπως μπήκε εδώ, δεν έχουμε πρόσβαση πρακτικά μέσα στο στεφανιαία μετά. Θα πρέπει, είναι πολύ δύσκολο να βρεις ακριβώς το στόμιό του, αλλά θα
η θεωρία ήταν και ο λόγος που κάναμε αυτό το πράγμα, ήταν το kissing balloon με το μπαλόν της βαλβιδοπλαστικής, ήταν να μπορέσουμε να το κάνουμε αυτό το πράγμα, να έχουμε μια ευκολότερη πρόσβαση. Και γι' αυτό λόγο κάναμε την αξονική που δείχνει ότι υπάρχει patency. Τώρα, όσο εύκολα θα μπορέσουμε να το κάνουμε αυτό, πραγματικά δεν το ξέρω.
Επειδή έχω προσπαθήσει αγγιογραφικά, είναι σχεδόν αδύνατο. Είναι σαν να πρέπει να περάσει μια κλωστή μέσα την κεφαλή της βελόνας. Οπότε είναι κάτι που θα πρέπει να το θυμόμαστε. Ότι άπαξ και το βάλουμε και χρειαστεί να πάμε στα στεφανία, θα μπούμε μέσα από ένα cell και θα κάνουμε transformation το stent. Και το δεύτερο, μια που είμαστε όλοι μαζεμένοι εδώ, πόσο σας ανησυχεί να κάνετε ταυτόχρονα μια αγκιοπλαστική και ένα stent και μετά να προχωρήσετε στη βαλβίδα, στο ίδιο session? Υπάρχει κάποιος που ανησυχεί γι' αυτό?
Εγώ νομίζω, δεν ξέρω αν μου επιτρέπεις, Κώστα. Ναι. Συνήθως το κάνουμε σε διαφορετικά session. Εκτός από τους ανθρώπους, εκτός από τους ασθενείς που πιστεύω ότι είναι υψηλού κινδύνου για επιπλοκή, γιατί νομίζω πως αυτοί οι ασθενείς, αν κάνουν βαγοτονία, μπορεί να έχεις κάποια επιπλοκή από τα στεφανία, αν έχεις επιμήκη στενώσεις. Νομίζω πως είναι από τους ασθενείς οι οποίοι δεν θα βγουν εύκολα από την επιπλοκή των στεφανίων, όχι από την επιπλοκή της αορτικής βαλβίδας.
Προσωπικά, η μόνη περίπτωση οξείας θρόμβωσης stent που είχα στο Ωνάσιο, το θυμάμαι ακόμα, ήταν ένα περιστατικό που έκανε βαγοτονία και έκανε μεγάλη βραδικαρδία μετά την τοποθέτηση του stent και χρειάστηκε τοποθέτηση προσωρινού ματοδότη. Ήταν αρκετό αυτό για να θρομβωθεί το stent. Επομένως, όταν βάζουμε ένα stent και μετά πάμε να κάνουμε τάβη στο ίδιο session, αν για οποιοδήποτε λόγο ο ασθενής βρεθεί με χαμηλή παροχή, για μικρό χρονικό διάστημα θα θρομβωθεί αυτό το stent. Είναι πολύ πιθανό να θρομβωθεί αυτό το stent. Και μετά γίνεται πολύ πολύπλοκη αντιμετώπιση. Ο Νεκτάριος, ο κύριος Πιλάτης, κάτι ήθελε να πει. Στο μικρό.
Εγώ η μόνη περίπτωση να κάνω αγκιοπλαστική μαζί με τη βαλβίδα, μια φορά έχει γίνει, ήταν σε περιστατικό το οποίο είναι πολύ εύκολο, μια σοβαρή στένωση, ας πούμε, σε στεφανείο αγκείο, εύκολα προσβάσιμο όμως μετά την τάβη. Δηλαδή να μπει μια βαλβίδα χαμηλού προφίλ και αν χρειαστεί, αν γίνει κάποια επιπλοκή, να είναι πολύ εύκολα προσβάσιμο. Σε αντίθετη περίπτωση δεν θα το...
Άρα έχουμε μία άποψη του Νεκτάριου που λέει σε πολύ εύκολο περιστατικό, σε πολύ εύκολο PCI και την άποψη του Γιάννη, ο οποίος μας είπε σε ένα περιστατικό.
Πάντως, Κώστα, να θυμίσω ότι υπάρχουν μελέτες, μία από τις οποίες είναι τυχοποιημένη, που έδειξε ότι δεν υπάρχουν διαφορές. Το κάνεις πριν, μετά, είναι το ίδιο πράγμα. Οπότε, νομίζω πως πρέπει να έχουμε την κλινική σκέψη που είναι εξατομικευμένη για κάθε ασθενή, ποιο είναι πιο καλό.
Το ερώτημα, μπορώ να παρέμβω, Κώστα?
Βεβαίως.
Ναι, το ερώτημα είναι, ο Πέτρος Δάρδας. Το ερώτημα είναι, τι θα κάνεις πρώτα? Θα κάνεις πρώτα την αγκιοπλαστική, θα κάνεις πρώτα την τάβη? Γιατί υπάρχει περίπτωση, αν η αγκιοπλαστική είναι δύσκολη για αφιάρωση, έχουν πασιβεσκομένα αγκία. Πολλές φορές μπορεί να χρειαστεί rotablation. Την ώρα της αγκιοπλαστικής, ο άρρωστος να κάνει αιμοδυναμικό compromise. Οπότε, εδώ τίθεται το ερώτημα, τι κάνεις πρώτα? Ναι. Κατά την άποψή μου, αν η αγκιοπλαστική είναι complex, αν απλή αγκιοπλαστική, εντάξει, πώς να την κάνεις, αν η αγκιοπλαστική είναι complex, θα πρέπει να δεις από τι υποφέρει πιο πολύ ο άνθρωπος. Αν είναι ασταθής ηθάγεια, αν υποφέρει από τη στένωση αορτής, αλλά αν η αγκιοπλαστική είναι complex και χρειαστεί rotablation, θα προτιμούσα πρώτα να κάνω την βαλβίδα και μετά την αγκιοπλαστική.
Επομένως, συμφωνούμε όλοι ότι one rule doesn't apply to all.
Εξατομίκευση. Ευχαριστούμε πάρα πολύ. Θα προχωρήσουμε στο επόμενο περιστατικό από το Ιπποκράτιο, ο κύριος Καρανάσκιος.
Καλησπέρα και από μένα. Ο κύριος Λάτσος δεν μπορούσε λόγω κάποιων υποχρεώσεων, οπότε θα σας παρουσιάσω εγώ αυτό το περιστατικό. Πρόκειται για έναν άνταγο 4 ετών με συμπτωματική πολύ σημαντική στένωση της αορτικής βαλβίδας, με υψηλό διχειρητικό κίνδυνο, για τον οποίο αποφασίστηκε να προχωρήσουμε σε διαδερμική παρέμβαση. Και βλέπουμε ήδη από την αξονική την προεπεμβατική ότι υπάρχει πολύ υψηλό ασβέστιο σε όλες τις πτυχές στα στεφανία, οπότε αναμένω από πριν κάποια δυσκολία. Το πλάνο είναι λίγο παλιότερο περιστατικό, ότι θα έπρεπε να φυτέψουμε μια 29 mm core valve. Οπότε το πλάνο μας ήταν να πάμε κανονικά με προδιαστολή. Με conscious sedation προχωρήσαμε με παρακέντηση αριστερής στεφανίας, βάλαμε από πριν μια συσκευή το STAR και βάλαμε το θικάρι το 18 French. Εδώ πέρα είναι η αρτογραφία πριν από την τάβη. Περάσαμε με ευθύσιμα και με άμπλες λευτένα και μετά βάλαμε ένα κόνφιντα. Ωραία όλα αυτά, αλλά το μπαλόνι δεν μπορούσε να περάσει μέσα από τη βαλβίδα. Οπότε εδώ είναι το ερωτηματικό τι θα μπορούσαμε να κάνουμε. και μετά κινηθήκαμε λίγο σε λογική στεφανιαίων και αποφασίσαμε να βάλουμε ένα body wire στην κοιλία, μήπως καταφέρουμε να περάσουμε το μπαλόνι. Ωστόσο, η ιδέα μας δεν απέδωσε καρπούς, δεν μπορούσαμε να περάσουμε εντός της κοιλίας, οπότε είχαμε ένα νέο θέμα. Τελικά αυτό που κάναμε ήταν πάλι σε λογική στεφανία, να δοκιμάσουμε με ένα μικρότερο μπαλόνι, το οποίο βέβαια ήταν αρκετά μικρότερο, δηλαδή πήγαμε ένα μπαλόνι περιφερικών που είχαμε διαθέσιμο στα 8 χιλιοστά. Όπως βλέπετε εδώ κατάφερε να γίνει η έκπληξη του μπαλονιού, ήδη ζορίστηκε και αυτό το μπαλόνι λιγάκι. Οπότε μετά υπήρχε ο χώρος για να περάσουμε το κανονικό μπαλόν των 21 χιλιοστών. Στη συνέχεια προχωρήσαμε με την εμφύτευση. Βλέπουμε εδώ την εμφύτευση. Ένα καλό αποτέλεσμα, δεν είχαμε διαφύγη, καλό gradient και κλείσαμε και τα πόδια χωρίς κάποιο πρόβλημα. Σε ευχαριστώ.
Πράγματι βλέπουμε πώς μπορούν να συνδυαστούν δύο διαφορετικοί κόσμοι. Δεν πρέπει όσοι ασχολούμαστε με τις δομικές καρδιοπάθειες να ξεχάσουμε τη στεφανία νόσο. Ευχαριστούμε πάρα πολύ, κύριε Καρνάσκιο. Δεν ξέρω αν υπάρχει κάποια ερώτηση. Ο κύριος Νίκας.
Δεν ξέρω αν είναι αληθές αυτή η σκέψη που έχω, αλλά μιλώντας με έναν χειρουργό στην Αγγλία, μου είπε ότι όλες οι βαλβίδες οι περισσότερες αορτικές βαλβίδες είναι fenestrated. Είναι σίγουρο το μπαλόνι δηλαδή πέρασε μέσα από το true lumen της αορτικής στένωσης ή μήπως πέρασε από κάποιο μικρό fenestration και δεν μπορούσε να περάσει μετά το άλλο μπαλόνι?
Υπάρχει πιθανότητα αυτή, πράγματι.
Δεν μπορούμε να το αποκλείσουμε. Το θέμα είναι πως με το μπαλόνι ουσιαστικά έγινε χωρίς να μπορέσουμε να περάσουμε το μεγαλύτερο μπαλόνι.
Πράγματι, όταν γίνεται αυτό και μπορεί να συμβεί, ίσως πριν προχωρήσεις στην στρατηγική που ακολουθήσατε να αποτραβήξεις το σύρμα και να δοκιμάσεις να ξαναπεράσεις. Βέβαια, αυτό με την προϋπόθεση ότι ήταν εύκολο το πέρασμα. Αν έκανες πάρα πολύ ώρα και ήταν πολύ δύσκολο να περάσεις το σύρμα, θα ήταν λίγο χαζό να τραβήξεις πίσω. Αλλά γενικά, εάν το σύρμα δεν είναι στη σωστή θέση, τότε αυξάνεται το ρίσκο για πολλές και διάφορες επιπλοκές. Από ό,τι φαινόταν όμως εδώ, όταν κάνατε τα μικρά τα μπαλονάκια, το σύρμα ήταν στη σωστή θέση. Δηλαδή ήταν στην κομισούρα ανάμεσα στο non-coronary και στο right. Επομένως, νομίζω το είδατε και δεν ανησυχήσατε για τη θέση του σύρματος.
Όταν μπήκε μέσα το Confida είχαμε καλή θέση, δηλαδή δεν είχαμε ιδιαίτερο θέμα μέσω της ανταλλαγής που κάναμε, αλλά σε καμία περίπτωση δεν μπορώ να αποκλείσω ότι τελικά το πέρασμα ήταν λίγο διαφορετικό.
Ξέρω ότι είχατε και ένα δεύτερο σύρμα, αφού είχατε και πάτη του ΒΑΕ. Και τα δύο πέρασαν από την ίδια μεριά, δύσκολο.
Αλλά το άλλο δεν δοκιμάσαμε από την αλήθεια μέσω του Applets να...
Δεν προσπαθήσατε μέσω του δευτέρου σύρματος να πείτε.
Ακριβώς. Δοκιμάσαμε μόνο από το πρώτο.
Αυτό είναι πάντα ένα πράγμα που να το κάνετε. Να δοκιμάζετε από το δεύτερο. Όταν δεν περνάει με το πρώτο, περνάει με το δεύτερο. Συμβαίνει και στα στεφανία αυτό πάρα πολύ συχνά.
Θα το κρατήσουμε τη σκέψη για την επόμενη φορά.
Κάτι άλλο που θα μπορούσε να δοκιμαστεί είναι να βάλουμε ένα μικρό μπαλόνι βαλβιδοπλαστικής, να το σπρώξουμε, να σφινώσει πάνω στο στόμιο, στη βαλβίδα και να το ανοίξουμε. Αυτό μπορεί να σπάσει το ασβέστιο και να διευκολύνει μετά την διέλευσή του.
Και αυτή είναι πράγματι μια σκέψη σωστή. Λοιπόν, σας ευχαριστούμε πάρα πολύ, κύριε Καρανάσιο. Θα περάσουμε στον επόμενο ομιλητή μας. Είναι ο κύριος Νίκας, ο Δημήτρης Νίκας από τα Ιωάννινα. Stand stuck in the middle, how a difficult TAVI procedure became more difficult. Σας ακούμε, κύριε Νίκα.
Από ό,τι φαίνεται, η αρχή μας είναι ότι μαθαίνουμε από τα λάθη μας. Οπότε νομίζω ότι είμαι ο μόνος πάλι που θα παρουσιάσει επιπλοκή. Είναι ένα δύσκολο περιστατικό και μάλλον το κάναμε και πιο δύσκολο κι εμείς. Είναι ενδιαφέρον όμως. Πρόκειται για μια γυναίκα 83 χρονών με σοβαρή αορτική στένωση, η οποία είχε βάλει πριν 2 χρόνια μια βιοπροσθετική βαλβίδα, μια μάγνα, 25 χιλιοστά. Αυτή η βαλβίδα εκφυλίστηκε πάρα πολύ γρήγορα, με αποτέλεσμα να κάνει μια σοβαρή στένωση μέσα σε 2 χρόνια. Και τελικά η ασθενής αυτή προγραμματίστηκε για TAVI επέμβαση με μια Evolutar 26 χιλιοστά. Και εμείς πήραμε το κλασικό application, είδαμε ακριβώς ποια βαλβίδα ταιριάζει, μας έδωσε την επιλογή των 26 χιλιοστών για τη βαλβίδα αυτή. Το παράξενο αυτή την ασθενή είναι η ανατομία των στεφανίων. Βλέπετε πως εκφύει τη δεξιά στεφανία αρτηρία, εντελώς διαφορετικά, από την αντίθετη τελείως πλευρά από ό,τι θα έπρεπε να είναι. Και ένα πολύ χαμηλό στέλεχος, η έκφυση του οποίου φαίνεται να είναι compromised ιδιαίτερα από την βαλβίδα την ίδια. Στην αξονική ήταν περίπου 4 χιλιοστά. Και όπως θα δείτε τις εικόνες, είναι η περίπτωση 2 που έδειχνε προηγουμένως ο Γιάννης Ιακώβου. Βλέπετε ότι είναι μια βαλβίδα η οποία ουσιαστικά έχει στραφεί, είναι tilted προς την περιοχή του στελέχους. Ενώ από την δεξιά στεφανία αρτηρία υπάρχει μια πολύ καλή απόσταση. Ουσιαστικά από την μεριά του στελέχους, ουσιαστικά είναι μια βαλβίδα που έχει στραφεί προς την περιοχή του στελέχους. Όσον αφορά το περιφερικό access, όλα είναι καλά, δεν έχουμε κάποιο ιδιαίτερο πρόβλημα. Είπαμε να κάνουμε stent protected, δηλαδή να κάνουμε ένα chimney, αν χρειαστεί σε αυτή την ασθενή, μήπως και κλείσει το στέλεχος. Ουσιαστικά δεν είχαμε πρόβλημα στο access. Η βαλβίδα τοποθετήθηκε καλά, όπως ακριβώς υποδεικνύει και το application, στη σωστή θέση. Και ταυτόχρονα, όπως παρατηρείτε, είχαμε και ένα stent, ένα μακρύ stent 4x32, το οποίο το είχαμε stand-by στο στέλεχος, προκειμένου να το εκπτύξουμε σε περίπτωση που δούμε ότι υπάρχει πρόβλημα στο πάτηση των στεφανίων αγίων. Η βαλβίδα τη βλέπουμε ότι είναι σχεδόν μισοεκπτυγμένη, φαίνεται ότι δεν υπάρχει πρόβλημα και τελικά η βαλβίδα εκτίθεται τελείως, απελευθερώνεται και βλέπουμε ότι υπάρχει πλήρης πέτηση στο στέλεχος, οπότε και αποφασίζουμε να αποσύρουμε το stent. Αλλά δυστυχώς, όπως βλέπετε, παρά τη μεγάλη δύναμη που βάλαμε για να το αποσύρουμε, αυτό ήταν αδύνατο. Και όπως παρατηρείτε εδώ, ουσιαστικά χάσαμε το stent μέσα στο στέλεχος. Βλέπετε τον καθητήρα, ο οποίος έχει κολλήσει δίπλα στο stent και το stent το οποίο έχει χαθεί και ουσιαστικά είναι στο στέλεχος χωρίς το μπαλόνι. Lost stent δηλαδή. Αυτό που κάναμε, βάλαμε στην αρχή ένα μικρό μπαλόνι, εφόσον διατηρούσαμε τη δίωδο του σύρματος μέσα από το stent, βάλαμε ένα μικρό μπαλόνι μέσα από το stent το οποίο είχε χαθεί, το φουσκώσαμε και προσπαθήσαμε να το αποσύρουμε. Στην αρχή φάνηκε ότι τα πράγματα πήγαιναν καλά, αλλά όπως βλέπετε εδώ, ουσιαστικά τραβάμε με πολύ μεγάλη δύναμη και το stent, όπως βλέπετε, ουσιαστικά κολλάει ανάμεσα στη βαλβίδα και στην αορτή, ανάμεσα στη βαλβίδα και στον καθητήρα, με αποτέλεσμα μετά να φύγει τελείως. Ουσιαστικά τι κάναμε, το stent πάλι κόλλησε και το επιμικίναμε ουσιαστικά μέσα στην αορτή. Ήταν αδύνατο να το αποσύρουμε. Χωρίς πολύ καλά να καταλάβουμε γιατί γίνεται αυτό το πράγμα. Τελικά αποφασίσαμε να κρασάρουμε το stent. Βάλαμε μπαλόνια 3,5, 4, ακόμα και 5. Χρησιμοποίησαμε μπαλόνια, όπως βλέπετε εκεί, από καροτιδικά stent που χρησιμοποιούμε, για να μπορέσουμε να το κρασάρουμε. Κάναμε άιβους στη συνέχεια για να δούμε αν αυτό δεν ήταν καλό το κρασάρισμα. Θα σας δείξω εικόνες μετά. Αλλά τελικά δεν ήταν εφικτό. Οπότε κάναμε ουσιαστικά crashing στο stent με 2 μπαλόνια, 4 χιλιοστά. Ταυτόχρονα 2 μπαλόνια τα φουσκώσαμε μέσα στο στέλεχος για να μπορέσουμε να το κρασάρουμε με ένα ικανοποιητικό αποτέλεσμα. Βλέπετε εκεί τα 2 μπαλόνια τα οποία φουσκώνουν μαζί για να μπορέσουμε να εκπτύξουμε και να πακτώσουμε το stent στο τείχομα του στελέχους. Αυτό είναι το άιβους. Βλέπετε στην εικόνα α ουσιαστικά ότι είναι το stent πώς είναι κρασαρισμένο και πώς ουσιαστικά πλέει μέσα στο στέλεχος μετά τις διαστολές ακόμα και με 5 mm μπαλόνια. Αργότερα βλέπετε στην εικόνα β το stent πώς ουσιαστικά πακτώθηκε ικανοποιητικά στο τείχομα του stent με τα 2 μπαλόνια 4 και 4, 8 δηλαδή χιλιοστά, τα οποία χρησιμοποιήσαμε. Εδώ βλέπετε ουσιαστικά την εικόνα του stent το οποίο βρίσκεται στο proximal μέρος του στελέχους. Καταλαβαίνετε ότι πρόκειται για ένα τεράστιο στέλεχος. Τώρα πόσο είναι αυτό, 8-10 χιλιοστά. Και εδώ το stent το οποίο ουσιαστικά έχει μείνει και έχει κολλήσει ανάμεσα στο τείχομα της αορτής και της βαλβίδας. Τελικά, εφόσον κάναμε και μεταδιαστολή με ένα μπαλόνι στη βαλβίδα και είδαμε ότι το στέλεχος ήταν εντάξει, αποφασίσαμε να αφήσουμε και το stent, θεωρώντας ότι μάλλον αυτή μια μεγάλη γωνία που είχε και το στέλεχος σε σχέση με την στραμμένη αυτή η βαλβίδα ήταν η αιτία που δεν μπορούσαμε να το αποσύρουμε αφού το βάλαμε. Η ασθενής μεταφέρθηκε στη μονάδα με διπλή αιτιομεταλλιακή θεραπεία, πήγε πολύ καλά, βγήκε από το νοσοκομείο την τρίτη κιόλας μέρα. Δυστυχώς απεβίωσε 1 μήνα μετά από μια σοβαρή λίμωξη αναπνευστικού, η οποία δεν ήταν COVID κιόλας, αλλά παρά τα αυτά, παρότι έκανε μια παρατεταμένη νοσηλεία σε ένα περιφερειακό νοσοκομείο, δεν τεκμηριώθηκε ποτέ κάποιο οξύστεφανείο επεισόδιο, ούτε τεκμηριώθηκε ποτέ έμφραγμα. Τι μάθαμε από αυτή την περίπτωση? Μάθαμε ότι ουσιαστικά η απόφραξη των στεφανίων είναι ένα πολύ σημαντικό πράγμα και πάντα πρέπει να παίρνονται μέτρα για την αποφυγή του, διότι μπορεί να είναι και καταστροφική, ακόμα και θανατηφόρα. ότι η stent protector technique, το τσίμνιο όπως λέμε, είναι μάλλον η πιο καλή τεχνική να χρησιμοποιήσουμε και να προστατεύσουμε τα στεφανέα, αλλά όπως είπε ο κύριος Πάργης προηγουμένως, καλό να τη χρησιμοποιούμε μόνο σε περίπτωση διάσωσης. Η μπαζίλικα τεχνική, δηλαδή ουσιαστικά η διχοτόμηση της στεφανέας ψυχής από την βιοπροστατική βαλβίδα, την χειρουργική βιοπροστατική βαλβίδα, είναι μια τεχνική, αλλά δεν την ξέρουμε. Τουλάχιστον δεν έχουμε εμπειρία σε αυτήν και είναι μια πολύ δύσκολη τεχνική, κόμπλεξ, και νομίζω ότι πρέπει να γίνεται μόνο από ειδικούς οι οποίοι γνωρίζουν καλά να την κάνουν. Και βέβαια νομίζουμε ότι σε αυτή την περίπτωση αυτή η παράξενη γωνία που υπήρχε μεταξύ της βαλβίδας, της αορτής, αλλά και του στελέχους, όπως είδατε στις εικόνες, αλλά κυρίως και στην αξονική, που είδατε μια βαλβίδα να είναι στραμμένη τελείως προς την περιοχή του στελέχους, ήταν το αίτιο για το οποίο ουσιαστικά κόλλησε το stent. Επίσης, τι μάθαμε άλλο? Μάθαμε αυτό που κάνουμε πια ήδη, ότι πάντα από εδώ και πέρα αφήνουμε παρκαρισμένο ένα guideliner, ένα extension catheter μέσα στους στέλεχους του ασθενούς, έτσι ώστε αν χρειαστεί να βάλουμε το stent, αν χρειαστεί να μην βάλουμε το stent, να μπορούμε εύκολα να το αποσύρουμε. Σας ευχαριστώ πάρα πολύ.
Δημήτρη, σε ευχαριστούμε πάρα πολύ. Αυτό έλεγα πριν στον Κώστα. Να ρωτήσω, Κώστα, για αν μπορούσαμε να βάζουμε ένα guideliner, ένα mother and child. Αυτό ερώταγα πριν ακριβώς τον Κώστα.
Αυτό το πράγμα που τα κάνουμε τώρα πια, έχουμε 2-3 περιπτώσεις, μπορούμε να τις συζητήσουμε κάποια φορά, κάνουμε και ένα registry, μπορούμε να βάζουμε πάντα ένα guideliner παρκαρισμένο μόνιμα μαζί με το stent μέσα στο στέλεχος.
Ένα άλλο approach το οποίο θα σας έβγαζε τελείως από όλη αυτή την ιστορία είναι να βάζετε μια balloon expandable βαλβίδα, μια sapien η οποία θα έμενε μέσα στην άλλη βαλβίδα και δεν θα είχατε κανένα πρόβλημα να κάνετε εύκολα προστασία και να αποσύρετε το stent αν χρειαστεί. Γενικά σε αυτές τις περιπτώσεις νομίζω ότι όταν χρησιμοποιείς self-expanding μεγάλες βαλβίδες μπαίνεις στο άγνωστο λίγο μέσα, ενώ με μία sapien δεν έχεις αυτό το πρόβλημα και σε αυτές τις περιπτώσεις προσωπικά ακολουθώ αυτή την εύκολη λύση.
Παρά τα αυτά, όπως είδαμε, η βαλβίδα δεν απέφραξε τελικά το στέλεχος. Το πρόβλημα ήταν, και δεν καταλάβαμε ποτέ καλά γιατί υπήρχε αυτή μια γωνία η οποία ουσιαστικά εμπόδιζε το stent να βγει. Κάπου γράπωσε εκεί το stent, είδε ότι το στέλεχος ήταν τελείως ανοιχτό. Δεν υπήρχε πρόβλημα, αλλά δυστυχώς δεν μπόρεσε ποτέ να βγει το stent.
Κάτι άλλο είναι ότι θα πρέπει όταν τοποθετείς τη βαλβίδα, όποια βαλβίδα και να χρησιμοποιήσεις, το stent να είναι εκεί, νομίζω, που πρέπει να μπει, που θα ήθελες να το βάλεις. Να μην το κρατάς δηλαδή βαθιά μέσα στον LED και μετά να έχεις δυσκολία να το αποσύρεις. Αν το stent μείνει εκεί ακριβώς που θες να το τοποθετήσεις, τότε απλώς όταν έχεις πρόβλημα το φουσκώνεις. Νομίζω άκουσα τη φωνή του κυρίου Μιχάλη online. Λάμπρο, είσαι μαζί μας?
Βεβαίως.
Ωραία. Θα ήθελες να συνεχίσεις τις παρουσιάσεις?
Όχι, πέστε εσείς γιατί δεν το έχω μπροστά μου και το πρόγραμμα, δεν το βλέπω, αλλά
εντάξει,
εδώ που είμαι.
Έχουμε μαζί μας λοιπόν τον Γιώργο, τον Γεωργίου από την
Αλλά
Κύπρο.
θα είμαι εδώ και θα κάνω ό,τι σχόλιο απαιτείται.
Έγινε. Γιώργο, καλησπέρα. Χαρά μας να είσαι μαζί μας και ακούμε την παρουσίασή σου.
Λοιπόν, καλησπέρα. Θα ήθελα να ευχαριστήσω και εγώ με τη σειρά μου την Οργανωτική Επιτροπή και ειδικά τον Κώστα τον Σπάρια για την τιμητική πρόσκληση. Θα τον ευχαριστήσω όμως κυρίως γιατί ήταν ο άνθρωπος ο οποίος μας ενέπνευσε και μας ενέταξε στο θαυμαστό κόσμο των διαθεκατιατριακών επεμβάσεων. Το περιστατικό στο οποίο θα αναφερθώ αφορά άντρα ηλικίας 79 ετών, ο οποίος πάσχει από χρόνια αποφαρκτική πνευμονοπάθεια ως βαρύς καπνιστής που ήταν, από πνευμονική υπέρταση, είναι ένα παχύσαρκο άτομο με μέτρια επηρεασμένη την νεφρική του λειτουργία, στο οποίο το 2015, το Γενάρη, είχαμε κάνει διακαθεδριακή εμφύτευση αορτικής βαλβίδας, τοποθετώντας μια sapien βαλβίδα 26 χιλιοστών, χωρίς οποιοδήποτε πρόβλημα. 3 χρόνια αργότερα, ο ασθενής αυτός εμφάνισε οξύ στεφανιό σύνδρομο, για το οποίο έγινε αγκιοπλαστική στον πρόσωπο κλάδο και στον επιχείλιο κλάδο με εμφύτευση φαρμακευτικού stent. Πρόσφατα και συγκεκριμένα πριν από 3 μήνες άρχισε να παρουσιάζει συμπτώματα, να έχει δύσπνοια στην ελάχιστη προσπάθεια. Το BNP του ήταν κοντά στο 1200 και από το υπερηχογράφημα διαπιστώθηκε ότι έπασχε από σοβαρή στένωση της αορτικής του, της βιοπροσθετικής του βαλβίδας, από εκφύλιση που καταγράφηκε στις εξετάσεις που του έγιναν. Εδώ είναι το διαθωρολογικό υπερηχογράφημα, στο οποίο δεν μπορεί κανείς να αξιολογήσει καλά την βαλβίδα λόγω του μεταλλικού frame και των ηχοανακλάσεων. Όμως αυτό μπορεί να διαπιστώσει κανείς ότι είχε μια ταχύτητα ροής κατά μήκος της αορτικής βαλβίδας που ξεπερνούσε άγγιζε σχεδόν τα 5 μέτρα ανά δευτερόλεπτο, με ένα gradient σχεδόν στα 100. Το δε ισοφάγιο περικογράφημα έδειξε μια σαφή πάχυνση και εκφύλιση των τυχών της βιοπροσθετικής βαλβίδας, επιβεβαιώνοντας τη διάγνωση της σοβαρής στένωσης της βιοπροσθετικής βαλβίδας. Η αξονική αγγιογραφία, η ECG gated που έγινε, έδειξε ότι δεν υπήρχαν θρόμβοι πάνω στην βαλβίδα. Η δε απόσταση των στεφανίων αρτηριών από το μεταλλικό frame, αλλά κυρίως από τόσο της αριστερής όσο και της δεξιάς στεφανίας αρτηρίας, ήταν τέτοια που μας καθησύχαζε ότι δεν θα είχαμε οποιοδήποτε πρόβλημα εμφυτεύοντας μια νέα βαλβίδα μέσα στην προηγούμενη. Αν και δεν το συνηθίζουμε σε όλα μας τα περιστατικά, αντίθετα είναι εξαιρετικά σπάνια που το κάνουμε, στο συγκεκριμένο ασθενή βάλαμε μια συσκευή Sentinel για να προστατεύσουμε τον εγκέφαλο από πιθανά εμβολικά επεισόδια. Εδώ βλέπουμε κάτω αριστερά την αορτογραφία με την Sapien βαλβίδα την εκφυλισμένη και ακολούθως εμφυτεύσαμε χωρίς ιδιαίτερα προβλήματα μια καινούρια Sapien 3 26 χιλιοστών. Στόχος εδώ είναι να κρατήσουμε αυτό το επίπεδο, το πάνω επίπεδο, το αορτικό άκρο, στο ύψος της προηγούμενης βαλβίδας, γιατί ξέρουμε ότι το από κάτω ανεβαίνει προς τα πάνω, από την κοιλία προς τα πάνω. Οπότε κάτι τέτοιο κάναμε με αργή εμφύτευση και ταχεία βηματοδότηση πάνω στο σύρμα. Τώρα που το βλέπω, το σύρμα είναι και λίγο επιφανειακά, αλλά εν πάση περιπτώσει είχα μια καλή βηματοδότηση χωρίς οποιοδήποτε πρόβλημα. Και έτσι εμφυτεύσαμε την Sapien 26 χιλιοστών εντός της προηγούμενης. Η επέμβαση έγινε με conscious sedation. Στο κέντρο στο οποίο εργάζομαι είναι ένα ιδιωτικό μικρό σχετικά νοσοκομείο, ιδιωτικό. Χρησιμοποιούμε δύο βαλβίδες, μία self-expanding της Medtronic και μία balloon expandable της Edwards. Αν και μικρό κέντρο, κάνουμε γύρω στις 150 εμφυτεύσεις το χρόνο αυτά τα τελευταία 2 χρόνια με το νέο σύστημα υγείας. Είναι περίπου 50-50 η αναλογία της εμφύτευσης των δύο βαλβίδων. Εδώ είναι το αιμοδυναμικό αποτέλεσμα πριν και μετά την εμφύτευση της βαλβίδας και βλέπουμε τη σημαντική πτώση του gradient κατά μήκος της αορτικής βαλβίδας. Όπως είπα και προηγουμένως, έγινε με conscious sedation. Ο ασθενής μόλις άρχισε να ξυπνά, άρχισε να εμφανίζει πόνο στη θαχικό, οπισθοστερνικό. Έγινε ένα επικλίνηση περιχογράφημα και ένα καρδιογράφημα. Στο καρδιογράφημα, όπως βλέπετε, υπήρχαν οξυκόρυφα DAF σε όλες τις προκάρδιες και ίσως και μια μικρή ανάσπαση στις πλάγιες απαγωγές. Αμέσως χρησιμοποίησαμε έναν EPU καθετήρα και διαπιστώσαμε πως το στόμιο του προσιού κατώντα κλάδου ήταν αποφραγμένο. Το πιο πιθανό σενάριο με αυτά τα δεδομένα ήταν ότι εμβολίστηκε ένα μικρό τεμάχιο από την εκφυλισμένη βαλβίδα στον πρόσιο κατώντα κλάδο. Γι' αυτό το μόνο πράγμα που κάναμε ήταν να βάλουμε ένα καθετήρα αναρρόφησης export στον πρόσιο κατώντα κλάδο, με αποτέλεσμα να αναρροφήσουμε αυτό το τεμάχιο της εκφυλισμένης βαλβίδας που είχε ένα μήκος περίπου στα 5 χιλιοστά, με αποτέλεσμα να αποκατασταθεί η ροή στον πρόσιο κατώντα κλάδο. Δεν χρειάστηκε να εμφυτεύσουμε stent. Υπήρχε λίγο στην κορυφή ακόμα ένα συμβολισμός και μια απόφραξη του κορυφαίου τμήματος, αλλά ο ασθενής σταθεροποιήθηκε τόσο αιμοδυναμικά όσο και υπερηχογραφικά και ηλεκτροκαρδιογραφικά. Εδώ είναι υπέρηχος 24 ώρες μετά, όπου βλέπετε έχει μια ικανοποιητική συσταλτικότητα τόσο στο βραχίνα άξονα όσο και στην δομή της 4 κιλοτήτων. Το gradient είχε πέσει στα 28 χιλιοστά, που είναι ένα αποδεκτό αποτέλεσμα μετά από διπλή βαλβίδα. 3 μέρες μετά από την τοποθέτηση της Sapien βαλβίδας στην βιοπροσθετική αυτή του προηγούμενου τσάβη, ο ασθενής, και ενώ ήταν έτοιμος και όδευε προς το εξιτήριο, εμφάνισε σημεία και συμπτώματα οξέως πνευμονικού ειδήματος, το οποίο επιβεβαιώθηκε με την ακτινογραφία θώρακος. Στο υπερηχογράφημα δεν μπορούσαμε να έχουμε ξεκάθαρη εικόνα και υπήρχε μια θολερότητα στο ύψος μέσα στο frame της βαλβίδας και όπως διαπιστώσαμε με την καταγραφή της κλίσης πίεσης, είχαμε πάλι ξανά μια ταχύτητα των 5 μέτρων ανά δευτερόλεπτο και ένα gradient κοντά στο 100, με μια συσταλτικότητα όχι και τόσο καλή όσο στην ημέρα ακριβώς μετά την εμφύτευση. Ο ασθενής ήταν αιμοδυναμικά σταθερός, έγινε μια άμεση σκέψη πως επρόκειτο για θρόμβωση, πρώιμη θρόμβωση της βαλβίδας. αιμοδυναμική αστάθεια δεν υπήρξε. Έτσι, η πρώτη σκέψη για χορήγηση νοδολιτικής αγωγής απομακρύνθηκε. Χορηγήθηκαν τεφλέβια διουρητικά. Αποφασίσαμε να θεραπεύσουμε τον ασθενή με χαμηλού μοριακού βάρους ηπαρίνη, με δόση εφόδου και ακολούθως ένα 12ωρο. Και 24 ώρες αργότερα ξεκινήσαμε ριβαροξαπάν. Ο ασθενής σιγά σιγά σταθεροποιήθηκε. Και ένα μήνα μετά πήρε εξιτήριο την 7η μέρα από την διενέργεια της διακαθεδριακής εμφύτευσης. Ένα μήνα μετά είναι σταθερός. Η κλίση της έχει πέσει εκεί κοντά που ήταν προηγουμένως, κοντά στα 30 χιλιοστά της κλίσης υδραργύρου, ενώ η συσταλτικότητα του έχει αποκατασταθεί πλήρως. Σας ευχαριστώ για την προσοχή σας.
Γιώργο, σε ευχαριστούμε πάρα πολύ. Όταν έδειξες τις εικόνες της αξονικής, που ήταν still frames, βλέποντάς τις από εκεί, είδα ότι υπήρχε πάχυνση και μαύρο χρώμα πάνω στις βαλβίδες, πάνω στις γλοχίνες. Εικόνα η οποία συνάδει με HALT, δηλαδή και τελικά όπως εξελίχθηκε αυτό το περιστατικό, εκ των υστέρων βέβαια το λέμε, όχι εκ των προτέρων, πιθανότατα είχε θρόμβο αυτή η βαλβίδα πριν και κομμάτια από αυτού του θρόμβου φύγανε και κάναν την εμβολή και γι' αυτό έκανε πάλι τόσο γρήγορα θρόμβο μετά. Είχα ένα παρόμοιο περιστατικό το οποίο μπήκε για να κάνουμε τάβη και ως συνήθως την προηγούμενη μέρα, το προηγούμενο βράδυ καθόμαστε και κάναμε review όλες τις αξονικές και κάνοντας review την αξονική η συνεργάτης μου, κυρία Κοκοβέλη, είπε πολύ μαύρο, πολύ πάχυση οι γλοχίνες, μήπως να κάνουμε πρώτα μία θεραπεία με συντρόμ για 1, 2, 3 μήνες και μετά να τη φέρουμε πίσω. Πράγμα που
αυτό ακριβώς κάναμε και εμείς σε αυτόν τον ασθενή. Του χορηγήσαμε τυφλά για 2 μήνες ριβαροξαπάν και δεν είχαμε κανένα αποτέλεσμα. Δηλαδή τον περιμέναμε, υπήρξε μια... Όχι, και πριν. Δηλαδή υπήρχε ένας φόβος μήπως είναι θρόμβωση σε αυτή τη βαλβίδα. Ήταν 7,5 χρόνια μετά την τοποθέτησή της.
Ναι.
Το σκεφτήκαμε, ο αξονικός δεν έδειξε την τυπική εικόνα της θρόμβωσης και υπενθυμίζω ότι η αναρρόφηση που έγινε έδειξε ένα τεμάχιο εκφυλισμένης βαλβίδας και όχι τον κλασικό θρόμβο. Ήταν ένα τεμάχιο, δεν ξέρω αν μπορώ να το ξαναδείξω, αλλά ήταν ένα κομμάτι της βαλβίδας της βιολογικής που είχε εκφυλιστεί και είχε εμβολιστεί. Δηλαδή προφανώς αποκόπηκε αυτό το κομμάτι και εμβολίστηκε στον πρόσωπο τον κλάδο.
Προφανώς έχεις δει όλη την αξονική και ξέρεις καλύτερα από εμάς. Εγώ απλώς είδα ένα still frame εκεί πέρα και εδώ το συζητούσαμε με τον Γιώργο ότι σαν πιθανό σενάριο αυτό, αλλά προφανώς έχεις δει όλη την αξονική, όλο το scrolling up and down και πιστήκατε ότι υπήρχε και επασβέστωση και ήταν πραγματική στένωση ασβεστοποιός και όχι HALT. Αλλά είναι κάτι που χαίρομαι που ακούω ότι το κάνατε κι εσείς. Βέβαια, σε αυτές τις περιπτώσεις τα NOAC δεν είναι τόσο αποτελεσματικά. Το ξέρουμε ότι δεν είναι τόσο αποτελεσματικά όταν έχουμε HALT μετά όσο είναι το syndrome. Το έχουμε δει σε δικά μας περιστατικά όπου δοκιμάσαμε κάποια στιγμή στο παρελθόν και δεν κάναν καμία αλλαγή στα gradient που παρακολουθούσαμε περιογραφικά και όταν γυρίσαμε σε oral anticoagulation, σε syndrome, τότε πραγματικά είδαμε αποτέλεσμα. Απλά είναι ένα πολύ ενδιαφέρον περιστατικό, το βλέπουμε όλοι μας και καλό είναι όταν έχουμε υπόνοια ότι υπάρχει HALT, όταν υπάρχει θρόμβος και δεν βλέπουμε άσπρο, δεν βλέπουμε ασβέστιο, αλλά βλέπουμε μόνο μαύρο πάνω στις λοχίνες, ακόμα και χρόνια μετά δεν έχουμε να χάσουμε κάτι με το να δώσουμε 2 ή 3 μήνες συντρόμου πριν προχωρήσουμε στην επέμβαση.
Ο κύριος Νίκας έχει μια ερώτηση ή διαπίστωση.
Όχι. Είναι μια μικρή ερώτηση. Θέλω να ρωτήσω, το Sentinel όμως έπιασε τίποτα? Αυτό είναι πολύ ενδιαφέρον γιατί, και νομίζω πολύ καλά κάνατε, γιατί φανταστείτε αυτό το κομμάτι να πήγαινε στον εγκέφαλο. Και το δεύτερο είναι, αυτή είναι ερώτηση, και όπως είπε ο Einstein, there are no silly questions, there are only silly answers. Οπότε ρωτάω λοιπόν, αυτή η έγχυση που κάνουμε πάνω στο μπαλόνι με τον καθετήρα την ώρα εκείνη της εμφύτευσης της βαλβίδας, της διάνοιξης, είναι απαραίτητη σκέφτομαι μήπως αυτή η έγχυση αυτού του μεγάλου όγκου σκιαγραφικού μήπως εκτρέπει οπωσδήποτε θρόμβους προς τα στεφανία, που είναι η μόνη δίωδος της ροής του αίματος εκείνη τη στιγμή.
Έχεις δίκιο. Πάντοτε τραβάμε το pigtail αρκετά ψηλά όταν κάνουμε αυτή την έγχυση. Εδώ δεν πρόσεξα που ήταν το pigtail. Και να κάνω και την ερώτηση που έκανε ο Γιώργος προηγουμένως. Αφού έκανε επαναστένωση, είπε ο Γιώργος, η Σάπιεν, γιατί ξαναβάλατε Σάπιεν?
Στην ουσία ήταν μια βαλβίδα στα 7,5 χρόνια. Δεν ήταν τόσο νωρίς που έκανε. Ο λόγος που βάλαμε τη Σάπιεν ξανά ήταν γιατί θέλαμε να έχουμε πρόσβαση στα στεφανία εύκολα, γιατί ήταν στεφανιός ασθενής. Στα 3 χρόνια είχε οξύ στεφανό και είχε στέντ στα στεφανία του. Και δεν μπορούσαμε να αποκλείσουμε το ενδεχόμενο να θέλουμε ξανά εγκαιοπλαστική μετά από 2-3 χρόνια.
Τέλεια. Και το τελευταίο, υπήρχε κάποια νεφροπάθεια σε αυτή την ασθενή ή κάποια αυξημένη παραθορμόνη ή κάτι δηλαδή που να προδιέθετε σε πρώιμη...
Είχε επηρεασμένη την νεφρική λειτουργία, για την παραθορμόνη δεν μπορώ να απαντήσω, δεν γνωρίζω. Αλλά η κρεατινίνη ήταν στο 1,65.
Κάτι το οποίο θα δικαιολογούσε τη σχετικά πρώιμη εκφύλιση.
Απλώς θα ήθελα να ρωτήσω κι εγώ κάτι. Πόσο απαραίτητο είναι να βλέπουμε την ασβέστωση σε αυτές τις εκφυλισμένες βαλβίδες και όχι μόνο να είναι μια πάχυνση και εκφύλιση του ιστού χωρίς την αποτιτάνωση, τη χαρακτηριστική?
Έχεις απόλυτο δίκιο. Δεν γνωρίζω την απάντηση. Απλά είναι πάντοτε καθησυχαστικό το να βλέπεις την επασβέστωση στην αξονική πάνω στις γλοχίνες. Σε αντίθεση με το να υπάρχει παντελής έλλειψη επασβέστωσης και να βλέπεις μία πάχυνση των γλοχίνων με μαύρο χρώμα προς τις βάσεις τους. Δεν μπορώ να δώσω απάντηση, απλά η αίσθησή μου είναι ότι είναι καθησυχαστικό το ένα σε σχέση με το άλλο.
Δεν έχω να πω κάτι, σωστό, συμφωνώ απόλυτα.
Ο κύριος Μιχάλης έχει κάποιο σχόλιο?
Όχι, το μόνο που θα... Πώς και δεν κάνατε ένα διοσοφάγιο υπέροχο μετά τη δεύτερη βαλβίδα, στο δεύτερο χρόνο που ξαναστένεψε η βαλβίδα, μου κάνει εντύπωση. Θα σας έλυνε ορισμένες απορίες του τι συνέβαινε εκεί.
Νομίζω εκεί δεν υπήρχαν πολλά άλλα περιθώρια να είναι κάτι άλλο εκτός από θρόμβωση της βαλβίδας. Στην αρχή, το πρώτο 24ωρο ήταν και ασταθής ο ασθενής, ήταν με πνευμονικό είδημα. Μετά θα μπορούσαμε να κάνουμε, η αλήθεια, αλλά νιώθαμε βέβαιοι ότι αυτό συνέβαινε με τη βαλβίδα. Δεν υπήρχε κάτι άλλο που μπορούσε να είναι, που να ανεβάσει τον gradient, δηλαδή από 28 στο 100 μέσα σε 2-3-24 ώρα. Δεν μπορώ να φανταστώ κάτι άλλο που μπορεί να οδηγήσει σε τόση μεγάλη αύξηση του gradient μέσα σε τόσο μικρό χρονικό διάστημα.
Όπως δεν είναι και το πιο συνηθισμένο η θρομβώση σε τόσο χρονικό διάστημα. Ούτε αυτό είναι το εξαιρετικά συνηθισμένο. Ήταν ένα ενδιαφέρον, μη συνηθισμένο περιστατικό, αλλά βέβαια, όπως λένε, την επιτυχία nobody can beat success.
Το τελικό αποτέλεσμα όμως ήταν πολύ καλό, οπότε
αυτό λέω και εγώ, ότι
πολύ Γιώργο, συγχαρητήρια και προχωράμε
αυτή που μετράει.
Με τον κύριο Πιλάτη, ο οποίος είναι εδώ μαζί μας, physically. Νεκτάρης, ακούμε.
Ευχαριστώ πολύ, Κώστα, για την τιμητική πρόσκληση και εσένα και όλη την Οργανωτική Επιτροπή. Το περιστατικό είναι ένα σύμπλοκο περιστατικό, σύμπλοκη πολυβαλβιδοπάθεια μιας ασθενούς 82 ετών με ρευματική πολυβαλβιδοπάθεια, η οποία είχε χρόνια συμπτώματα δεξιάς καρδιακής ανεπάρκειας. Πρόσφατα ανέπτυξε πνευμονικό είδημα, σοβαρή ορθόπνοια και πνευμονικό είδημα και επιδείνωση της δεξιάς καρδιακής ανεπάρκειας, και η οποία φάνηκε, η επιδείνωση αυτή, να οφείλεται εκτός των άλλων προβλημάτων των βαλβίδων σε μια σοβαρή επιδείνωση της στένωσης της αορτικής βαλβίδας, σε σοβαρή πια, low flow, low gradient, η οποία πιθανώς να οδήγησε και στο πνευμονικό είδημα σε έδαφος επασβεστομένης μέτριας προς σοβαρή στένωση μητροειδούς βαλβίδος, με μέτρια, ήπια προς μέτρια ανεπάρκεια και σοβαρή ανεπάρκεια τριγλόχινας βαλβίδος με διάταση και υποκινησία της δεξιάς κοιλίας. Το Euroscore 2 υποεκτιμά τον κίνδυνο του χειρουργείου γιατί δεν λαμβάνει υπόψη του την ασβεστοποιό μητροειδική βαλβιδοπάθεια, η οποία έχει ένα πολύ υψηλό κίνδυνο χειρουργικό, πάνω από 30%, όπως επίσης και διακαθετηριακής αντιμετώπισης σε πρόσφατα registries, πάνω από 30% θνησιμότητα στο μήνα, αν πάμε να αντιμετωπίσουμε διακαθετηριακά με την κλασική μέθοδο της βαλβίδας, της αναστραμμένης Edwards μέσα στην ασβεστωμένη μητροειδική βαλβίδα. Αυτό είναι το διεσοφάγιο της αορτικής βαλβίδος, περιορισμένη διάνοιξη αυτής. Δεν υπάρχει ακουστική σκιά, δεν έχουμε ασβέστωση, δηλαδή σημαντική ασβέστωση της βαλβίδος. Το στόμιο της είναι πολύ μικρό, εδώ πλανιμετρημένο στα 0,5 τετραγωνικά εκατοστά. Και εδώ βλέπουμε στην αξονική ότι δεν υπάρχει ασβέστωση των πτυχών του δακτυλίου. Υπάρχει σημαντική ασβέστωση του STJ, αλλά όχι όμως της αορτικής βαλβίδος. Και βλέπουμε μια σημαντική ασβέστωση του βαλβιδικού και υποβαλβιδικού μηχανισμού της μητροειδούς βαλβίδος. Καλό κλάσμα εξώθης αριστερής κοιλίας με έντονη επασβέστωση του υποβαλβιδικού μηχανισμού της μητροειδούς, τεράστιοι κόλποι, αμφωτερόπλευρα, πάλι βλέπουμε την ασβέστωση του υποβαλβιδικού μηχανισμού, διάταση της δεξιάς κοιλίας με απουσία συναρμογής των γλοχίνων της τριγλόχινας. Εδώ είναι η μητροειδής, πλανιμετρημένη με σοβαρή στένωση, από την εξίσου συνεχίαση η στένωση είναι μέτρια προς σοβαρή. Και εδώ βλέπουμε την έντονη επασβέστωση τόσο του μητροειδικού δακτυλίου όσο και του υποβαλβιδικού μηχανισμού της μητροειδούς που καθιστά πολύ υψηλού κινδύνου οποιαδήποτε από τις κλασικές προσεγγίσεις επιδιόρθωσης και αντικατάστασης. Σοβαρή ανεπάρκεια της τριγλόχινας βαλβίδος και η ανεπάρκεια της μητροειδούς ήπιου προς μετρίου βαθμού. Τώρα, στην αξονική της με πρωτόκολλο τάβη έχουμε έναν αορτικό δακτύλιο, ο οποίος είναι πολύ ελλειπτοειδής, πολύ ελλειπτικός, με τη μικρή διάμετρο στα 14 χιλιοστά και τη μέση διάμετρο στα 19 περίπου, με καλούς κόλπους του Βαλσάλβα σε διάμετρο, προς το μικρό εύρος, αλλά όχι ιδιαίτερα μικρούς, και ένα ακόμα μικρότερο LVOT. Βλέπουμε τη μικρή διάμετρο στα 12 χιλιοστά και μια μέση διάμετρο στα 17. Έτσι, αυτό μας βάζει σε κίνδυνο για pop-out της βαλβίδας κατά τη διενέργεια της τάβη. Το STJ πολύ ασβεστωμένο, σχεδόν κυκλοτερός και με διάμετρο 22 χιλιοστά κατά μέσο όρο. Μικρά περιφερικά αγγεία, οι κοινές μοιραίες αρτηρίες κάτω από 4,5 χιλιοστά και στις δύο πλευρές, αλλά οπότε έχουμε πολλούς προβληματισμούς για το περιστατικό αυτό, ρευματικής αιτιολογίας πολυβαλβιδοπάθεια, η βαλβίδα η αορτική χωρίς ασβεστώσεις, οπότε θα σταθεροποιηθεί, θα εγκιστρώσει η βαλβίδα, θα έχουμε μια καλή σταθερότητα όταν την ανοίξουμε. Μικρός δακτύλιος και LVOT με κονοειδή διαμόρφωση, οπότε αυξημένος κίνδυνος pop-out της βαλβίδος, και στη J μικρής διαμέτρου, αν βάλουμε κάποιο μπαλόνι μεγαλύτερο από 22 χιλιοστά, κίνδυνος ρήξης της αορτής. Μικρή ανατομία περιφερικών αγγείων, ευτυχώς όμως χωρίς σοβαρή επασβέστωση. Και από την άλλη μεριά, δύο άλλες βαλβίδες με σοβαρά προβλήματα. Οπότε, αντιμετωπίζοντας την αορτική βαλβίδα και ελαττώνοντας τον κίνδυνο του πνευμονικού ειδήματος, ποιος είναι ο χρόνος και ο τρόπος αντιμετώπισης της ασβεστοποιού στένος ανεπάρκειας μητροειδούς και της σοβαρής ανεπάρκειας της τριγλόχινος, πόσο γρήγορα και πότε και πώς πρέπει να επέμβουμε. Επειδή η ασθενής κρίθηκε πάρα πολύ ψηλό κίνδυνο χειρουργείου, για χειρουργία αποφασίσαμε να κάνουμε την αορτική βαλβίδα, όχι όμως να βάλουμε one-shot βαλβίδα, γιατί λόγω της ανατομίας, αν μας ξέφευγε, θα είχαμε πολύ σοβαρό πρόβλημα πια. Οπότε επιλέξαμε μια βαλβίδα να είναι σταθερή κατά την απελευθέρωση, ώστε να τον περισσότερο, εύκολη στην επαναπρόσληψη και επανατοποθέτηση και με κυλινδρική διαμόρφωση, οπότε να έχουμε μικρότερη τάση και στο LVOT και στο STJ. Και η βαλβίδα που επιλέξαμε ήταν η Navitor 23 mm, η μικρή βαλβίδα Navitor, για την πολύ μικρή ανατομία της ασθενούς. Περιφερική πρόσβαση ευτυχώς δεν είχαν πρόβλημα, παρόλο που τα αγγεία ήταν μικρά, μπόρεσε πέρα στο θικάρι με σχετική ευκολία. Ανεβάσαμε τον καθετήρα. Αυτή είναι η view, η overlap, cusp overlap view, μικρή ανατομία. Εδώ είναι η 3 cusp view. Κάναμε την διάνοιξη της βαλβίδος με ένα 16 mm μπαλόνι, μικρό μπαλόνι, και ανεβάσαμε την Navitor εύκολα. Είναι μια βαλβίδα η οποία είναι αρκετά εύκαμπτη και την τοποθετήσαμε όπως προέβλεπε και προβλεπόταν με το dot της βαλβίδος να είναι ακριβώς στην 3 cusp view εδώ, να είναι ακριβώς στο δακτύλιο, στο αορτικό δακτύλιο. Έτσι, εδώ επιβεβαιώνεται η σωστή θέση της βαλβίδος σύμφωνα με τις οδηγίες. Το dot να είναι στον αορτικό δακτύλιο, ανοίγοντας τη βαλβίδα και πηγαίνοντας στην κατά ένα μικρό μέρος, κατά ένα μικρό ποσοστό και πηγαίνοντας στην cusp overlap, βλέπουμε ότι η βαλβίδα έκανε pop-out. Έτσι, έχει φύγει από τη θέση της και επιβεβαιώνεται η υποψία και ο υψηλός κίνδυνος σε pop-out λόγω της κονοειδούς διαμόρφωσης του υποβαλβιδικού αορτικού ανατομίας, του LVOT. Λοιπόν, ξαναβάλαμε τη βαλβίδα και τοποθετήσαμε το μάρκερ κάτω από το δακτύλιο και με μια τάση προς τα έσω, ώστε να αποφύγουμε πάλι το pop-out της βαλβίδας, και ανοίξαμε σιγά σιγά τη βαλβίδα στην cusp overlap view, που είχε από ό,τι φαίνεται είχαμε καλύτερη ορατότητα της βαλβίδος. Την ανοίξαμε λίγο περισσότερο, κάναμε μια μικρή τροποποίηση στη θέση της. Βλέπουμε ότι το ceiling cuff λειτουργεί αμέσως, έχουμε ελάχιστη ανεπάρκεια. Εδώ που την ανοίξαμε λίγο περισσότερο, σχεδόν μηδενική ανεπάρκεια. Η βαλβίδα λειτουργεί αμέσως γιατί είναι intravalvular. Περιμένουμε λίγα λεπτά να σιγουρευτούμε ότι έχει σταθεροποιηθεί, ότι δεν μας κάνει pop-out, και αφού βλέπουμε ότι η θέση είναι σταθερή, απελευθερώνουμε τη βαλβίδα. Είναι λίγο βαθιά όπως βλέπετε, γιατί φοβηθήκαμε μην ξαναπέσει, μην ξαναφύγει προς τα πίσω. Έχουμε μια καλή θέση τελικά, δεν έχουμε καθόλου παραβαλβιδική ανεπάρκεια. Βέβαια, μετά την τοποθέτηση εμφανίζεται μπλοκ του αριστερού σκέλους που δεν προϋπήρχε, χωρίς όμως κολυφοκυλιακό αποκλεισμό. Έτσι, εδώ πάλι καλή θέση, χωρίς ανεπάρκεια. Το gradient ήταν 4 mm μετά την τοποθέτηση και το πόδι, η αριστερή μυριαία αρτηρία που επιλέξαμε να περάσουμε, έκλεισε χωρίς προβλήματα, χωρίς στένωση, με 2 proglides και χωρίς διαρροή. Συμπερασματικά, η χειρουργική αντιμετώπιση της ρευματικής πολυβαλβιδοπάθειας, έδαφος, Calcification, MSMR είναι εξαιρετικά υψηλού κινδύνου, όπως έχουν δείξει και πρόσφατα registries, όπως και η κλασική διακαθετηριακή αντιμετώπιση. Η τάβη σε ρευματική στένωση χωρίς επασβέστωση είναι εφικτή με μια προσεκτική επιλογή της βαλβίδος, και αυτό που θα καθορίσει μάλλον τη βραχυπρόθεσμη όπως και τη μακροπρόθεσμη πρόγνωση του ασθενούς είναι η ανεπάρκεια της τριγλώγινας βαλβίδος, όπως φαίνεται, και η δεξιά καρδιακή ανεπάρκεια, όπως φαίνεται από 2 μικρές μελέτες που έχουν, αναδρομικές που έχουν ανακοινωθεί, και πρέπει να υπάρχει ένα πλάνο για γρήγορη αντιμετώπιση της πάθης της μητροειδούς και της τριγλώγινας βαλβίδος. Για τη μητροειδή Calcification MSMR, πιθανώς η καλύτερη προσέγγιση στην περίπτωσή μας θα ήταν η Transatrial approach, υβριδική προσέγγιση, χειρουργική και διακαθετηριακή. Ευχαριστώ πολύ για την προσοχή σας.
Νεκτάριο, πολύ ωραία. Τι συνέβη με τη μητροειδή βαλβίδα μετά από αυτή τη βαθία τοποθέτηση αυτής της βαλβίδας? Άλλαξε κάτι στο gradient της μητροειδούς, επιδεινώθηκε ή στην ανεπάρκεια της μητροειδούς?
Όχι, η ανεπάρκεια εδώ έχω 2 μήνες μετά την τοποθέτηση της βαλβίδος της αορτικής. Η ανεπάρκεια της τριγλώγινας παρέμεινε ίδια, ίσως να επιδεινώθηκε και λιγάκι. Η μητροειδική βαλβίδα είναι αυτή. Η ανεπάρκεια παραμένει ίδια, τα gradients δεν άλλαξαν, αλλά η δεξιά καρδιακή ανεπάρκεια παρέμεινε ως ήταν και είχε και μια μικρή επιδείνωση, οπότε συνάδει αυτό με τη μικρή βιβλιογραφία που έχουμε, την πτωχή βιβλιογραφία, ότι μάλλον η ανεπάρκεια της τριγλώγινος καθορίζει και την πρόγνωση, και το πλάνο ήταν να κάνουμε μια επαναξιολόγηση για να δούμε αν μπορέσουμε να κάνουμε χειρουργείο, υβριδικό χειρουργείο, Transcatheter για τη μητροειδή και ένα δακτύλιο στην τριγλώγινη. Ευχαριστώ πολύ.
Νεκτάριο, πολύ ωραία. Τι συνέβη με τη μητροειδή βαλβίδα μετά από αυτή τη βαθία τοποθέτηση αυτής της βαλβίδας? Άλλαξε κάτι στο gradient της μητροειδούς, επιδεινώθηκε ή στην ανεπάρκεια της μητροειδούς?
Όχι, η ανεπάρκεια εδώ έχω 2 μήνες μετά την τοποθέτηση της βαλβίδος της αορτικής.
Τέλεια. Η μόνη μου ανησυχία σε αυτές τις περιπτώσεις είναι εάν θα μπει βαθιά μία self-expanding βαλβίδα και επηρεάσει την πρόσθετη εγλωχία της μητροειδούς με αποτέλεσμα να επιδεινώσει τη στένωση και την ανεπάρκεια, κάτι που το έχουμε δει να συμβαίνει. Προφανώς όμως εδώ ίσως το radial force αυτής της βαλβίδος ή όπως τακτοποιήθηκε εκεί δεν ενόχλησε. Γιατί φαίνεται ότι η πρόσθετη εγλωχία κινείται ελεύθερα. Δηλαδή έχει μείνει αρκετά ψηλά το frame, μακριά από το tip που έχει την κίνηση.
Δεν ξέρω μήπως ο κύριος Μιχάλης, ο καθηγητής, έχει κάποιο σχόλιο, έχει μια σχετική...
Όχι, αυτό είναι ένα δύσκολο πράγμα. Γιατί ο συνδυασμός της... όχι όσον αφορά την Abductor, νομίζω ότι έκανε μια καταπληκτική τοποθέτηση ο κύριος Πιλάτης, ακολουθώντας πολύ προσεκτικά τα βήματα και νομίζω ότι πρέπει κάποιος να τον συγχαρεί, διότι ήταν ένα δύσκολο πραγματικά περιστατικό, το οποίο νομίζω ότι ήταν και σε οξύτο αιμονικό είδημα με το που μπήκε και στο αιμοδυναμικό εργαστήριο, αν κατάλαβα καλά. Και ήταν πραγματικά ένα δύσκολο και για τους αναισθησιολόγους ο τρόπος που το χειρίστηκαν και ήταν φοβερός ο τρόπος που αυτή η γυναίκα απεξαρτήθηκε από αυτό το οξύτο αιμονικό είδημα και φαίνεται ότι πράγματι η επιτυχής επίλυση της στένωσης της αορτής τουλάχιστον βραχυπρόθεσμα έδωσε τη λύση. Πάντα εμένα με προβληματίζει η μεικτή στένωση της μητροειδούς μαζί με τη στένωση της αορτής, με προβληματίζει πάρα πολύ, διότι ιδιαίτερα αν και η κοιλία είναι υπερτροφική και μικρή, που συνήθως είναι μικρή, διότι τότε μπορεί να μπλέξεις και ειδικά να σου κάνει ενδοκινοτικά gradient, αλλά νομίζω ότι εδώ το αποτέλεσμα ήταν πάρα πολύ καλό. Συγχαρητήρια στον κύριο Πιλάτη για την πραγματική του έτσι πολύ καλή τοποθέτηση της βαλβίδας.
Ευχαριστώ πολύ.
Συγχαρητήρια.
Θα κάνουμε μια αλλαγή τώρα λόγω ενός προβλήματος που έχει ο καθηγητής, ο κ. Τζιακάς. Και θα προηγηθεί, θα ζητήσω συγγνώμη λίγο από τον κύριο Ραμπατζή, απλώς υπάρχει ένα πρόβλημα για να προλάβει την πτήση του.
Κύριε Ραμπατζή, θα είμαι πολύ σύντομος ως beginner. Καταρχήν, ευχαριστώ πάρα πολύ τον Πρόεδρο, ο οποίος με προέτρεψε να παρουσιάσω το περιστατικό. Δεν έχω ακόμα ξεκινήσει να μαθαίνω από τα λάθη μου, αγαπητέ Δημήτρη. Τζιακάς είναι το όνομα της διαφάνειας, παρακαλώ. Ναι, λόγω της αλλαγής, με συγχωρείτε. Καταρχήν, το περιστατικό αυτό που θα σας παρουσιάσω δεν είναι τόσο spectacular, ούτε τόσο challenging όπως δείξαν οι προηγούμενοι συνάδελφοι και θα δείξουν και στο... Και παρόλα αυτά, κάτι μαθαίνεις από, ειδικά άμα είσαι, αν και έχω κλείσει 20 χρόνια στο αιμοδυναμικό, ενασχόλησή μου με το TAVI είναι τους τελευταίους 9 μήνες. Αν θέλαμε να βάλουμε και κάποιο τίτλο, θα έλεγε κάποιος ότι τα πράγματα καμιά φορά δεν είναι όπως φαίνονται, αλλά δεν είναι ούτε καν όπως λέγονται. Πηγαίνοντας σύντομα στην παρουσίαση του περιστατικού, πρόκειται για μια γυναίκα 80 ετών, η οποία έχει ένα κανονικό BMI, ένα BSI κανονικό και έχει μια εκφυλιστική σοβαρή στένωση της αορτικής τρίπτυχης αορτικής βαλβίδος. Η λειτουργική της κατάσταση κατά νύχτα ήταν 3 με 4 και είχε και λίγο στιθάγχη. Τα υπόλοιπα δημογραφικά της στοιχεία είναι από σχεδόν δεκαετία που είχαμε βάλει ένα στέντ που είχε βατότητα κανονική, διαβήτη, δυσλιπιδεμία, αρτηριακή υπέρταση, μια θηροειδοπάθεια και μια μέτρια πνευμονική υπέρταση, μια καροτιδική νόσο, μέτρια επίσης και ένα κανονικό GFR για την ηλικία της. Το STS score ήταν 4,7 και το Euroscore 6,68. Δεν υπάρχει motion κίνηση στο βίντεο, απλώς στον υπέρηχο. Ο υπέρηχος έδινε την εντύπωση ότι πρόκειται για μια τρίπτυχη κανονική επασβεστομένη αορτική βαλβίδα με μια ταχύτητα που έφτανε τα 4,2 και ένα AVA index στο 0,4 τετραγωνικά εκατοστά τετραγωνικό μέτρο. Εδώ επίσης το ίδιο. Στην αξονική. Η αξονική είχε στο STJ ένα average γύρω στο 25 χιλιοστά. Στους κόλπους του Βαλσάλβα από 25 έως 29 ανάλογα τη διάμετρο. Και ο δακτύλιος η αίρια του δακτυλίου ήταν στα 379 χιλιοστά. Το LVOT ήταν λίγο πολύ το ίδιο. Η αορτή είχε μια οριζόντια φορά, ήταν στις 71 μοίρες, με καλά ύψη και για το στέλεχος και για τη δεξιά και για το STJ. Το λαγονομοιραίο σύστημα είτε αριστερά είτε δεξιά είχε ένα ικανοποιητικό κάλιβερ, οπότε δεν υπήρχε πρόβλημα. Αποφασίσαμε την εμφύτευση μιας Sapient 3 Και με βάση την έρευνα που σας έδειξα στην αξονική, καταλήξαμε να τοποθετήσουμε να βάλουμε μια 23 βαλβίδα στην ασθενή αυτή. Η παρακέντηση στο ύψος της κοινής μυρίας δεν είχε κανένα πρόβλημα. Η αορτογραφία, όπως τη βλέπετε εδώ. Εκείνο που δεν φαίνεται, αλλά φαίνεται το επόμενο στάδιο, είναι ότι δυσκολευτήκαμε πάρα πολύ να περάσουμε το σύρμα. Εφόσον περάσαμε το σύρμα, το οποίο είχε αυτή την οξία γωνία που έχει το pigtail, αναρωτηθήκαμε εκ των υστέρων, εγώ εκ των προτέρων ο κ. Σπάργιας, ο οποίος είπε εξ αρχής ότι κάτι συμβαίνει με αυτή τη βαλβίδα, παρόλο που θεωρούμε ότι είναι τρίπτυχη, ίσως δεν είναι ακριβώς έτσι. Η πορεία κατά τη διάρκεια της επέμβασης επιβεβαίωσε αυτό το πράγμα. Βλέπετε το σύρμα, ακόμη και για ποιο λόγο. Όταν έγινε η προδιάταση με τον μπαλόνι είναι 20 χιλιοστά διάμετρο, αλλά ήταν στα 15 ml. Αποφασίσαμε να μειώσουμε κατά ένα τουλάχιστον ml, όπως το ίδιο κάναμε και με την 23 βαλβίδα. Αντί να χρησιμοποιήσουμε την nominal διάταση, αντί για τα 17 πήγαμε στα 16 ml. Εκείνο που παρατηρεί κάποιος είναι ότι κατά τη διάρκεια της διάνοιξης αλλά και στην ώρα της αορτογραφίας κάτι άλλο θα σας δείξω. Παρ' όλα αυτά, κατά τη διάρκεια όταν εκτύχθηκε πλέον η βαλβίδα, ότι η έκπτυξή της ήταν έκεντρη, με την έννοια ότι δεν ήταν ακριβώς αυτό που θέλαμε. Δηλαδή, με άλλα λόγια, το σύρμα κατά τη διάρκεια της διέλευσής του δεν είχε την πορεία αυτή μεταξύ του non-coronary και του right cuspid, αλλά ήταν κάπως διαφορετικά. Δηλαδή, με άλλα λόγια, συμπεριφέρθηκε και μετά την προδιάταση. Βλέπετε εδώ δεν υπάρχει μάλλον δεν κάναμε μεταδιάταση, το αφήσαμε έτσι, φοβούμενοι, μάλλον ήμασταν σίγουροι πλέον ότι δεν πρόκειται για μια τρίπτυχη βαλβίδα, αλλά μια λειτουργικά δίπτυχη βαλβίδα, η οποία συναντάται σε ένα ποσοστό στο 1/5 των οκτατζενάριων, των ασθενών, οι οποίοι είναι πάνω από πάνω από 80 έτη ασθενείς. Η ετερόπλευρη δισκιαγράφηση με το ProGlide κτλ. Δεν απέδειξε κανένα πρόβλημα. Και στο τέλος άφησα αυτό για να σας δείξω ακριβώς αυτή την εικόνα, όπου η non-coronary μαζί με τη right συνενώνονται, ενώ η αριστερή, το αριστερό cuspid είναι πιο ελεύθερο. Σας ευχαριστώ.
Δεν ακούγεσαι, Κώστα, μίλα στο μικρόφωνο.
Το scroll up και το scroll down που πρέπει να κάνουμε, και αυτό που είπες, Λάμπρο, το πρωί, ότι μην κάνεις στάβη αν δεν μάθεις από πριν να διαβάζεις την αξονική μόνος σου. Φαίνεται λοιπόν εκεί ότι ήταν μια δίπτυχη αυτή η βαλβίδα και συμπεριφέρθηκε έτσι, το είδαμε στην πράξη.
Ήταν τρίπτυχη, συμπεριφέρθηκε ως δίπτυχη. Τέλος πάντων, δίπτυχη στο τέλος.
Ευχαριστούμε πολύ, Δημήτρη, και θα ζητήσουμε συγγνώμη από τον Άκη τον Ραμπατζή, που είναι τώρα στο πόντιουμ. Άκη, είσαι μαζί μας?
Άκη, κάνε unmute.
Καλησπέρα. Δεν σε ακούμε, πρέπει να ανοίξεις το μικρόφωνο σου.
Ναι, οκ, συγγνώμη, καλησπέρα. Μ' ακούτε τώρα?
Τώρα, Άκη, κάνε mute. Χαμήλωσέ το λίγο.
Οκ. Λοιπόν, μ' ακούτε?
Πολύ καλά.
Ωραία. Απλά επειδή νόμιζα το έκανε το control, λοιπόν, καλησπέρα σε όλους τους αγαπητούς συναδέλφους και πάρα πολλούς φίλους. Θα ξεκινήσω με το πρώτο περιστατικό. Είναι μια γυναίκα 77 χρονών με μια μάγνια βαλβίδα μικρή, 19 χιλιοστών, που έχει τοποθετηθεί το 2013 και με μια έσωμαστική στον πρόσθετο κατέοντα κλάδο. Εκφυλισμένη βιοπροσθετική βαλβίδα, λοιπόν, με πάρα πολύ ψηλή ταχύτητα, όπως βλέπετε, και άλλα χαρακτηριστικά. Έχει μια σοβαρή πνευμονική υπέρταση με μια υπολογισμένη πίεση γύρω στα 95, με 3 βαθμούς στένωση μητροειδούς και χρόνια κολπική μαρμαριγή. Όπως ήταν αναμενόμενο, οι μετρήσεις, η γιαγιά, να σας πω, είχε ύψος 1,57 και γύρω στα 52 κιλά βάρος, στενό άνιουλους, η περίμετρος, στενό LVOT. Και το άλλο πρόβλημα που είχε ήταν ότι τα πόδια της ήταν μικρής διαμέτρου, είχε αρκετό ασβέστιο, κυρίως στο διχασμό των αλαγωνιών πριν την κοιλιακή αορτή, επιλέξαμε να πάμε από την δεξιά μυριαία αρτηρία, γιατί μας φάνηκε με λιγότερο ασβέστιο. Όπως βλέπετε και εδώ, αρκετά μεγάλη ποσότητα ασβεστίου, σε κάποιες περιπτώσεις 270 μοίρες. Με το application, λοιπόν, οι βαλβίδες ήταν η S3 βαλβίδα και η Evolut. Εκείνο που ξέχασα να σας πω λόγω του χρόνου, δυστυχώς, είναι ότι τα στεφανιαία της Αγγεία, το στέλεχος, το αριστερό σύστημα ήταν 8,8 εκατοστά από τη ρίζα και η δεξιά στεφανιαία αρτηρία στα 5,8 χιλιοστά. Είχε βέβαια την έσωμαστική, αλλά η επιλογή μας για αυτή την ασθενή ήταν μια Sapien βαλβίδα, η S320. Μπορείτε να εκτιμήσετε εδώ αγγιογραφικά τις εικόνες της ασθενούς. Είχαμε αγγιοχειρουργό στην αίθουσα των φίλων του Κώστα τον Παπάζογλου. Λοιπόν, βλέπετε λοιπόν η παρακέντηση έγινε χωρίς προβλήματα, τοποθετήθηκαν 2 ProGlide. Το πρώτο πρόβλημα στο να αναβάσουμε το SIF ήταν εκείνη η καμπή που βλέπετε και που κάναμε μια διαστολή με μπαλόνι. Όπως βλέπετε στην άλλη προβολή δεν περνούσε ούτε το θικάρι από στην αορτή, οπότε μετά από μια επιτυχή διαστολή πέρασε το θικάρι. Εδώ λοιπόν με ένα σαφάρι εξές στην αριστερά κοιλιά βλέπετε την τοποθέτηση την θέση εμφύτευσης της βαλβίδας. Βάλαμε 2 ml περισσότερο. Αυτή είναι λοιπόν η εμφύτευση, χωρίς ιδιαίτερα προβλήματα. Αυτό είναι το αποτέλεσμα μετά την εμφύτευση, ένα αποδεκτό νομίζω αποτέλεσμα. Και τα πόδια χωρίς ιδιαίτερα προβλήματα. Εδώ είδα να χαιρετήσω και την κυρία Ζάχου που είναι στο ακροατήριο. Πήραμε φωτογραφίες στα θικάρια και βλέπετε το θικάρι που πέρασε την αορτή, το ότι καταστράφηκε από το ασβέστη. Είχε σκιστεί το θικάρι το 14 French. Σε ένα χρόνο, όπως είναι αναμενόμενο, αυτοί οι ασθενείς έχουν ένα μέσο gradient λίγο παραπάνω από τους υπόλοιπους. Είχε ένα μέσο gradient 19, είναι ασυμπτωματική με 17 μέσο gradient και η πίεση στην πνευμονική είναι γύρω στο 60 με την κατάλληλη διούρηση. Το δεύτερο περιστατικό είναι ένας άντρας 80 ετών με πάλι μια μάγνα βαλβίδα σχετικά μικρή, 21 το 2010, πολύ ψηλό gradient γι' αυτός και μια υφολική απόφραξη της δεξιάς στεφανιαίας αρτηρίας. Με το application εδώ επιλέξαμε να βάλουμε βαλβίδα πόρτικο. Βλέπετε εδώ τις κλασικές μετρήσεις της αγγιογραφίας. Καλά ύψη είχαμε στις στεφανιαίες αρτηρίες. Έχει αρκετό ασβέστη στο αγγεία αλλά μπορούσε να κάνει accommodation το SIF γιατί είναι αρκετά μεγάλης διαμέτρου, όπως βλέπετε τα λαγόνια. Η μόνη διαφορά σε αυτόν ήταν ότι αριστερά ο διχασμός στην αριστερή λαγόνιο ήταν ψηλά το bifurcation, οπότε δεν μπορούσαμε να παρακεντήσουμε. Και το σημείο παρακέντησης στη δεξιά είχε πάρα πολύ ασβέστιο, οπότε αποφασίσαμε να κάνουμε πάλι με αγγιοχειρουργό με cut down αυτή την επέμβαση. Στο ίδιο session έγινε αγκιοπλαστική στη δεξιά στεφανιαία αρτηρία, που ήταν και σχετικά δύσκολη θα έλεγα. Λοιπόν, και εδώ βλέπετε μια σχετικά οριζόντια θέση της αορτής. Στην αρχή η βαλβίδα, βλέπετε το βάθος εμφύτευσης είναι λίγο χαμηλό. Στη δεύτερη μας προσπάθεια το βάθος εμφύτευσης είναι μάλλον ψηλό. Και στην τρίτη προσπάθεια φαίνεται ότι είναι σε κατάλληλο σημείο. Με την απελευθέρωση της βαλβίδας λίγο μετακινήθηκε προς low μεριά και αν δείτε στο still image που σας έχω δίπλα, νομίζω είμαστε γύρω στα 5,5 με 6 χιλιοστά, δηλαδή ουσιαστικά 1 χιλιοστό παραπάνω από, από την προβλεπόμενη θέση. Εδώ ένα αυξημένο gradient και εδώ, έχει περάσει όμως πάνω από ένας χρόνος από τον ασθενή, είναι τελείως ασυμπτωματικός, έχει ελάχιστη παραβαλβιδική διαφυγή και ένα μέσο gradient που είναι γύρω στο 24. Θα ήθελα λοιπόν να σας ευχαριστήσω και να πω ότι στις valve είναι λίγο πιο τεχνικά απαιτητικές και θα πρέπει να επιλέγουμε μάλλον supra-angular βαλβίδες γιατί έχουν καλύτερα gradient και δεν θα πρέπει να έχουμε πολύ παραπέρα τους αγγιοχειρουργούς γιατί μπορεί να διευκολύνουν πάρα πολύ την επέμβαση που αν ξεκινούσαμε με μια τακτική καθαρά διαδρομική μπορεί να είχαμε σταματήσει την επέμβαση λόγω χειρουργικών επιπλοκών από τα αγγεία. Ευχαριστώ πολύ.
Πολύ ενδιαφέροντα περιστατικά, κύριε Ραμπατζή. Θα ήθελα να ρωτήσω, δεν έχω εμπειρία, δεν ξέρω ο Κώστας αν έχει, ή ο κύριος Μιχάλης, από valve με πόρτικο. Δεν πρέπει να κάνουμε προδιαστολή πριν. Θα κάνατε μάλλον προδιαστολή, θα την προτιμήσουμε. Γιατί ήταν στένωση.
Προδιαστολή όχι. Μεταδιαστολή μπορεί. Η προδιαστολή ποτέ σε βιοπροσθετικές βαλβίδες, γιατί μπορεί να κάνουν οξύ ανεπάρκεια και την κάνουν συχνά. Έχουμε μαζί μας και τον κύριο Μπαϊκούση ή κάνω λάθος? Νίκο, είσαι μαζί μας? Ο κύριος Μπαϊκούσης είναι μαζί μας? Όχι.
Πού ήταν κάποια στιγμή? Εγώ ένα σχόλιο θα ήθελα να κάνω. Εντάξει, τώρα όσον αφορά το πόρτικο valve δεν έχει CE mark, εγώ το αποφεύγω να τη βάζω. Διότι προτιμώ να βάζω υλικά τα οποία είναι εγκεκριμένα και για νομικούς λόγους, πέρα από το αν πιστεύω ότι θα λειτουργήσει ή όχι. Το δεύτερο που θέλω να πω είναι, αυτό είναι άσχετο με το περιστατικό αυτό, αλλά με τα valve έχω δει πολλές φορές οι χειρουργοί να έχουν μπερδέψει λίγο τα νούμερα των βαλβίδων τα οποία που έχουν τοποθετήσει. Γι' αυτό μην πολύ στηρίζεστε στο ότι γράφουν τα χειρουργικά χαρτιά, ότι έχει 23, έχει 25. Κάντε μόνοι σας τις μετρήσεις για να δείτε τι πραγματικά βαλβίδα είναι και τι βαλβίδα θα βάλετε μετά στη συνέχεια με βάση τα applications τα οποία υπάρχουν. Έχω δει πολλά τέτοια λάθη, όσο και αν φαίνονται περίεργα. Αυτό ήθελα να πω. Κατά τα άλλα, Άκη, νομίζω ότι ήταν εξαιρετική τοποθέτηση. Η οριζόντια βαλβίδα, έτσι όπως τοποθέτησες πραγματικά masterpiece. Ήταν δύσκολη βαλβίδα. Η τοποθέτηση, πάντα οι βάλβοι είναι δύσκολες και στο crossing και σε όλα. Σίγουρα δεν κάνουμε προδιαστολή. Μεταδιαστολή πάντα κάνουμε. Εγώ κάνω σχεδόν σε όλες μεταδιαστολή και νομίζω ότι είναι πάρα πολύ χρήσιμο. Είναι πολύ σημαντικό αυτό το... Βέβαια, επίσης να σου πω ότι η εικόνα την οποία βλέπεις αγγιογραφικά σε ξεγελάει για το ύψος και από το που βγαίνει. Δεν είναι και μόνο αξονική τομογραφία μπορεί να δεις πόση απόσταση έχει από το άνιουλους η έκφυση των στεφαναίων. Και επίσης βέβαια αυτό το οποίο είναι σημαντικό όσον αφορά την απόφραξη, όσο όχι όσον αφορά τη μελλοντική προσπέλαση, για τη μελλοντική προσπέλαση είναι σημαντικό του ύψους. Για την πιθανή απόφραξη είναι να μετρήσεις το πώς είναι η απόσταση αυτού του υποτιθέμενου δαχτυλίου της βαλβίδας από τα στεφανιά και να μετρήσεις την απόσταση η οποία πρέπει να είναι πάνω από 4 χιλιοστά, όπως λέμε, και αν πας για το ST junction και αυτό να είναι πάλι λίγο πάνω από 2,5 χιλιοστά, για να μπορέσει να περνάει το αίμα. Βέβαια, όσον αφορά την πρόσβαση στη μελλοντική, είναι πολύ σημαντικό και αυτό το καταλαβαίνουμε, γιατί μετά πρέπει να μπει πίσω από τα leaflet, πρέπει να μπει ανάμεσα και θα είναι μια περίεργη φορά η πρόσβαση των στεφαναίων σε μελλοντική περίπτωση που χρειάζεται να τα ξαναεπισκεφθούμε.
Μπορώ να κάνω μια ερώτηση εγώ?
Ναι.
Ήθελα να ρωτήσω τους έμπειρους εκεί συναδέλφους σε ποιες περιπτώσεις αποφασίζουν να κάνουν balloon valve fracture, να κάνουν σπάσιμο της βαλβίδας στη τεχνική αυτή.
Εγώ θα σας απαντήσω που δεν είμαι έμπειρος και μετά θα απαντήσω πώς θα σου είναι έμπειρος, γιατί εγώ δεν το έχω κάνει ποτέ. Το πρώτο πράγμα είναι πρέπει να δεις το app και να δεις αν αυτό σπάει ή όχι. Υπάρχουν βαλβίδες οι οποίες σπάνε πιο εύκολα και βαλβίδες οι οποίες είναι εξαιρετικά απίθανο να σπάσουν. Και το δεύτερο είναι ότι όταν έχεις μια μικρή βαλβίδα, η οποία προφανώς τη φαντάζεσαι και μάλιστα και με το CT βλέπεις ότι μάλλον θα μπορούσε να είναι και κάπως μεγαλύτερη και η οποία θα έχεις μεγάλη πιθανότητα εκφύλισης της νέας βαλβίδας την οποία θα βάλεις μέσα στην παλιά βαλβίδα. Όταν δηλαδή πας για πολύ μικρά νούμερα, τότε καλό είναι να κάνεις valve fracture. Για μένα βέβαια να ξέρεις ότι το σημαντικό είναι ότι η νόσος της αορτής είναι ένα ταξίδι μέσα στον χρόνο, το οποίο αρχίζει και σχεδιάζεται από την πρώτη επέμβαση. Γιατί ανάλογα με το πόσο χρόνο είναι ο άρρωστος, οι βαλβίδες κρατάνε συγκεκριμένο χρονικό διάστημα και πρέπει να έχεις σχεδιάσει όλα σου τα βήματα. Και αν μιλάμε για έναν νέον άνθρωπο, νομίζω ότι δεν μιλάμε για τη δικιά σου ηλικιωμένη κυρία, η οποία φαντάζομαι ότι η βαλβίδα της θα επιζήσει περισσότερο από αυτή, αλλά είναι πολύ πιθανό. Αλλά ειδικά για νέους ανθρώπους, πιθανώς και η δεύτερη βαλβίδα να είναι χειρουργική τοποθέτηση για να πάμε στην τρίτη βαλβίδα, η οποία θα είναι το τάβι. Αυτή είναι η προσωπική μου άποψη. Αλλά, εν πάση περιπτώσει, εξαρτάται και από το περιβάλλον που ζει, την ικανότητα των χειρουργών, ποιος θα το κάνει, τι θα κάνει και το καθεξής. Αυτά από μέρους. Ο κ. Σπάριας νομίζω έχει πολύ μεγαλύτερη εμπειρία και πιθανώς να έχει σπάσει αρκετές.
Συμφωνώ απόλυτα σε όσα είπε ο κ. Μιχάλης. Πρώτα απ' όλα να σπάει η βαλβίδα. Για παράδειγμα, η τριφέκτα και η Hancock είναι αυτές που δεν σπάνε, όλες οι άλλες πάνε. Και από εκεί και πέρα να θες οπωσδήποτε να έχεις ένα καλύτερο αποτέλεσμα. Αν τελειώσεις, αν ξεκινήσεις με μία ταχύτητα 4 και ένα mean gradient 40 και βάλεις τη βαλβίδα σου και είσαι με μία ταχύτητα 3,5 και ένα mean gradient 35, προφανώς δεν έχεις επιτελέσει το έργο σου, θα πρέπει να το βελτιώσεις. Και τότε θα κάνεις fracture, σίγουρα. Νομίζω ότι πρέπει να προχωρήσουμε.
Και πάντα το fracture μετά την τοποθέτηση της βαλβίδας.
Όχι απαραίτητα.
Νομίζω ότι
περιγράφεται και πριν, δεν ξέρω τι είναι καλύτερο.
Νομίζω ότι πρέπει
δεν ξέρω και πόσο μεγαλώνουν οι βαλβίδες άμα τις βάλεις μετά, πόσο μπορεί να μεγαλώσει και αυτή που βάλεις.
Νομίζω ότι πρέπει να προχωρήσουμε, γιατί σίγουρα θα έχουμε κι άλλο valve και θα συζητήσουμε το fracture εκεί. Ο κύριος Δάρδας, αν δεν κάνω λάθος, Πέτρος, είσαι μαζί μας, ακούμε.
Ευχαριστώ πάρα πολύ για μια ακόμα φορά και τον Κώστα και όλη την Οργανωτική Επιτροπή. Θα μιλήσουμε για αορτοπάθεια και καρδιογενές σοκ. Και εάν θα πρέπει να αρχίσουμε να σκεφτόμαστε για τάβη διάσωσης, όπως έχουμε την εγκυκλαστική διάσωση. Ξέρουμε ότι η φυσική ιστορία της αορτοπάθειας μπορεί να κρατήσει για χρόνια, αλλά όταν αρχίσει να δίνει συμπτώματα, τότε τα συμπτώματα αυτά μπορεί να εξελιχθούν πάρα πολύ γρήγορα. Θα δείξουμε 2 τέτοια περιστατικά, όπου πραγματικά μπροστά στα μάτια μας είχαμε μια ταχύτατη εξέλιξη της αορτοπάθειας. Το πρώτο περιστατικό είναι μια γυναίκα 78 χρονών, η οποία είχε κάνει χημειοθεραπεία και ακτινοβολία πριν από 38 χρόνια για λέμφωμα. Πριν από 3 χρόνια είχε ξανακάνει χημειοθεραπεία για όγκο μαστού, υπερλιπιδεμική με βαριά στένωση της αορτικής βαλβίδας, χωρίς όμως ιδιαίτερα συμπτώματα, πέρα από κάποια ελαφρά δύσπνοια τους τελευταίους μήνες. Όταν την αξιολογήσαμε, είχε ένα κλάσμα 50% με ένα max gradient 95, ένα valve area 0,29, είχε και αυτή MAC με μέτρια ανεπάρκεια της μητροειδούς, μια ήπια αστεφανία νόσο και μια προσελανοειδή αορτή. Βλέπετε εδώ πέρα το διαφορακικό υπερηχογράφημα που κάνουμε στην ασθενή, μια πολύ βαριά και επεσβεστομένη στένωση της αορτικής βαλβίδας, MAC με καλή διάνοιξη και με τουλάχιστον μετρίου βαθμού ανεπάρκεια. Την κάναμε και ένα δυσοφάγιο για να εκτιμήσουμε καλύτερα τη βαλβιδοπάθεια της μητροειδούς. Φαίνεται η ανεπάρκεια της μητροειδούς, φαίνεται και η βαλβίδα της αορτής, η οποία είναι έντονα επασβεστομένη και υποκινητική. Και βλέπετε εδώ τρισδιάστατα την ανεπάρκεια της μητροειδούς. 3 μέρες μετά την εκτίμηση για τάβη, και ενώ η ασθενής δεν είχε ιδιαίτερα συμπτώματα, ανέφερε ότι τις τελευταίες 2 μέρες στεναχωρέθηκε από κάτι, μπαίνει το μεσημέρι, το απόγευμα, με οξύπνιο γονικό είδημα στο νοσοκομείο και με υπερτασική κρίση. Μέσα σε 1 ώρα και μπροστά στα μάτια μας, μέχρι το βράδυ, είχε αναπτύξει πλήρες καρδιογενές σοκ, με μια πίεση γύρω στο 7 και με ένα υπέρηχο που φαινόταν ένα κλάσμα της οφύσεως με το ζόρι 20%, βαρύτατη ανεπάρκεια της μητροειδούς. Η ασθενής μπαίνει σε full ινότροπη υποστήριξη, συνεννοούμαστε και μέσα σε λιγότερο από 1 ώρα τη μεταφέρουμε στο εργαστήριο για τάβη διάσωσης. Αυτό έγινε 1 η ώρα το βράδυ. Και βλέπετε εδώ την διασωληνώθηκε ασθενής. Το δυσοφάγιο δείχνει μια dying heart, μια καρδιά η οποία πεθαίνει. Και μια αορτική βαλβίδα η οποία με το ζόρι άνοιγε. Γίνεται μια αρχική αγγιογραφία για να δούμε πού βρισκόμαστε, και επειδή οι συνθήκες ήταν πάρα πολύ επίγουσες, αποφασίσαμε να κάνουμε direct τάβη. Παρ' όλα αυτά η βαλβίδα δεν άνοιγε. Κάνουμε λοιπόν ένα μπαλόνι, 20 μπαλόνι. Μετά από το μπαλόνι έγινε αυτό που φοβηθήκαμε, η γυναίκα έκανε VF arrest, χρειάστηκε να την ανατάξουμε ηλεκτρικά. Τοποθετήσαμε πολύ γρήγορα την βαλβίδα, η οποία άνοιξε με ένα λόγο ικανοποιητικά. Παρ' όλα αυτά, μετά την τοποθέτηση, η οποία λόγω του γρήγορου της επέμβασης έγινε σχετικά ψηλά, μάλλον ήρθε προς τα πάνω η βαλβίδα και είχε σοβαρή ανεπάρκεια στην αορτική, οπότε αναγκαστήκαμε, κάναμε ένα δεύτερο μπαλόνι, 20 διάρι. και με το που έγινε αυτό βλέπουμε ότι μολονότι είχαμε ψηλή εμφύτευση, δεν έχουμε σχεδόν καθόλου ανεπάρκεια και καθόλου gradient. Έχουμε άμεση βελτίωση της αιμοδυναμικής εικόνας, με πολύ καλή διάνοιξη της βαλβίδας, με βελτίωση της ανεπάρκειας μητροειδούς, με βελτίωση του κλάσματος εξώθησης. Μέσα σε μία ώρα σταμάτησαν και τα ενότροπα και βλέπετε εδώ την εικόνα από το δυσοφάγιο που ήδη είχαμε, με ένα gradient γύρω στο 4 με 5. Βλέπετε την εικόνα στο υπερηχογράφημα 4 μέρες μετά την εμφύτευση, λίγο πριν φύγει ασθενής, με ένα mean gradient 3,5 και με αποκατάσταση της λειτουργικότητας της αριστερής κοιλίας. Ένα χρόνο μετά είναι πάρα πολύ καλά. Το δεύτερο περιστατικό είναι ένας ασθενής ο οποίος είχε βάλει μια τραϊφέκτα βαλβίδα πριν από 2 χρόνια. Αυτό έγινε το περιστατικό το 2018. Το 2016 είχε βάλει μια τραϊφέκτα βαλβίδα και ένα αλφιέρι stitch λόγω ανεπάρκειας μητροειδούς. Έρχεται σε εμάς με ένα ιστορικό περίπου 8 μέρες μια αυξανόμενη δύσπνοια. Όταν ήρθε σε εμάς η οξύπνο είδημα και πολύ γρήγορα ανέπτυξε καρδιογενές σοκ, καρδιακή ανακοπή, VF-arrest, χρειάστηκε να τον σοκάρουμε με full αιμοδυναμική υποστήριξη, full ενότροπα, μια πίεση 90 με 30 και βλέπετε εδώ πέρα το διαθωρακικό δείχνει μια βαριά ανεπάρκεια στην τραϊφέκτα βαλβίδα, ενώ η μητροειδής, το αλφιέρι stitch λειτουργεί καλά. Και αυτός ο ασθενής μεταφέρθηκε επειγόντως στο κηλικείο, στο Cath Lab, αφού διασωληνώθηκε, έγινε το δυσοφάγιο περιτογράφημα, όπου φαίνεται και ο λόγος της οξείας ανεπάρκειας της βαλβίδας τραϊφέκτα. Αν το δείτε εδώ, φαίνεται η βαριά ανεπάρκεια και εδώ φαίνεται ότι έχει αποκοπεί η μία γλωχίνα, συγκεκριμένα η δεξιά στεφανία γλωχίνα της τραϊφέκτα, έχει σπάσει. Οπότε γίνεται η άμεση εμφύτευση μιας βαλβίδας Evolut Pro, 26 χιλιοστών, με μια συστολική πίεση 40 την ώρα της εμφύτευσης. Και με το που άνοιξε η βαλβίδα, η πίεση αμέσως ανέβηκε στο 150. Και βλέπετε εδώ, πριν από την τοποθέτηση, είχαμε 90 με 30 πίεση με full ενότροπη υποστήριξη. Η πίεση αυτή έπεσε στο 40 και αμέσως μετά ανέβηκε στο 150. Και βλέπετε εδώ το δυσοφάγιο με πλήρη αποκατάσταση. Έτσι, συμπερασματικά, η φυσική ιστορία της αορτοπάθειας μπορεί μερικές φορές να μας προλάβει και οι ασθενείς μπορεί να αναπτύξουν πολύ γρήγορα καρδιογενές σοκ, οπότε ίσως μια στρατηγική τάβη διάσωσης θα πρέπει να είναι μέσα στη φαρέτρα κάθε επεμβατικού καρδιολόγου που ασχολείται με structural disease. Σας ευχαριστώ πολύ.
Συγχαρητήρια, Πέτρο. Φαίνεται ότι οι ασθενείς στον Άγιο Λουκά έχουν πραγματικά υψηλή άγια προστασία, γιατί όταν μπορούν αυτά τα περιστατικά να βγουν όπως μας εντυπωσίασες και να πάνε καλά, πραγματικά μπαίνει μια ανώτερη δύναμη εκεί και βοηθάει. Ευχαριστούμε πολύ. Δεν ξέρω αν υπάρχει κάποιο σχόλιο.
Αυτό ισχύει που λες πάντα.
Φυσικά. Οπότε ήρθε η ώρα ο συμπροεδρεύων κ. Κατσιμακλής να συνεχίσει με το δικό του περιστατικό. Γιώργο, σε ακούμε. Συγγνώμη. Ο κύριος Τσικαδέρης ή εσύ παρουσίασες και τα δύο περιστατικά, σωστά? Είσαι mute.
Ναι, είναι ο κύριος Τσικαδέρης.
Είναι και ο κύριος Τσικαδέρης.
Ναι, έχω
δεν τον είδα, συγγνώμη. Δημήτρη, δεν σε είδα.
Ναι.
Αποκρύφτηκες. Προχωράμε με τον κύριο Τσικαδέρη, επομένως.
Ο Άγιος συνεχίζεται.
Ναι. Λοιπόν, το περιστατικό το δικό μου είναι για έναν ασθενή 81 ετών.
Κάνε λίγο share screen with us, please.
Το κάνει.
Δημήτρη, πρέπει να κάνεις το full screen share. Εντάξει.
Ναι. 81 ετών, ο οποίος παρουσιάστηκε νύχα 4 ξαφνικά.
Δημήτρη, πάμε το λιγάκι σε παρουσίαση προβολής.
Και μέσα σε 3 μήνες είχε μια ξαφνική επιδείνωση. Δεν είχε προηγούμενο ιστορικό. Και εδώ βλέπουμε την εκτίμηση στην αξονική. Βλέπουμε ότι έχει μεγάλες διαστάσεις, με σχετικά καλά αγγεία στα πόδια, λίγο στενά και από τις δύο πλευρές. Στην αξονική βλέπουμε ότι η κατανομή του ασβεστίου είναι πολύ υψηλή, κυρίως στο non-coronary sinus και στο right coronary sinus. Ο ασθενής έκανε 2 φορές πνευμονικό είδημα την εβδομάδα πριν γίνει η τάβη και 2 μέρες πριν την τάβη ήρθε στο νοσοκομείο διασωληνωμένος. Εδώ βλέπουμε το υπέρηχό του και βλέπουμε ότι λόγω της χαμηλής καρδιακής παροχής έχει και θρόμβο μέσα στο οτείο. Η βαλβίδα είναι πολύ επασβεστωμένη. Και εδώ βλέπουμε το θρόμβο που εξορμάται από το οτείο και τον καπνό στον αριστερό κόλπο. Έγινε προδιάταση με μπαλόνι 20 και τοποθετήθηκε μια Evolut Pro 34. Εδώ έχει προηγηθεί το μπαλόνι. Γίνεται η τοποθέτηση της βαλβίδος. Και μόλις τοποθετήθηκε η βαλβίδα, δεν ήταν δυνατόν να αποσυρθεί ο κόνος. Ο κόνος εμπλεκόταν στην βαλβίδα και δεν μπορούσε να βγει. Οι λύσεις θα ήταν 3. Η μία ήταν να τραβήξουμε όσο το δυνατόν πιο πολύ μπορούσαμε, με κίνδυνο να φύγει η βαλβίδα. Η δεύτερη λύση που σκεφτήκαμε ήταν να βάλουμε ένα μπαλόνι παράλληλα και να διαστήλουμε, αλλά φοβηθήκαμε μην παραμορφωθεί πολύ η βαλβίδα και χαλάσει. Και η τρίτη λύση ήταν να βάλουμε ένα snare. Ήταν και η λύση η οποία αποφασίσαμε. Εδώ έχουμε βάλει το snare. Πιάνουμε τον κόνο. Και μετακινούμε. Καταφέρνουμε και βγάζουμε. Βλέπετε στο τέλος ότι η βαλβίδα είναι παραμορφωμένη από το ασβέστιο, ο σκελετός της βαλβίδας είναι παραμορφωμένος από το ασβέστιο που ήταν στο non-coronary sinus. Οπότε, στη συνέχεια, και εδώ φαίνεται πολύ καθαρά αυτό, ξαναπεράσαμε το σύρμα και κάναμε μια διαστολή με ένα μπαλόνι 25. Και εδώ βλέπουμε το τελικό αποτέλεσμα και βλέπετε ότι το frame έχει αποκατασταθεί. Εδώ είναι αμέσως μετά. Και 1 χρόνο μετά βλέπουμε ότι έχει μια πολύ καλή αριστερή κοιλία και η βαλβίδα είναι στρόγγυλη και λειτουργεί σωστά 1 χρόνο μετά. Ευχαριστώ πολύ.
Κύριε Τσικαδέρη, πραγματικά ήταν ένα πολύ ωραίο περιστατικό, πώς μπορέσατε και λύσατε ένα πρόβλημα το οποίο θα το παρουσιάσω και εγώ αμέσως. Το επόμενο περιστατικό περιέχει μια παρόμοια επιπλοκή. Έχουμε κάποια ερώτηση?
Δεν μου λες, Δημήτρη, γιατί πιάστηκε ο κόνος, πού το αποδίδεις?
Γιατί η βαλβίδα ήταν σαν να είχε αλφιέρι stitch, ήταν σαν 8, επειδή δεν μπορούσε να εκτυχθεί καλά λόγω του ασβεστίου. Και παρόλο που αλλάζαμε τη γωνία, δεν ήταν δυνατόν να το αποσύρουμε.
Εντάξει, θα ήταν ενδιαφέρον και αυτό που λες με τον μπαλόνι, να μην είναι ιδιαίτερα μεγάλο, απλώς να το σπρώξει λιγάκι από να το ταρακούν. Το ίδιο πράγμα δηλαδή που κάνεις.
Ναι.
Και βέβαια ήταν και πολύ καλό το γεγονός ότι κατάφερες μέσα από αυτήν την παραμορφωμένη βαλβίδα και δεν πήγες μέσα από κανένα στράτ όταν έκανες τη μεταδιάταση, γιατί γι' αυτό θα ήταν εξαιρετικά τραυματικό. Δηλαδή και πολύ δεν είναι και εύκολο δηλαδή, να το καταλάβεις πώς είναι, δεν είναι και το πιο απλό πράγμα. Ήταν πολύ έτσι...
Είναι αυτό που λέγαμε το πρωί, ότι όταν αυτές οι self-expanding βαλβίδες κάνουν folding, κάνουν ένα σχήμα U, σαν πέταλο δηλαδή, τότε πρέπει οπωσδήποτε να διορθωθεί αυτό και μια άλλη παράπλευρη πιθανή επιπλοκή, η απώλεια, θα είναι να κολλήσει το κόνος που έγινε εδώ. Αλλά συγχαρητήρια, τα καταφέρατε και βγήκατε. Ευχαριστούμε πολύ, Δημήτρη, και έχουμε τον κύριο Κατσιμακλή τώρα στο πόντιουμ να μας παρουσιάσει το δικό του ενδιαφέρον.
Πάντως δεν έχουν μόνο Άγιο στον Άγιο Λουκά. Είναι συν Αθηνά και χειρακίνη.
Κώστα, προχωρήσουμε στο επόμενο περιστατικό. Είναι ένα περιστατικό valve-in-valve. Πρόκειται για έναν ασθενή 78 χρονών. Αυτά είναι τα σωματικά του στοιχεία, το ιστορικό του, για να πάω λιγάκι πιο γρήγορα. Το βασικό που πρέπει να δούμε είναι ότι το 2014 είχε βάλει μια χειρουργική βαλβίδα βιοπροσθετική, μια LabCorp νούμερο 23. Είναι, για τη συγκεκριμένη βαλβίδα έκανα την ερώτηση πριν στον Άκη τον Αραμπατζή για προδιαστολή. Αυτό είναι το υπέρηχο το προεγχειρητικό πριν την επέμβαση. Προχωράω έτσι γρήγορα. Είναι μερικά στιγμιότυπα του υπέρηχου. Εδώ βλέπουμε τη βαλβίδα. Πραγματικά σχεδόν ακινητική, μόνο μία πτυχή μερικώς ανοίγει. Είναι τα στοιχεία από την αξονική αγγιογραφία που κάναμε. Βλέπουμε πραγματικά πόσο μικρός είναι ο δαχτύλιος, είναι περίπου 18, ενώ από κάτω ο χώρος εξώθησης, η διάμετρος του είναι 26. Δεν είχαμε πρόβλημα με την πρόσβαση. Πάω γρήγορα. Αυτή είναι η βαλβίδα η LabCorp. Είναι μια βιοπροσθετική βαλβίδα η οποία δεν φαίνεται καθόλου. Είναι όπως η τραϊφέκτα και όπως η mitral flow, όμως οι γλοχίνες είναι από την εσωτερική πλευρά. Είναι μια βραζιλιάνικη βαλβίδα, η οποία δεν ξέρω αν έχει χρησιμοποιηθεί πάρα πολύ. Ανήκει στις χειρινές βαλβίδες, όχι στις περικαρδιακές, και στις χειρινές, όπως έψαξα λιγάκι την βιβλιογραφία, μπορούμε να κάνουμε, επειδή ακριβώς δεν φαίνονται οι περισσότερες από αυτές, μπορούμε να κάνουμε προδιαστολή. Χρειάζονται, γιατί είναι μεγάλη στένωση που προκαλούν και έχουν πολύ ινώδη ιστό. Αυτός είναι ο μπούσουλας που έχουμε από τον Βίνι Μπάμπατ. Είναι μια 23 βαλβίδα που μπήκε, η εσωτερική διάμετρος είναι 21. Εμείς τη βρήκαμε στη 18 στην αξονική που κάναμε, οπότε σχεδιάσαμε να λύσουμε το πρόβλημα με μια Evolut Pro 23. Αυτό είναι το setup της επέμβασης. Με ύπνος πηγαίνουμε, δεν διασωληνώνουν τους ασθενείς. Ο βηματοδότης, ένα pigtail από την δεξιά κερκιδική. Με μάντα θα πηγαίναμε γιατί υπήρχε ικανή διάμετρος και με ένα θικάρι Cook 16 friends γιατί θα χρησιμοποιούσαμε την Evolut Pro. Με υπέρηχο γίνονται πάντα οι παρακεντήσεις. Θα το προχωρήσω λίγο. Pigtail στη μη στεφανιαία της προσθετικής και εδώ κάνουμε προδιαστολή. Κοιτάξτε πόσο δύσκολα ανοίγει το μπαλόνι. Και κάναμε και μια δεύτερη μετά, για να είμαστε σίγουροι ότι θα μπορέσουμε να περάσουμε τον κόνο της βαλβίδος. Χρησιμοποιήσαμε ένα σκληρό σύρμα, ένα Landerquist. Στη βιβλιογραφία για τις συγκεκριμένες βαλβίδες χρειάζεται προδιαστολή. Για τις συγκεκριμένες, για τις LabCorp. Και εδώ είναι η πρώτη προσπάθεια. Η βαλβίδα κάνει pop-out. Προχωράμε στη δεύτερη. Για να προχωρήσω έτσι πιο γρήγορα, προχωράμε στην τρίτη. Η τρίτη ήταν πιο βαθιά, προσπαθήσαμε να αποσύρουμε τη βαλβίδα, δεν μπορούσαμε, τη μαζέψαμε τρίτη φορά. Πάμε τέταρτη φορά. Στην τέταρτη φορά η βαλβίδα δεν ανοίγει. Ο ασθενής καταρρίπτεται και διασωληνώνεται και μπαίνει σε αγιοσπαστικά. Μέχρι να ετοιμάσουμε τη νέα βαλβίδα πια, η οποία θέλει τουλάχιστον 4 λεπτά για να ετοιμαστεί. Πέμπτη προσπάθεια, νέα βαλβίδα, νέο delivery system. Το καταφέραμε, την εμφυτεύσαμε. Όμως τώρα υπήρξε ένα δεύτερο πρόβλημα. Το πρόβλημα είναι πώς θα αποσύρουμε τον κόνο, γιατί στην προσπάθειά μας να αποσύρουμε τον κόνο, ο κόνος δεν μπορούσε να βγει. Προσπαθήσαμε, βγάλαμε το σύρμα αυτό, χρησιμοποίησαμε ένα πιο μαλακό σύρμα, μήπως μπορούσαμε να βγάλουμε τη βαλβίδα χρησιμοποιώντας ένα πιο μαλακό σύρμα. Πάλι δεν μπορούσαμε και θα σας δείξω μετά δείχνοντας τον υπέρηχο. Γιατί μετά καταλάβαμε ακριβώς για ποιο λόγο δεν Η βαλβίδα έχει κάνει tilt, έχει κάνει μια κλίση, έχει μια κλίση, γιατί έχει πάρει τη χειρουργική κλίση, μάλλον την κλίση που είχε η χειρουργική βαλβίδα, η οποία είχε μπει στραβά. Αν θυμάστε στην αρχή, έκανα μια επισήμανση ότι ο δαχτύλιος ήταν 18, αλλά ο χώρος εξώθησης 26. Οι λύσεις ήταν αυτές που είπε πριν ο κύριος Τσικαδέρης. Εμείς πριν πάμε να βάλουμε ένα snare, σκεφτήκαμε να βάλουμε ένα pigtail, το οποίο δεν το έχουμε καταγράψει. Βάλαμε ένα pigtail και τον γλιστρήσαμε, ένα δεύτερο σύρμα, ένα pigtail, και γλιστρήσαμε το pigtail ακριβώς στο σημείο που ήταν το delivery system. Έτσι καταφέραμε και γλίστρισε ο κόνος πάνω στο pigtail και καταφέραμε και το βγάλαμε. Εδώ που παίζει τώρα το βίντεο βλέπουμε πού ακριβώς στάκαρε το delivery system πάνω ακριβώς στη βαλβίδα και πώς την έχει παραμορφώσει ακριβώς στο άκρο. Αυτό ήταν το υπέρηχο μετά και εδώ μπορούμε να δούμε πού είναι η βαλβίδα και πόσο από κάτω χώρος υπήρχε στο χώρο εξώθησης όπου και κολούσε το delivery system. Αυτό ήταν επειδή ο χειρουργός είχε ράψει τη βαλβίδα εξ αρχής στραβά. Εδώ το βλέπουμε ακόμα καλύτερα. Τώρα, αυτό που πρέπει να ξέρουμε πάντα, ότι στις valve-in-valve πάντα θα χρησιμοποιήσουμε ένα σκληρό σύρμα, Landerquist ή backup Meyer. Χρήση προδιαστολής, γι' αυτό και το ρώτησα πριν, πάλι επιμένω, μόνο για συγκεκριμένες βαλβίδες. Προσοχή σε αυτές τις συγκεκριμένες χειρουργικές βαλβίδες. Η διαδικασία της TAVI είναι μια πολύ δύσκολη επέμβαση που πρέπει να σχεδιαστεί με τη βοήθεια μιας πολύ καλής ποιότητας αξονικής τομογραφία και πρέπει πάντα να υπάρχει πλήρης περιγραφή της προηγούμενης χειρουργικής επέμβασης. Κάτι που θα πρέπει να γίνεται και από όλους εμάς, τώρα τους χειριστές της TAVI, για τις μελλοντικές TAVI. Ευχαριστώ πολύ.
Επομένως, για μένα το take-home message εδώ, Γιώργο, είναι ότι όταν έχεις LabCorp είναι πολύ πιθανό να χρειαστεί προδιαστολή. Έχουμε κάνει 2 ή 3 LabCorp. Ομολογώ ότι δεν είχα πρόβλημα. Οπότε, από εδώ και πέρα, μετά από αυτό που μας έδειξες, νομίζω ότι όταν θα βλέπω LabCorp, θα βλέπω το υπέρηχο πολύ πιο προσεκτικά, το gradient, aortic valve area και όλα αυτά. Γιατί η γενική γνώση είναι ότι όταν έχεις μια βιοπροσθετική και κάνεις προδιαστολή, τότε πολύ συχνά μπορεί να σκιστεί και να έχεις οξύ ανεπάρκεια.
Να έχεις οξύ ανεπάρκεια.
Σε ευχαριστούμε πάρα πολύ. Να συνεχίσουμε με τον partner στο ίδιο νοσοκομείο, τον Αντώνη τον Μαστροκοστόπουλο, ο οποίος θα μας δείξει το επόμενο ενδιαφέρον σας περιστατικό.
Ευχαριστώ πολύ κύριε Σπάρια και πάλι σας ευχαριστώ για την τιμή να μιλήσω σε αυτό το συνέδριο. Είναι ένα άλλο περιστατικό που έχουμε κάνει, δεν είναι όλα τα περιστατικά στο ναυτικό νοσοκομείο έτσι, δεν είναι όλα τόσα μπελαλίδικα και με τόσες επιπλοκές. Μια ασθενής η οποία είχε κάνει αντικατάσταση μητροειδούς βαλβίδας με μεταλλική, είχε κάνει και πλαστική τριγλώσινος. Από τη στεφανιογραφία δεν είχε κάτι το σημαντικό, ήταν μια γυναίκα αυτόνομη, σε καλή κατάσταση, η οποία όμως είχε παραπονεθεί για δύσπνοια στην ελάχιστη προσπάθεια. Από τον υπέρηχο βλέπετε ένα peak gradient 140, ένα mean gradient 95, ένα στόμιο 0,5. Ήταν ασθενής υψηλού κινδύνου. Εδώ πέρα βλέπετε από την αξονική, η οποία κάναμε πριν, δεν πιστεύαμε ότι θα αντιμετωπίσουμε κάποιο ιδιαίτερο πρόβλημα, εκτός και η γωνίωση ήταν καλή, δεν είχε πάρα πολύ ασβέστιο, όπως επίσης και εκεί πέρα που θα είχαμε κάνει την παρακέντησή μας, όπως είπε ο κ. Κατσιμακλής, εμείς πλέον κάνουμε τις παρακεντήσεις με υπέρηχο, γιατί έχουμε δει ότι μπορούμε να αποφύγουμε ακριβώς το ασβέστιο και παρακεντούμε με μεγαλύτερη ακρίβεια. Είχαμε λίγο ασβέστιο στην κοιλιακή αορτή, αλλά όχι όμως κάτι που να μας είχε ανησυχήσει ιδιαιτέρως. Αυτό που μας προβλημάτισε και αυτό που μας προβληματίζει όταν υπάρχει μεταλλική μητροειδούς είναι ακριβώς η απόσταση που σε εμάς ήταν στα 4,9 χιλιοστά, ώστε να μην έχουμε κάποια δυσλειτουργία των δίσκων της μεταλλικής βαλβίδας. Έτσι λοιπόν από τις διαστάσεις που είχαμε πηγαίναμε για μια Evolut Pro 29 και από το Annulus και από όλες τις μετρήσεις δεν είχαμε κάποιο ιδιαίτερο πρόβλημα. Το setup, όπως έχουμε πει, εμείς χρησιμοποιούμε μη οπιοειδή αναισθησία. Αυτό είναι ένα πρωτόκολλο που κάνουν οι αναισθησιολόγοι στο τμήμα μας. Από την σφαγίτιδα χρησιμοποιούμε ένα καλώδιο προσωρινού βηματοδότη για να κάνουμε τη βηματοδότηση. Εάν ο ασθενής έχει ήδη βηματοδότη, τις περισσότερες φορές βηματοδοτούμε από το σύρμα στην αριστερή κοιλία. Pigtail συνήθως το βάζουμε από τη δεξιά ή από την αριστερή κερκιδική. Αυτό είναι μια συνεχής διαμάχη που έχουμε και με τον τρίτο operator, τον κύριο Γκύρη στο ναυτικό νοσοκομείο. Εγώ προτιμώ δεξιά, αυτός προτιμάει αριστερά. Για λόγους να αποφύγουμε αν υπάρχει κάποια υλικό στο αορτικό τόξο, αν θέλετε να το συζητήσουμε και αυτό μετά. Θα βάζαμε pro-style σε αυτήν την ασθενή, ένα θικάρι central και όπως είπαμε την Evolut Pro 29. Έτσι λοιπόν ξεκινήσαμε, αυτή είναι η πρώτη αορτογραφία που παίρνουμε για να δούμε ότι έχουμε κάνει ότι η λήψη που έχουμε από την αξονική μας είναι καλή και ότι μπορούμε. Τα στεφανία βλέπουμε ότι είναι βατά, δεν έχουμε κάποιο πρόβλημα και ήταν η προβολή στην οποία θα δουλεύαμε. Βλέπαμε εδώ πέρα και τους δίσκους της μητροειδής ότι ανοίγουν φυσιολογικά, δεν είχαμε κάποιο πρόβλημα. Έτσι λοιπόν ξεκινήσαμε πάντα, κάνουμε βαλβιδοπλαστική σε αυτή την περίπτωση, γιατί όπως είχαμε και ένα peak gradient 140. Εμείς όταν κάνουμε την βαλβιδοπλαστική, και αυτό αν θέλετε μπορούμε να το συζητήσουμε, αφήνουμε το pigtail στην ανιούσα αορτή και τις περισσότερες φορές κάνουμε και έγχυση για να δούμε πόσο καλό sealing έχουμε κάνει, μειώνοντας βέβαια τα PSI στο assist. Έτσι εδώ πέρα βλέπουμε την βαλβιδοπλαστική που κάναμε, δεν υπήρχε ένα μικρό waste, το οποίο αυτό εν συνεχεία έφυγε. Βλέπετε εδώ πέρα την ορτογραφία που κάναμε, βατά τα στεφανιαία αγκία και τα δύο. Δεν είχαμε κάποιο πρόβλημα, επομένως είπαμε να συνεχίσουμε κανονικά. Έτσι λοιπόν ξεκινήσαμε να κάνουμε την τοποθέτηση της βαλβίδας. Όπως είχαμε πει, η απόσταση ήταν στα 4,9, έπρεπε επομένως να στοχεύουμε για μια υψηλή τοποθέτηση. Ξεκινήσαμε εδώ πέρα, ανοίγουμε τη βαλβίδα, βλέπουμε αυτήν την προβολή εδώ που βλέπετε και προς τα δεξιά. Είναι μια οριακή, είναι αρκετά υψηλή σε αυτό που θα θέλαμε εμείς. Αλλάζουμε προβολές, commissural alignment, για να δούμε ακριβώς πώς φαίνεται σε αυτή την περίπτωση ή δεν μας άρεσε. Επομένως ξεκινήσαμε δεύτερη προσπάθεια. Αυτή τη φορά η θέση μας άρεσε καλύτερα από την προηγούμενη. Ξανά πάλι την ελέγχουμε από διαφορετική για να δούμε το ύψος της εμφύτευσής μας. Βλέπετε εδώ πέρα πάλι δεξιά ότι είμαστε λίγο πάλι υψηλά, φοβόμασταν, δηλαδή είμαστε οριακά στο 0 ή θα μας πήγαινε στο 0 όταν θα γινόταν η τελική απελευθέρωση. Επομένως τι κάνουμε, πριν απελευθερώσουμε τη τη σπρώχνουμε λίγο πιο μέσα και βλέπουμε εδώ πέρα μια θέση η οποία είναι ανεκτή, μας άρεσε πάρα πολύ. Λέγαμε ότι ωραία, δεν θα έχουμε κάποιο θέμα κατά την απελευθέρωση. Εδώ τώρα, και να θυμίσω ότι αυτό το περιστατικό έγινε σε ένα live case demonstration, αυτό που είδαμε ήταν τι? Όταν ανοίξαμε τη βαλβίδα και μετά ήταν μια βαλβίδα που μπορώ να σας πω δεν έχω την καταγραφή, αλλά ήταν σε αυτή την θέση, και είχαμε ένα πρόβλημα όταν πήγαμε να αποσύρουμε τον κόνο. Και αυτό το οποίο είδαμε, και το λέμε ότι οφείλεται μετά στον κόνο, είναι ότι η πρώτη λήψη που κάναμε μετά είναι αυτές που βλέπετε εδώ πέρα. Η βαλβίδα έχει εμβολιστεί, έχει πάει πιο πάνω, έχουμε φύγει τελείως από την θέση που θα θέλαμε, κάνουμε ανεπάρκεια και έχουμε αυτή την εικόνα εδώ πέρα. Η ασθενής αρχίζει και καταρρίπτεται αιμοδυναμικά, επομένως σε αυτή την περίπτωση είχαμε δύο επιλογές. Η πρώτη ήταν να πάμε να βάλουμε δεύτερη βαλβίδα, η δεύτερη λύση να πάμε να κάνουμε με ένα snare, να τραβήξουμε τη βαλβίδα ακόμα πιο πάνω για να μην επηρεάσουμε, για να δούμε. Εμείς αποφασίσαμε να κάνουμε το πρώτο και να βάλουμε μια δεύτερη βαλβίδα. Βάλαμε τη δεύτερη την βαλβίδα, όπου όπως βλέπετε εδώ πέρα είχαμε ένα πρόβλημα. Το σύρμα, όπως βλέπετε, είναι διαφορετικό. Αυτό είναι ένα lander quiz, γιατί δεν μπορέσαμε να περάσουμε μέσα από την πρώτη βαλβίδα τη δεύτερη βαλβίδα με το confida το σύρμα το οποίο είχαμε. Επομένως έπρεπε να αλλάξουμε και σύρμα, να βάλουμε το lander quiz για να μπορέσουμε να κατεβάσουμε τη βαλβίδα μας. Όταν βάζει κάποιος μια δεύτερη βαλβίδα, έχουμε κάποια προβλήματα. Μπορεί να μην μπορούμε να την προωθήσουμε, να πρέπει να χρειαστεί να αλλάξουμε το σύρμα. Έχουμε μια πίεση χρόνου, ειδικά αν ο ασθενής μας καταρρίπτεται, και ότι θα πρέπει να κάνουμε τη σωστή τοποθέτηση, αλλά δεν έχουμε όμως το pigtail πολλές φορές στη θέση εκεί που θα θέλαμε για να είμαστε περισσότερο ακριβείς κατά την τοποθέτησή μας. Έτσι λοιπόν εμείς όταν βάλαμε τη δεύτερη βαλβίδα, αυτό το οποίο είδαμε και φαίνεται καλά σε αυτήν εδώ πέρα την προβολή είναι μεν ότι είμαστε πιο μέσα, δεν επηρεάζεται η λειτουργία της μητροειδούς, αλλά φαίνεται το στέλεχος. Με τις εγχύσεις που κάναμε δεν μπορούσαμε να διακρίνουμε δεξιά φαίνεται η δεξιά στεφανία αρτηρία, αλλά η αριστερή στεφανία αρτηρία δεν φαίνεται. Έτσι λοιπόν είχαμε μια ασθενή η οποία καταρρίπτεται, η οποία είχαμε όλα αυτά, οπότε τι αποφασίσαμε αυτή τη στιγμή? Να κάνουμε το snare. Βγάλαμε και τις δύο βαλβίδες όπως βλέπετε πιο πάνω, περάσαμε μετά πάλι ένα σύρμα και βάλαμε έναν καθετήρα pigtail διαμέσου και των δύο βαλβίδων και είχαμε αυτήν εδώ πέρα την εικόνα. Τα στεφανία που φαινόταν πλέον και το στέλεχος, φαινόταν και η δεξιά στεφανία αρτηρία, η μητροειδής βαλβίδα λειτουργεί κανονικά, δεν είχαμε κάποια ρήξη, δεν είχαμε κάτι που είχαμε κάνει snare τη βαλβίδα και εδώ είχαμε πάλι. Θα προχωρήσουμε ή θα σταματήσουμε εδώ πέρα την επέμβαση. Εμείς αυτό που κάναμε ήταν τι? Προσπαθήσαμε και λέγαμε να περάσουμε πάλι, αφού είχαμε το pigtail όπως είδατε στους κόλους του Βαλσάλα, να περάσουμε πάλι ένα σύρμα. Μπορέσαμε και το κάναμε αυτό, ξαναβάλαμε το lander twist μέσα, αλλά αυτό το οποίο δεν μπορούσαμε να κάνουμε και στην αρχή για να μην την ξαναπατήσουμε πάλι, είναι δεν μπορούσαμε να προωθήσουμε ούτε ένα μπαλόνι για να πούμε πρώτα ότι μπορούμε να περάσουμε την μπαλόνι, γιατί δεν ξέραμε πώς είχαμε περάσει από όλα αυτά τα κελιά που είχαν πλέον οι δύο βαλβίδες, πώς ακριβώς ήμασταν. Και επειδή δεν μπορέσαμε ούτε να περάσουμε τον μπαλόνι βαλβιδοπλαστικής, η επέμβαση σταμάτησε εδώ πέρα. Δεν προχωρήσαμε παραπάνω, σταματήσαμε εδώ και συμπερασματικά τίποτα δεν είναι απλό, δεν υπάρχει απλή επέμβαση τάβη. Πάντα πρέπει να υπάρχει ένα εναλλακτικό σχέδιο, γιατί ποτέ δεν ξέρουμε τι μπορεί να γίνει και πάντα πρέπει να γνωρίζουμε ότι υπάρχουν όρια και θα πρέπει να σταματάμε εκεί που προέχει το καλό του ασθενούς. Σας ευχαριστώ πάρα πολύ.
Τελειώσατε.
Ναι, κύριε Μιχάλη, ναι, κύριε καθηγητά.
Συγχαρητήρια. Είχε gradient μετά από αυτό η ασθενής?
Εννοείται αν μετρήσαμε πόσο gradient είχε. Δεν είχαμε με τη βαλβιδοπλαστική, δεν μπορέσαμε να κάνουμε κάτι.
Όχι, δεν είναι το θέμα της βαλβιδοπλαστικής. Θα σου πω τι. Όταν βάλεις τέτοιες βαλβίδες μέσα, οι οποίες βγουν μετά τις βγάλεις, για οποιοδήποτε λόγο, τις τραβήξεις και τις βγάλεις, κάνεις μία περίπου βαλβιδοπλαστική με αυτό το καινούριο σύστημα που θέλουν να βγάλουν της μηχανικής βαλβιδοπλαστικής. Το οποίο δεν είναι μπαλόνι και πραγματικά το gradient είναι πολύ μικρό τις πιο πολλές φορές.
Κύριε καθηγητά, ήταν το μισό στη μονάδα την επόμενη μέρα. Η ασθενής είχε 120 περίπου gradient την επόμενη μέρα στη μονάδα, γιατί τότε καταφέραμε, γιατί θυμάστε, ήταν σε live demonstration το περιστατικό. Ήταν περίπου, αν θυμάμαι καλά, είχε μειωθεί περίπου στα 3,5 μέτρα η ταχύτητα.
Ναι, είναι χαρακτηριστικό. Δηλαδή πέφτει πάρα πολύ το gradient. Και πέφτει και για καιρό. Και δεν είναι μόνο τις ημέρες. Δηλαδή είναι μια μηχανική βαλβιδοπλαστική αυτή, η οποία Δεν ξέρω πόσο κρατάει, πιθανώς όχι πολύ, ή αρκετό, αλλά είναι πολύ καλύτερο από τον μπαλόνι. Και είναι εντυπωσιακό. Δεν σας συνιστώ να βάζετε και να βγάζετε βαλβίδες στα πλαίσια της βαλβιδοπλαστικής, βέβαια, αντί για βαλβιδοπλαστική, αλλά
είναι περισσότερο από εξάμηνο.
Η οποία κρατάει.
Πάντως είναι περισσότερο από το εξάμηνο της βαλβιδοπλαστικής.
Ναι.
Εδώ θα είχε πολύ ενδιαφέρον να μετρήσεις, να βάλεις ένα καθετήρα και να μετρήσεις τις πιέσεις από την κοιλία πάνω από την αορτή και πριν τη βαλβίδα και μετά πάνω από τη βαλβίδα. Να δεις ακριβώς αν στη διαστολή η λειτουργούσα βαλβίδα που άφησες έριχνε τη διαστολική πίεση. Αν έριχνε τη διαστολική πίεση στην αορτική ρίζα, τότε αυτό θα ήταν μία ένδειξη να πας να βάλεις ένα stent και να την ανοίξεις. Εάν δεν έβλεπες κάτι τέτοιο, τότε θα μπορούσες να αποδεχτείς κάτι το οποίο νομίζω κάνατε.
Ναι. Βέβαια το πρόβλημα είναι ότι εδώ δεν περνάει μπαλόνι, όχι stent.
Ναι, γιατί μπορεί το σύρμα που περάσαμε μετά και τελικά να μπαίνει και μέσα από τα κελιά.
Ναι, αλλά είναι δύσκολο έτσι κι αλλιώς να περάσει σύρμα κανονικά. Πιθανώς pigtail να περνάει.
Με pigtail, μόνο με pigtail.
Αλλά δεν είναι εύκολο, δηλαδή το έχω δει. Περνάει, αλλά δεν θέλει και τύχη.
Ο κύριος Πιλάτης.
Ναι, εντυπωσιακό περιστατικό. Να ρωτήσω, υπήρχε δυνατότητα να μπει μια Edwards μετά την πρώτη αποτυχία, δηλαδή μετά το pop-out της βαλβίδος, αντί να μπει δεύτερη με Dronic, να μπει Edwards, γιατί...
Και αυτή η δυνατότητα.
Γιατί νομίζω ήταν αναμενόμενο ότι με μια δεύτερη evolute μέσα στην πρώτη θα σχηματίζεται ένα covered stand, το οποίο έχει μεγάλη πιθανότητα να κλείσει τα στεφανία.
Αυτό που λέτε, κύριε Πιλάτη, για λογιστικούς λόγους.
Και με την Edwards θα συνέβαινε αυτό. Και με την Edwards θα συνέβαινε αυτό. Θα έπρεπε πρώτα να τραβηχτεί.
Θα έπρεπε πρώτα να γίνει snare, να τραβηχτεί. Επειδή όμως είχε καταρριφθεί ασθενής, γι' αυτό προτιμήσαμε να το κάνουμε αυτό. Αλλά πρώτα πρέπει η snare να ανεβάσει τη βαλβίδα και να βάλει τη δεύτερη μετά.
Καλησπέρα, μπορώ να κάνω μια παρέμβαση.
Βεβαίως.
Ο κ. Τενταφύλου.
Μάλιστα.
Με ακούτε? Ποιο είναι το endgame για αυτόν τον άρρωστο? Δηλαδή, θέλω να πω τώρα, θα μείνει έτσι? Έχετε σκεφτεί κάποια λύση?
Εγώ προσωπικά, άμα με ρωτάτε, είμαι τρομοκρατημένος και δεν νομίζω ότι θα συμφωνήσω ότι για να περάσουμε μέσα από δύο βαλβίδες θέλει τύχη. Δεν είναι μόνο ικανότητα, δεν είναι μόνο skills. Εγώ προσωπικά σε αυτήν την ασθενή, επειδή και μετά και αυτή κατάλαβε τι έγινε, της το εξηγήσαμε τι ακριβώς έγινε, πάρα πολύ να την ξαναακουμπήσω. Εγώ προσωπικά. Και δεν νομίζω ότι ούτε οι ασθενείς προς το παρόν θέλουν να τις κάνουμε κάτι.
Ανεξάρτητα από αυτό, η λύση τώρα που θα πρόθυνε κάποιος είναι όπως έγινε η πρώτη τάτη, με transeptal δηλαδή και S3. Έτσι μπορεί να λυθεί το πρόβλημα. Βέβαια πρέπει να βρεθεί αυτός που θα το κάνει.
Θα μπορούσε, έχετε δίκιο. Ή θα μπορούσε, παραδείγματος χάρη, πάλι να γίνει με τον αρχικό τρόπο να πιάσεις με λάσο τις δύο αυτές βαλβίδες, να τις πιάσεις και μετά να καταφέρεις να βάλεις. Αλλά ίσως ο τρόπος που λέτε εσείς είναι πιο...
Να πω την άποψή μου, νομίζω ότι μπορεί κάλλιστα να γίνει εδώ Sapien. Χρειάζεται προσοχή στο να περάσει το σύρμα αυτή τη φορά με pigtail, σίγουρα να μην είναι μέσα από στράτς αυτών των βαλβίδων. Θα πρέπει να γίνει ένα τεστ μετά, περνώντας ένα μπαλόνι βαλβιδοπλαστικής αχρησιμοποιητό, που δεν το έχεις φουσκώσει, να κάνεις ένα τεστ ότι περνάει ελεύθερα, να σιγουρευτείς, και κατόπιν με τη Sapien έχεις το πλάστο, ότι έχει το delivery system, το οποίο είναι deflectable, οπότε δεν θα έχεις πρόβλημα, θα μπορέσεις δηλαδή να πάρεις τη στροφή και να το απομακρύνεις κάθε φορά που θα ακουμπάει στις βαλβίδες. Βέβαια, καταλαβαίνω, Αντώνη, την ανησυχία σου, γιατί όταν έχει συμβεί αυτό που έχει συμβεί, φανταστείτε να πας με τη Sapien και κάτι να συμβεί, να κολλήσει και να αναγκαστείς να την τοποθετήσεις, αλλά πάλι όχι στην αορτική βαλβίδα. Οπότε χρειάζεται σκέψη και νομίζω σε αυτές τις περιπτώσεις πρέπει ο ασθενής να το ζητήσει, όπως πολύ σωστά είπατε. Δηλαδή, αν ο ασθενής γίνει συμπτωματικός και πει ότι δεν είμαι καλά και κάτι πρέπει να γίνει, τότε ναι, θα σκεφτόμουν Sapien.
Τώρα εδώ πέρα θα είναι Transcatheter Procedure.
Ναι.
Αν μου επιτρέπετε πάντως, κύριε Σπάρια και κύριε Τρενταφύλλου, για αυτό που είπατε, Με βάση αυτό, εάν μας ξανακαλέσετε, κύριε Σπάρια, επειδή το έχουμε προγραμματίσει, του χρόνου θα σας δείξουμε ένα περιστατικό το οποίο έχουμε δοκιμάσει να το βάλουμε 3 φορές. Εν τέλει δεν μπορέσαμε και θα προγραμματίζουμε την 4η φορά να είναι τέλη Μαΐου, η οποία θα είναι κιόλας και από τη μασχαλιαία αρτηρία η τοποθέτηση της βαλβίδας. Αν πάνε καλά τα πράγματα αυτή τη φορά, θα σας το δείξουμε στο επόμενο το 2023.
Αντώνη, πάντως έχω δει τέτοιο περιστατικό να το λύνει ο Τσιτσέ μετά από 2 pop-out με Evolut να βάζει εστρία. Στην ίδια συντρία.
Την ίδια είπατε.
Σίγουρα μπορεί να γίνει. Καταλαβαίνω ότι κολλάει η μεγάλη κάψουλα της Evolut όταν μπαίνει μέσα σε όλο αυτό το μέταλλο και δεν έχεις τη δυνατότητα να κάνεις deflection, κάτι που μπορείς να το κάνεις με την Sapien 3. Πολύ ενδιαφέρον περιστατικό. Αυτά για να βλέπουμε ότι κανένα τάβι δεν είναι straightforward, όλα μπορούν να συμβούν. Και...
Ευχαριστούμε πολύ, Αντώνη.
Ευχαριστούμε, Αντώνη.
Ευχαριστώ.
Και θα προχωρήσουμε στο επόμενο περιστατικό από τον κύριο Ψαθά, ο οποίος θα μας παρουσιάσει το δικό του περιστατικό. Κύριε Ψαθά, σας ακούμε.
Ευχαριστώ πάρα πολύ και θέλω να ευχαριστήσω και εγώ για την τιμητική πρόσκληση και για τους οικοδεσπότες εδώ. Εγώ θα φύγω από την αορτή, θα πάω στη μητροειδή, θα κάνω έτσι μια αλλαγή. Θα μιλήσω...
Έπρεπε να είναι αύριο, αλλά δεν πειράζει, θα το δεχτούμε και σήμερα.
Λοιπόν, είναι ένας άντρας 85 ετών με νεφρική ανεπάρκεια, πνευμονική υπέρταση, χαπίτης, θηροειδοπάθεια. Το 2009 είχε βάλει χειρουργικά είχε κάνει τριπλή αορτοστιφανία παράκαμψη, είχε βάλει μια μαστική αρτηρία στον πρόσθετο κατιόντα, ένα φλεβικό μόσχημα σε έναν επιχείλιο και στη δεξιά στιφανία αρτηρία και είχε κάνει αντικατάσταση μήτροειδούς και είχε βάλει μια Σεντζούντ 29 mm. Το τελευταίο διάστημα παρουσιάζει επανειλημμένες νοσηλίες με εικόνα καρδιακής ανεπάρκειας και έφτασε και σε εμάς με ένα κλάσμα στο τρίπλεξ που είδαμε, ένα κλάσμα εξώθησης 70% με μια πνευμονική υπέρταση, με μια διάταση της δεξιάς κοιλίας και μια ήπια δυσλειτουργία αυτής και διαπιστώθηκε μια βιοπροσθετική βαλβίδα στη θέση της στη μητροειδική θέση με έκεντρη σημαντική ανεπάρκεια και στένωση εκφυλιστικής αιτιολογίας. Βλέπουμε εδώ κάποιες εικόνες. Κάναμε ένα διεισοφάγιο τα οποία επαληθεύτηκαν όλα αυτά τα ευρήματα που βρήκαμε. Βλέπετε εδώ πέρα. Πολύ γρήγορα. Η στεφανιογραφία που κάναμε, μία κλειστή δεξιά, ένα στέλεχος 90+% με ολική απόφραξη στη μεσότητα του προστίου κατιόντα, καθώς επίσης και κλειστός ο πρώτος επιχείλιος, ένα φλεβικό μόσχημα που πήγαινε στον πρώτο επιχείλιο και ένα άλλο φλεβικό μόσχημα στην περιφέρεια της δεξιάς στιφανίας και η λίμα με καλή ροή και καλή κατάφυση στον πρόστιο κατιόντα. Χωρίς λοιπόν ιδιαίτερα προβλήματα από τη στεφανία ανώσο. Έτσι αποφασίσαμε λοιπόν να βάλουμε μία βαλβίδα Sapien 3 29 mm σε μία valve-in-valve, σε μία βιοπροσθετική βαλβίδα. Μέσω τρασέπταλ λοιπόν, με safe sept, βλέπουμε και την εικόνα από το υπέρηχο και από το διεισοφάγιο. Γίνεται με μπαλόνι Atlas Gold 14 mm, μια καλή διάνοιξη, επανειλημμένη μάλιστα 2-3 φορές, με καλή κίνηση στο τσεκ του μπαλονιού. Ανεβαίνει μια βαλβίδα Sapien, βλέπετε εδώ πέρα η διάνοιξή της, η οποία άνοιξε αρκετά καλά, πολύ καλά μάλιστα. Βλέπουμε εδώ. Ακολούθως εκτιμήθηκε η βαλβίδα και με διεισοφάγιο. Βλέπετε ότι δεν έχει ανεπάρκεια και με κοιλιογραφία, χωρίς να έχει καμία ανεπάρκεια και παραβαλβιδική διαφυγή. Με 3D λειτουργούσε πάρα πολύ καλά και ήμασταν πάρα πολύ ευχαριστημένοι σε αυτό το σημείο και πάρα πολύ χαρούμενοι γιατί ήταν και η πρώτη μας βαλβίδα. Αλλά θα ήθελα, αν μπορείτε, να δείτε τους χρόνους, δεν ξέρω, έχει κάποιο... Το πάνω. Τέλος πάντων, άμα δείτε την ώρα, βλέπετε ότι είναι 12 η ώρα ακριβώς. Βλέπουμε αυτή τη βραδία ροή στον αριστερό κόλπο, η εικόνα smoke, και 12 και 7 λεπτά βλέπετε εκεί που είναι το βελάκι ακριβώς στο οτίο, αρχίζει και μαζεύει θρόμβο. Ουσιαστικά έχει την εικόνα λάσπης, αν μου επιτραπεί η έκφραση, μαζεύει θρόμβο στο αριστερό οτίο. Δείτε εδώ πριν ξεκινήσουμε την διαδικασία και την εμφύτευση πώς είναι το αριστερό οτίο, ανοιχτό και καθαρό, και βλέπετε ακριβώς μετά την εμφύτευση πώς έχει γεμίσει με θρόμβο το αριστερό οτίο. Είναι μια εικόνα φυσικά που μας το ρίβησε. Συγγνώμη, μπορώ να γυρίσω πίσω. Σε αυτό λοιπόν το σημείο χορηγής, ενώ εξετάσαμε το ACT, όπως βλέπετε εδώ πέρα ήταν στο 340, δώσαμε μπόλους και άλλη ηπαρίνη, ενστικτωδώς θα έλεγα. Μετά από 3 μέρες πήγε στη μονάδα ο ασθενής για παρακολούθηση, ενώ ήταν αιμοδυναμικά σταθερός, ασυμπτωματικός και οι μετρήσεις μας ήταν πάρα πολύ καλές. Οδηγήθηκε στη μονάδα, χορηγήθηκε αντιπαικτική και διπλή αντιαιμοπεταλιακή αγωγή. Βλέπετε μετά από 3 μέρες ότι αρχίζει να λύεται ο θρόμβος στο οτίο και ο ασθενής πήρε μετά από 5 μέρες από την εμφύτευση εξιτήριο, αιμοδυναμικά σταθερός, με πολύ καλό υπέρηχο και πολύ βελτιωμένη την κλινική του εικόνα. Ψάχνοντας να βρούμε λοιπόν για αυτή την επέμβαση πληροφορίες, δεν βρήκαμε πάρα πολλά πράγματα και γι' αυτό λοιπόν θα σας παραθέσω πληροφορίες για το mitral clip. Από εκεί βρήκαμε περισσότερες πληροφορίες. Όπως βλέπετε, οι επιπλοκές για την τοποθέτηση του mitral clip παρουσιάζεται η οξεία θρόμβος, η παρουσία θρόμβου, ενώ δεν υπήρχε. Επίσης, από μία σειρά 100 ασθενών, το 9% από αυτή τη σειρά διαπιστώθηκε παρουσίασε θρόμβους, αλλά όλες σχεδόν οι περιπτώσεις ήταν πάνω στο θικάρι, στο σύρμα ή στο delivery system του mitral clip. Ενώ πάλι μέσα για τις επεμβάσεις του mitral clip υπάρχουν περιπτώσεις για θρόμβωση του οτίου. Τώρα, η αιτία, να πούμε, που έγινε αυτό, τι πιστεύουμε, οι αιτίες μάλλον για τις επιπλοκές θρομβώσεων είναι η κακή χορήγηση της ηπαρίνης, δηλαδή ο μη έλεγχος του ACT ή η χαμηλή δόση ηπαρίνης, η χαμηλή ροή του αίματος στο οτίο, ενώ το οτίο είχε συνηθίσει από την ανεπάρκεια της μητροειδούς μια μεγάλη ταχύτητα του αίματος, φτιάχνοντας απότομα την ανεπάρκεια αυτή, υπάρχει βραδία ροή του αίματος, λιμνάζει δηλαδή το αίμα στο αριστερό κόλπο. Η παρουσία πολλαπλών devices μέσα στον αριστερό κόλπο κατά τη διάρκεια της εμφύτευσης και σε αυτή την επέμβαση αλλά και στα mitral clip, ο καθετήρας, τα σύρματα, ακόμη και τα devices τα ίδια, αλλά και μια ενδοθηλιακή, ενδοθηλιακό σοκ, δυσλειτουργία λόγω της επέμβασης. Φυσικά οι επιπλοκές είναι θρομβοεμβολικά και αιμορραγικά. Θρομβοεμβολικά να φύγει ο θρόμβος και να εμβολήσει και τα αιμορραγικά λόγω της μεγάλης χορήγησης αντιπαικτικών να έχουμε αιμορραγικά. Σαν θεραπεία φυσικά αντιπαικτική αγωγή και μεγάλη προσοχή ούτως ώστε να διατηρούμε το ACT σε θεραπευτικά επίπεδα. Ευχαριστώ.
Ομολογώ ότι δεν έχω δει τέτοια επιπλοκή ούτε σε mitral clip, ούτε σε όλα τα mitral valve in valve που έχουμε κάνει. Όπως πολύ σωστά είπες, πιστεύω κι εγώ ότι αν ήταν dominant η ανεπάρκεια της μητροειδούς που δημιουργούσε αυτή την αυξημένη ροή και το στροβιλισμό και ξαφνικά μπήκε μία βαλβίδα, εξαφανίστηκε η ανεπάρκεια της μητροειδούς χωρίς να αλλάξει πρακτικά το gradient, γιατί όταν βάζουμε αυτές τις βαλβίδες πάντοτε κρατάνε ένα gradient, δηλαδή από ό,τι είδα ήταν 5 το gradient πριν, φαντάζομαι παρόμοιο θα έμεινε και μετά. Οπότε η έλλειψη αυτής της κινητικότητας του αίματος μπορεί να το δημιουργήσει και πολύ σωστά το αντιμετωπίσατε όπως το αντιμετωπίσατε. Γενικά, οι βαλβίδες στη μητροειδή είναι θρομογόνες. Δηλαδή, αυτές οι βαλβίδες έχουμε δει σε αυτές τις βαλβίδες πολύ γρήγορα να πιάνουν halt. Αυτό που συζητάμε για το τάβι στην μητροειδή. Γι' αυτό και εκεί είναι πολύ πιο liberal χορήγηση ερυθροδοτικής αγωγής γενικά. Νομίζω ότι μπορούμε να προχωρήσουμε. Σας ευχαριστούμε πολύ. Έχουμε τον κύριο Τριανταφύλου στο παράθυρο, online with us. Σας ακούμε. Δεν σε βλέπουμε. Αν θες να ανοίξεις την κάμερα, έχεις κλειστεί την κάμερα.
Κώστα, δεν σε ακούμε και δεν σε βλέπουμε.
Και δεν σε βλέπουμε. Ίσως κάτι να του έχει τύχει, οπότε ας προχωρήσουμε με τον κύριο Ζαΐρη μέχρι να λύσει το πρόβλημα του κύριου Τριανταφύλου. Μιχάλη, είσαι μαζί μας? Μα μέχρι πριν από λίγο ήσασταν και οι δύο. Πού πήγατε?
Εγώ είμαι εδώ είμαι.
Okay. Σ' ακούμε, Μιχάλη.
Μ' ακούτε? Ο Τριανταφύλου είμαι.
Τριανταφύλου. Κωνσταντίνα, έλα, συγγνώμη, δεν σε βλέπουμε πριν. Αν έχει συνδεθεί, ο Τριανταφύλου.
Ναι, μισό λεπτάκι, share. Τώρα με βλέπετε, με ακούτε?
Ναι, Κώστα, σε βλέπουμε.
Αλλά εντάξει, κάνω share screen και προχωράω. Συγγνώμη για την καθυστέρηση. Ευχαριστώ πάρα πολύ για την πρόσκληση και φέτος να μιλήσω σε αυτό το πολύ καλό συνέδριο που είναι θεσμός πλέον για τις δομικές καρδιοπάθειες. Θα παρουσιάσω ένα περιστατικό το οποίο απλώθηκε στην αντιμετώπιση του σε ένα χρόνο. Με συγχωρείτε λίγο. Λοιπόν, είναι μια ασθενής η οποία είναι 83 ετών, 1,66 ύψους, 76 κιλά. Πρώτη φορά νοσηλεύτηκε στο νοσοκομείο μας το Μάρτιο του 2021 λόγω οξείας αριστερής καρδιακής ανεπάρκειας και non-STEMI. Στη στεφανιογραφία που θα σας δείξω σε λίγο είχε κόμπλεξ στεφανία νόσου 3 αγγείων. Από παράγοντες κινδύνου ήταν υπερτασική και με μια ήπια αναψυκή ανεπάρκεια με EGFR 67. Ένα αιματοκρίτη γύρω στο 36. Το καρδιογράφημα είχε χρόνια κορπική μαρμαρική με μπλοκ δεξιού σκέλους και μη ειδικές διαταραχές αναπόλωσης. Βρέθηκε ένα κλάσμα γύρω στο 40-45%, μικρή υπερτροφική αριστερή κοιλία. Ένα άβα που υπολογίστηκε στο 0,9, άρα έχει σοβαρή στένωση αορτικής βαλβίδας, με μέτριες ανεπάρκειες αορτικής και τριγλόγινας και ήπια πνευμονική πέταση. Τα σκορ, το Euroscore 2 και το Logistic βγήκαν 10,6 και 14,6 αντίστοιχα, το STS 5,3. Συζητήσαμε με χειρουργούς, απορρίφθηκε χειρουργικά. Αυτή ήταν η στεφανιογραφία που έγινε στις 4 Μαρτίου του 2021. Βλέπουμε πολύ σοβαρή στεφανία νόσο, επιμήκη βλάβη στον πρόσιο κατιόντα, σοβαρά σβεστομένη με 2 υφολικές στενώσεις εγγύηση και λίγο μετά το πρώτο διαφραγματικό. Επίσης, μια επιμήκη σοβαρά σβεστομένη βλάβη στον πρώτο επιχείλιο κλάδο. Επίσης, εδώ στη Spider αριστερά φαίνεται ότι έχει μία πλάκα το στέλεχος που δημιουργεί μία στένωση 50%, μία βλάβη στην αρχή του προσίου κατιόντας βεστομένη που και εκεί φαίνεται ενδιάμεσης βαρύτητας και μία κριτική βλάβη στο στόμιο της δεξιάς στεφανίας αρτηρίας. Ψηλό σύνταξη σκορ λοιπόν, σοβαρή στένωση αορτικής βαλβίδας. Βλέπετε πόσο ασβέστιο φαίνεται ακτινοσκοπικά στη ρίζα της αορτής. Παρ' όλα αυτά, παρότι επιμένουμε εμείς και επανερχόμαστε προς τους καρδιοχειρουργούς, λόγω του φράιλτη της αρρώστου, η απάντηση είναι ότι απορρίπτεται χειρουργικά και πρέπει να δούμε τι μπορούμε να κάνουμε εμείς. Θεωρήσαμε ότι σε πρώτη φάση που έχει να αντιμετωπίσουμε τις κριτικές βλάβες στην αριστερή στεφανία αρτηρία. Προχωρήσαμε λοιπόν σε μια αγγιοπλαστική 5 μέρες μετά, το 2021 Τρίτου, με rotablation. Αυτό είναι ένα BER 1,25, το οποίο διέρχεται. Είχαμε δυσκολία να κάνουμε crossing με μικροκαθετήρα της υφολικής στένωσης που ήταν εδώ. Τελικά καταφέραμε να περάσουμε το rotawire και να κάνουμε αυτό. Μετά τα πράγματα απλοποιήθηκαν. Κάναμε και προδιαστολή με non-compliant μπαλόνι. Βάλαμε ένα μακρύ stent 335. Μετά προχωρήσαμε στον επιχείλιο κλάδο. Εδώ ευτυχώς πέρασε πολύ εύκολα ένα μπαλόνι. Κάναμε διαστολή μόνο με non-compliant μπαλόνια. Αυτό απλοποίησε την επέμβαση που ήταν αρκετά χρονοβόρα συνολικά. Κάναμε μία εμφύτευση ενός μεγάλου stent 1,275-30. Είναι αυτό το αποτέλεσμα που βλέπετε εδώ. Λόγω της αμφιβολίας που είχαμε για το στέλεχος και τον εγγύς πρόστιο, κάναμε και άϊβους και είδαμε ότι το MLA στο στέλεχος ήταν πάνω από 6, το MLA στον πρόστιο κατιόντα ήταν πάνω από 5 στον εγγύς, άρα είπαμε ότι δεν χρειάζεται να τα πειράξουμε. Είδαμε ότι χρειάζεται κάποιες μεταδιαστολές στο στένο του προσίου κατιόντα μέχρι τα 3,5 χιλιοστά και είχαμε αυτό το αποτέλεσμα, που είναι αρκετά decent, πιστεύω, για το πρόβλημα της ασθενούς, σε 2 προβολές. Η ασθενής έκανε μια συζήτηση μαζί μας σχετικά με το να κάνει και την επέμβαση της βαλβίδας, λόγω του ότι αυτή η πρώτη επέμβαση ήταν αρκετά επίπονη και χρονοβόρα, δεν ήθελε προς το παρόν να προχωρήσει και σε άλλη επέμβαση. Στο μεταξύ μπήκε σε διπλή αντιμεταλλιακή αγωγή, σε διπλή αγωγή με ριβαροξαμπάν και κλοπιδογρέλη λόγω της αγκιοπλαστικής και λίγους μήνες μετά, στις 10 Αυγούστου του 2021, νοσηλεύτηκε για αιμορραγία από το ανώτερο πεπτικό, με πτώση του αιματοκρίτη στο 7,6 μέλαινες. Στην γαστροσκόπηση που έγινε δεν βρέθηκε κάποιο έλκος, βρέθηκε μόνο χρόνια ατροφική γαστρίτιδα. Θεραπεύτηκε σχετικά εύκολα αυτή η αιμορραγία με μία μονάδα μετάγγιση, σταθεροποίηση και 8 μέρες μετά κρίθηκε από τους αστηρολόγους ότι μπορεί να μπει πάλι σε κάποια αντιπικτική αγωγή. Μπήκε, άλλαξε το ριβαρόξαμα, ξαπήξαμε 2 φορές τη μέρα και έγινε εξτήριο 10 μέρες μετά. Επειδή είχε δύσπνοια, ήταν σε επαφή μαζί μας, η δύσπνοια προχωρούσε. Κάποια στιγμή προχωρήσαμε και σε μια αξονική, προετοιμάζοντας στο μυαλό μας μια τάβη. Είδαμε αυτά τα ευρήματα, ένα περίμετρο diameter γύρω στο 23, πολύ ασβέστιο στη ρίζα. Ένα άγκατσον σκόρ που μας δόθηκε από τους ακτινολόγους σε αυτό το πολύ ψηλό νούμερο που βλέπετε. Τα στεφανία στόμια ήταν αριστερά στα 12 χιλιοστά, δεξιά στα 15. Είχε ένα ύψος μέχρι το Anatomical Junction από το δακτύλιο γύρω στα 22. Πολύ ασβέστιο Anatomical Junction που βλέπετε εδώ, με μία μέση διάμετρο γύρω στα 24,5 σε αυτό το επίπεδο. Και να σας μείνει αυτή η εικόνα για αυτό το περιστατικό, πολύ ασβέστιο. Αυτό είναι το πρόβλημά μας και ο δισταγμός μας. Όσον αφορά τους άξονες, τους αρτηριακούς, δεν είχαμε κάποιο ιδιαίτερο πρόβλημα, λίγο ασβέστιο, αλλά επαρκής διαμέτρους και χωρίς ελικώσεις. Τελικά ζητάμε έγκριση για τάβη, την παίρνουμε τον Οκτώβριο του 2021. Η ασθενή συνεχίζει να διστάζει. Μέχρι το Φεβρουάριο του 2022 μπαίνει μέσα όχι πλέον για non-STEMI, αλλά για οξεία καρδιακή ανεπάρκεια πάλι, με καλό αιματοκρίτη, μία αιμοσφαιρίνη που ήταν τότε γύρω στο 12. Γίνεται μια στεφανιογραφία για να δούμε πού ήμασταν σε σχέση με τη στεφανία νόσο. Γίνεται ακριβώς την ίδια ημερομηνία με την πρώτη στεφανιογραφία ένα χρόνο μετά, 4 Μαρτίου του 2022. Βλέπουμε ότι τα stent στο αριστερό σύστημα είναι όπως θα θέλαμε να είναι και ότι υπάρχει ακόμα αυτή η στομιακή στένωση στην δεξιά στεφανία αρτηρία. Αποφασίζουμε λοιπόν ότι πρέπει να ολοκληρώσουμε την επαναγγείωση πριν προχωρήσουμε για τάβη. Και γίνεται αυτή η αγκιοπλαστική σχεδιάστηκε να γίνει με λιθοτριψία, όχι με rotablation αυτή τη φορά. Έχει πολύ ασβεστοθεί στομιακή βλάβη. Μπήκε ένα σύρμα, μπήκε ένα μπαλόν non-compliant 2,5. Μετά μπήκε body wire για να περάσει το μπαλόν της λιθοτριψίας που ήταν ένα 3,12. Αυτό ήταν το αποτέλεσμα μετά τη λιθοτριψία. Μετά αυτή είναι η τοποθέτηση του stent. Μπήκε ένα stent 3,5-12 και έγινε μια μεταδιαστολή για να έχουμε καλό αποτέλεσμα με ένα OPN 3,5-15. Έτσι φαινόταν στο stent boost το stent, αρκετά καλό και αυτό είναι το αγγιογραφικό αποτέλεσμα. Είμαστε ικανοποιημένοι λοιπόν και πλέον η ασθενής δέχεται να κάνει και την τάβη και 12 Απριλίου, πριν ένα μήνα δηλαδή, προχωρήσαμε και αυτή ήταν η απλούστερη από τις επεμβάσεις που κάναμε. Πολύ straightforward, μπήκε μία S3, σημαδέψαμε το αν όριό της να είναι στο όριο λίγο κάτω από τα στεφανία, γιατί σκεφτόμαστε ότι πιθανώς να χρειαστούμε άξιο στο μέλλον και δεν θέλαμε να έρθουμε σε επαφή με το ασβέστιο που είχε στο Anatomical Junction. Ξέραμε ότι το ύψος μας το επέτρεπε, όπως το είχαμε υπολογίσει από την αξονική, και αυτό είναι το τελικό αποτέλεσμα και χωρίς πρόβλημα στους άξονες. Τώρα, ένα μήνα μετά, η ασθενής είναι καλύτερα από ποτέ σε σχέση με το πώς την είχαμε γνωρίσει. Έχει πολύ καλή λειτουργική κατάσταση. Μέχρι τώρα δεν έχουν προκύψει προβλήματα. Πρόσφατες εξετάσεις δείχνουν ότι ο αιματοκρίτης είναι σταθερός και είναι σε θεραπεία με απίξεπαν 2,5 mg 2 φορές τη μέρα και κλοπιδογρέλη 75 mg τη μέρα. Φυσικά η παρακολούθηση της θα συνεχιστεί. Έχουμε κάποιες σκέψεις για το μέλλον, μήπως χρειαστεί κάτι στο στέλεχος και στο εγγύς πρόσθετο να εξελιχθούν εδώ οι βλάβες, αλλά πλέον έχουμε access γιατί έχουμε επιλέξει την S3. Και συμπερασματικά έχω να πω ότι όταν ένας άρρωστος με κόμπλεξ στεφανία νόσου και σοβαρή στένωση αορτικής βαλβίδας με τόσο ασβέστιο απορριφθεί χειρουργικά, μας βάζει πολλά προβλήματα. Προβλήματα όσον αφορά το σχεδιασμό της επέμβασης, αν θα προηγηθεί η αντιμετώπιση της στεφανίας νόσου ή της βαλιδοπάθειας και τεχνικά προβλήματα για να το κάνουμε αυτό. Όλες αυτές τις προκλήσεις όμως μπορούμε πλέον με τις γνώσεις που έχουμε να τις αντιμετωπίσουμε και τα καινούργια όπλα που έχουμε, όπως η τάβη, η λιθοτριψία και το παλιό ροταμπλέιτο, γενικά όλα αυτά που μας βοηθούν να πολεμήσουμε το ασβέστιο πλέον βοηθούν. Δεν ξέρω αν κάποιος άλλος το έκανε με άλλη σειρά, πάντως σε εμάς έτσι δούλεψε καλά. Σας ευχαριστώ πολύ για την προσοχή σας.
Κώστα, πραγματικά πάρα πολύ ενδιαφέρον περιστατικό. Σε ένα περιστατικό όλη η καρδιολογία, θα λέγαμε, όλη η επεμβατική καρδιολογία. Λόγω του χρόνου θα προχωρήσουμε στο επόμενο περιστατικό από τον κύριο Ζαΐρη.
Δεν σ' ακούμε, Μιχάλη, κανένα mute. Άνοιξε το μικρόφωνο σου, δεν ακούγεσαι.
Ακούμε.
Ναι, τώρα ναι.
Τώρα ακούμε. Λοιπόν, το περιστατικό που θα σας παρουσιάσω είναι ένα περιστατικό τάβη, το οποίο δεν θα σας εντυπωσιάσει, αλλά μένα με τρόμαξε πάρα πολύ. Και γιατί με τρόμαξε? Γιατί αυτή είναι μια γυναίκα η οποία είναι 81 ετών, είναι από την Κάρπινο και μεγαλώσαμε μαζί. Δηλαδή ήταν σαν δεύτερη μου μάνα. Μια γυναίκα λοιπόν 81 ετών, η οποία με πήρε τηλέφωνο ένα βράδυ και μου λέει: Μιχάλη μου, ξέρεις κάτι, εχθές με μαζέψανε έπεσα στην κουζίνα, έπλυνα τα πιάτα, έπεσα κάτω και με μαζέψαν τα παιδιά. Έκανε δηλαδή ένα συγκοπτικό επεισόδιο. Της είπα να πάει να τη δει ένας καρδιολόγος στην Κάλυμνο, ένας φίλος, συνάδελφος. Με πήρε έντρομο τηλέφωνο, μου λέει: έχει σοβαρή στένωση αορτικής βαλβίδας. Εν πάση περιπτώσει, έρχεται η γυναίκα στην Αθήνα. Όπως ξέρουμε, τα συμπτώματα της σοβαρής